Okay, let's start. So you know who I am, I'm sure, Dr. Goljan. My students call me Poppy. I prefer that, actually. That's what my grandchildren call me. Okay, just some ideas about how to study this. You don't use the pathology from Kaplan, you use this. And that's why you got it for. That's why you came. Okay, I'm sure that you looked at the first part, which basically is high yield. Now, when I say high yield, what does that mean? It means it's generated from students that have taken the exam previously, and there are topics that were on their test. And so there's high yield in anatomy, everything except behavioral science in here. Some of you that have taken the exam will recognize many of the questions you had on it. Many people that have taken the test, that have gone through these high yields, have seen quite a few questions on their test. There's only a certain number of ways they can ask a question, and so I've got a lot of the ones they've asked here. Study it and know it absolutely cold, backwards, forwards, and inside out. Okay, that's probably the most important thing there. There's even more high yields in the actual book itself. So that's very, very, very important that you go through the high yields. I can't believe that some people that have taken this course did not go all the way through the high yield, and then I saw them again the next time. Okay, so did you go through the high yield? Well, not really. There you go. Okay. So they're high yield because they come from students, not because I'm some kind of genius who can figure out and read their minds. Okay? So make sure you do those. Also, you'll see questions there. There are questions that actually come from high yield. And there are questions on each of the topics that I cover. And if I were you, the way I would do this, I would not try to follow me in the book, because I don't feel any obligation to go through everything in this book. I can't actually do all of pathology in 40 hours, or I guess if you subtract the breaks and stuff like that, it's a little closer to 30 hours. It's impossible. So all I can do is pick out the most important things that I think that you should hear. The rest of it is something that you can read at your own leisure. My suggestion is to listen to me and not write. You don't have to write a single thing. Everything you need to know is in there. So why would you need to write? In terms of what's important, everything's important. So, forget the underlining because you need a paintbrush. You can start at the top and go straight down, okay? That means underline an individual thing. Guys, these notes took 25 years to put together over time. And it dwindled down to the absolute quintessence. I mean, it's like an espresso, you can just maybe have a little drop and you're already fixed, okay? It's got it all there. So there's no reason to underline anything. Everything's important. There's no reason to look at it while I'm talking, because you're going to do one or the other. You're going to either look at it or you're going to listen. You can't do both. My suggestion is to listen. And then what you do at the end of the day is you go through the questions that I have on that subject, and you have answers to them. Okay? If you can answer those questions, then there's no real reason to go and read the notes, is there? And so that's how you do it. You listen carefully and attentively. Then in the evening or during breaks, you start trying to answer the questions. Okay, there's 300 and something of them there. There's quite a few questions there. And that's how I do it. I also gave you, people always asking about pictures. I can't give you my pictures because they're all copyrighted. Okay, some of you don't understand copyright. You think anything you can just copy. Okay, you can't. Okay. And so I took Robin's textbook. Most people have that pathology book, 6th edition, and you got an extra handout that goes through the page and the illustration of the picture in the Robin's textbook that could potentially be a picture like it on the exam. For those that are interested in they've got to have pictures. Okay, well, I looked all the way through Robin's and I picked out their best pictures of things that have been on the exam, not the exact picture. The ones that they usually put the exact picture, the ones I have, because they come from existing pathology sets. So you got that. Okay, so I think, let's see, anything else in there? That's about it. That's what I would suggest that you do. All right? Now, we break every 50 minutes for exactly 10 minutes. I have a little clock there. When that 10 minutes is up, I start. I don't care. I could be talking to you. I will stop in mid-sentence and we will begin. Okay? We've got to have some kind of order. Otherwise, you get up, sitting up here all day answering questions instead of lecturing. Okay? In terms of the questions that you may want to ask me, please limit it to the stuff that we're talking about. Not about your grandma with this disease or that, okay? That's not what we're here for. Okay, not about even part 2, okay? Not even about part 2. We're here for part 1. Okay, so limit the questions to what we're talking about now. Okay, and that way other people can get an opportunity to ask a question. Probably shouldn't be a whole lot of questions because I think it's pretty clear stuff. But whatever. That's the way we work it, okay? Please, no questions during class. I mean, obviously, with this many people, with probably 800 different dialects here, okay, it would be very difficult to be able to answer those questions. So you save them until the breaks. Usually I come in a little early during the lunchtime. When we come back, maybe 15 minutes before it starts. I stay maybe 5 or 10 minutes after 5 o'clock. We go all the way to 5. And you should get your questions answered. But most of the questions that you would have are answered already in the book. I've heard every single question that has been asked. So I anticipate them, and so most of the time it really won't be necessary. Okay? So that's it. Ready to go? Okay, let's start up. If we could just have to press this. Okay. Cell injury is the first topic. It's very important. Key issues in cell injury deal with hypoxia, getting into things like carbon monoxide poisoning, cyanide poisoning, and things of that nature. And probably the next biggest thing would be apoptosis is a hot topic right now, and free radicals, so we'll go through those. And then growth alterations, that's big time. Okay, atrophy, hyperplasia, that kind of stuff. So those are the things we'll concentrate on in this chapter. First thing is terms. When I said hypoxia, the first thing that should have come to your mind is inadequate oxygenation of tissue, which is basically the same definition as shock. Okay? Now remember, why do we need oxygen? We need oxygen for the oxidative phosphorylation pathway. That's where we get ATP from. That's in the mitochondria. In fact, it's specifically in the inner mitochondrial membrane is where the electron transport system is called oxidative phosphorylation. Remember, the last reaction is oxygen to receive the electron. So oxygen is an electron acceptor, as you recall. Protons are being kicked off that electron transport system, eventually end up going back into the membrane and forming ATP. It's just that simple. That's why we need oxygen. So basically it all boils down to we need oxygen for ATP. Okay? And the ATP is mainly generated in the mitochondria. Pretty simple concept. I know you haven't had biochemistry. You fortunately have the best biochemistry teacher around, Dr. Hansen. She's the one that wrote the notes on biochemistry, and I think they're pretty good. All right, some oxygen terms. You need to know oxygen content. You may have had this in PASO already, since you did respiratory. This is important because it's important for you to understand what carries oxygen. Okay, and this formula actually goes through that. You forget the number, that's irrelevant. It's the hemoglobin, which is the most important of the three things, times the oxygen saturation, which a lot of you don't understand, plus the partial pressure of arterial oxygen. Okay, so these are the three main things that carry oxygen in our blood. Hemoglobin, and then on that hemoglobin, the oxygen attached to the heme group, that's called oxygen saturation. And then the amount of oxygen that's actually dissolved in plasma, that's the partial pressure of arterial oxygen. Okay? If you want just a visual of what oxygen saturation is, this is a red blood cell. Remember, there's 4 heme groups. Iron has to be +2, if you recall. If it's +3, cannot carry oxygen. And so all 4 heme groups on hemoglobin are occupied by oxygen. On every one of the red blood cells, the oxygen saturation is 100%. So it's the oxygen in the red blood cell attached to the heme group. That's oxygen saturation. That's what you measure with a pulse oximeter. The partial pressure of oxygen is the oxygen dissolved in your plasma. Okay. So how does the oxygen flow? It flows from the alveoli through the interface. It dissolves in the plasma, increases the partial pressure of oxygen. That's what this is. It diffuses through the red blood cell membrane and attaches to the heme groups on the red blood cell, on the hemoglobin. That's your oxygen saturation. So you should therefore understand that if the partial pressure of oxygen is decreased, what has to happen to the oxygen saturation, please? It has to be decreased. Because where did it get its oxygen from? The amount that was dissolved in plasma. That should be perfectly obvious to you. Okay? So those are your terms, guys, that you must know to understand tissue hypoxia. Okay, one of the first causes of tissue hypoxia is ischemia. This is another definition. Ischemia, recall, is a decrease in arterial blood flow. Not venous, arterial. Now, the most common cause of ischemia is a thrombus in a muscular artery, because that's the most common cause of death in the United States, a myocardial infarction. That's a classic example of ischemia. Got a thrombus that's blocking arterial blood flow, producing tissue hypoxia, right? And so that's the most common cause of ischemia is a thrombus in a muscular artery. But how about a decrease in cardiac output for whatever reason? A hypovolemia, cardiogenic shock, would that qualify as tissue hypoxia, as ischemia? Sure, because you have a decrease in arterial blood flow. Okay. The second most common cause of tissue hypoxia is hypoxemia. There's a lot of books and a lot of students think that hypoxia and hypoxemia are the same. No. Hypoxia is the big term. Hypoxemia is a cause of hypoxia. They're not the same. Hypoxemia deals with the partial pressure of arterial oxygen, which I've already just defined for you. That's the oxygen dissolved in plasma, arterial plasma. That's the partial pressure of oxygen. When that is decreased, that is called hypoxemia. Okay. Now, you've had Tasso. You've had him for respiratory. I know you haven't had him for cardiovascular. He's outstanding. I know everything he teaches. Okay, he's a good friend of mine. And so I know that he's taught you this. He's taught you ventilation, perfusion, and diffusion. He's taught you the alveolar arterial gradient, the AA gradient. He's taught you that already, so it's not necessary to have to repeat those things, even though we will. Okay? Why? Because some people, it goes in one ear and out the other. If that's you, then what you do is you put a little plug in one ear, and then it stays in there, okay, to make sure the ear that's open is faced towards me, and it'll just stay in your brain. What he may not have talked about is respiratory acidosis in this regard, in terms of hypoxemia. It's Dalton's law, guys. So some of the partial pressures of the gas must equal 760 at atmospheric pressure. We have oxygen, CO2, and nitrogen. Nitrogen remains constant. So when you retain CO2, carbon dioxide, that's respiratory acidosis. You already knew that. But what has to happen to the CO2 when the CO2 goes up? It has to go down. It has to. It's not, well, I think I'm going to go down. No, you're going down because you still have to come out with 760. So every time you have respiratory acidosis from any cause, you have hypoxemia. You have a low PO2, arterial PO2. Have to. CO2 goes up, what goes down? Okay. And vice versa. CO2 goes down, respiratory alkalosis, what happens to PO2? Goes up. Have to. Okay, so that's that inverse relationship. Now, you know, in terms of ventilation defects, probably the best example of a ventilation defect is respiratory distress syndrome, another name, hyaline membrane disease. The adult variety is called adult respiratory distress syndrome. And that's producing a ventilation defect, which you already know about, because Pascal taught you. But you've lost ventilation to the alveoli, but what do you still have? Perfusion. So you have no ventilation, but you have perfusion. What have you created? An intrapulmonary shunt. You all know that. How are you going to recognize it on an exam? Very simple. You'll have a patient with hypoxemia. They say they gave them 100% oxygen for 20 minutes, and the PO2 didn't increase. I mean, duh! What does it mean? It means you got a shunt. God. I mean, that's so simple. The student sitting there, what's going on here? Never heard about this. I mean, come on. I mean, it's not hard. They didn't give them oxygen? Well, that's a possibility. They thought they were, but they didn't. But that's kind of reading into the question. Okay, so that's how you can tell whether you have a shunt going on there. You give 100% oxygen, the PO2 doesn't go up. Come on. There's a massive ventilation defect there. And if it's a little dude, it's hyaline membrane disease. If it's an adult, it's adult respiratory distress syndrome, period. Okay, we have perfusion defects. Okay, that means you knock off blood flow. Well, you know the most common perfusion defect, don't you? I could have got it on the stinking plane coming here because it was over 2 hours. Pulmonary embolus. That's going to be a board question, guys. It's on the radio all over the place. You know, prolonged flights and sitting down and not getting up. Why? They tell you sit down. You can't get up. It's choppy weather. You know, I got to go pee. No, sit. Okay? Well, you're sitting there. You get some stasis in your deep veins of your leg. Get a little propagation of a clot, and 5 days later or 3 days later, you throw off an embolus. That's a perfusion defect. So now we have ventilation, but we have no perfusion. That's increasing what? Come on, you're going to do pass so poor bad if you don't give me the answer. Dead space. So perfusion defects produce an increase in dead space. Ventilation defects produce intrapulmonary shunts. Very simple stuff. Now, if you give oxygen, 100% oxygen to someone with a perfusion defect, you will get the PO2 up. Why? Because not every single vessel in the lung is not perfused, so other areas of the lung can make up for the difference. So that you can easily separate then a ventilation from a perfusion defect by giving oxygen, 100%. If it doesn't go up, it's a ventilation defect. You got intrapulmonary shunting. If it eventually increases, then you know you got a perfusion defect, a dead space problem. The third thing is a diffusion defect. That's where you have something in the interface that oxygen can't get through. Like what? Like fibrosis. Probably the best example is sarcoidosis, a restrictive lung disease. Oxygen has enough trouble getting through the stupid membranes. You put fibrosis there, it really has a problem. We have pulmonary edema. How's oxygen going to get through all that crap? Can't. So you have a diffusion defect. Or just plain old fluid, like in heart failure. You know, when you get that initial dyspnea in a patient with heart failure because you've activated the J as in jerk, J reflex, innervated by the 10th nerve. With fluid or anything innervates that J receptor, what happens is you get dyspnea. Okay, that's kind of like you're trying to take a breath, but you can't take a full breath. That's because you stimulated the J receptor and you can't take that full breath because it produces dyspnea. That's because you have fluid in that interstitium of the lung and they're irritating the J receptor. That's a board question too. Everything I've said so far is on boards. Okay, so these are the 4 things that produce hypoxemia. Okay, all of which you already know, I think. But I'm just putting it into a different context and maybe that's the pass a bit. We're not done with hypoxia yet. You can have hemoglobin-related problems causing hypoxia. Okay. Of course, anemia would be a classic one, wouldn't it? And if you looked at oxygen content, you can. Then they said, what would you expect in a patient with anemia? One of the classic things that students always fall for is a decrease in PO2. They think that you have hypoxemia when you have anemia. Of course you don't. Don't you have normal gas exchange in a patient with anemia? Sure. So the PO2 should be normal. The oxygen saturation should be normal, but what's decreased? The hemoglobin. That's what anemia is. You still have normal respiration, so the PO2 is normal, the oxygen saturation is normal. Common mistake. But boy, you got a 5-gram hemoglobin, you don't have a whole lot of oxygen to give the tissue, do you? Because it decreased hemoglobin. You might have a normal oxygen saturation, a normal PO2, but you only have 5 grams of hemoglobin. You ain't carrying a whole lot. So you have tissue hypoxia. That's why they have exertional dyspnea when you have anemia. Exercise intolerance. You have tissue hypoxia from a decrease in hemoglobin. Then we get into our little friends carbon monoxide and methemoglobinemia. Carbon monoxide's on every board. You all know that. You just have to recognize how they're going to present it. Well, the big one is usually a heater in the wintertime. These little room heaters oftentimes have combustible material in them, and you can get carbon monoxide from that. You're in a closed space with a room heater. That's a favorite one that they ask. Automobile exhaust, of course, is another one, but another big one's a house fire. In fact, there's two things that produce tissue hypoxia in a house fire. One is carbon monoxide poisoning because of the fuel of the combustible things. The other one's cyanide poisoning because upholstery is made out of polyurethane products. Okay, when there's heat, you get cyanide gas given off. So patients that come out of house fires commonly have both carbon monoxide and cyanide poisoning. That's very important. So you get 2 for 1. Now remember, carbon monoxide is very, very diffusible. It has a very high affinity for hemoglobin. Okay, but this oftentimes also causes confusions with students. Okay, what does it mean? Basically it means that the problem is going to be oxygen saturation is going to be decreased because it's sitting on the heme group rather than oxygen. I mean, you can recite for me 210 times greater affinity for hemoglobin, and then you don't know what it means. What it means is it's sitting on the heme group instead of oxygen. That's what it means. That means oxygen saturation is decreased. Period. That's the only thing that's decreased. Hemoglobin is certainly normal. It's not anemia. And the oxygen and the PO2, the amount dissolved in oxygen dissolved in plasma, is totally normal. The problem is that when it diffuses into the red blood cell, carbon monoxide sitting on its place. It's like someone taking your seat during a break, and you come back and someone's there. All right. Every time you see that happen, from now on, you say, "Hey, you carbon monoxide, I'm 100% oxygen. I'm displacing you now." Okay. So then you get 2 for 1 for that. You know how to treat it with 100% oxygen. And you know that if someone's sitting in your seat, it's decreasing oxygen saturation. And then, unfortunately, you recall that when you have a decrease in oxygen saturation, you have clinical evidence of cyanosis. You all knew that too. When they say cyanosis, basically what they're saying is that you have a decrease in oxygen saturation. That's what gives you cyanosis. But why don't you see that in carbon monoxide poisoning? Because of that red pigment, that cherry red pigment masks it. That's what makes it such a hard diagnosis to make. The most common symptom that was on board is headache. That's the first symptom of carbon monoxide poisoning is headache. It's all in your notes. Okay, methemoglobin is very interesting. I think it was unfair the way they answered the first time. Lately, they've been asking the DAT zone question. First, what is methemoglobin? It's iron plus 3, not plus 2. So if iron is plus 3 on the heme group, then oxygen can't bind to it. So the only thing that's screwed up with methemoglobin poisoning is oxygen saturation again. Okay, that's because the iron's plus 3 rather than plus 2. But oxygen saturation is decreased. If you're lucky, they may give you a history in a patient with methemoglobinemia that they draw blood and it's chocolate colored. That's because there's no oxygen on the heme groups. The PO2 is totally normal. The hemoglobin concentration is totally normal. It's the oxygen saturation. So in other words, the seat's empty, but you can't sit in it, okay, and stay there because it's plus 3, okay, not plus 2. That's why red blood cells have a methemoglobin reductase system. Okay, you'll find out where that's located in biochemistry, but it's basically right where you make NADH, about halfway down in the glycolytic cycle. Right there is where the methemoglobin reductase system is, and it can convert by reduction, can reduce plus 3 back to plus 2. The question there's 2 questions that they use for methemoglobinemia. One was a dude coming out of the Rocky Mountains, and he was cyanotic. They gave him oxygen, and he was still cyanotic. I guess you have to just really read in between the lines because that's all the history they give you. He's probably drinking water up there in the mountains, and the water oftentimes up in the mountains is loaded with nitrites and nitrates. These are oxidizing agents, and what they do is they oxidize hemoglobin, and so the iron becomes plus 3 rather than plus 2. The tip-off was the fact that giving oxygen didn't correct the cyanosis, okay? And you had to arrive at the fact that it was probably a methemoglobinemia, and then they wanted to know what the treatment was, which is IV methylene blue. An ancillary but not the primary treatment is vitamin C. Vitamin C, you recall, is a reducing agent. But that's not your main treatment. It's intravenous methylene blue. The most recent one for methemoglobinemia was Dapsone. Dapsone, as you know, is used in treating leprosy. It's in your high yield. Don't worry about it. You'll see it. Dapsone. Dapsone is a sulfur drug. Sulfur and nitro drugs, guys. Sulfur and nitro drugs do two things. I want you to tie this together. One is they produce methemoglobin. Two is that they have the potential for producing hemolytic anemia and glucose 6-phosphate dehydrogenase deficiency. So when they talk about hemolysis and G6PD deficiency, they're talking about oxidizing agents, okay, causing an increase in peroxide, which destroys the red blood cell. And it's interesting, the same drugs that can produce hemolysis and G6PD deficiency are nitro and sulfur drugs, okay? And they're also the same kind of drugs that produce methemoglobin. So it's possible when you have exposure to Dapsone or Primaquine or trimethoprim sulfamethoxazole or nitro drugs, nitroglycerin, nitroprusside, whatever, you can have a combination of a hemolytic anemia, G6PD deficiency, and methemoglobinemia because they're oxidizing agents. Do you understand that? Okay. Very common, by the way, to see methemoglobinemia in HIV. Why? Great board question. Come on. Because they're on trimethoprim sulfamethoxazole for treatment of what? Come on. Pneumocystis carinii. There you go. So what's the potential complication of that therapy, please? Methemoglobinemia. Right? That's an integration, guys. That's the kind of stuff the boards is made up of. I feel so sorry for the boards people, don't you? Not really. More. Okay. It's all in your notes. The more you read, the higher the score. Pretty simple. The less you read, the lower the score. Very, very simple. Straight log. Straight up. Guaranteed. Okay. Get through the notes if you can. Okay, and then we have shift curves, and I'm sure Tasso went through this, so oftentimes they're biochemistry. What kind of curve do you want? Outside of the plate. No, we're talking left and right shifted curves. What kind do you want? You want a right shifted. You want to have hemoglobin that has decreased affinity for oxygen, so it wants to release oxygen to tissue. That's what you want. Okay, what's going to make it go that way? Well, that famous compound, name it, 2,3-BPG, bisphosphoglycerate. Okay, what else? Fever does. What else? Low pH, because acidosis. Right shifts the curve, that is correct. Okay, now what about, what's another thing that does that was recently on boards? High altitude. When you go into high altitude, it right shifts your curve. So you'll have a respiratory alkalosis. You have to hyperventilate in high altitude. Because why? You just told me a little while ago. What did I say happens when you decrease CO2 respiratory alkalosis? What happens to PO2? It goes up. Isn't that what happens when you're at high altitude? And then what else happens? You right shift your curve because high altitude causes an increase in synthesis of 2,3-BPG. That's a board question. That's how we can get oxygen up there. Very interesting. I think so too. So what left shifts? Well, carbon monoxide left shifts, methemoglobin left shifts, hemoglobin F, fetal hemoglobin left shifts, decrease in 2,3-BPG. What's the opposite of acidosis? Alkalosis. There you go. Alkalosis left shift. That's bad. That's going to produce tissue hypoxia. So we have a double whammy with carbon monoxide so far. We got it decreasing oxygen saturation, and second, we have it left shifting the oxygen dissociation curve. That's not too cool. We got one more to go for carbon monoxide, don't we? Okay, so those are hemoglobin-related problems. Then we have the problems related to the oxidative pathway. Now, probably the most important one is cytochrome oxidase, which is the last enzyme before it transfers the electron to oxygen, which is an electron acceptor. And of course, there's two things. What I remember is the 3 C's. Cytochrome oxidase is the first one. And the next one is cyanide and carbon monoxide. Inhibit cytochrome oxidase. So just remember the 3 C's. Cytochrome oxidase, carbon monoxide, cyanide all like each other. Okay. So we have a third thing for carbon monoxide producing tissue hypoxia. It blocks cyanide. It blocks cytochrome oxidase. So it decreases O2 sat, so you can't carry a lot of oxygen. Less shifts your curve, so even what little you carry, you can't release. Okay? And then if you were able to release it, okay, if you go to the end there, they come on electrons. And no electron comes to it because you blocked the cytochrome oxidase, and the whole system shuts down. You are screwed. Okay, so that's why carbon monoxide is such an important board question. Uncoupling you'll get in biochemistry. Basically what it means is the ability for the mitochondria and the inner mitochondrial membrane to synthesize ATP. What's happening is that the inner mitochondrial membrane is permeable to protons. You only want protons to go through a certain hole in that membrane. And you want it to go through this pore at the base of which is ATP synthase, and you're going to get ATP. You don't want protons just randomly going into the mitochondrial matrix because nothing's going to happen. That's what uncoupling agents do. Okay, examples would be dinitrophenol. This is chemical that they use for preserving wood. That does it. Alcohol's an uncoupling agent. Salicylates are uncoupling agents. It causes the protons to just go right through the membrane. Not cool. You're draining off all those protons, and you're getting very little ATP from it. Well, since our body is in total equilibrium with each other, you start draining protons off, then those reactions that were generating the protons to begin with, those would include reactions that make NADH and FAD, remember? Mm-hmm. Those are the protons that were delivered to the electron transport system, right? So any reaction that makes NADH and any reaction that makes FADH, okay, any of those reactions, you're going to rev those reactions up when your protons are decreased. And so all the reactions start increasing, to make more NADHs and FADHs to make more protons. Well, you all know from just simple chemistry that when you increase the rate of a chemical reaction, what happens to the temperature? It goes up. So what risk do you have for this type of thing, please? Hyperthermia. Anyone that's been in the business of medicine a while, I'm sure some of you looks like have been in that business for a while, knows that in salicylate toxicity, one of the complications is hyperthermia. That's because it's an uncoupling agent. And most of you probably know that if you're an alcoholic on a hot day, you have a good chance of developing a heat stroke because you already have uncoupling of oxidative phosphorylation. And so to throw on top of it alcohol, which is an uncoupling agent, you've got a bad situation. That's why alcoholics are so susceptible to heat stroke, because their mitochondria are already screwed up. Okay, so that's what uncoupling agents do. Very interesting. And then arteriovenous shunting, we won't mention that. So these are all the causes of tissue hypoxia. We started with ischemia, then we went to hypoxemia, respiratory acidosis, ventilation defect, perfusion defect, diffusion defect, hemoglobin-related things, anemia, carbon monoxide, methemoglobin, left-shifted curve, problems with cytochrome oxidase and blocking it, carbon monoxide, cyanide, and uncoupling agents. All those produce tissue hypoxia. All right, very important that you know those. Those are just absolute key things on boards, absolute key things. So let's see if you learned anything. Fill in the blanks. Respiratory acidosis, what happens to hemoglobin? Let's assume it's just acute respiratory acidosis. Nothing. What's going to happen to oxygen saturation? Decrease it. And what's going to happen to the partial pressure of oxygen? Decrease it. Okay, so you're going to decrease both oxygen saturation and PO2. Why is oxygen saturation decreased? Because PO2 is decreased. Okay, anemia. What's the only one of these three things that's going to be affected? Hemoglobin. Oxygen saturation, PO2 is normal. How about carbon monoxide and methemoglobin? These doesn't have an effect on hemoglobin concentration. No. How about oxygen saturation? Yes. How about PO2? No. Very good. How do you treat carbon monoxide poisoning? 100% oxygen. Now you treat methemoglobinemia. IV methylene blue. What else can you give as an ancillary treatment? Ascorbic acid. You got it. First concept finished. All right. Now let's see what happens when you have a decrease in ATP, because you have tissue hypoxia. Okay? Well, the biggest thing of these three things, and probably the only one, well, two biggest things, is that you have to go into anaerobic glycolysis. Now, I know you haven't had that yet, but anyone in this room that doesn't know what anaerobic glycolysis is in big-time trouble. Okay? Remember, the end product of anaerobic glycolysis is lactic acid. Pyruvate is converted into lactate. Why? Because of an increase in NADH. So you need to make NAD, because you're going to need the NAD to feed back into the glycolytic cycle so you can make 2 more ATP. You want to know why you have to use anaerobic glycolysis when you have tissue hypoxia? The answer is your mitochondria is the one that usually makes all your ATP, except there's one place you can get 2 ATP without going into the mitochondria. And where is it? It's an anaerobic glycolysis, which every cell can do, including RBCs. So you're surviving on 2 ATPs per glucose for your ATP if you have tissue hypoxia, because your mitochondrial system is totally shut down. If there's no oxygen at the end of that electron transport system, you're screwed. You can only get 2 ATP without having to go through that system by anaerobic glycolysis. So what's the good news? The good news is you get 2 ATP. Okay, what's the bad news? You get a buildup of lactic acid in the cell and outside the cell. You all know that you have an increased anion gap metabolic acidosis and tissue hypoxia. I mean, that's a given. You know that. And it's lactic acidosis from anaerobic glycolysis. But within a cell, it does havoc. An increase in acid in a cell will denature proteins. Okay? In other words, the structural proteins of the cell, denaturing it is not good. That's altering its configuration. It's screwing it up. And in terms of enzymes, it denatures them too. So that means that the cell can't even auto-digest itself anymore because its enzymes have been destroyed because of the buildup of acid. That's called coagulation necrosis, guys. So when you have tissue hypoxia, one of the things that can happen within a cell is coagulation necrosis, which is one of the types of necrosis that you need to know, of course. And when you look at coagulation necrosis from a gross point of view as opposed to a microscopic point of view, that's termed infarction. Okay, so that's where we're going with that eventually. So a buildup of acid, lactic acid in the cell produces what type of necrosis? Coagulation necrosis, that's correct. Okay. Second thing that happens when you lack ATP is all ATPase pumps are screwed up. Why? Because they run on ATP. That's the power. How do muscles work? ATP. How does everything work that needs energy? ATP. And we have these pumps. And we have a sodium-potassium pump. You already know about this pump because there's a certain drug that blocks it. It's called digitalis. And we block that, put that pump with digitalis to allow sodium to go into the skin, into the cardiac muscle to open up what? Calcium channels so that you can get an increase in force of contraction. Am I correct? Isn't that what you learned in pharmacology? Yes or no? Okay. So sometimes you want the pump blocked. Okay. Sometimes you want to enhance it. Okay. But anyway, if there's no ATP, then what happens is sodium can get into the cell. Well, who does sodium always bring with it? Water. And so you're going to get cellular swelling. Now, that's reversible. It won't kill you. They got swollen up a little bit, you know. Just have some pretzels with a lot of salt tonight. Okay, you'll be a little swollen in the morning. Little eyelids will be all kind of fused shut. I mean, you're not dead, are you? You're just kind of swollen up. Okay? That's the one they like the most on boards, is this pump. So when you have a tissue hypoxia, they can give you any scenario they want from the ones that we just discussed for tissue hypoxia. What's going to be happening in that cell? It's going to be swollen up. Why? Decreased ATP. So sodium goes into the cell. Now all you got to do is get oxygen back and it'll pump it out. All that excess sodium and water, and the cell goes back to normal. So it's totally reversible. Okay, so I think of these three things, the two most important one is that in tissue hypoxia, the cell has to undergo anaerobic glycolysis, and of course the mature red blood cells doing that all the time, because the mature red blood cells don't have mitochondria. And so that's the main energy source right there. So that's a normal thing for red blood cells. It says, hey, I'm just in heaven. Okay, I'm just doing what I normally do, anaerobic glycolysis. Okay, but in other tissues, they don't like that. They'd rather have the whole thing going from pyruvate not into lactate. They want it to be going into forming citrate and go into the TCA cycle. They want the citrate to go out into the cytosol, make some fatty acids. They want the whole shish kebab, not lactic acid. Okay? All right. So these two things are the most important things in terms of tissue hypoxia and what happens. So we said that cellular swelling, of course, they give names in this in pathology, but they don't on boards. They just say cellular swelling. They don't use the terms like hydrophic degeneration, crap like that. I mean, that's just junky stuff. They just say cellular swelling. In fact, they try to use very, very little things that give away answers. Okay, so, all right, because in most of your courses you had to memorize everything, right? Hydrophic degeneration, you know. All these anchovy paste abscess. And now you're never going to see that crap. You're not going to see that stuff on this test. Not a chance in God's green earth. No way. They're going to take all those little crutches that you use away from you and just describe them and not actually use those names. Courvoisier sign, the palpable gallbladder with carcinoma of the head of the pancreas. Forget it. Okay, there's going to be a guy with painless jaundice and a palpable gallbladder and light-colored stool. They're not going to say a colic stool. No. They're just light-colored. And you have to come up with the fact it's carcinoma in the head of the pancreas. Okay. If you knew it was Courvoisier sign for the palpable gallbladder, but it ain't going to help you on the boards. Okay. Now, a cell without oxygen, now that's coffee. Starbucks makes coffee. Anything short of Starbucks is not coffee. Okay. It's just colored water. All right. Now, you can prove me wrong by bringing some of your national brands, and I'll taste it and I'll be able to check it, but we'll see. I've had some good stuff from some Costa Rica. Somebody gave me some of the Costa Rica. Oh, food, that was wonderful. I mean, my hair went up. This is good stuff. It's actually legal. All right. Don't have to worry about shipping it into the country clandestinely. I mean, woo, just give it to me. There's Mountain Dew for the little kids, and there's that kind of coffee for us. Whoa. All right. So, a cell without oxygen for a while, eventually things are irreversibly going to occur. They're interested in this too. One of the big actors for irreversible change is calcium. They really like to know what happens to calcium in tissue hypoxia. The answer is it enters cells. Actually, there's a pump, just like there's a sodium potassium ATPase pump, there's a calcium ATPase pump also. And so what happens is that if ATPs decrease, calcium now has easy access to the cell. And when it's in the cell, it's unbelievable. It activates all these enzymes. It activates phospholipases in the cell membrane. That's not cool. It's going to cause damage to the cell membrane. It's going to activate enzymes in the nucleus. That's not cool because you're going to end up getting nuclear pycnosis and eventually the nuclear chromatin just plain disappears. It goes into the mitochondria. Oh, God, it just has a blast in there. That's like a kid going to McDonald's in one of those, tube things. Oh, look at that. It just destroys the mitochondria. So it activates enzymes. Calcium's famous for that. You all know that hypercalcemia produces acute pancreatitis. And maybe you just put something together now for the first time. It can activate your actual enzymes in your stinking pancreas. And you get an acute pancreatitis from hypercalcemia. So it's no small wonder that if it goes into a cell, it does the same stinking thing. Okay, so that's one of the key things for reducing irreversible change is our little friend calcium. Of the two that get damaged, that's the worst thing to get damaged. I think cell membrane is the worst. Because that's the thing that's preventing bad things from the outside from getting into a cell. So if you start destroying that, your cell's irreversibly damaged. But then to add insult to injury, and I'll go up the mitochondria, the energy-producing factory, it's all over. It's all over. Okay, so all those things are irreversible when you screw up the cell membrane. And when our little friend calcium gets in, does this thing, it's all over. Cell dies. A lot of times it releases enzymes. We all know those different enzymes, CK, and CKMB for myocardial infarction could release that. Could release transaminases in hepatitis, SGOT or ALT, or AST, ALT, those kinds of things. Amylates in pancreatitis, those kinds of things can get released when that tissue, that cell dies. Okay? So that's that concept. Two others, and we're away from tissue hypoxia right now, is free radicals. Free radicals are very important. This little, we'll slip it up over here, is showing a liver in a person that has this kind of brownish pigment. It's very commonly seen in older people when their organs undergo atrophy. This is called lipofuscin, the so-called wear and tear pigment. Now you can't look at that and tell me that's lipofuscin without history, because that could just as easily be hemosiderin and hemochromatosis and hemosiderosis. It could easily even be bilirubin. So you would need more information to be able to say that's what it was. But what I'm basically saying is that when you have free radical damage, one of the end products of that is lipofuscin, because certain things in a cell are not digestible, and those include lipids. And so that's what lipofuscin is. It's a lipid that you just can't break down all the way. Now, what is a free radical? Okay, a free radical is a compound that has an unpaired electron in its outer orbit. That's not cool. That makes it very unstable. Okay, that means it's going to damage something because it's just not all there. You know, if we have an unpaired electron in our brains, what happens? We do crazy things, you know. And so it's going to damage things. Now, interestingly, what are we breathing right now? Oxygen. Oxygen can be a free radical. No. Yeah. You give someone 50% or higher oxygen for any period of time, they're going to get superoxide free radicals. Is that bad? Oh, yeah. Oh, yeah. Ever heard of reperfusion injury? You know, when we give our tissue plasminogen activator for somebody that has a coronary thrombus and we try to dissolve that thrombus, and we do most of the time, and oxygenated blood goes back into that damaged cardiac muscle. Have you ever heard of the reperfusion injury? Do you think that maybe involves oxygen-free radicals? Oh, yeah. It really does a job in those injured cells and knocks some of them off. Mm-hmm. And that, you know, about kids with respiratory distress syndrome, they can end up with oxygen-related free radical injury. They can go blind. Okay, the free oxygen-free radicals can destroy the retina. That's called, that used to be called retroretinal fibroplasia. Now it's called retinopathy of prematurity. It also can produce damage to your lungs. It's called bronchopulmonary dysplasia, where you get fibrosis in your lungs. And you have chronic crippling lung disease from that. Oh, so it's not good. So oxygen is a free radical. And then water in our tissues can be converted into hydroxyl free radicals. Now, that's what ionizing radiation does. That's not UVB light. That's non-ionizing radiation. When you get radiated for a cancer, you get hydrolysis of water, you form hydroxyl free radicals. And they can produce mutations in those tissues, and you all know that a complication of radiation therapy is cancer. Most common cancer in radiation, please? Leukemia. Mm-hmm. So that did it because of free radicals, hydroxyl free radicals. Iron loves to make free radicals as a reaction called the Fenton reaction. That's what makes iron overload diseases so dangerous, because wherever tissue iron is located, you're going to get hydroxyl free radicals, and they're going to damage that tissue. If you got it in your liver, you're going to get cirrhosis. If you have it in your heart, you're going to get restrictive cardiomyopathy. You get it in your pancreas, it ain't going to work anymore. And you're going to get malabsorption, and you're going to get diabetes. So we'll take this story up after our 10-minute break. Continue our free radical discussion. How many of you took Tylenol this morning? If you did, you took a poison. Everybody takes Tylenol. Baloney. Should be taken off the market. It's the #1 cause of fulminant hepatitis due to a drug. Why? Free radicals. Free radicals. Tylenol is acetaminophen, and as you learned, or maybe learned, yes, you would have learned this in pharm a little bit, you learned a little bit more in biochemistry about the cytochrome P450 system in the liver. Metabolizes drugs, but also can change drugs into free radicals. It's oftentimes not the drug, as you know from pharmacology, that actually, when it, that you take does the activity. It's oftentimes changed in the liver into the active metabolite. Like I think phenytoin fits that kind of category. Okay. And so acetaminophen, in terms of the mechanism for its injury, it's free radical. Okay, and the organ that it really targets is, of course, the liver, but it also targets the kidneys, but that's another story for kidney when we get to that. And so drugs can form free radicals. The one they like most, of course, is acetaminophen, because it's the number one cause of drug-induced fulminant hepatitis in the United States. Okay. Now, they asked the board question on where in the liver acetaminophen toxicity manifests itself. I'll show you that in a little bit when I have a picture of the liver and discuss the concept of where in the liver damage occurs, and I'll discuss that concept. The answer is right around the central vein is where the damage is. So drugs can form free radicals. Anybody know what the treatment is? They do. This would be part one material. N-acetylcysteine, big deal. That's memorization. How does it work? Well, it turns out that free radicals have things that neutralize it. Thank God. We have free radicals that they get neutralized because they hurt us. Who knows what the neutralizer is for superoxide free radicals? No, the answer is superoxide dismutase, otherwise known as SOD. Superoxide, just think superoxide free radical. Superoxide dismutase is what basically disarms and neutralizes oxygen-free radicals. Okay, now glutathione, where does that come from, please? Please? The hexose phosphate shunt, you recall, is what generates glutathione. Also is what generates NADPH, which is the main substance that we use for all anabolic biochemical reactions, things that synthesize steroids, you recall, cholesterol, etc. That you get in biochemistry with Dr. Hansen a little bit more. Okay, so I'm sure that you're not totally up on that. But glutathione is mainly made, guys, in the pentose phosphate shunt. That's the end product, and its main function is to neutralize free radicals. It loves to neutralize drug-free radicals, and it also loves to neutralize any free radical that derives from peroxide. Now, many free radicals that derive from peroxide, that stuff that you put on your little cuts and stuff, hydrogen peroxide, is fantastic stuff. It breaks down into free radicals that just kill everything in sight. Okay, and glutathione can neutralize it. Okay, and so it gets used up in neutralizing the acetaminophen free radicals. When you give it N-acetylcysteine, otherwise known as Mucomyst, you basically replenish. Glutathione is made out of N-acetylcysteine. And so you're giving the substrate to make more glutathione so that you can keep up with neutralizing the acetaminophen free radicals. So you're trying to keep the glutathione levels up. Basically, that's the mechanism of giving N-acetylcysteine. Okay? Because glutathione is being used up by neutralizing the acetaminophen free radicals. So we give it more substrate. It's kind of like methotrexate, the leucovorin rescue, so that you don't get your folate deficiency. The leucovorin basically makes a substrate that you can still make your DNA, even with a block of dihydrofolate reductase. It just supplies the substrate that you can continue to make DNA. So it gets around it that way. It's the same similar situation. You're supplying the substrate and acetylcysteine to continue making glutathione so that you can keep neutralizing your acetaminophen, keep the patient alive. Now that's what they ask on board, not what's the treatment for acetaminophen toxicity. What mechanisms? Mechanisms. Why is the name of the game on the boards, guys, not what. Why. Not what. Why. That's mechanism. That's also for part two. I taught part two also. Okay. Why? They assume you know the what. They want to know the why. Okay. So always when you're thinking about, that's why I'm always explaining why, how, pathogenesis, mechanism. That's what they're interested in. Not your ability to memorize things. They know you can do that. Can you apply the information is what they're interested in. The answer to that is yes, you can. Okay. All right. Thank you. All right. Okay. Carbon tetrachloride. I haven't heard of a carbon tetrachloride question in a long time. So I think that probably has been kind of abandoned. That's seen in the dry cleaning industry. That can also be converted into a free radical in the liver. It's formed CCl3, and you get fulminant liver failure with that. They're really interested in acetaminophen for two purposes. One, fulminant liver disease, free radical, and also, along with aspirin, God forbid anyone in this room is taking something with acetaminophen and aspirin at the same time for any prolonged period of time, you might be saying bye-bye to your kidneys right now. Say bye-bye if you're on that, because you are destroying them big time. Free radicals from acetaminophen are annihilating your renal medulla. You only get 10% of the blood supply, guys. It's relatively hypoxic in your renal medulla. And so free radicals are whipping away and knocking off your renal tubules, and of course aspirin's knocking off the vasodilator of your kidneys, which is PGE2. It's made in at the afferent arteriole, and so that means angiotensin II, a vasoconstrictor, in charge of your renal blood flow. Not a good combo of angiotensin II controlling your blood flow in your kidneys, and then having acetaminophen free radicals in your kidneys, knocking off your renal tubules in your medulla. What are you going to do? We're going to slough off your renal papilla, or totally destroy your ability to concentrate and dilute. What? Urine. Yeah, it's called analgesic nephropathy, guys. And you better believe acetaminophen is big time in it. Okay? So get yourself a little bit off on the liver, and also concentrate on the kidneys also. Can screw that up too. I think that's it for free radicals. I think we've done enough harm with that, scared enough people with it that took Tylenol this morning, possibly an aspirin with it. Okay? Remember, it's a cumulative thing, probably over years. So you're safe if you just took it today. Okay, apoptosis is a big, big hot term. I tried reading it in Robbins, and I got totally confused, which means it's poorly written. Unless that, or I read ADD really bad, and I just don't get it. But I do have attention deficit big time, and I probably, because I read it slowly, and then I got a little bit off. Slowly again, I got a little bit off. But even reading it 10 times, you know, after I was able to eventually get through it with my attention deficit problem, I still didn't quite have a real good grasp on it, okay? But I can tell you this. What's in your notes is the gist of what I was able to pick up on what apoptosis is all about. It's programmed cell death, guys. Apoptosis, we have genes, apoptosis genes, that are involved in cell death. And so one of the theories of aging is that we're programmed to die, and that's true. Of course, there's other abnormalities too, things that we screw up our bodies with, like smoking and drinking and that kind of stuff. We can do a pretty good job on all on our own without involving our apoptosis genes at all. You know, we can just kill ourselves with whatever. So it's involved in the genes involved in cell death, programmed cell death. Okay. It has lots of functions, normal functions. One of the biggest ones is in embryology, so it's got a great embryology tie-in. Remember, organs, initially like our small bowel and all that, used to be solid, so how did they get lumens? Apoptosis. Every time I ask you how, you're going to say apoptosis. Okay, that way you'll get used to saying apoptosis. Are you ready? Okay, guys, what's the king of our body? Say Y chromosome. Y chromosome. And say with pride. Say it again. Y chromosome. Okay. It's not WHY chromosome. Y chromosome. Y chromosome. Because, guys, when our Y chromosome came into existence from our dads, the germinal ridge went the testicle route. Okay. One of those chemicals that came out immediately was Mullerian inhibitory factor. Now, why is it, guys, so important that we had Mullerian inhibitory factor from our little testicles and our germinal ridges? The answer is all those Mullerian structures. Now, let me recite them for you. Uterus, there. Cervix, there. Upper one-third of vagina, there. Okay. Gone. Okay, that's why we have no Mullerian structures, because of apoptosis working through Mullerian inhibitory factor, which was the signal. Mullerian inhibitory factor is a signal. There has to be a signal for apoptosis. What is the signal? The caspases. That's a big word. That's right. And what do the caspases do? Destroy everything. Okay? And so and then wraps them up in a nice little bundle surrounded by membranes called apoptotic bodies, which are phagocytose and destroy. And what's left over that you can't digest is lipid. So apoptosis got rid of our Mullerian structures now. What is your big letter of the alphabet? X. You should say X, please. X. Some people just refuse to do this. They just refuse to do this. Okay? They refuse to play this game. I'm trying to teach you by saying X, that's all. Even though you only got one functional one. The other one's a bar body. That's cool. At least you got some little dumbbell there to work out with. Okay. So, what is so good about apoptosis in you guys? Well, the absence of a Y chromosome caused your germinal ridge to go the ovarian route. And you made a factor that knocked off what structures? Wolffian duct structures. Yeah. Mesonephric duct. Well, what would they have developed in you? Oh, epididymis, seminal vesicles, those little vas deferens. You don't want any of that crap, do you? No. Okay? So they went by apoptosis. What's my thymus look like right now in my anteromediastinum? It's kind of small versus a kid, which is kind of big. So when you do a chest race with a kid, what do you expect to see when you do a lateral X-ray? Big old, a lot of stuff going on in that anterior compartment there. What is it? Thymus. What if it was absent? Pituitary syndrome. Very good. What else would they have? Tetany. Okay. Well, what caused our thymuses to involute? Apoptosis. So it's involved in normal embryology and things outside of, when we're adults as well. It's also involved in cancer killing. Apoptosis is a major mechanism for killing cancer cells. Okay? And then atrophy, the process of atrophy. When we have atrophy and we reduce cell mass, okay, or tissue mass, most of the time those cells go out by a process called apoptosis. And a couple of examples of some of these things, and hepatitis also is a good example. You've heard of the term Councilman body. This is a liver, and hepatitis here is this little very, very eosinophilic cell without a nucleus. This is an example of apoptosis. Do you see any inflammation around there? No. And so it's individual cell death without a whole lot of inflammation around it. It just needs a signal, okay, which could be a hormone or a chemical or whatever, and then that activates the caspases, which are enzymes, and it ends up destroying that particular cell without any inflammatory infiltrate whatsoever. Okay, so Councilman body is a good example of apoptosis. So a lot of times when we have a virally infected cell and cytotoxic T cells come and destroy it, it's destroyed by apoptosis. Okay, these are neurons in the brain. They shouldn't look like this. A nice and red cytoplasm and a very pycnotic nucleus. That's not a very nice looking neuron. Okay, that's because this patient probably has atherosclerotic plaques in his carotid artery with ischemia to the brain, and it's produced apoptosis of his neurons. And so they lost brain mass and had brain atrophy, okay, related to ischemia by the process of apoptosis. So we see that it's involved in good things, embryology, things in normal involution, things like thymus, okay? It's also involved in pathology, cancer, killing cells that are virally infected or neoplastic cells, knocking them off, those kinds of things. So it has a very, very important role in pathology and very commonly asked on exams. So what's the name of those enzymes that are involved in this? That's the caspitases. Think of Casper the friendly ghost, okay? And that's close enough. You're sure if you saw it as a math something on an exam, you better caspitases, you'd see that. That's the dude, okay? Let's think of Casper the friendly ghost. Never seen him, because I don't believe in ghosts or whatever. All right, a couple pictures. Let's talk about types of necrosis now and look at some actual gross and some microscopic, mainly gross, manifestations of tissue damage, which we call necrosis. When we damage tissue and it dies, it's called tissue necrosis. And there's names that are applied to different types of necrosis. Remember I told you that when we have ischemia or a tissue hypoxia, I have no oxygen, lactic acid level builds up in a cell. It denatures everything in the cell that's a protein, including the enzymes, and we ended up with what type of necrosis? Coagulation necrosis. Well, this is what it looks like in a patient with a myocardial infarction. You can see here that the anterior wall of the left ventricle is pale, so this is and we call the gross manifestation of coagulation necrosis, that's called infarction. So when we can see it with our eyes, that's called an infarction. When we look at it under the microscope and we see tissue that looks like cardiac muscle, but it has no striations in it, it has no nuclei in it, it's very bright red, we see no real inflammatory infiltrate here. This thing is all denatured by the increase in lactic acid, which destroyed the enzymes, and so these cells, these tissues cannot be broken down. Neutrophils are going to have to come in from the outside to break these cells down. So when you see vague outlines of what used to be whatever the tissue is or what it's supposed to be, this should have been cardiac tissue. That's called coagulation necrosis. Okay, and that's responsible for the color changes that we see in this heart. Now, as you know, they divide infarctions into pale ones and hemorrhagic ones. They think it's kind of stupid. Dead is dead, but they think it's important. And so how are you going to work your way through that? How are you going to think about that? Well, it's basically the consistency of the tissue that determines whether it's going to be pale in appearance versus hemorrhagic in appearance when you infarct tissue via coagulation necrosis. If it's good consistency, and when the tissue dies, including the blood vessels, then when the blood vessels die and the red blood cells are released, they can't really diffuse out into that tissue because the tissue has good consistency, so it'll grossly look pale. And so organs that you would expect to be pale would be, of course, heart. Kidney usually is pale, it's got good consistency. Spleen, yeah, not a bad consistency, it's usually pale. Liver, which is the rarest of the organs to infarct because of a double blood supply, is pale because they have good consistency. But I think you would all agree that bowel has very, very loose textured consistency that it would likely be hemorrhagic. Certainly a testicle, if it underwent torsion, that's a big board question, a torsion of the testicle question. Then that's going to be hemorrhagic. It's very, very meshy. And of course, the lungs, unequivocally, is going to be a hemorrhagic infarction because it has a loose consistency. And so when those blood vessels rupture, the RBCs can easily trickle out into the damaged tissue and produce a hemorrhagic appearance. Okay. All right, so this is a pale infarction. This is the example of coagulation necrosis. All right, let's look at some more examples. What's this organ? Spleen, and there's an example of a pale infarction. Now, most of these are due to embolization. Now, where do most emboli in the systemic circulation arise? The left side of the heart. Okay, so could you name a couple things that could have embolized to this spleen to produce a pale infarct of it, please? A vegetation. Now, don't think rheumatic fever. That's not a good one to pick because the vegetations in acute rheumatic fever rarely embolize. They're too small. But infective endocarditis, that'd be another story. Yeah, the little piece can run through all. Sure. Now, maybe you were thinking mitral stenosis, which is the usual when you have a heart repeatedly attacked with the beta group A streptococcus. Then you get mitral stenosis. Then you can get these big old clots, thrombi in the left atrium. get a little bit of atrial fibrillation. The absolute worst arrhythmia, another board question. The arrhythmia most associated with embolization in the systemic circulation is atrial fibrillation, because it produces stasis for one in the atria, clot formation, and then it vibrates in there, and little bits and pieces of clot can come off and embolize. Okay, so usually it could be clot, it could be a vegetation that embolizes, and it could go to little places like the spleen and produce a pale infarction. Okay, what's this called, please? Dry gangrene. How do you know it's not wet? Well, because you don't see any pus oozing off of here. Okay, now if you had played odds on whose foot this belonged to, who would it be? Diabetic. And where do you think the problem's going to be? The popliteal artery. It's going to have atherosclerosis in it, possibly even be thrombosed. And remember, the most common cause of non-traumatic amputation of the lower extremity in the United States is diabetes, because it enhances atherosclerosis. Popliteal artery is a dangerous artery. Next to the coronary is probably one of the most dangerous arteries, because it's got a small lumen, and you put atherosclerotic plaque in it, you've got a big-time problem. Okay. So this is a good example also, this dry gangrene of coagulation necrosis related to ischemia. What was the definition of ischemia? Decrease in arterial blood flow. And what would the pathogenesis of that decrease in arterial blood flow be due to in this patient? Atherosclerosis of what vessel? Popliteal artery. Okay. What's the pathogenesis of this myocardial infarction? Coronary thrombosis, overlying what? An atheromatous plaque. So atherosclerosis was the thing initially producing the ischemia, and then the lumen got blocked by a thrombus. Okay? Just trying to get you to make sure that you understand mechanisms. Okay, this is a piece of small bowel. Here's the normal color of small bowel. You can obviously see that this is hemorrhagic. And if we took a section through it, we would see vague outlines of what used to be small bowel. So what's this an example of? A hemorrhagic infarction of the small bowel. You notice that it's a very small portion here. Looks like it got trapped somebody. Would anyone want to venture a guess on what it was trapped into and get that question right on the boards? How about an indirect inguinal hernia sac? Remember, the second most common cause of bowel infarction is getting a piece of small bowel trapped in an indirect inguinal hernia sac. The most common cause, you recall, is adhesions from previous surgery. And we do that when we do GI. But you can clearly see this is a small segment of small bowel, and it looked like it probably got incarcerated in an inguinal hernia sac. Okay, now this is a hemorrhagic infarction. Okay, what's this tissue, please? Lung. And what's this thing right here? It's a hemorrhagic infarction of lung. Notice it's wedge-shaped. Notice that it went to the pleural surface. So would you have an effusion? Sure. You'd have an effusion. That would be an exudate. You learned that in immunology. Okay, it'd be hemorrhagic. It'd have neutrophils in it. The whole bit. Okay. And if you inflame the pleura, what kind of chest pain do you have, please? Pleuritic chest pain. That's a knife-like pain on inspiration. Comprende? That means do you comprehend? I can speak all languages, by the way. Okay. Here's the embolus right over here in the pulmonary vessel that produces hemorrhagic infarction. Okay, right now all we're doing is mentioning types of necrosis. We do this all over again when we go through the systems. So we'll see the same slide again. Okay, now there is an exception to the rule for coagulation necrosis as being the underlying type of necrosis seen in infarctions. And that exception to the rule, and there's only one, is the brain. When you infarct the brain, and the most common infarction occurs right here. That's why you listen to this area in the neck with your stethoscopes. You're listening for a bruit. That's a noise that's going to be going through a vessel that has a narrow lumen. Okay? And if you can hear a bruit, it's usually significantly narrow. See, that's the place, guys, where a platelet thrombus develops over an atherosclerotic plaque. It blocks it. You end up with a stroke. It's also the place where little bits and pieces of atherosclerotic plaque chip off and produce transient ischemic attacks. Transient ischemic attacks in atherosclerotic disease, it's just little tiny bits of atheromatous plaque going into small little vessels in the brain, producing motor or sensory abnormalities that go away within 24 hours. That's what they are. Okay. When the brain, as you know, has very little meshwork in it. You know, you can put your finger right through it real easy. In fact, what's analogous to the fibroblast in the brain? The astrocyte, okay, because of its protoplasmic processes. So in a sense, it's acting like a fibroblast. It can't make collagen, but its protoplasmic processes give some structure to the brain. So when we infarct the brain, which hardly has any structure, it just basically liquefies. And so the type of necrosis we see when we infarct the brain is not coagulation necrosis. You're not going to see vague outlines of what used to be brain tissue. It's just going to be a cystic space like you see here. It's liquefactive necrosis. So the exception to the rule for infarctions not being coagulation necrosis, the exception to the rule is the brain, where it undergoes liquefactive necrosis because there's no structure to it, and so it just leaves a hole. It liquefies, it doesn't coagulate. Okay, small point, but I put this purposely together. This is a cerebral abscess over here, okay, and this is a old atherosclerotic stroke over here. Both of these are liquefactive necrosis, but this is an example of an infarction that produced this one right here. This is an example of an infection. So we know what coagulation necrosis is. It can be pale, it can be hemorrhagic grossly. Now we talk about another type of necrosis called liquefactive. And it actually says what it does. Liquefactive means it liquefies. And when I think of something liquefying tissue, the very first thing that comes to my mind is a neutrophil. Because its main purpose in life is to phagocytose and destroy things with its enzymes, to liquefy them. And so for all intents and purposes, a liquefactive necrosis in most cases relates to an infection when neutrophils are involved, usually acute inflammation, producing an abscess or some type of inflammatory condition, and it liquefies tissue. So when I think of liquefactive necrosis, I most commonly think of acute inflammation related to neutrophils damaging the tissue. The one exception to that rule is a liquefactive necrosis in the brain related to an infarct. Okay, that would be not an inflammatory condition, it just liquefies. But this would be an example of liquefactive necrosis due to an actual infection in the brain. So either way, whether you infarct the brain or you have an infection in the brain that produces an abscess, it's the same process, liquefactive necrosis. This is something you're a little bit more familiar with, an abscess over here. Now you can see that this is pointing, so play odds on what the Gram stain would show. Let's see what you learned in microbiology. You should see gram-positive cocci in clusters. Why are they in clusters, please? Coagulates, okay, and that's why you form abscesses with Staph aureus. Coagulates, converts fibrinogen into fibrin, and so it localizes the infection. Neutrophils can't get out because of the fibrin strands around it, and that's why you have an abscess. Okay, now what does strep do? Well, it releases hyaluronidase. And so that breaks down the glycosaminoglycans in your tissue, and so infections spread through tissue. That's called cellulitis. They expect you to know stuff like that. Okay? But from the point of view of necrosis, because this is an infection, neutrophils are involved, what type of necrosis? Liquefactive necrosis. Okay, here's the lung. Okay, and we see these little yellowish areas here in the lung all over the place. This patient had high fever and productive cough. A Gram stone showed what? Gram-positive diplococcus, which was what? Strep pneumoniae, the most common cause of bronchopneumonia. Okay? But right now we're just talking about necrosis. So since these are areas of abscess formation and bronchopneumonia due to strep pneumoniae, what type of necrosis is it, please? Liquefactive necrosis. Good. Why isn't it hemorrhagic necrosis or hemorrhagic infarction? Well, first of all, it should be hemorrhagic, and it's pale. And second of all, it's little discrete round things, whereas an infarct of the lung would be located where? Right at the periphery in a wedge-shaped configuration. Do you recall that? Always goes to the periphery, guys. That's why I get pleuritic chest pain. There's no way in God's green earth this can be a bronchopneumonia, infarction. No way. It's pale and is round. That's an abscess. Of course, they would give you history like I gave you to know it's pneumonia. And then type of necrosis, liquefactive. Don't you, when you do a Gram stain, don't you see neutrophils in a Gram stain? Phagocytosing, strep pneumoniae, yes or no? Okay. So that's showing that's acute inflammation, that's liquefactive necrosis. All right, what's this? Let's say it's a patient with fever, night sweats, and weight loss. TB. So what will we call this type of necrosis? Granulomatous type of necrosis, okay? I will discuss the pathogenesis of the granuloma. Hopefully it's already been done for you, but I suspect it wasn't. Things like interleukin-12 were not mentioned. Subset, 1, helper T cells were not mentioned. Then you didn't have a discussion of the pathogenesis of granuloma or a positive PPD, okay, which is on boards. So right now we're just getting into the concept of granulomatous type of necrosis, another term, caseous necrosis. Very confusing to students. I mean, most people know caseous means kind of cheesy, okay? If we squeeze this particular lesion here in the lung, it had a cheesy consistency that's called caseous necrosis. What does it really mean? It basically means you either have a mycobacterial infection, any mycobacterium, including atypicals, or a systemic fungal infection. Period. That's it. Those are the only things that can produce caseation in a granuloma. Well, what is it? Well, it's the lipid in the cell wall of those organisms that's giving it that cheesy appearance. It's the lipid in the cell wall. Okay. So, having said that, do you get granulomas and sarcoidosis? You should already know the answer to that. Yes, you do, but are they caseous? No, because they're not related to mycobacterium or systemic fungi. Do you get granulomas and Crohn's disease? Yes or no? Yes. Are they caseous? No. Why? Because they're not related to mycobacterium or systemic fungi. So caseation is a term literally that only is associated with mycobacterial infections and systemic fungal infections, period. No other type of granuloma has caseation with it other than those particular diseases. Okay, so caseous necrosis is another one you want to remember. These are foreign body giant cells, okay, and we'll discuss that when we do inflammation. Okay, here's a pancreas. There's the duodenum over here. This is the pancreas. Does it look normal? Say no, because we are talking about pathology. Okay, so you'd always be safe and say no, it's very abnormal, even though you have no idea how it's not normal. At least it'll help you sound good about yourself. When you say I got one right, it's not normal. Okay, what's normal? I don't know, but it's not normal. Okay. Now, women can get away with that because they have intuition. They can say, I just feel it in my body that it's not normal. Okay? And they're right. They're absolutely right 99% of the time. Like 99.9% with my wife. And she had no rational reason for believing it. That's the cool part. God, do I wish I had that gift. All right, so here's a person. Now, where's the pain going to be here, guys? Just to show you how simple this board is. God almighty, is it simple. They give it away in the stem of the question. Somebody has epigastric distress with pain what? Radiating where? Into the back, pancreatitis. Cannot be peptic ulcer disease, guys. The pancreas is retroperitoneal. When it gets inflamed, the pain is referred into the back. Peptic ulcers are not retroperitoneal. So you just have epigastric pain. Totally simple. Totally simple. They put all that stuff in the stem of the question. If you know anything about physical diagnosis, a lot of the systemic pathology questions are, you just get a boom like that. You just literally give it away. So pain radiating into a back, okay, is pancreatitis for all intents and purposes. So what type of necrosis do you think we are now dealing with? Enzymatic fat necrosis. So it's fat necrosis related to enzymes. What about a woman that has pendulous breasts, okay, and she damages them maybe from running without support, and she gets fat necrosis, okay, is that enzymatic? No, that's traumatic fat necrosis. And can it calcify? Oh, yeah. Can it look like cancer on an x-ray, on a mammogram? Oh, yeah. Does it scare the living daylights out of a woman? Oh, yeah. But what's the difference between that and calcification in a cancer? It's painful versus painless. So traumatic fat necrosis usually occurs in breast tissue or other adipose. But enzymatic fat necrosis is unique to the pancreas because it's the enzymes that are breaking down fat into fatty acids which combine with calcium salts to produce chalky areas of enzymatic fat necrosis. These little chalky white areas, guys, have calcium in it. There's calcium bound to fatty acids. It's called saponification. It's actually forming a soap-like salt. Can these be seen on X-ray? Say yes. Yes, because they have calcium in them. So if they show you an X-ray, some dude that had pain that constantly penetrated into his back, and they show you this X-ray, and you see in the area of the right upper quadrant, these little tiny stifle calcifications in the area of the pancreas. What is it? It's pancreatitis in a patient who is a alcoholic. There you go. It's the simple little things that they do on these boards. Simple little things. Not hard. Not hard. You make this test harder than it really is. It really isn't hard. Most of it's because you're so stinking nervous, because your whole life depends on doing well. If you had all the time in the world, okay, you could put your feet up and just kind of go la-li-la-li-la, you just kill this test, because it ain't all that hard. But you throw on top of it a little anxiety, I can see where you can get, just things start getting jumbled up there. I will guarantee you by the end of Friday, when we're done here, your level of confidence should be going up. Because I got a lot of the testing and notes right there. Yeah. This is what enzymatic fat necrosis looks like histologically. Wherever you see blue in a histologic section, let's say in a coronary vessel, and you know it's atherosclerotic, and you see some bluish discoloration. It's always calcium. Calcium kind of stains blue. It's actually called dystrophic calcification. That's calcification of damaged tissue. And so this is the calcium salt. This little bluish area would correspond with these white areas that we see grossly. This, of course, is hemorrhage. This patient had hemorrhagic pancreatitis. So they could put this picture up there, and they have. And they can ask you what enzyme would be elevated. That was an easy one. Except amylase wasn't listed. Lipase, very good. Okay, which one's more specific, amylase or lipase? Lipase, why? Because amylase is in your parotid glands. It's also in your small bowel. It's in your fallopian tubes. Not very specific, but lipase is only found in your pancreas. That was a board question. Or they could show this, and they could say, what type of necrosis is it? Enzymatic fat necrosis. But usually, nothing that simple. Usually they could go around and go through mechanisms. You say, what's the underlying cause of this thing? Answer, alcohol. Produces these little thick secretions in the ducts, and then they end up getting activation of the enzymes, and you end up with pancreatitis. So whenever you see bluish discoloration and, say, an atherosclerotic plaque or something like this in the pancreas, that's calcium. The last of the types of necrosis of importance is fibrinoid necrosis. Now, what's oid mean? Looks like but isn't. So if there was someone in here that was an exact replica of me, and I don't see anyone that is, then you'd be golyanoid. Okay? That means if you look like me, but you're not me. Okay, so fibrinoid means it looks like fibrin, but it ain't fibrin. Okay, now this is just showing you just a panorama of different diseases we will talk about later. Right now we're concentrating on fibrinoid necrosis and what it means. It's the necrosis of immunologic disease. So let me show you some immunologic diseases. Well, palpable purpura. When you see that word palpable purpura in the stem of a question, that's a small vessel vasculitis. Okay? It's immune complex type 3. Automatically. Just all I have to do is say palpable purpura, type 3 hypersensitivity, small vessel disease. Boom. Done. Okay? And fibrinoid necrosis kind of has its immune complex deposition. In this case, a small vessel. And they also ask, what's the pathogenesis of how immune complexes work? Did you know? Did your immunologist tell you? How do you get damage in type 3 hypersensitivity? An immune complex? You know what an immune complex is. Yeah, it's an antigen and an antibody circulating in the circulation. Good. And then where does it deposit? Little places that the circulation can take it to. Okay, so it could be in a glomerulus, it could be in a small vessel, okay, whatever. How does it work? It activates the complement system, the alternative system to be exact, and it produces C5a. And what did you learn about inflammation? What is C5a? One of its functions. It's chemotaxic to who? Neutrophils. So who do you think does the damage of type 3 hypersensitivity? Neutrophils do. And why are they there? Because the immune complex activated the alternative complement system. The immune complex really has very little to do with it, other than activating the complement system. It's neutrophils that do the eventual damage. And that was actually asked on board. This is Henoch Schönlein's purpura. If you felt this person's legs would be palpable purpura, and this is what their blood vessels would look like. So that's type 3 hypersensitivity. Now someone mentioned rheumatic fever. And there's the vegetations of rheumatic fever along the mitral valve. They're sterile. But if we took sections through them, we would see fibrin-like material in them without any bugs, fibrinoid necrosis. So it's necrosis of immunologic disease. Okay? Little nodules on the extensive surface. Let's say the person has morning stiffness. Hazard a guess? Rheumatoid arthritis. If we took a section to that, what type of necrosis would we see? Fibrinoid necrosis, because it's immunologic damage. So fibrinoid necrosis is the necrosis of immunologic damage. Could be in a vessel, like a vasculitis. Could be in the kidney, like a glomerulonephritis. Don't you think we're going to see fibrinoid necrosis and lupus glomerulonephritis? Good gracious, sure you are. If it involves immune complexes, sure. Absolutely. Okay. Now, what do you see? See something bad. Bad. What organ? Good. Now let me show you some anatomy here, and then we'll get to fatty change, which is what we're really going to be talking about. This is the triad area. Triad means what? 3. So there's 3 structures. Okay? Portal vein. What's the other vessel? Hepatic artery. What's the next one? Bile duct. Those are your triad. Now remember, the liver is unique and it has a dual blood supply. Okay? And so the hepatic vein and hepatic artery and portal vein will dump their blood where? Into sinusoid. So the liver is an example of a sinusoid organ. What are some other sinusoid organs? Bone marrow, spleen, or also have sinusoids in them too. That's histology. Okay? What's characteristic of sinusoids? Gaps. Gaps between the endothelial cells where there's just absolutely nothing there, so that things can fit through them. Like what? Red blood cells, inflammatory cells, as opposed to glomerular basement membrane, which is fenestrated. That means it has little tiny pores right through the cell. Okay, that's little windows that go through the actual cell. Whereas in sinusoids, they have gaps between the cells of the endothelium, so actual large cells can get through them. That's not true of the glomerular basement membrane. I mean, it's totally intact, except it's got these little pores, little windows that can go through it for filtration. It's totally different histologically than sinusoids. These are simple little things that are commonly asked on boards that test your knowledge of histology, which is the least important thing on the boards. All right, here's your sinusoid. So portal vein blood and hepatic artery blood are dribbling through these sinusoids, and eventually they will be taken up by this little vessel here, which is called the central vein. The central vein becomes finish the sentence, hepatic vein, which empties into, finish the sentence, inferior vena cava, which goes back to right side of the heart. So there's a communication, therefore, isn't there, between the right side of the heart and the liver. Yes? So if you have right heart failure and blood builds up behind the failed heart, what's going to happen to this little structure right over here? It's going to be congested with blood, and we're going to get what the so-called nutmeg liver, or congestive hepatomegaly. It's all related to each other. If any of you have seen the high yields, you already know they've had MRIs where you had to identify where the hepatic vein is. So that was easy because all you had to do was look for that vessel, whatever looked like a vessel going into the inferior vena cava. That was the hepatic vein. And then they asked questions about, what if you block the portal vein? What happens to the liver? Nothing. Because it's before the liver. Well, if you block the hepatic vein, but Chiari syndrome, what happens to the liver? It gets really congested. So obviously, when they ask questions like that, what are they after? Do you know the blood flow to the liver? See? Now, here's a concept. Which part of the liver is most susceptible to injury? Normally, this part around the central vein. Why? because this part gets first dibbies on the oxygen coming out of through the sinusoids. That's called zone 1. And then zone 2 is to be right about in here. That's where yellow fever likes to hit. Mid-zone necrosis, yellow fever, Aedes aegypti. Okay, that'd be here. They get the next dibbies on it. And by the time it gets to zone 3, which is around the central vein, don't get nothing. It's kind of like the renal medulla. Getting only 10% of the blood supply, cortex gets 90. Well, this is analogous to the renal medulla. Notice where the fatty change is, all around zone 3. So I'm going to ask you a question. When they ask the question about acetaminophen toxicity, and they ask you what part of the liver is most affected, we will say the part around the central vein. Why? Because it gets the least amount of oxygen, so it really would not have a chance to combat free radical injury. You with me? Concepts. Concepts. What's the most common cause of fatty change? Alcohol. Okay, there's your metabolism of alcohol. Look at it, please. Okay. Now you're going to go through this again. We'll go through it again and you get this also in biochemistry. Okay? The big thing I want you to see is NADHs all over the place and acetyl-CoA. Acetate. Acetate's a fatty acid, guys. Acetyl-CoA can be converted into fatty acids. In the cytosol, remember? Okay. Now, NADHs are part of the metabolism, guys, of alcohol. So what does that mean in terms of biochemical reactions? A lot, guys. What caused pyruvate to form lactate in anaerobic glycolysis, please? The NADH drove it that direction. So what type of metabolic acidosis is always seen in alcoholics, please? Lactic acidosis. Why? Mechanism. The increase in NADH drives it in that direction. And so you know if pyruvate is forced to become lactate, then you also know that in the fasting state, an alcoholic is going to have trouble making glucose by gluconeogenesis because you need pyruvate to start it off. But if it's forced to become lactate, you got a problem. So you automatically can figure out. And alcoholics have fasting hypoglycemia. Not only that, what else can we make with acetyl-CoA? Ketone bodies. Acetoacetyl-CoA, HMG-CoA, huh? Acetoacetic acid, beta-hydroxybutyric acid, huh? And which of those two keto acids do you think you're going to see in an alcoholic? Acetoacetic or beta-hydroxybutyric? Beta-hydroxybutyric because it's an NADH-driven reaction. So what two types of metabolic acidosis do you see in an alcoholic, please? You see lactic acidosis because you're driving pyruvate into lactate, and you're getting increase in synthesis of ketone bodies because of the excess acetyl-CoA. And what's the main keto acid, please? Beta-hydroxybutyric acid. Very good. It's got 2 or 3 more questions on board. Now let's get to why it produces fatty change. Ooh, okay. This is glycolysis, guys, around reaction 4. You get these little simple intermediates here. We've got our little friend dihydroxyacetone phosphate. Look at our little NADH reaction. Whoa. And it's forcing it to become glycerol 3-phosphate, which will be a big-time board question. You've heard of the glycerol shuttle? Glycerol 3-phosphate shuttle for NADH, you get ATP? Well, that's what it's famous for. We know another thing it's famous for. It's the carbohydrate backbone for making triglyceride. What you got to do is add 3 fatty acids to glycerol 3-phosphate. Voila, we got triglyceride. And since we're talking about the liver, what do you think that this lipid fraction is in the liver? VLDL, very low density lipoprotein. That's where our endogenous triglyceride is synthesized in the liver. From what? Glycerol 3-phosphate. Derived from what? Glycolysis. Now this would sound like heresy. Would restricting fat decrease the synthesis of VLDL? Of course not. Would restricting carbohydrates reduce the synthesis of VLDL? Absolutely. Because it's a glucose intermediate that it's made from. Glycerol 3-phosphate is a product of glycolysis. And so you can see why now fatty liver is most commonly due to alcoholism. Okay, because of this reaction here, which is on board. Okay. 10 minutes. unfortunate that you didn't have biochemistry before me, but that's the way it goes sometimes. A lot of my integrations involve all subjects. You know, farm, you've already seen some farm, you've seen some histo, you've seen a lot of biochemistry, and you've seen some physiology already. So actually, you understand a little bit better if you've had those things before, and they can't always stick me at the end of every single board review. There's other ones around the country that I have to do. And so it's unfortunate. Those that have had biochemistry before, you're able to follow me a little bit better on these things. But these things will begin making more sense when you have your biochemistry. In terms of keto acid synthesis and fatty acid synthesis, you're probably a little bit weak on this. I'm actually writing a book on biochemistry with another guy. And so I'm kind of up on this right now because I just finished doing this stuff in the book. Okay, so I have an advantage in that I'm pretty up on this stuff at this particular time. In fact, I finished the last chapter yesterday on the plane, which was held up. I'm showing another, what is this? This is the liver, fatty change. So which of these two kids has the fatty change? The one on the right, because the one on the right has kwashiorkor. Big deal. What's the mechanism? Okay, I'm going to give you a hint. When you make VLDL and you want to get it out of the liver, don't you have to put a protein around the outside of it, yes or no? What do we call those proteins? Apoproteins. That's your hint. What's the problem in kwashiorkor? A decrease in protein intake. They have an adequate number of calories, but it's all carbs. And so they can't get the VLDL that they make in the liver out of it because they have no apolipoprotein to cover it and put it out into the bloodstream and solubilize it in water. See, lipids and water don't mix. You all know that. And so you have to put protein around a lipid for it to dissolve in water. Okay, so that's why the big protuberant abdomen that kids with kwashiorkor have are due to two reasons. One, they have decreased protein, which decreases oncotic pressure, and you get ascites. That's one reason. But the biggest reason is they have huge livers related to fatty change. And the mechanism of this is different than an alcohol. In alcohol, it's related to increasing synthesis of the LDL for the mechanisms we just talked about. In this case, it's due to lack of protein that to put around the VLDL to get it out of the liver. And so that's the reason for the fatty change here. So mechanisms. Okay, there's a whole section in there that I'm not talking about, that and it deals basically with hemosiderin. The section, this has nothing to do with hemosiderin, so don't look at this and think about where's the hemosiderin. There ain't any. It's calcium up there. The discussion that I'm not going to do right at this point is dealing with hemosiderin and ferritin. All I'll basically say at this point is that ferritin is a soluble form of circulating iron. That's a wonderful marker for your iron, the amount of iron you have in your bone marrow. It would be the test of choice for diagnosing any iron-related problem like iron deficiency, anemia, chronic disease, or iron overload diseases like hemochromatosis, hemosiderosis. Get a serum ferritin. It'd be elevated. In the iron overloads, it'd be decrease in iron deficiency. That's a soluble form of iron storage. Hemosiderin is an insoluble form, and it's usually stored in macrophages in the bone marrow. That's all I'm going to say at this point. You can stain it with a stain called Prussian blue, and it'll show up. Now, so let's do this. Types of calcification. We got two types, dystrophic and metastatic calcification. Now, dystrophic, what's dys mean? Abnormal. Dysmenorrhea, painful, abnormal menses. Dyspnea, difficulty breathing. Dysphagia, difficulty swallowing. Then you have to decide whether it's solids, liquids, both, whatever. Okay, so dystrophic means abnormal calcification. It means that you've had damaged tissue and it gets calcified. And if you have any damaged tissue, calcium can calcify it. You play football and you got a big giant hematoma in your thigh, let's say. You had a good chance of that getting calcified. Dystrophically, the calcium will bind into that and produce calcium deposits. Now, you saw an example of dystrophic calcification already. Could you please tell me what it was? was enzymatic fat necrosis. Remember I showed you those little chalky areas? That's a good example of dystrophic calcification. Okay. The serum calcium is totally normal, just that you damage tissue, and calcium loves to calcify damaged tissue. Happens in an atheromatous plaque too. A lot of the really serious damage in atherosclerosis is the dystrophic calcification part of it, and that's what makes them. They're so hard to dissolve. The only way you can get rid of dystrophically calcified blood vessels is to be on an incredible diet called the Ornish diet. And you can actually reverse calcified atheromatous plaques with that diet. But boy, you've got to be some kind of unbelievable. I mean, that's purest of the pure vegetarian diets that exists. But you can't reverse it. The calcium does a bad job on your vessels. Okay, so this is an example of dystrophic calcification. It's also the most common cause of aortic stenosis, because this is an aortic valve. It's also the most common cause of a certain type of hemolytic anemia, which we'll discuss when we get to it. Is anything abnormal with these valves? How many valves should you have in aortic, guys? 3. How many do you see? 2. So 2 are doing a job of 3, huh? And so because 2 are doing the job of 3, they get damaged, and they get dystrophically calcified. That's what this is right here. And it narrows the orifice of the aortic valve, producing aortic stenosis. Okay. Right now we're interested in just recognizing processes now. We do aortic stenosis again when we get to the systems. A lot of you running up here, you know, I mention a lot of these things in advance, but then we go through systems and we hit these things again. Right now you're getting the vocabulary that you're going to need to go through systemic pathology. Okay. A lot of times we'll give you some advanced information, which we go over again. Now, sometimes if you have hypercalcemia or hyperphosphatemia, either one, calcium could be actually made to deposit in normal tissue that hasn't been damaged. Could you please tell me, if someone had hypercalcemia in this room right now, what would you have? What would be the cause of it? Primary hyperparathyroidism would be the most common cause of hypercalcemia in us here. But what if we were in a hospital right now, we got a consult to work up hypercalcemia? What would it be? Malignancy-induced hypercalcemia, that's correct. Because you have hypercalcemia, you can actually put calcium in normal tissue. That's called metastatic calcification. Dystrophic, it's damaged tissue with a normal serum calcium. Whereas in metastatic calcification, it's a high calcium or high phosphorus. Now, some of you may not know, but when you deposit calcium in bone, it's the phosphorus part of the solubility product that drives calcium into bone. So if you have high phosphate levels, very dangerous, because it'll take calcium and drive it into normal tissue. That's why when they have renal failure and they have high phosphate levels in renal failure, they have to dialyze off the phosphate, because that phosphate is going to be driving calcium into normal tissue, like your heart, your conduction system there, into renal tubules and the basement membrane. That's called nephrocalcinosis, and damage things. So dystrophic and metastatic calcification, 2 terms that you need to know. Most of the time we're going to be dealing with dystrophic calcification. I just picked this one to show you. So this is a congenital bicuspid aortic valve, is the most common cause of aortic stenosis in the United States. You should have 3 valves, only have 2, they get damaged because they're doing all the work. Okay, anything abnormal with this smear? Say yes. Okay, now this is dealing with a defect in the cell membrane, name it spectrin, which is spherocytosis. Okay, if you can't see a central area of pallor, guys, it's a spherocyte. If you can't see a central area of pallor, like a donut, it's a spherocyte. And you'll see why when we do hematology. That's tomorrow. We'll start it. But I want to just mention it now when we talk about cell membrane defects, which is part of this particular chapter on cell injury. There's one of the classic cell membrane defects is the absence of spectrin in the red blood cell membrane, causing the red blood cell not to be able to form a biconcave disc. You need spectrin in order to keep a biconcave disc. If it's defective, then it forms a sphere, that cell. That's the defect that you want to remember. Spectrin, spherocytosis. In fact, they both begin with SP. Okay, spectrin, spherocytosis. Okay, Arnold Schwarzenegger will probably be in this movie, although I hear he's trying to get out of that role model, for destroying everything. And it's going to be called the ubiquinator. And this is a concept here of ubiquitin. Ubiquitin is a stress protein, probably in us right now. Maybe you more than me. I'm not as stressed probably as you. Your ubiquitin levels are pretty high. It's a stress protein. And at some of your intermediate filaments, which you should know what they are, intermediate filaments are things like keratin, desmin, vimentin. These are part of the superstructure of our cells that keep our cells, from collapsing on themselves and being one big protoplasmic mass. Okay, they're called intermediate filaments. Okay, they're like the frame of a house, upon which the building is made. We have intermediate filaments are the frame upon which things are built for a cell. When they get damaged, then the ubiquitin ubiquinates it. Okay? In other words, marks it for destruction. That's where Arnold Schwarzenegger comes in, because he goes around and looks for all those intermediate filaments, and he sees those that have been tagged, ubiquinated, and destroys them. And some of these ubiquinated products have names, actually. This one is a liver. Now, fatty change and alcoholism is as simple as if you can recognize a open space and you know it's liver tissue, what do you think it is? It's a fatty liver. Okay. I mean, this is not for a pathologist, this exam. This is for second-year medical students. Okay? So if you got a liver and you see a spaces in it, that's fatty change. And if you play odds on it, always play the odds alcohol. Okay? So you see a space here. So what does that mean? Fat, which means alcohol. Therefore, these pink things that you see here probably are the pathology. They probably have an arrow to them. These are called Mallory bodies. And that's an example of ubiquinated. The filament that's damaged is keratin. And so it forms what are called Mallory bodies, which we use histology to say, hey, this patient has alcoholic hepatitis. We see these Mallory bodies here in fatty change. So that actually has a name that helps us. Okay, so Mallory bodies are an example of an ubiquinated neurofilament. Now this one's been asked on the boards a lot. This is a silver stain. These are neurofibrillary tangles. Okay, and it was a tricky question. I had to look it up because I did not know the answer when I heard about it on a student's exam. I thought they were going to put it in the context of Alzheimer's disease, where it's loaded with neurofibrillary. Wasn't one of the choices. Okay, I came down to two diseases. I think one was Huntington's chorea, and the other one was Jakob-Creutzfeldt disease. The only two that I could narrow it down to. The other ones clearly weren't associated with neurofilaments. Turned out that Huntington's didn't, but in Jakob-Creutzfeldt you can form neurofibrillary tangles. So you will see that listed in one of your high yields there. That was very tricky, very unfair, but that's the way the game is sometimes. Okay, so you're not always going to get the 99th percentile on this test. They're always going to throw in something to ruin your perfect score. Okay, and so that's how they tried to do that. But it's interesting. A lot of those things that they ruin people's perfect scores with are on your high yield. Whoa! So that decreases that decreases the chance of getting you, doesn't it? Yeah, I think so. Remember the tau protein? The tau, T-A-U protein is associated with neurofibrillary tangles. Well, that's an example of an ubiquinated neurofilament. Okay? This one here is well, you tell me, you have neuroanatomy. Is that pigment? Yeah. So what do you think this is? Substantia nigra. What do you think disease we're talking about? Parkinson's. There you go. And here's a little inclusion. Some of you thought that was a nucleus. They're not red color. They're blue color. That is an inclusion called a Lewy body, seen in Parkinson's disease. What's the neurotransmitter deficient in? That's on every board. Dopamine. There you go. Dopamine. Okay. So the Lewy body is an example of an ubiquinated thing. So a couple interesting things here. Of course, this is also a neurofilament that's been damaged. So we have neurofibrillary tangles, Lewy bodies, and Mallory bodies, all an example of ubiquination. Now, this is big, 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 big. I can't say it. Big times to the power. Important. Okay? You've got one sheet of paper that has it all. But before we do, cell cycle, which you already should have had, this should not be new stuff. You did have cell biology, did you not? I don't know. How do you spell that? Well, it's cell biology. You've had it, I hope, cell cycle. Okay, all right. But before we do this, let's make sure you know the three types of cells, which is histology. One, you have a cell that is, what I'm blocking on it, stable. What'd you say? Labile. I knew that. Okay. Labile cells or label cells. What does that mean? It means it's a cell that the division is via a stem cell. Okay. I said stem cell. Now you stop talking to me. Name three tissues that have stem cells. Bone marrow, skin, basement membrane of skin. Remember, germinal cell or basement membrane layer. Great. The crypts, the base of the crypts in the intestine, all have stem cells in them. And they have a tendency of being in the cell cycle a lot. So you had pharmacology, and you knew about a lot of drugs that are cell cycle specific and some that are cell cycle non-specific. Recall? So what do you think would be those cells most affected by those drugs? The label cells that are in the cell cycle the most, right? And so isn't it true that most of the time when you had Trevor? Okay. God, Trevor? I don't know, never heard of him. Okay. That was that guy that says he's from England. Okay, but he's from England, Arkansas. We all know that. And we know that fake accent of his. It's fake. He's a fake. I'm just trying to expose him. He's basically trained over there with Krebs. He got that little English dialect, which made him sound a lot smarter than where he's really from, England, Arkansas. Okay? And then he tries to pass it off like he's British. Right. Okay. We're good friends, by the way, so don't worry about it. He knows about this. I always do this. Okay. Doesn't it make sense that when you talk about bone marrow suppression with these different drugs that block the cell cycle, doesn't that make sense? You get bone marrow suppression since there are stem cells there. Okay. Diarrhea, mucositis, and all that kind of stuff. Doesn't that make sense? Aren't there stem cells there? And all these kinds of rashes that occur on the skin. And then also, what was the other one? We have the GI tract, diarrhea. Don't forget diarrhea all the time? Aren't there stem cells there? So there's nothing magic about those complications, are there? Because they have stem cells. And those cells that are in the cycle the most are the ones that be most affected by cell cycle specific or non-specific drugs. Does that make sense? So we have label cells, and we have stable cells. Stable cells are in the GO phase. They're in the resting phase. Most of our parenchymal organs, liver, spleen, kidney, in terms of muscle, only smooth muscle. The other muscles are not stable cells. Stable cells will do the division, but most of the time they're resting in a GO phase, and something has to stimulate them to get into the cell cycle and divide. Okay, it could be a growth hormone, it could be some kind of hormone that does it, like estrogen, for example. If a woman in the proliferative phase of her menstrual cycle, then her endometrial cells would have been initially in a GO phase, and then when estrogen came up, it stimulated the GO cells to go into the cell cycle. Okay, so that would be the stimulator for it. Most of the time it's some kind of growth factor or hormone. So they can divide, but most of the time they have to be invited to do that by some hormone or growth factor. Those are stable cells. Permanent means they can no longer get into the cell cycle. They have been permanently differentiated, and they no longer can get into the cell cycle. The other types of muscle, striatum, cardiac, fit that. Also neurons are permanent cells. You lose a neuron, it's gone. With the stem cell stuff now, it's possible to be able to get neurons in there now, potentially, because a stem cell research, and it can basically become whatever it wants. And so we don't know where that's going. But permanent cells can't get into the cell cycle. So what's the only muscle that is not a permanent tissue? Smooth muscle. Now, see, the reason why you know this, have to know this, is the term hypertrophy and hyperplasia. Hyperplasia means an increase in number, hypertrophy in size. Would a permanent cell be able to undergo hyperplasia? No, because that means more copies of it. But could it potentially undergo hypertrophy? Yes. But it can undergo hyperplasia. Can a smooth muscle cell undergo both hyperplasia and hypertrophy? Yeah, now you're catching on. Now you're catching on. There you go. These are little things that the board people think about. They just sit around, they have one hand, the right hand, usually in a vice, and someone that kind of goes in and they got in pain, and they come up with these weirdo ideas when they're in pain to get students. Okay, that's how they make up questions best when they're being tortured. Okay. Now you learn that the most variable phase of a cell cycle is the G1 phase. Okay, women, what's your most variable phase of the menstrual cycle? Is it your proliferative phase, or is it your secretory phase? What's your proliferative phase that can vary the most? Just stressed? Well, I'd be willing to bet that cycles are thrown off all over the place. And with stress, that's because your proliferative phase can be shorter or longer. But once you've ovulated, it's straight on from that. That doesn't change at all. So in other words, the proliferative phase would be kind of analogous to the G1 phase of the cell cycle, which can be shorter or lengthened in a cell. None of these other phases, S, G2, or M, they're written in concrete for that cell. So if I asked you, and like the boards would, if cancer cells, most of them have a longer cell cycle. In other words, it takes them longer to get through a cell cycle. What would be responsible for that? A longer G1 phase. There you go. Or if you had a cancer cell that had a shorter cell cycle than normal, then what would be the answer to that? A shorter G1 phase. So you see, I can put that into a clinical concept. G1 phase is kind of the mastermind of everything. Now, hopefully you learned about cyclin-dependent kinase. Okay, even though that's biochemistry, the term kinase, what does kinase always mean? Always. Phosphorylation. Okay, good. And phosphorylation usually involves sending a message to something. Activating something. Usually when you phosphorylate something, you activate something. Usually when you dephosphorylate something, you inactivate. Glucagon, I just learned this the other day, glucagon is a phosphorylator. Insulin is a dephosphorylator. That's why they're arch enemies. Okay? So glucagon is more likely to activate protein kinase, whereas insulin would dephosphorylate it and inactivate it. So remember, glucagon, phosphorylator, insulin, dephosphorylator. That's interesting. Well, that really helped you, actually. I just learned that 2 days ago. Okay, so we have this thing, inactive cyclin D-dependent kinase. Well, who activates it? Well, cyclin D does. And who makes it? G1 phase makes cyclin D. Okay, so once cyclin D is made in the G1 phase, then it activates this enzyme, the cyclin-dependent kinase. Now it's active. Okay, you with me so far? All right. Now, the key area in a cell cycle to control is from going from G1 to S phase. That's the absolute most critical area. Because if you had a mutation, and then you went into the S phase and you duplicated it, then you have the potential for cancer. And so the real checkpoint, like we have in the security out here, I saw at Newark, my God in heaven. I mean, it looked like I couldn't believe it. Boom. And so this is the key area right here. Okay, getting into the S phase, because if something that's a mutation gets into it, we run the risk of cancer. There are two suppressor genes that control this. The RB suppressor gene, chromosome 13, makes a protein called RB protein. What does it do? Prevents the cell from going from the G1 to the S phase. That itself was a board question right there. So, how do we get G1 phase to go into the S phase? Watch. That's that active cyclin D-dependent kinase phosphorylates the RB protein, and when it phosphorylates it, it can go from the G1 phase into the S phase. But it's a problem. Don't you see a problem? Is that good that it can go into the S phase? Well, yeah, for something that's divided, but what if there was a mutation? Would that be good? So who checks that enzyme? P53 suppressor gene. That's on chromosome 17. It makes a protein product that actually inhibits the cyclin D-dependent kinase. Now, can you see what that would do? What would that do? If I inhibited this kinase, what would happen to the cell? Would it be able to go into the S phase? Yes or no? Okay, so RB suppressor gene. Suppressor means suppressor, right? What are we suppressing? Its ability to go from the G1 into the S phase. You with me? So RB suppressor gene, we see, to prevented it, didn't we? So did the p53 suppressor gene, prevented it, because by blocking this enzyme, okay, we can't phosphorylate the RB protein that's going to remain in the G1 phase. The p53 suppressor gene is the number one most important gene for cancer, human cancer. Number one. Numero uno. Big time. In fact, the human papillomavirus, this is a neoplasia, so don't start looking for it. Human papillomavirus inactivates the RB suppressor gene and the p53 suppressor gene. That's a nasty little virus, the human papillomavirus. Makes two gene products. Hopefully you even learned these in microbiology, E6 and E7. E6 knocks off the p53 and E7 knocks off the RB suppressor gene. That's incredible. All right, can you understand now, if I knock off, by, say, a point mutation, an RB suppressor gene, what's going to happen? Think. What did it normally do? It made an RB protein to prevent the cell from going into the S phase. So what's the answer? What's going to happen if you knock off the RB suppressor gene? No RB protein. What's to prevent it from going into the S phase? Nothing. Therefore, you run the risk of cancer. Could you name a couple? How about retinoblastoma, for which it stands? Well, what if you were a kid and you had some pain in and around your knee? What cancer would that be? Osteogenic sarcoma, Codman's triangle, sunburst appearance on X-ray, remember? If you were a woman, okay, and you had a breast cancer, RB suppressor gene can be involved in that too. So it's not just retinoblastoma that it's associated with. Depending on your age bracket, it hits you at different areas. So you can see then, by knocking off the RB suppressor gene, you can get cancer. How about knocking off the p53 suppressor gene? Okay, what would that mean? Well, that mean that kinase would always be active, and it'd always be phosphorylating the RB protein, and that means you'd always be going into the S phase. Would that be good? No. So if you knock off either one of those genes, then what happens at the G1 phase? Goes into the S phase. The p53 is actually called the guardian of the cell. I really like that term because you know what really why it inhibits it from going into the G1 phase? Let me tell you why it does it. It gives the cell time to detect if there are any abnormalities in DNA. No splicing defect, some codon thing, whatever. Okay? And so we have DNA repair enzymes, as you'll learn, that can splice out those abnormalities and correct it, and then the cell's all ready to go then into the S phase. If the cell has been damaged too much in its DNA, then it's actually removed by apoptosis. And so that's why it's such an important gene, because it gives the cell an opportunity to clean itself up DNA-wise before it gets before it goes into the S phase. Pretty clever. Okay, so these are the two very important genes that control the cell cycle. You are guaranteed a number of questions, maybe 2, 3, 4 questions related to this. Now, the S phase means synthesis phase. That's where everything's doubled. That includes DNA, chromosomes. So you're 4N at this point. You were 2N and G1. Now you're 4N. You got double the chromosomes. Everything's doubled. If you were a muscle, you had double the number of contractile elements. Everything's doubled. G2 phase is where you make a tubulin. Tubulin's the protein from which you make the microtubule to the mitotic spindle. That's blocked by etoposide and by bleomycin. And then you have enfomitosis. Okay? And mitosis is where the cell divides into 2N cells. And the cell can either go into a geo-resting phase, or the cell can continue going on in the cycle and divide again, or it could be permanently differentiated, depending on how it wants to go. Okay, very important. The students have problems, including me, with, you have to know the normal, otherwise you'll never understand this thing. If you knock off the RB suppressor gene, no RB protein, then there's nothing to prevent it from going into the S phase. Not good. That one's easy. The one that's harder is the p53. The p53 suppressor gene normally makes a protein that inhibits this kinase, and that way you prevent the RB protein from being phosphorylated, then it stays in the G1 phase and gives the cell an opportunity to correct the DNA defects. So if you knock it off, then who's inactivating the kinase? Nobody. And so you end up constantly phosphorylating, and you constantly divide, and you can end up with the potential for cancer. Okay? Very important. Very important. Now, where does Inca alkaloids work? Mitotic spindle, paclitaxel. Come on, guys, you had pharmacology. Come on, talk to me. Paclitaxel, end phase. Just watch where this thing is. I'll give you the answer, okay? Okay? Colchicine, etoposide, G2. Bleomycin, methotrexate. All right, S phase, good. Okay. Griseofulvin, end phase. Okay. Must know. Guys, they've done it already. They put the cell cycle up. This is A, B, C, and D, and E. Okay? Then they mention a drug, and you have to figure it out. A patient with rheumatoid arthritis is a macrocytic anemia. The drug responsible for this is located, does what, in what phase of the cell cycle? You answer it. The answer would be M. That'd be methotrexate. Blocking dihydrofolate reductase. Whoa! That's how they do it? Yes. Why did they just say methotrexate? Where does it go? It's too easy. You can memorize it. So they'll give you a clinical scenario. Would you like another one? Kinda. All right. You've got a HIV positive person that has dyspnea and tachypnea and whiteout of the lung. He's put on a drug, and he ends up with cyanosis. And say, where would the drug have worked? Nowhere, because it's none of those drugs. Forget about it. That's all right. I didn't do that purposely. It's Dapsone, and I don't know where I'm thinking about Dapsone in this thing. But let me see another one. Okay, this drug used to be used in the treatment of acute gouty arthritis, but because of side effects, it's no longer used. Where would that one work? Emphase, and what's the name of that drug? Colchicine. Very good. Okay. This drug is a chemotherapy agent made from a yew tree. Not yew, Y-O-U, Y-E-W. And it's paclitaxel, and that would be Emphase. Okay. Vinca alkaloids are made from what? Some kind of, what is the Vincas? Periwinkle plants. Okay. This is all stuff they ask on boards, guys. Okay, so you got to know these things. Cell cycle is very important for form, for cell biology, for neoplasia. Must know. All right, last part of cell injury are the different growth alterations. Big time important. Big time important. The first one I like to deal with is atrophy. First, know that the diagnosis is a decrease in tissue mass, and the cell actually decreases its size, and kind of it just has enough organelles in it to survive. So it has less mitochondria than normal, and it's just trying to eke it out until whatever it is that it needs to stimulate, it can come back. Okay? So when we think of atrophy, we have to think of a lot of different things. Okay? This is hydronephrosis, and you know what's actually causing this thinning of the cortex and medulla? Well, it's compression atrophy. Okay, what's the most common cause of hydronephrosis? You can see that the pelvis is dilated, a stone in the ureter. Okay, but they could ask you something this simple. They can put this up and they'll say, what's the growth alteration in this slide? The answer is it's atrophy. Because of the increased pressure on the cortex and medulla, that's going to produce ischemia. The blood flow is going to decrease, and that's going to produce atrophy of the renal tubules. So it's an example of atrophy. Okay? All right, here's a brain. This is not a brain that you would want, okay, because it's got hills and dales in here. You'd like it to be all hills and no dales, okay? And this is an atrophied brain, okay? And this could be atrophied because of atherosclerosis, which would be the most common, but also could be atrophied because you have knocked off the neurons in it in layers 3, 5, and 6. Anybody give me an example of that? Alzheimer's disease, where you have degeneration of neurons. Okay, neurons are cells, guys. If they get destroyed, remember the cerebral cortex has its neurons in layers 3, 5, and 6. They get destroyed. Wouldn't that reduce the overall mass of the brain? Sure. So atherosclerosis could be a cause. Alzheimer's disease could be a cause. Okay, related to the beta amyloid protein, which is toxic to neurons, and many other things causing that. This is muscle. Okay, and you can see this atrophy of the muscle here, lots of things. Lou Gehrig's disease, amyotrophic lateral sclerosis. If you knock off the nerve to the muscle, you need nerve to constantly stimulate it so that it remains big, the muscle, until it undergoes atrophy, or a leg in a cast. The one I like most, guys, though, is endocrine-related things. Okay, for if I have hypopituitarism, what would my adrenal gland look like? What part of my adrenal gland would be atrophied? Exactly. Cortex isn't good enough. Which layer of the cortex? Fasciculata and reticularis, that's right. Not the zona glomerulosa. Why is that? Because ACTH has nothing to do with stimulating aldosterone release. Fasciculata, remember, is where you make what? Cortisol, glucocorticoids, fascicular reticularis is where you make sex hormones. That's your 17 keto steroids, testosterone, right? ACTH is responsible for stimulating those things, but not the zona. So you had atrophy of the fascicular and reticularis. Guys, they already had a picture of the adrenal gland. And they had all the layers, A, B, C, and then they had medulla with D on it. And they asked all kinds of different questions. And you had to know which one of those were affected. Okay. So that's your histology, physiology, pathology, integration, which they just love. If I'm taking thyroid hormone, what's happened to my thyroid gland? It's atrophied. Why? Because I'm taking thyroid hormone, what is it doing to my thyroid-stimulating hormone? Decreasing it. I have nothing stimulating my gland. Therefore, it undergoes atrophy. There you go. Okay? All right. This was one on the boards right here. This, as they said, was a biopsy of the pancreas from a child with cystic fibrosis. And they said, what's the growth alteration present? Well, the answer is atrophy. Okay, I want you to look at these. These are tubules, and they're filled with this reddish stuff that's like concrete. Remember, in cystic fibrosis, when your cystic fibrosis transmembrane regulator on chromosome 7 is defective, then you can't, then you have problems with secretions. They become thicker. Okay? And so it blocks the ducts like these are doing, and so that means then that the glands which are making the fluids in the pancreas, the exocrine part, if you block the lumen, there's a back pressure on them, and just like we had atrophy of the renal cortex and medulla from a back pressure related to urine, the same thing happens if you block the lumen of the duct. You get atrophy of the glands, and this is why you get malabsorption in all children with cystic fibrosis. So the answer is atrophy. That's for a lot of students. Okay, here we have a aorta. Okay, and we have right over here we have the atherosclerotic plaque. Okay, so what's this kidney an example of? Atrophy. And what type of hypertension does this patient have? Renal vascular hypertension. What's the renin level coming out of this kidney, please? High. See? They want you. You should have been able to look at this and be able to know what's that growth alteration. In fact, if you knock this one off, then what? The other one's doing all the work. They could just as easily point to the other kidney and say, what growth alteration's there? Hypertrophy. Or they can point to this one and say, what's the renin level coming out of the renal vein? Increased. What's the renin level coming out of the renal vein? Decreased. Suppressed. All kinds of things. Okay. But they're like growth alterations. Or they can do this. They can point to this and say, the growth alteration noted in this patient is similar to a growth alteration in. And then you have to find some other cause of atrophy, another thing that's related to atrophy. So in other words, you have to know, that's an example of atrophy, and then they give you 5 choices, and you have to think which one of those is also an example of atrophy. That's another way to do it. Maybe it could be one of these. Is that hard? Not really. But is it scary a little bit? Yeah. But now you know how they do it, don't you? So should it be as scary? Not when you already know how they do it, guys. I would not think so. Who should be scared? The people not taking this review. They have no idea what's on this test. They're looking at first aid for boards and stuff like that. You know, what do they say? You know, I'm just going to study first aid for boards. They ain't going to make it. Not enough. Not enough high-yield stuff on first aid for boards to make it. Not enough. Not enough. They have no idea what's on the test. They don't have any idea how their questions are asked. Do you? Oh yeah, you're gonna know by the end of Friday. You're gonna know all the little tricks, and they're all in your notes right there. Direct correlation. You read through page 1 to wherever the end is, you'll do extremely well. Unless you get nervous. All right, so what growth alteration is this? Hypertrophy, and this is a picture of what hypertrophied muscle is. Now, how would I do this one? Well, I would look at this thing and I would say, okay, this is an example of, let's see, how would I do this? I might ask a question about what I would see. Maybe if I wanted to make this cell biology, I would say, what is the N of this? Just 2N? Oh, let me give you a hint first. Okay? Hypertrophy of a cardiac muscle, which is a permanent muscle, the supposed block is before the G2 phase. Okay, so now what would be the answer? What would be the number of chromosomes in this one? Would this be a 2N, which is normal, a 1N, a 3N, or a 4N? 4N. Because if you block G2 just before G2, that's after the S phase and everything's doubled, then this muscle cell here would be 4N. So you just say it. They'll say 1N, that would be something like a sperm, okay, which would be 23 chromosomes. Then I'll put 2N, that'd be a normal diploid cell. 3N, that would be really bad because that means you probably have cancer or some trisomy disease, okay? And then 4N would be the answer in this. You have double the number. That's right. So I could do any number of things with this. So hypertrophy is an increase in size of the cell, not number. Not number. We'll go further with this when we do cardiovascular. I play games with you. Hyperplasia, what is that definition? Number. It's an increase in number of cells. Okay? This is a normal proliferative gland. Okay? There's piles of mitoses all over the place here. And eventually what's going to happen is you're going to get endometrial mucosa kind of looking like that. So what's this an example of? Hyperplasia, because there's more of them. Okay? That's why it's called proliferative phase, guys. You're increasing the number of endometrial glands. By increasing cell divisions, you're getting more cells dividing, more glands. Can you see why if you had unopposed estrogen, you can end up with cancer? Because if you didn't have progesterone to undo everything that estrogen did, you're going to get cancer. You're going to go from hyperplasia to atypical hyperplasia to endometrial cancer if you have unopposed estrogen. So that's a very important concept. Hyperplasia left unchecked, you run the risk for cancer. With one exception, lucky for us guys, this is the only good thing about prostate cancer. Prostate hyperplasia does not predispose to prostate cancer. So the worst thing you'll have is that you'll be getting up 3 times at night, like me. Okay? But I don't have to worry about prostate cancer deriving out of hyperplasia, because they're 2 different processes, hyperplasia and prostate cancer. That's the only exception I know of, though. Here's some more examples. This is a gravid uterus. That's a woman's uterus after she's delivered. This is an example of 50-50, 50% hypertrophy of the smooth muscle cells in the wall of the uterus, and 50% is related to hyperplasia. That's equal amount both sides. This is a bone marrow. This would be a beautiful thing to throw at you. Okay, normally you should have 3 times as many white blood cells as red blood cells. Okay. Well, the only white blood cells I see are that one, and that one. All the rest of these are red blood cells. So my question would be, I'd say, this is a bone marrow aspirate from which of the following patients? Okay, so if there's an increase in RBCs, that's RBC what? Hyperplasia. Okay, would you expect to see that in iron deficiency? No, because you're lacking iron to make RBCs. Would you expect to see it in thalassemia? No. Why? Because you have a defect in making globin change. Would you expect to see it in someone with chronic obstructive pulmonary disease? Yes, because they have hypoxemia releasing a hormone. What would that hormone be, please? Erythropoietin. And where exactly is it made, please? I was on boards. It's made in the endothelial cell of the peritubular capillary. So this is a erythropoietin-stimulated marrow, guys. So they assume that you know it's RBC hyperplasia. And then ask you a clinical scenario and say, which one would it fit? Don't worry, you have questions in the questions I put down for you have things like that in it, so don't worry about it. I have all the examples of these things. Okay, what's this? Come on, guys. Everyone knows what this is on the elbow. Come on. Psoriasis. So this is a histologic section of psoriasis. See these little white silvery scales? That corresponds to this right over there. Does that look like normal skin? Say no. So what is psoriasis an example of? Hyperplasia. It's an unregulated peripheral proliferation of squamous cells in your skin. And so you get this raised red plaque with silvery scales on it corresponding to this excess in stratum corneum. It's hyperplasia. Unregulated. That's why methotrexate can work in it, because it's cell cycle specific to the ES phase, and it prevents the basal cells from proliferating. Ooh, I'm getting this. I'm starting to get this. I hope so. We're only almost, 2 hours into this? Where are we? 3. You start to get the idea of how they ask things. Now, that should either scare you or make you confident. Okay? It's one of the two. Most of you get scared. Oh, I didn't know that. But now you do. Think about what you know now. Yeah, I'd be scared if I didn't know what was on the test. I'd be less scared if I had some idea what was on the test. Ooh. Okay. Depending on what your makeup is. Unlike most of you, I get scared. But if I'm really, really studied up, I really didn't get too nervous about tests because I thought, well, what could they ask me that I haven't studied? I at least I think it's a chance. We didn't have board reviews when we took national boards either. Okay, now, this is a cool one, okay? This is the prostate gland, and that's the bladder. Okay? So this prostate gland probably looks like this. So what do you think the process is over here on the prostate gland? Hyperplasia. See, a lot of you think it's prostate hypertrophy because you have pathologists that don't know dork from dork sign out your prostate curettings. Any pathologist that writes prostate hypertrophy ought to go back to school again. It's not hypertrophy of glands and smooth muscles, hyperplasia. It's a hormone-related thing. All hormone-stimulated glands undergo hyperplasia, not hypertrophy. So you have hyperplasia of the prostate gland, but look at the wall of the bladder. It's too thick. Why is it too thick? Now think of it trying to get urine through this narrow opening in the urethra there. Think it's having to work. What happens to muscle when it works? So the bladder wall is thickened because of hypertrophy of smooth muscle cells related to an increase in afterload, concept in cardiovascular phys. And this is hyperplasia of the prostate gland with hypertrophy of the bladder wall related to smooth muscles. They wouldn't do that. Why do you think I put it up there? Oh, yeah, they could do that. Oh, yeah. The last one is, not last, next to last, is metaplasia. Metaplasia is the replacement of one adult cell type by another. Okay, so here's an esophagus, part of stomach, and this is all ulcerated away. We take a section through where, right at the edge of this mucosa here, and we can see that there are mucus-secreting cells here and goblet cells. Is that what should be present in the lower esophagus? Glandular cells? Yes or no? What should be there? Squamous. But they're glandular and mucus secreting. So what's that an example of? Metaplasia, glandular, and it's got even a name. Name it. Barrett's esophagus. Did you know that Barrett's esophagus is the precursor for adenocarcinoma? And that adenocarcinoma, the distal esophagus, has surpassed squamous cell carcinoma of the mid-esophagus is the most common esophageal cancer in the United States. So gastroesophageal reflux disease is now the #1 precursor for esophageal cancer. And instead of it being squamous, it's an adenocarcinoma. 10-minute break. Okay, let's continue. Okay, what's the lining of your main stem bronchus, please? What's the lining of your main stem bronchus, please? Ciliated columnar, pseudostratified columnar. So if you were a smoker, then what would be an example of a metaplasia? Squamous, that's right. If it underwent squamous metaplasia. Okay? How about this one? Let's say I had increased goblet cells in the main stem bronchus, which is seen in all smokers. Is that an example of hyperplasia or metaplasia? It's hyperplasia, because you normally have goblet cells in the main stem bronchus, but also smokers have goblet cells in the terminal bronchioles. Is that an example of hyperplasia or metaplasia? Metaplasia, because there aren't normally goblet cells in the terminal bronchiole. See, they can ask questions like this because this proves whether you know histology or not. If you have goblet cells in the stomach, would that be normal or would that be abnormal? Abnormal. They should be present in the intestine. They should not be present in the small intestine. So that would be called glandular metaplasia, and that is a precursor for adenocarcinoma of the stomach. What's the most common cause of adenocarcinoma of the stomach? Helicobacter pylori. So because Helicobacter pylori produces damage to the pylorus and antral mucosa, produces a chronic atrophic gastritis, with intestinal glandular metaplasia, that's the precursor lesion for adenocarcinoma. So what you're seeing here is that hyperplasia left unchecked could potentially produce cancer. For example, endometrial hyperplasia is the most common precursor lesion for endometrial adenocarcinoma, and that's usually due to unopposed estrogen. Okay? Exception is prostate hyperplasia, does not progress into prostate cancer. Okay, but we can also see that metaplasia can go through a process ending up as cancer. Let's take lung. Okay, ciliated columnar epithelium becomes squamous, squamous metaplasia. And then you get what is called squamous dysplasia. We'll see a picture of that in a second. And then from dysplasia, the squamous epithelium can go into cancer, squamous carcinoma. So you can have that progression too. Okay. And the esophagus and the distal esophagus, it went from squamous to a glandular epithelium because squamous epithelium can't handle acid. So it needs mucus-secreting epithelium as a defense against the acid injury. Okay? But unfortunately, that glandular metaplasia can go on into an atypical metaplasia and go on into an adenocarcinoma of the distal esophagus. So some of these things are precancerous types of processes. Now, in parasitology, you all know about the one in the bladder, right? There's only two parasites that actually produce cancer. One's Clonorchis sinensis, producing cholangiocarcinoma. That's the Chinese liver fluke. And this one, which is in the bladder, this is Schistosoma hematobium. Okay? And so it causes the transitional epithelium to undergo squamous metaplasia. And from squamous metaplasia, squamous dysplasia, and from squamous dysplasia, squamous cancer. There you go. So it converted transitional epithelium to squamous, that's the metaplasia part. Then that went under dysplasia and became a squamous cell carcinoma. There's lots of these different ones, and I got most of those progressions down there for you that are important. This is dysplasia. Okay, remember is abnormal. Dysplasia is actually an atypical hyperplasia, actually. Okay. Now, they don't expect you to be pathologists, but I think anyone would know if this is squamous epithelium, it's distinctly abnormal. I mean, it's lacking order to it. We have nuclei that are big up near the surface. Man, it's the basal cell layer that does the dividing. Why should the cells at the top be bigger than the ones that are dividing? So you can see this lax orientation. I don't think it requires a pathologist to figure out this is abnormal. Okay? And if they say this is a cervical biopsy in a woman that has a human papillomavirus infection, or they say this is a main stem bronchus biopsy, I mean, you should be able to tell that this is dysplastic. You're not going to say, severe, moderate, mild. That's pathology. How many are going to become pathologists? Not a whole lot of you. But you should be able to know that dysplasia is a precursor for cancer, be it glandular dysplasia or be it squamous dysplasia. It's a precursor for cancer. What's the precursor for squamous cell carcinoma of the skin, guys? It's right over here. I'll give you the last one that I heard about. It was very clever. A farmer that had a lesion on the back of his neck, which they said he scraped off, and then 3 months later, it grew back. Well, this is what grew back. So what was it? What was the answer to that one? This is actinic keratosis, another name, solar keratosis, and it's a precursor for squamous cell carcinoma of the skin, not basal cell, squamous cell. I think you can see that there's some abnormal squamous epithelium here, and so this is actinic keratosis, another name, solar. This is UVB light damaged skin. It was clever, scraped it off, and then it grew back. Farmer, sun exposure. They always use farmers for this thing. Okay, maybe the next one will be on his ear. Okay, and he scraped it off and it grew back. They could do anything. Maybe it was on the face and he scraped it off and it grew back. And it's a farmer who has exposure to sun. It's the same thing. The answer is it's actinic keratosis or solar keratosis. What's its significance? A precursor to squamous cancer. Maybe it was on the forearm. Anywhere they want, they could put this. They can take this thing and probably find 50 areas in sun-exposed areas to ask this question. Okay, still the same answer. Scraped it off. It came back in a sun-exposed area. Duh. I think it has something to do with sun exposure. In this case, not basal cell. Actinic keratosis doesn't predispose to a basal cell squamous cell. Basal cells are more common than squamous cells. Okay. Inflammation is the next section. Now you've had inflammation, or at least you should have. I have to look at what you got on immunology. In fact, I'll do that over lunch. Part of innate defenses involves when we get an infection, what happens and stuff like that. So you should be reasonably familiar. So I'm going to hit it more from the pathology point of view and it's stuff on inflammation that's asked on boards. Okay? That's the bee sting. This exact picture was on boards. And I think probably this little thing here was probably labeled A, and then this over here was labeled B. And maybe something way out on the edge was labeled C. That's about as far as you can go. Remember, they can go anywhere from 3 A, B, C to, I forget what they can go up to, 6 or 7 choices on part 1. Part 2, you can get more than one answer. They might do select 2, select 4, and on part 2 they do matching. Part 1 usually doesn't have matching. Sometimes they change. I don't know whether they're going to be doing that or not. So don't be surprised if you see 4 choices and sometimes 3 choices, or sometimes 6 or 7 choices for a question. But they're only single select. Okay. Now, remember there's Latin terms applied to acute inflammation. So let's go through these things. We see redness here. That's rubor. Okay, now who's the king of the vasodilators, of the chemical mediators in acute inflammation? Histamine. Now what is it vasodilating? Arterioles. All right. So histamine is responsible for the redness of acute inflammation. This happens to be due to a bee sting. Okay? And what is it working on? It's working on arterioles. Okay, if we felt this, it'd be hot. That's calor. What's that do to you? Histamine again. Because when you vasodilate, it's all in the notes. Well, everything is there. Right? In fact, I can almost see it in my notes there. People copying all this down. It's all there. Okay? You vasodilate, that gives off heat. That's why in endotoxic shock or septic shock, you get warm skin as opposed to cold skin. It's because you're vasodilating the arterioles. Okay? So again, histamine. Histamine is related to that. 2. All right? That's the tumor of acute inflammation because it's a raised structure. What's that do to? Increased vessel permeability. Well, who increases vessel permeability in acute inflammation? Histamine. What vessel? Don't say arterial. Venial. That's right. So increased vessel permeability is in the venials. Think about it, guys. Is an arterial thicker than a venial? Yes or no? How are you gonna get an exudate through an arterial? Well, it's got smooth muscle in it, a couple layers of that, an internal elastic line. Forget it. Okay? But a venial is very, very thin. It's just basically a endothelial cell, basement membrane. All you got to do is drill a hole through the basement membrane, you're out. So increased vessel permeability doesn't occur at the arterial level, it occurs at the venial level. And histamine contracts the endothelial cells and leaves that basement membrane bare. And so you get increased vessel permeability, producing an exudate, swelling of tissue. That's the tumor of acute inflammation. Now this probably hurt. That's dolor. Histamine doesn't have anything to do with this. This is bradykinin. Remember, bradykinin is part of the kininogen system, which is between Hageman's factor 12 and 11. So when you activate the intrinsic pathway, you automatically activate the kininogen system. Because the moment you activate 12, Hageman's factor, that activates not only 11, but activates the kininogen system, and the end product of that is bradykinin. Who degrades bradykinin? Angiotensin-converting enzyme. I just made a correlation for you. Isn't it true that you get angioedema as one complication of an angiotensin-converting enzyme inhibitor? Yes or no? Okay, so if you inhibit angiotensin-converting enzyme, what else are you inhibiting? The metabolism of bradykinin, which increases vessel permeability, producing the angioedema, the swelling of tissue. How it produces cough, I'm not exactly sure, but it also can produce cough. That's how they're asking farm questions lately. They'll give you some scenario and some side effect, and they'll say, what drug is the patient on? That's how they've been doing it lately. Okay. All right. So, you know they're interested in this because I know they had this picture, and I know they had it labeled, and you had to tell, so bradykinin and PGE2 are the two things producing pain. So that's the only one of the four Latin terms for acute inflammation that's not due to histamine is the pain. Okay. Now, just very quickly going through the different things that happen in acute inflammation is that the neutrophils in the small vessels will begin getting sticky because of adhesion molecule synthesis. Okay, so will the endothelial cells begin synthesizing adhesion molecules, and eventually the neutrophils will stick to the endothelial cells. That's called pavementing. Some people call it margination. And then they will go and look for bare basement membrane on those venules, and with what type of collagenase do you think they have? Type 4 collagenase, because what's the collagen? Type 4. So neutrophils have type 4 collagenase, and they drill a hole through it. What else has type 4 collagenase in it? Cancer cells. How do you think that they get through and metastasize? They have to stick to endothelial cells, so they have to have adhesion molecules, usually against laminin in the basement membrane. They also, in order to get through the basement membrane, they have to have collagenase to get through. Okay? So cancer cells pretty much are like a neutrophil in a way it can get into tissue. A cancer cell has the same things for getting into tissue. To invade tissue. Okay, so when they get out of the small vessels, usually the venules, they emigrate. Okay, now they have to know what direction to go. Okay, so obviously, neutrophils have to be female in origin because they're the only ones that know directions. Okay, men, as you know, get lost and don't want to get direction. They'd rather be lost than stop and ask directions. You all know that. Okay, so it's directed chemotaxis. Okay, now could you name a couple of things that are involved in telling them where to go? C5a, LTB4 are chemotactic agents. In fact, they're also involved in making adhesion molecules on neutrophils. So it's kind of interesting that those things that make adhesion molecules also give directions to C5a and LTB4. Okay? So that's the normal sequence of things in acute inflammation. Now, we know that if we have an infection, let's say Staph aureus, that's producing acute inflammation, we know that the bacteria are being prepared before they're getting destroyed. And what's that process called, please? Opsonization. Could you please name two opsonizers? IgG and C3b. Okay. Okay, who can name a disease, sex-linked recessive child, where you're missing all immunoglobulins, including IgG? We would say gamma-globulinemia. So what do you think the most common cause of death then is? Infection, because you can't opsonize things. You may not have put that together. You may have known that it produces hypogammaglobulinemia, but you're not putting together what's the mechanism of the infection. The mechanism of the infection is to have no IgG to opsonize bacteria. Therefore, you can't phagocytose it. So you were 3/4 there, but not all the way. And unfortunately, it's that last quarter they asked on board. Why? Not what. Why? That's how you think. That's how you study. Why? Okay? Mechanisms. You study everything that you have had all the way through and all the other things. Why? Mechanisms of the drugs. You know, all mechanisms. You'll annihilate this test. Annihilate it. And not interested in your memorization abilities. What is going to be very little part of the test. Single-step reasoning, I don't think exists on a board examination. So it's 2 steps. And it's usually involved why. Not what, why. They assume you know the what. They want to know why. Very important. Okay, so they're opsonized by IgG and C3b, which means then that neutrophils must have receptors for those. Okay? And so we know that it's a neutrophil for acute inflammation. And what is it for chronic inflammation? The macrophage monocyte. Remember, monocytes, when they get tired becoming a monocyte, become macrophages. Okay? And if they're couch potatoes, they want to be fixed macrophages. Okay? If they want to move around as a macrophage, then they'll be wandering ones, like alveolar macrophages and stuff like that. Okay? But anyway, so they would have to have receptors for those opsonins, IgG and C3b. It makes sense, doesn't it? There's no memorization involved. That all makes sense. And then they're going to get phagocytosed. Okay? So this is a phagolysosome. And what will happen is when you phagocytose this bacteria, the lysosomes will go down the microtubules and empty their enzymes into this. Okay? You learn about an interesting disease in biochemistry where because you can't phosphorylate mannose residues in the Golgi apparatus, then the enzymes cannot, there are no enzymes not marked with the phosphorus on them, and so the lysosomes are empty. And that's called eye cell disease. That's good. They love that one. They love that one. Okay. Now that involves that dolicol, glycosaminoglycan type of stuff. Kind of interesting stuff. Gets a little bit hairy in there, but they ask it. And Hanson's very good. You guys are really lucky to have her. She's really a good lecturer, very clinically oriented biochemist. And so she's going to put some finishing touches on this stuff. And boy, you're really going to be ready. Ooh. And of course, you got Paso, you know, doing his cardiovascular. I mean, he's sick. He wasn't sick. He couldn't have been sick. Paso's never sick. Paso's never sick. Tell him I said so. He wasn't sick. He just using some excuse. I'm only kidding. Good guy. All right. So here's this bacteria, Staph aureus, in a hot tub. Okay, surrounded by enzymes. And you learn in microbiology all different kinds of ways that they can get, evade destruction. What's interesting, things like chlamydia can actually get out of a phagolysosome. That's interesting. I'd like to know how it does that, a Houdini. Okay, but sometimes they have mucus around them and all kinds of things. Okay, you learn about the oxygen-dependent myeloperoxidase system, which is big-time boards, big-time boards. Okay, remember that oxygen, molecular oxygen, is converted by NADPH oxidase, which is in the cell membrane of neutrophils and monocytes, but not macrophages. They lose that system. And notice there's a very important cofactor, NADPH. Where's most NADPH synthesized? Common last board question. Pentose phosphate shunt. And what's the enzyme responsible for that? That particular part of the reaction, glucose 6-phosphate dehydrogenase. That's converting glucose 6-phosphate into 6-phosphogluconate. You're getting NADPH, and then you're getting a neutralizing factor for free radicals. Name it, glutathione. Okay, so make sure you know where we are. That's where the NADPH came from. And it's converting molecular oxygen into a free radical, superoxide. That's an unpaired electron in its outer orbit that gives off energy. That's called a respiratory burst, which can be measured by radiation detectors, but the one they like on exams is nitroblue tetrazolium, NBT dye test. What they do is get a little test tube, and they add in this dye that's colorless, called N as in Nancy, B as in boy, T as in Tom. They stick it into this test tube, and if neutrophils and monocytes are working okay, they'll phagocytose it, they'll have a respiratory burst, and that free radical oxygen will cause the color, a change to occur in the dye and make it colored, usually a bluish color. And then they take some of the neutrophils out, they smear them on a slide, and see if they see any color in the dye, and if they do, then they know that the respiratory burst is working. If they see that there isn't any color in the dye, that means they were not able, they did not have a respiratory burst system. And they know that they have chronic granulomatous disease of childhood. Okay. What happens to the free radical oxygen? It's converted by, it neutralizes superoxide. It mutates into peroxide. Woo! You know, that itself could kill bugs. But there's something better than peroxide. And that is, there's an enzyme called myeloperoxidase. You know those little red granules that you see in monocytes, little red granules that you see in neutrophils? You know those are lysosomes, right? That's what the little what you call as urophilic granules, those are lysosomes. You can see them in a peripheral blood. Okay? Myeloperoxidase is one of many enzymes in there. And it's going to catalyze the reaction, guys. It's going to combine peroxide together with chloride to form bleach. Ooh. Does bleach kill bugs? Big time. It'll kill you too if you drink it. Okay? It won't kill you too. It'll kill anything. What's bleach? Whoa. So you can see why this is the most potent bactericidal mechanism for killing things. The oxygen-dependent myeloperoxidase system. And what two cells have it? Neutrophils and monocytes. How about macrophages? No. They lose that system once they become a macrophage. They get punished. You don't get oxygen dependent. What are you going to leave me with? Lysosomes. You go out with a huff. I want to become a couch potato. Go ahead. Become a fixed macrophage if you want. By the way, what's the macrophage of the central nervous system? Microglial cell. So what's the reservoir cell for CNS AIDS? The microglial cell. What's the reservoir cell and outside the CNS? The dendritic cell, which is a macrophage, and where is that located? In the lymph nodes. That should not be, okay? Those are in your high yield stuff, on the microbiology and immunology. Okay. Can you see something here? How about this one? If I have glucose 6-phosphate dehydrogenase deficiency, then why is it that infection is the most common thing that precipitates hemolysis? You answer the question. The answer's right up there. You have no NADPH, which means you have no functioning oxygen-dependent myeloperoxidase system, which means you would be susceptible to infection, which would set off the hemolysis of the red blood cells. Correlation right there. Ooh, it's pretty cool. Yes, it is. All right, so let's talk about some diseases so that we can get some. We have chronic granulomatous disease of childhood, which is sex-linked recessive. So what does that mean? Who gives it to the boy? Mommy, who's an asymptomatic carrier. Okay, remember both female carriers, both females, okay, then you have 50 of the females, all of the females of a male with a disease, okay, are asymptomatic carriers. And they transmit the disease to 50% of their sons. Okay, I used to teach a genetics part, but I have no more time to do that, but I put all my genetics notes in my high yields, because they really were high yield, big time. It looked like you had pretty good genetics in there. I looked at that part. It looked good. Okay, so in chronic granulomatous disease of childhood, they're missing an enzyme, NADPH oxidase. So I'm going to ask you a question. Do they have, what's the NBT type dye test show? It's abnormal. It doesn't show color of the dye. So what are they missing? The respiratory burst. So do they have superoxide? No. Do they have peroxide? No. Do they have myeloperoxidase? Yes. Do they have chloride? Yes. So, if some bacteria that they phagocytose in a neutrophil or monocyte could make peroxide and add that to the inside that phagolysosome, would that be all that this kid would need to be able to kill the bacteria? Yes. We have myeloperoxidase. We have chloride. What these kids are missing is peroxide because they have no NADPH oxidase. All living organisms make peroxide. That includes all bacteria. all bacteria contain catalase, which is an enzyme that you already know breaks down peroxide. And so we run into that microbiology question that's always asked in relationship to chronic granulomatous disease of childhood. What can they kill? What can't they kill? They can't kill staph, but they can kill strep. And the reason for that is Staphylococcus is not only coagulase positive, it's catalase positive. So if this was Staph aureus here, when it makes its peroxide, and it will, it also will release catalase and neutralize it, and so the kid can't kill the staph. And it will kill the kid. But if this was a Streptococcus, which is catalase negative, and when it makes its peroxide, as any normal bacteria would, it doesn't have catalase, and so it's adding what this kid really needed to make bleach, and so this kid can kill strep. So kids with chronic granulomatous disease of childhood can kill strep, but can't kill staph, and it all has to do with which one of the bacteria are catalase positive, staph, which one's negative, strep. Classic board integration tie-in. Classic. Now, next question is, let's keep this here. Myeloperoxidase deficiency has been added over the last year into the boards. Do they have a respiratory burst? Think before you answer. Of course they do, because they have NADPH oxidase. Okay, do they have peroxide? Yes. Do they have superoxide free radicals? Yes. Do they have chloride? Yes. Do they have myeloperoxidase? No. Okay. And so they have a respiratory burst, a normal NBT dye test, but they can't kill the bacteria. Why? Because they can't make bleach. Okay. So what would we call this type of defect? We have opsonization defects. That would be things like Bruton's A gamma globulinemia, missing IgG. There are certain C3 deficiencies also. That'd be an opsonization defect. We have certain defects that are chemotactic, where the cells don't respond to chemotaxis. Then we have defects in microbiocidal defects. That means ability to kill bacteria. Chronic granulomatous disease of childhood and myeloperoxidase deficiency are both microbiocidal defects. They can't kill bacteria, but for different reasons. And myeloperoxidase deficiency is because they can't make bleach, because they're missing the enzyme, but they do have a respiratory burst. Whereas in chronic granulomatous disease, they can't make bleach either, but they have an acid respiratory burst. So that's the main difference between the two. Plus, myeloperoxidase deficiency is not sex-linked recessive. It's autosomal recessive. The next board question is the kid whose umbilical cord doesn't fall off when it should. And then it's removed surgically, and they say that histologically it doesn't show neutrophils within the tissue, or neutrophils lining the small vessels. So that's an adhesion molecule defect. Now they can sometimes just say adhesion molecule defect, sometimes they say a beta-2 integrin defect, sometimes they put that, because integrins are adhesion molecules. But whatever it is, the umbilical cord needs to have an inflammatory reaction involving neutrophils, so they have to stick in order to get out. Okay, so they can't stick, they can't get out, and you can't get rid of your umbilical cord. That's a classic adhesion molecule defect. All three of these things have been on exams, big time. Must know. Okay, now you should be familiar with all of these already, but just as a little review, what's the king of the chemical mediators of acute inflammation? Histamine. All right. What does it do to arterioles? Vasodilates. What does it do to venules? Causes increased vessel permeability. Good. Serotonin, what amino acid makes this? Tryptophan, very good. Is serotonin a neurotransmitter? Yes, some of you are deficient in it right now. So what do you have? Depression. Those of you that look like norepinephrine, you're deficient in both of those suckers. Okay. Since I'm manic depressive, I got, I just got whole piles of stuff. Okay. Anaphylotoxins, name me. C3A, C5A, big deal. That is memorization. What role do they play? The anaphylotoxins means what? That they stimulate mast cells to release what? Histamine, which causes vasodilatation and increased vessel permeability. Do you think they may even play a role in shock? I think so. Because if you activate the complement system, those two suckers are going to be there. You're going to have those dudes around. Okay. Bradykinin we talked about. C3b we mentioned. Prostaglandins, most of them increase vessel permeability and dilate. Leukotrienes, remember those are, we'll show you those in a second. Nitric oxide will be on the test because that's big time now. It's made in endothelial cells, other places too, but mainly endothelial cell is a potent vasodilator. In fact, they synthesize it and it's used in treating things like pulmonary hypertension and stuff like that. It's a big one now. You'll see that it plays a big time role in septic shock. Big time. Endothelin, no. Interleukin-1, yeah, that's one interleukin you want to know. Okay, because that's the one associated with fever. Interleukin-1 is a pyrogen. It stimulates the hypothalamus to make prostaglandins, which stimulates the thermoregulatory center to produce fever. Okay, and so you can see why things like aspirin work in producing fever because they inhibit prostaglandin synthesis. But in this case, the prostaglandin is located in the hypothalamus. Okay, all right. Factor 12, forget. Guys, can you picture this? Can you picture this up here? And maybe have A over there, B over here for that enzyme, C over there, D for that enzyme, E for that. Okay, maybe this one over here, I'd probably put F, G over there. Okay, and then they say platelet over here, and then you put E, whatever we're up to now, over there. And then they'll say endothelial cell and put a letter there. And maybe even go down here. They could have up to Z on this sucker. And all kinds of things they can do with this to screw you up. Okay? So, corticosteroids, where would you point? Right there. Inhibits phospholipase A2, which means you don't release arachidonic acid from phospholipids, which means you make neither prostaglandins or leukotrienes. That's why it's a supremo. I mean supreme. Anti-inflammatory agent, because both prostaglandins and leukotrienes are blocked by blocking phospholipase A2. And then remember your omega-6 fatty acids that can make arachidonic acid linoleic, not linolenic. That's omega-3. That's the one you want to eat every day in walnuts and fish oils because they act like aspirin. They block platelet aggregation. That's how omega-3s protect your heart. They just act like aspirin does. They inhibit platelets from aggregating. Okay, then you know about xylutin as a drug that blocks 5-lipoxygenase. And then you have other ones that block the receptors. Okay, those really weird ones, Zartrolust, whatever kind of crazy things that begin with Z. Okay. Then you got LTC4D4E4, the slow reactive substance of anaphylaxis. These are the things seen in bronchial asthma. They're potent bronchoconstrictors. And so you can see why xylutin works so great in asthmatics because it's blocking all the leukotrienes, including those suckers. You already know that LTB4 is adhesion molecules in chemotaxis. We go over here. Okay, what does aspirin block? Cyclooxygenase. Okay. Irreversibly or reversibly? Irreversibly, if we're talking about a platelet. Okay? And then we come down to PGH2, where everything seems to derive from. Okay? PGI2 is made in the endothelial cell. And that's why it's called prostacyclin synthase. And this is the archenemy of thromboxane A2 made in the platelet. Okay? Thromboxane A2 is a vasoconstrictor, bronchoconstrictor, platelet aggregator. PGI2 in the endothelial cell is a vasodilator, okay? And it inhibits platelet aggregation. It's the archenemy of thromboxane A2. Drug blocks this, please. Name me. Thromboxane synthase. This drug is also used in doing it is used in doing stress testing for coronary artery disease. Dipyramidol blocks thromboxane synthase. Okay, dipyramidol. And you can do that as a, so where they don't have to do the treadmill thing, you can do a dipyramidol stress test. It's just blocks this, it blocks thromboxane A2. This right over here is this famous PGE2. This is famous for as a vasodilator in the kidney. This keeps a little fetus's patent ductus patent. Okay? This is what makes your mucus barrier in your stomach so that you don't end up with ulcers. Big one. Women, this is the little dude that causes dysmenorrhea, primary dysmenorrhea. It increases uterine contractility and has been made as an abortifactant to express fetal material. Okay, so there's a lot of good board questions here, all of which I've summarized in my notes. Lots of form in this one. Remember, make sure you know how your COX-2 things work. Okay. All right. Corticosteroids. I already mentioned one of the things why it's a fabulous anti-inflammatory agent. It blocks phospholipase A2. But what else does it do? It decreases adhesion molecule synthesis along with other steroids like epinephrine, norepinephrine. Now I want you to think. You decrease adhesion molecule synthesis, what would that do to the neutrophil count on the CBC? It increases because you remember from immunology that 50% in a white person, 50% of neutrophils are already stuck to the endothelium of small vessels and 50% circulate, and that's the one we measure. So if you decrease adhesion molecule synthesis, then those ones that were already stuck are now circulating. What would you do to your white blood cell count? Double it. And what do you know that corticosteroids do to B cells? Destroy them. They're lymphocytotoxic. You want to know by what mechanism? It starts with an A. P. There you go. Corticosteroids decrease your B cell count. That's any B and T, both, by apoptosis. It stimulates it and it destroys. In other words, the corticosteroids are the signal for who to kill the cells. Metastasis. All right. What do they do to the eosinophils? You already know what they must do because we know we use them in type 1 hypersensitivity reactions. So what must they do? Decrease them. So when we're on corticosteroids, what's the only thing increased? Neutrophils. Mechanism, decreased adhesion molecule synthesis. And what's decreased? Lymphocytes and eosinophils. Very good. Can you think in reverse? If you had Addison's disease, what would happen? Come on, come on. Do you have cortisol? Yes or no? No. So what happens to the neutrophil count? Decreases. What happens to the eosinophil count? Increases. Good. See, that's how you can take information like that and then start applying it clinically. You ever wonder why a person who has a myocardial infarction always has the 18,000 CBC, most of which are neutrophils? Mechanism. Epinephrine, there you go. And what does it do to adhesion molecule synthesis? Decreases it, boom, neutrophil count goes up. Wow. I think I'm getting this a little bit. Good. All right. They love electron microscopy of the inflammatory cells. Therefore, I have provided them on the screen for you, for your enjoyment. Isn't that cute? He provided neutrophils and stuff on the screen. That's a neutrophil. That's the electron microscopy. Now, usually on an EM, couldn't find one that it'd have another lobe or two in there, okay? What do you think this thing is with all this garbage in it? It's a phagolysosome, okay? And it's got little bits and pieces of things in there. That's a neutrophil. That's an electron micrograph. I haven't heard of them doing that one yet. But this one I have. And they did it in the lung. And they had next to it a type 2 pneumocyte. And they wanted you to identify the alveolar macrophage. That's a no-brainer. You see all these little black dots all over the place, those are lysosomes. Okay? That's the macrophage. Okay? I'll show you what a type 2 pneumocyte looks like when we do respiratory distress syndrome, and I'll show you what the lamellar bodies look like. Lamellar bodies are the structures within which lecithin and phosphatidylcholine is located. Because if they ask what the macrophage was in there, what do you think another one's going to be with that same slide? Which one makes surfactant? You see? There you go. This is a monocyte, guys. You know, it's kind of a grayish cytoplasm. And this is what it looks like by electron microscopy. Usually a single nucleus And if all this garbage in your cytoplasm, you know that that has to be something that scavenges around. This can form a foam cell, by the way, in an atherosclerotic plaque because it can phagocytose oxidized LDL. Did you know oxidized LDL is free radical LDL? And what vitamin neutralizes oxidized LDL? Vitamin E, very good. So this one's kind of easy. I'm not an electron microscopist, but this is a lymphocyte. And if you see an electron micrograph and it's all nucleus with very little cytoplasm, that's a lymphocyte. But just for fun, play odds on what that lymphocyte is. Okay? Choices. CD4 T, CD8 T, B cell. Play odds. All right, play odds T versus B. T, 60% of the peripheral blood lymphocytes are T. Now what's the normal ratio of helper, which is 4, to suppressor, which is 8? 2 to 1. So play odds on which one this would be. Helper T cell. Then it would be more likely a suppressor T cell, and then the least likely would be B cell, which would be only account for about 20% of your cells. So any cell that has just all nucleus is a lymphocyte. Okay, now this should be very easy. What's all this crap over here, these little things that look like a thumbprint? That's rough endoplasmic reticulum. What does rough endoplasmic reticulum make, please? It has the ribosomes on it, which make proteins. So this cell likes to make proteins, like immunoglobulins. So what do you think it is? Plasma cell. There you go. So the one that looks like it has, looks like a fingerprint in there with all these ribosomes in it is a plasma cell. This is multiple myeloma. Notice that the nucleus is eccentrically located. Notice also the cytoplasm is always sky blue. Makes plasma cells real easy to recognize. But they're the ones that have the most ribosomes because they're always making protein. What did a plasma cell derive from, please? A B cell. There you go. And where would they be located in the follicle, please? Oh, I already gave it away. In the B cell, please. Germinal follicle, very good. Okay, number 1 and number 2. We're not talking about going to the bathroom. Okay, number 1 has granules which are the same color as RBCs. Number 1 is a eosinophil. Number 2 has got granules that are more purplish and darker, basophil. So if you're not colorblind, it's easy to tell an eosinophil from the basophil. Eosinophils have a red color that's similar to the color of red blood cells, but basophils have more darker colors. Now this is an eosinophil. You know what's in those granules, guys? Crystals. It's the only inflammatory cell that has crystals in its granules. And you even know what the name of them are in the sputum of an asthmatic. You even know what the name of it is. What is it? Charcot-Leyden crystals. And what they are degenerated eosinophils in the sputum of an asthmatic, and they form these little crystals that look like spearheads. And they come from these crystals here. Ooh. What's the mechanism for killing invasive helminths? Let's see how good your microbiologist was. Type 2 hypersensitivity. And who's involved in it? Oh yeah, from who? Major basic protein. I mean, major basic protein could be the major involved in this thing. Remember these schistosome eggs that you saw in that biopsy specimen, remember? What were they coated by? IgE antibodies. What do you think, what kind of receptors do eosinophils have? IgE. And so they hook into those IgE antibodies and they release their chemicals. And the big one's major basic protein. And that destroys the helminth. But that's type 2 hypersensitivity because it's a cell hooking into an antibody on a target cell. See, where you get confused with type 1 hypersensitivity in eosinophils isn't the effector cell for type 1 hypersensitivity, guys. Who's the effector cell? The mast cell. And what did they release from their purple granules? Histamine, eosinophil chemotactic factor. So they were invited to the area of the type 1 hypersensitivity. What is their purpose in a type 1 hypersensitivity action? What is their purpose? Their purpose is that they also have histaminates in them, and they have aryl sulfatase, which neutralizes leukotrienes. So the real purpose for eosinophils in a type 1 hypersensitivity reaction actually is to knock off some of the chemical mediators producing the type 1 hypersensitivity reaction. But when it kills, an eosinophil kills an invasive helminth, it does so by type 2 hypersensitivity. It's not a type 1 hypersensitivity reaction. Okay. Cluster designations, just for fun, just to get you involved, because some of you look like you're in myasthenic crisis at this time. Okay, I want you to pick out the one for helper T cell. 4. Cytotoxic T cell. 8. The marker, the antigen recognition site for all T cells. 3. Good. The antigenic marker for histiocytes, which would include Langerhans cells. 1 is correct. Very good. The marker for the most common leukemia in children. That was asked recently, and that really irritated me because that's memorization. The answer is 10, and that's the CALA antigen. Remember you talk about the common ALL antigen, positive B-cell leukemias? Well, that's actually CD10, believe it or not, and that was on some kid's exam. So I added it to my notes. So when I taught the New York thing a couple of months ago, was it there? Yes, because I knew about it then, but the one before that, no. So they're going to get it wrong? Likely. Okay. 1530 actually is Reed Sternberg. CD21's been asked. I think it's dumb. It's only on B cells, and there's a virus that hooks into this receptor. Name me. Epstein-Barr virus. It hooks into that receptor, CD21, on B cells. Actually, the atypical lymphocytes are not the B cells, they're T cells reacting against the infected B cells. Ooh. Burkitt's lymphoma is a B cell lymphoma, guys. Not a T cell lymphoma. CD45 is on all leukocytes, so it's a common antigen on everything. These are the most important, in my opinion, cluster designations that you must know. Isn't it nice that you don't have to go beyond this? I would think so. I would like that. Fever must be important because I designated one slide to it. Who's responsible for fever most of the time? Interleukin-1. And it works, remember, via plastic vein. In fact, it's PGE2 again. That's what the hypothalamus is making. And then that stimulates the thermoregulatory center. Is fever good? Say yes. Yes, it is. Did you notice that you told me that it did what to the oxygen dissociation curve? Right shifted it. Why do we want lots of oxygen in our tissue when we have inflammation? Oxygen-dependent myeloperoxidase system. So when we give antipyretics to patients that have infections, is that bright? No. Because we're thwarting a mechanism for getting oxygen to the neutrophils and monocytes to do what they do best. Whoa. You're really getting into this, aren't you? Yeah. Also, hot temperatures in the body are not very good for reproduction of bacteria and viruses. So we're not just talking about bacteria, we're talking about viruses don't like high temperatures. That actually is a mechanism for killing them. Not a good idea to give antipyretics. Now, if you got a kid with a febrile convulsion, that's another story. But I mean, 103 temperature, 104, forget it. Forget it. It's killing bugs, bacteria, helping neutrophils do their thing, monocytes do their thing, getting lots of oxygen to tissue. 105, that's what I'm thinking about. Maybe lowering a little bit. Fever's good. Okay, types of inflammation. This is the most common. The reason I put this one here versus some other type of suppurative inflammation is because it's been asked on boards. This is a postpartum woman. She's got pus coming out of her lactiferous duct organism, Staph aureus. And so this is an example of suppurative inflammation. Okay, here's a bone in a child that had sepsis. Okay, and we see in the metathesis of bone a yellowish area, which turned out to be all an abscess. So what is this? Osteomyelitis. Organism. Staph aureus. Let's say the kid had sickle cell disease. Organism. Salmonella. Very good. That's very good. SS is not good because it's actually salmonella type of urine. Okay. Why is it the metathesis of bone? Because that's where all the blood supply to the bone goes. So what does that tell you about the mechanism of osteomyelitis? Hematogenous. So it comes from another source, then it gets to bone. Ooh, this is cool. Yes, it is. I agree with you. Okay? Hot. Spread out over the face. Cellulitis. Organism, if you play odds. Strep. Pneumoniae or group A strep pyogenes. Pyogenes. There you go. So this is erysipelas, an example of cellulitis. Now this one they love right here. Now here's the way I would ask this. Okay, in fact, Friday, my kiddos had their first TAF exam. This was the last picture on it. Okay? And it said the type of necrosis noted in this patient would be analogous to the type of necrosis in which the following. And I had Clostridium difficile, Clostridium perfringens, and some other stupid things. What was the answer? Clostridium difficile, because this is diphtheria, and this is a pseudomembrane. Corynebacterium diphtheriae, guys, a gram-positive rod, and it makes an exotoxin, which screws up riboxylation of proteins, elongation factor 2, that's what the toxin does. And the toxin damages the mucosa and submucosa, producing a pseudomembrane. The bacteria doesn't invade, it produces a toxin that damages the membrane, so does Clostridium difficile. And it also produces a pseudomembrane and a toxin, which is what we measure in stool to make the diagnosis. So the answer was Clostridium difficile. Okay. Did they get it right? 100%. 100%. That's the pseudomembrane of diphtheria. Ooh. Okay. All right. What's this type of inflammation called? That so-called bread and butter pericarditis? What's this called? Fibrinous. Fibrinous type of inflammation. Usually due to increased vessel permeability. We see this in lupus. This would be the most common heart lesion in lupus. So you'd have a friction rub. We see this in the first week of a myocardial infarction. Then 6 weeks later, called Drexler syndrome. We see it there too. We've seen with Coxsackie infections, which is always asked on boards. Okay, this is a third-degree burn, and this is a blister, and I just happened to show that. What's the most common organism producing infection in third-degree burns? Pseudomonas aeruginosa. Very good. What's the color of its pus? Green. Due to? Pyocyanin. Oh, this is good. This is even before lunch, and you guys are still awake. This is so incredible. At least some of you are awake. Not all. Okay, believe it or not, they had something similar to these schematics on someone's exam, which I couldn't believe. And they wanted you to have them labeled A, B, C, and D, apparently. Of course, they didn't have granulation tissue pointing to them and scar and all that kind of stuff. And they asked, what was it? They asked something about which stage. God, it was pretty simple, actually. They said which of the following was the stage within which there's a seal in the wound, in a primary intention wound. The answer was B. Okay. Well, I know what it was. I think they had, wasn't this type of thing. They had different things showing. They had something going over the top of a clot, underneath the clot, like you see here, and I have no idea what the other ones were. What this is showing is that the basal cell layer on both sides of the cut, okay, proliferate, and they go underneath the clot and seal it. They don't go over the clot, they go underneath it. They actually had a whole diagram and a whole series of things to pick that out. That was kind of weird, I thought. So when do we seal this primary? Let's say this is someone that had an appendectomy. By 48 hours, the wound is sealed off because the basal cells have formed a seal. The key for healing of a wound is the presence of granulation tissue. And there is a protein, guys, which is a very important proteoglycan, and that's fibronectin. That's involved in the healing of a wound. Fibronectin is an adhesion agent. It's a chemotactic agent and invites all the people around there, like fibroblasts, to help in the healing process. Granulation tissue starts on day 3, and it's really at its prime on day 5. You ever have a scab on a wound and you picked it off, and it bled like mad, and you pressed on it and it bled like mad? That's the granulation tissue. Some people call it proud flesh. Women that are pregnant can get them on the gums, called pyogenic granulomas. basically granulation tissue. No granulation tissue, no healing a wound. Very important. Fibronectin is very important. Name the type of collagen, please. Responsible initially, type 3. So we already know 2 collagens already. 4, and where was that located? Basement membrane 3, and where is that located? In the initial stages of wound repair. Okay, what's type 1? That's the good stuff. That's nice and strong. Highest tensile strength, tendons and bone, skin, and tendons and ligaments. That's very strong tensile strength. Okay, now what happens after about over the ensuing weeks and months to the type 3 collagen, please? It gets broken down by collagenases, type 3, and there's a metalloenzyme that's what trace element is actually an enzyme associated with the collagenase that helps convert type 3 into type 1 collagen, please. Zinc. That's why zinc deficiency commonly produces problems with wound healing, because it screws up the collagenase. You've got to replace the 3 with type 1. And what's the maximum tensile strength that you can get in a wound by 3 months? 80%. What's the most common cause of poor wound healing? Infection. What's this patient have? Oh, no, that's not it. Wait a minute. Where is it? What's this patient have? Ehlers-Danlos syndrome. Defect, please. Collagen. It could be in synthesis, breaking down, or whatever. Ehlers-Danlos. Okay, would you have poor wound healing there? Sure. Now, I don't have a picture now, but you will see one another time of another disease where the defect's in fibrillin, which is an elastic tissue. What's that one? Morphines. Both have screwed up wound healing. Lastly, before lunch, in a patient with scurvy, what's the defect? Defect is in hydroxylation of 2 amino acids. Name them. Proline and lysine. Okay. Do you happen to know why that's important to hydroxylate proline and lysine with ascorbic acid? What makes, remember, it's a triple helix, remember? Okay? Now, what makes those triple helixes stick together and form the tensile strength? Cross bridges. Cross bridge. When you cross bridge things that you want to increase the strength in, that gives the strength to them. Cross bridging. Lysyl oxidase is the enzyme. Copper is the cofactor for that. Well, guess what the cross bridges hook into, what they anchor into? They anchor into those places where you hydroxylated proline and lysine. And so you have weak, abnormal collagen in scurvy because there's no cross bridges. The cross bridges can't attach to anything, and so it's weak collagen. You therefore can't heal wounds. You end up with hemorrhages. You end up with hemarthrosis, all those terrible things associated with vitamin C deficiency. So you got to know more than hydroxylating proline and lysine. You got to know what that means. That means that the collagen that you make, that's weak tensile strength. Why? Can't cross bridge. Okay, we'll finish our inflammation at 1 o'clock. Okay, we were talking about scurvy, I think, last. Not to be confused with scabies, that's a different disease. This top picture here is what granulation tissue looks like. I think you can see it's got a lot of blood vessels. Okay, that's because of the basic fibroblast growth factor. You see a lot of inflammatory cells in here, from platelets to, not platelets, from the plasma cells and lymphocytes. Very, very rich vascular tissue that's absolutely essential for normal wound healing. You all know what this is? Keloid, you know. Don't make the big deal between a hypertrophic scar and a keloid. That's all baloney. Basically, a keloid is, or a hypertrophic scar, is just an excess in type 3 collagen deposition. Okay? And it causes these tumor-looking types of lesions on the skin. In terms of keloids, there is a genetic predisposition we see very commonly in the black population, but I got keloids pretty much too, so it can have some genetic increase. Now, this is a white little child here. What do you think was the underlying cause of this kid's keloids? Third-degree burn. Now, they've been hitting a lot lately the relationship of squamous cell carcinoma to scar tissue in third-degree burns, There was one that caused a lot of people, I'm sure, to get this one wrong. They said something about a chronically draining sinus tract in the skin, and they tried putting antibiotics on it and didn't work. This ulcer, a little ulcered lesion on the orifice of this chronically draining sinus tract. They said antibiotics didn't work, nothing worked. What is it? The answer is squamous cell carcinoma. You see, there's a lot of turnover that goes on in the scar tissue. And I gave you the impression that type 3 collagen is converted over into type 1 collagen. Well, that means fibroblasts are involved, and there's cell divisions going on. And whenever you have cell divisions going on, there's always a chance for mutation and cancer, and it's usually squamous. So I want you to remember that squamous cancer is very, very common in the setting of scars related to third-degree burns. In fact, big time. And also from chronically draining sinus tracts, like you see chronic osteomyelitis, right at that orifice of the draining sinus tract. There's a lot of hyperplasia of epithelium going on there, and it predisposes to squamous cell carcinoma. So they've been hitting that over the last year and a half on that particular concept. So I figured I would share that with you so you get another point on the test, if you happen to get that question. Okay, chronic inflammation. Let's compare acute with chronic. A lot of good immunology here. What's the main immunoglobulin of acute inflammation, please? IgM. Want to know why that is? At least I think the reason I think why it is that, you need a lot of complement components, don't you? Like C3A and C5A and C3B and all those different complement components involved in the healing process. And what's the most potent activator of the complement system? IgM. And why is that? It's got 10 antigen recognition sites. The pentamer. And so all you need is one IgM. Boom, you got that classical pathway. And it's going to go from 1 to 9 in terms of the complement cascade. IgG requires 2 of them to activate the classical system, and it doesn't go beyond C3. I only found that out recently, actually. I thought that, when you activated the complement system, it went from 1 to 9, period. No. If it's activated by IgG, it only goes to C3 and stops. Okay, so it doesn't go down to 5 and 6, 7, 8, and 9. And so you're not going to get your C5A, which is part of the, the anaphylotoxins, and C5A was important as a chemotactic agent with IgG. And so IgM is the primary one we see in acute inflammation initially, not IgG. But then, after 10 days to 2 weeks, there's an isotype switching, where that same plasma cell that was making IgM, you splice out the Mu heavy chain. Remember, it's the heavy chain that defines the specificity of an immunoglobulin. And it splices in, again, a heavy chain, and all of a sudden the same plasma cell is making IgG. So it's not a question of different cells making it. It's the same one was making M, now makes G by isotype switching. And then IgG is the primary immunoglobulin. But IgM first and then IgG later. Chronic inflammation is a very, very brief, maybe a couple-hour phase of IgM stint, but then it goes right to IgG immediately. So the main immunoglobulin of chronic inflammation is IgG, not IgM. The cells are different. Acute inflammation, the key cells are neutrophil. Now, of course, we're talking about the standard types of acute inflammation. It's neutrophil. If you're talking about an acute allergic reaction, what's one of the key cells you see? Eosinophils, very, very commonly. And, of course, mast cells are in tissue, so you're not going to be seeing those. And if we're talking about viral infections, what's the main acute inflammatory cell? Lymphocytes. So, the main actor can be a little bit different depending on the type of acute inflammation. But as a rule, it's neutrophils. And then when we talk about chronic inflammation, then we're talking about the monocyte and macrophages being the key. We're going to see plasma cells, a lot more plasma cells, and a lot more lymphocytes in tissue. We're not going to see pus. Pus or exudate is not a characteristic of chronic inflammation. That's a characteristic of acute inflammation. Basically, when we have that increased vessel permeability, and we have emigration of neutrophils into interstitial tissue, that protein-rich fluid, which is greater than 3 grams of protein per deciliter, and that cell-rich fluid is called an exudate, which basically is pus. That's what pus is. Okay? But this is a tumor of acute inflammation. You're not going to see an exudate in chronic inflammation. Okay? So I think those would be the big difference. Difference in immunoglobulins, difference in cell type as well, and absence of exudate. I just put a picture of chronic cholecystitis as a good example of chronic inflammation. But here's another good one, and that's the granuloma. When you talk about granulomas, there is no such thing as an acute granuloma. It's going to be, maybe that needs a little, I can't focus from up here. Can you see if you can get that bottom one a little bit better than that? Or maybe it's just not good. That's good. Thanks. This is a granuloma. This is a portion of lung that was split in half like that, so that's one half of it, that's the other. And so this is caseous necrosis of someone with TB. I want to take you through the formation of a granuloma. They're easy to identify, guys. You don't have to be a pathologist to identify this. If it's roundish and pink, and the key thing, you see multinucleated giant cells, guys, it's a granuloma. Period. Don't even think twice. Now, I'm not going to say, what is this? That's one-step reasoning. They're going to say, what's the pathogenesis of this? The answer is type 4 hypersensitivity. Okay, delayed reaction hypersensitivity. So we need to know who the main actors are in that. But some of you may not realize that cytotoxic T cells, when they kill, let's say, neoplastic cells, or they kill virally infected cells, that's also type 4 hypersensitivity. There's no antibody involved in that, is there? So that's another type of type 4 that you oftentimes forget. You always think granulomas, type 4. Well, yeah, well, how is that going to explain poison ivy? Okay, poison ivy actually is a type 4 hypersensitivity reaction, not type 1. Okay? So those are examples of delayed reaction hypersensitivity. So here's the way it works. We use TB as an example. Drop with infection, you recall. The alveolar macrophage phagocytoses it. Nothing happens. The alveolar macrophage takes it on a tour all around the body. It's called the lymphohematogenous spread. Still no problem. It's kind of introducing a tuberculous organism. Saying, hey, you did some epididymis here. Would you like to come here? That looks pretty interesting, but no, I'll pass on that. So it kind of takes a little trip. But meanwhile, that little macrophage is doing what macrophages do best, processing antigen. It's been processing that TB organism, or whatever else it's been phagocytosis, processes antigen. Then after weeks or so, it presents it to who? A helper T cell. So the key actors in delayed reaction hypersensitivity are macrophages that process antigen, and then they're going to present that antigen via their class 2 antigen sites, they're going to present it to helper T cells. Now, helper T cells are going to release all those cytokines. The ones that are involved in this granuloma are gamma interferon and the macrophage inhibitory factor. There are other cytokines like interleukin-2 and other kinds of things that have different functions. But those, the ones that really are involved in granulomas, gamma interferon and macrophage inhibitory factor. The gamma interferon is going to activate the macrophage to kill the TB, the cryptococcus, the histoplasmosis, or whatever other types of things that macrophages normally kill. Okay? So it's the gamma interferon that actually is the trigger for the macrophage to kill those organisms. The macrophage by itself cannot kill it. But when it gets activated by gamma interferon, it does kill it. Okay? And since systemic fungi and mycobacterium have a lot of lipid in the cell wall, we get a caseous necrosis. Now all these pink staining cells that you see here are epithelioid. Remember that term oid means looks like but isn't. They're not epithelial cells, they're activated macrophages. So an epithelioid cell is an activated macrophage. It's been activated by gamma interferon. When they die in style. They basically fuse together and they form multinucleated giant cells. It's kind of like their gravestone, in a sense. That's the way I look at it. Also helps us dumb pathologists to recognize it's a granuloma. We see them, you know. Oh, there's one, okay, but it's granuloma. Okay, all right. And so those are also just fused epithelioid cells, macrophages. A lot of also the black dots that aren't pink would be the helper T cells in it. So the two main actors in a granuloma are helper T cells, CD4, and macrophages. Now, the first part of the story here, in terms of there's two subsets of helper T cells. There's subset 1 and subset 2. Subset 1 is involved in type 4 in this type of hypersensitivity reaction. Macrophages have an interleukin called interleukin 12. And when a macrophage secretes interleukin 12, it causes the subset 1 helper T cells, it activates, it presents the antigen to them. Okay? And so what they turn out to be the subset 1 CD4 helper T cells, they become the memory T cells of the event. They're the only ones that can retain memory of this thing. It's interleukin 12 that actually made that connection with the memory of the antigen experience with that particular subset. Okay, and that's how there's memory of the fact that you have been presented with TB at some time in your life. The subset 1 helper T cells that are involved in that. Interleukin 12 was important in that reaction. Okay, so most people in after their first primary disease usually recover with no problem. And they get these granulomas, oftentimes become calcified dystrophically. You can see them on X-ray. But don't be fooled. like I was at one time, thinking that a calcified granuloma and someone with TB, everything has to be dead in it. And I even decalcified it for 3 months in this decalcifying solution, formalin, and I cut through it eventually. I said, there's no way I can. You look at all those cases with cirrhosis, they must be dead as a doornail, and I converted. I mean, that doesn't mean religiously. I mean, I had a TB conversion. Okay, so they are incredibly resistant to dying. That's why most cases of the secondary TB are reactivation TB. They're reactivation of TB that was already there, and some of those calcified granulomas you still have hanging around there. So most is reactivation. So let's explain the positive PPD then. Okay, how does that work? That's purified protein derivative. Okay, so you inject it into the skin. A little bit of this purified protein derivative. Now, who is the histiocyte or the macrophage of the skin? What's the name of that cell? Langerhans cell. Basically a histiocyte. So what's their marker? Cluster designation 1. All histiocytes, macrophages are cluster designation 1. Those are Langerhans cells, those dudes that have Burbick granules that look like tennis rackets on electron microscopy. They are the macrophage histiocyte of the skin. So they phagocytose that purified protein derivative, okay? And they process it very quickly, actually. And who do you think they're going to present it to? They're going to present it to that helper subset 1 that has memory of previous exposure to that protein in the wall of the mycobacterium. And so it hooks in by class 2 antigen sites, as all immune cells do. And once it gets presented with this purified protein derivative that's been processed now by the Langerhans cell, the helper T cell releases cytokines, producing the inflammatory reaction with the induration, which we call a positive PPD. Okay, so that's how a positive PPD works. A good correlation with this thing would be, what about older people? Well, older people usually don't host a very good type 4 hypersensitivity. And so oftentimes they have less of a brisk response to PPD. And sometimes you have to actually do a double type of PPD testing on them. So they have a less of an immune response. What about a patient with AIDS? Well, isn't it the helper T cell? That's the main thing that's decreasing, huh? So they may not get any reaction, and yet be basically a culture medium for the organism. Would a person with AIDS have a granuloma in tissue? It's impossible. It's impossible. There's no helper T cells. There's not enough of them to be able to form this granuloma. That macrophage inhibitory factor, which I didn't mention, actually keeps the macrophages in that area. That's why you get a very localized granuloma. And so when you got HIV and your helper T cell counts decrease, you don't form granulomas at all. And that's why you have basically TB organisms, mycobacteria, maybe intracellular, even more common than MTB, all over the body. No granulomas. No granulomas. That's because the helper T cells are decreased. When you do PPDs on them, you accept 5 millimeters. There's enough to cause, if you got a 5 millimeters in duration, that's enough to say it's positive, because that would be a pretty good immune response for a patient that's HIV positive to PPD. Okay, so I just wanted to mention those little corollaries with this. So you must know how a granuloma forms, and what I told you is the way it works. And a positive PPD, you need to know how that one works too. Okay, reactions to injury, hearts. Unfortunately, its reaction to injury, since it's permanent tissue, is scar tissue. Does scar tissue contract? No. So the more damage you have to your free wall of your left ventricle, what do you think is going to happen to the ejection fraction? That's your stroke volume divided by end-diastolic volume. Goes down, because fibrous tissue doesn't contract. There's some stuff happening now where they can get cardiac muscle tube go into the cell cycle and divide, and that's pretty cool stuff. They found something that's beginning to work on that, so we may have something that will prevent that from happening in the reasonably near future. Kidney, how does that react to injury? Same thing. It's going to form scar tissue. If I had to ask you which part of the kidney is most susceptible to, let's say, ischemia, what would you say? Medulla. And if I ask you what specific parts of the nephron, you had renal physiology, what's the most susceptible part of the nephron to tissue hypoxia? I'll give you, what do you think? Well, actually 2 places. Probably numero uno is the straight portion of the proximal tubule. Why? Because most of the oxidative metabolism is located in that. That's the part that has the little brush borders and all that stuff. That's where most of the reabsorption of sodium and, the reclaiming of bicarbonate, all those different things, the proximal tubule does, just about everything, is in that straight portion of the proximal tubule. That's considered the most susceptible. A close second, however,
is the medullary segment of the thick ascending limb. I'll show you a picture of a nephron somewhere down the pike this afternoon. That's where the sodium-potassium 2-chloride co-transport pump is, where Lasix, loop diuretics block. Okay? That area, that thick ascending limb in the medullary segment, is supposed to be a very close second for getting destroyed in tissue hypoxia. So the straight portion of the proximal tubule is number one, and the thick ascending limb, medullary segment, where that very, very important pump, the sodium-potassium 2-chloride co-transport pump, is located. Just for fun. You had renal fizz, yes? What's the pump do? Generates free water, guys. Free water. Remember, in your urine you have two kinds of water, obligated and free. Obligated means it's obligated to go out with every sodium, every chloride, every potassium. That's basically 20 mLs of water has to go out with every sodium. We're not birds. That just has, concentrated urea. That's it. Okay, can you imagine a bird that had actual urine? Okay, would have a tough time flying up there with a full bladder. Okay? Okay, so it just kind of concentrates it down. You don't need any free water. But we do. Because that's the only thing that antidiuretic hormone can reabsorb or get rid of. It's free water, not obligated water. And that pump generates free water. So if I just for fun, just to make sure that you understand this concept, this is all I'm going to even talk about this, because I get the feeling that you didn't know that, some of you. Free water is a very important concept, guys. And I don't have time to go over that aspect and path, because I got other things even more important than that. I already told you need 20 mLs. You get of obligated water for every sodium, every chloride, and every potassium. It's obligated. So how do you think you're going to generate water that isn't obligated? Well, you're going to take the sodium and the potassium and the chloride away from its obligated water. And that pump does it. A sodium potassium 2-chloride co-transport pump. Okay, I just reabsorbed one sodium. How much free water did I leave behind in the urine now? 20. I just reabsorbed one potassium. How much more do I have now? Another 20. I'm up to 40. I just reabsorbed 2 chlorides. How much do I have there? 40. So how much, by reabsorbing a sodium, potassium, and 2 chlorides, remember they balance each other in charge. You got 2 positives and 2 negatives with the chloride. How much free water did I generate? 80. That's how it does it. And that's the pump. That's the pump that Lasix blocks. And that's in the thick ascending limb medullary segment. I'll show you a picture. You have one in your notes, not in the path notes, but in the physiology notes. I go through renal fizz, because that's the part that students have trouble with. All right. Lung. Who's the repair cell of the lung? The type 2 pneumocyte. They can even repair type 1s and replace them. What is its other function, please? It synthesizes surfactant. Very good. That's the type 2 pneumocyte. So that's the repair cell of the lung. Central nervous system. The astrocyte. The astrocyte proliferates because it is a stable cell. It's not a neuron. It can proliferate, and it produces the increase in their protoplasmic processes. That's called gliosis. And that's the reaction to injury in the brain. It's an astrocyte proliferation, kind of analogous to the fibroblast laying down type 3 collagen in the wound. Okay? The astrocyte just proliferates, and so it has more of these little processes that stick out. And that's its reaction to injury, is that one. And then the peripheral nervous system, and this you'll have to do on your own, Wallerian degeneration. Big time board question, guys. You cut a nerve in half, what happens? What's the role of the Schwann cell and all that kind of stuff? That's stuff you should have had with some other lecturer during your board reviews. If you didn't get it, it's right there at the end of that chapter, the mechanism of how an axon regenerates itself. It's called Wallerian degeneration, when you cut a big nerve in half. So that's the reaction of the peripheral nervous system. Just for fun, common board question. What is the analogous cell in the central nervous system to the Schwann cell? The oligodendrocyte. What do they both have in common? They both make myelin. Schwann cell in the peripheral nervous system, oligodendrocyte, central nervous system. Very good. Anybody know a tumor of the Schwann cell? Schwannoma. Okay, what's another name for that if it involves the 8th nerve? Acoustic neuroma. Very good. And what genetic disease, which is autosomal dominant, has an association with them? Neurofibromatosis. Very good. Are we sharp in this room? Say yes. All right. Okay? Don't say, no, I don't know the answers to these things. Well, now you do. Okay? Look at it in a positive thing, not a negative way. There's a lot of things you don't know. There's a lot of things I don't know. I learn something new every day. And things I should know, I forget. Not good. But, so, just don't get down on yourself. Just say, hey, didn't know it, now I do. And the more you can, reinforce it by going over stuff, the more it's in your head. The less you reinforce it, it's gone. It is off in space. Okay? That's how some of you are getting a look towards the end of this morning session. This afternoon will be even worse. That's why I've had 10 salon injections put into each seat. When both eyelids droop, you're going to feel a little sharp prick in your little buttocks. Okay? And your myasthenic crisis will have ended as we increase the acetylcholine in your synapses of your eyelids. I just gave you the whole concept of myosin. Isn't that cool? All right. Even my jokes have something to learn from. Okay, sed rate, erythrocyte sedimentation rate, the most worthless test there is, and yet one of the most common ones ordered, and it means absolutely nothing. What it is putting blood, whole blood, into a little cylinder that's kind of perpendicular to a flat surface there, and you see how many millimeters in an hour it settles, the red blood cells settle. I think it's pretty clear that if they're stuck together like this, anybody know what that's called when it looks like coins? Rouleau. Or if they're aggregated together like this, I think maybe the weight when the density is greater, and therefore I would expect those to settle pretty quick, and we'd have an increased sed rate. What? Yeah. Okay, so what's the cause of this? Well, an increase in IgG and or fibrinogen. Well, that includes every acute and chronic inflammation that exists. Okay? Now, what causes RBCs not to rouleau, but kind of stick together in clumps? Well, IgM. Because there's a negative charge that normally keeps RBCs from sticking to each other. And so there has to be some kind of thing that has so big that it can offset that negative charge that repels RBCs from normally sticking to each other. That would be IgM. And you learned in immunology that was a cold or warm reacting antibody, please? Cold. So when we talk about cold agglutinins, what are we talking about? IgM antibodies. Okay? And they commonly produce that, agglutination. That's why in cold weather, you can get Raynaud's phenomenon. You go outside and your nose turns blue, your ears turn blue, the tips of your fingers turn blue, and you come inside and it goes away. If that doesn't mean cold something, then there's something wrong with the synapses going on in one's brain. You go out in the cold, you turn blue. You come in and you're warm, you turn pink. So obviously, there's some kind of cold reacting something doing that. Well, one of them could be an IgM antibody producing cold agglutinins like this, causing these RBCs to agglutinate in your digital vessels in your little nose and your ears, and so you're getting ischemia to those areas. Then you go inside and it warms up and they fall apart because once you get your blood's warmed up a little bit, IgM can't work, it falls off. Okay, and this goes away. It can also be cryoglobulins. These are weird types of globulins that have nothing to do with IgM that congeal they're in the plasma that congeal in cold weather. So cryoglobulins can also produce that kind of symptomatology. And of course, both of these have been on board with that scenario. IgM antibodies can do the scenario I just gave you, so could cryoglobulins. What letter does that begin with? C. What hepatitis begins with C? C. So, okay, there's a high association with hepatitis C with cryoglobulins. Very good. Okay. Sometimes I have to really coax you into getting the answer to this. So both of these things increase the sedimentation rate. Which one do you think it would be? This one on your right or this one on the left with multiple myeloma? Left, because that's IgG most of the time. Which about Waldenstrom's macroglobulinemia? Let's say macroglobulin. IgM. So is that going to be the one on the left or the one on the right? Right. Okay, because it's IgM. That's increasing Waldenstrom's macro. Macro begins with M. That's the main immunoglobulin. IgM. So you get more of this. Whereas the multiple myeloma, which is most commonly IgG, you get that. Okay. All these increase the sed rate. Totally worthless test, though. Oh, we can do the rest of the stuff. If I had acute appendicitis, which you don't, thank God, you get a CBC, complete blood cell count. What do you expect? You want to see what? Give me words. I want to see absolute neutrophilic leukocytosis. Good. What does that mean? Oh no. There's something absolute. Very good. Okay. What it means is that you truly have an increase in the number of neutrophils in your peripheral blood. Okay. You have more in there out there than normal. Okay? What else are you looking for? Toxic granulation. Okay? Well, that's a subjective thing. I can tell you the granules in these neutrophils is way more granules than they should be, more azurophilic granules than they should be. Okay? We'll tell you why in a second. What else do you want to see? Left shift. What does left shift mean? Okay? Well, assuming that you start from a myeloblast on the left, and that eventually, through a series of divisions, forms a segmented neutrophil on your right, we normally go from left to right in maturation. So when we do left shift, it means that we go back to immature neutrophils. And the definition is greater than 10% banned neutrophils, otherwise known as stats, is considered left shift. Every one of these neutrophils is a band. That one is, and that one is. If you had greater than 10% of 100 cells, by definition, that would be left shifted. If you even had one metamyelocyte or one myelocyte, that's automatically left shifted. Forget the bands. Okay, so what we in review see in acute inflammation, let's say acute appendicitis, is an absolute increase in neutrophils with toxic granulation and left shift. Left shift, those are the key things that we see. Now guys, what did we say was the most potent system for killing bugs? Say it. Oxygen-dependent myeloperoxidase system. Where did I tell you myeloperoxidase is located, please? In the azurophilic granules, those little red granules, which are what, please? The lysosomes. Wouldn't you like to have a lot of those around if you had an acute inflammatory reaction? Because that means we'd have more myeloperoxidase around to kill the bugs. Is that correct? That's what toxic granulation is. It's ensuring that we have enough myeloperoxidase around to work that most potent system we have to kill bugs, the oxygen-dependent myeloperoxidase system. So it makes more of them, and that's what we call toxic granulation. Dolly bodies, forget. They're totally worthless. These are Dolly bodies if you're interested. Done with inflammation, guys. We're on fluid and hemodynamics. Hope you had good renal fizz. Very important. I put a lot of my renal fizz notes in the physiology high yield. So if you're weak on it, that'll make you strong. If you're weak on immunology, just taking a look in the high yields microbiology. I took the best of my immunology kind of notes that I made for myself, and I stuck them in there. And everything about HIV you need to know is there. Okay? Everything that's on boards. It's all still there. So high yield, very important for you. The kind of like the clinical aspects of some of the things that you learned that we don't have enough time in pathology to cover all of those as well. First thing I'm going to do is going to play a little game here between transidate, exudate, increased vessel permeability, and lymphedema. So the term that we're going to be using here and defining is edema. What is it? It's excess fluid in the interstitial space. So what compartment is that? Extracellular or intracellular? Extracellular. Is it within a vessel or outside a vessel? Outside the vessel. That's the interstitial space, and there's excess fluid in there. That's called edema. Now, some edema is pitting. Some edema is non-pitting. Okay. Which one pits? Does increased vessel permeability with pus in the interstitial space, which is edema, does that pit? No. Okay. Would fluid, a transidate, someone with right heart failure, you see swelling of the lower extremities, there's fluid in the interstitial space there, would that pit? Yes. So exudates don't pit, transidates do pit. How about lymphatic fluid? You block the lymphatics and there's lymphatic fluid in your interstitial space. Does that pit? Early on it does, but after a while, no. So basically it's non-pitting. So the three things that produce edema are transidates, exudates, and lymphedema. Those are fluids in the interstitial space. And it's only the transidates that can produce pitting edema. The other ones are non-pitting. Now let's talk about transidates because they deal with Starling's forces. This guy Starling must have been important because it's the same dude that did Frank Starling that Pastor will teach you when he comes back to teach his cardiovascular next Monday, a week from today, because of that feigned sickness he had. Okay? And he will teach you about Frank Starling. That Starling is the same one that produces Starling forces, which talks about those forces that keep fluids in our blood vessels and those things that try to push it out. What keeps fluids in our blood vessels? Albumin. We call that oncotic pressure. So 80% of the oncotic pressure is related to our serum albumin concentration. So anytime we have hypoalbuminemia, then we would have leaking of a transudate, a protein poor less than 3 gram per deciliter, cell poor fluid, probably through capillaries and venules. So just leak out into the interstitial space, and that would be pitting edema. Now what's normally in our vessels trying to push fluid out? Hydrostatic pressure. Okay, so who's normally winning in a normal person in our blood vessels? Oncotic pressure is winning over hydrostatic pressure, or we would all be squishing our way down these stairs with dependent pitting edema, which mainly would be in your butts from sitting here all that time. Okay, of course if you did yoga, it'd be in your head. Okay, whatever part's dependent gets the fluid. Okay, that's all I can tell you. So what could produce transudate, protein-poor, cell-poor fluid on our interstitial space? A decrease in oncotic pressure and an increase in hydrostatic pressure. That's the concept. We're with each other. Yes or no? Okay, let's brainstorm albumin. Okay, what does it make? Liver. So you think you got chronic liver disease, you got low albumin, yes or no? There's one cause. Okay, can we get rid of it in any part of our body? Just think of all your orifices. Can you vomit it out in significant amounts? No. Can you poo it out? Sure, it's called malabsorption. Can you pee it out? Sure, it's called nephrotic syndrome. Can it come off our skin? Sure, third-degree burn. Basically lose plasma. Okay, what's another possibility for a low protein count? We already saw one. Little kid with fatty liver. Kwashiorkor, we decrease our protein intake. Will that lower our albumin level? Yes or no? See, I did it in a logical fashion. I did it in a way where I was just asking myself questions about albumin. Where does it make? Liver. Okay, cirrhosis. Low. Can I excrete it anywhere? Okay, I can't sweat it out now, but I can have a third-degree burn. It can lose plasma. Yeah. Can I poo it out? Sure, it's malabsorption, lose protein. Okay, how about intake problems? Yeah, kwashiorkor. And how about can I pee it out? Sure, it's called nephrotic syndrome. I mean, there's no memorization involved at all. All it is thinking. Okay? Having it down, you've got to know the normal first before you can know the abnormal. You don't know the normal, how can you know the abnormal? You can't. All you can do is memorize it. That doesn't mean a hell of beans when a patient comes in because they don't have a question stamped on their forehead. I have A, B, C, D, E. Okay? The stem of the question, of course, is the chief complaint. The A, B, C, D, E is your history, physical, and laboratory tests. It makes it a lot tougher than a USMLE Step 1 exam. And memorization will not help you one iota. You have to be thinking doctors. Okay, so here we go. Are we ready to think? So yes. But I'm so tired from eating. Well, that's your problem. You do know why you're tired? Because you're an alkaline tide. Because for every hydrogen that went into your stomach to make hydrochloric acid while you were thinking about food at around 11 o'clock. That was the cephalic phase of digestion at vagus nerve, as you know, which stimulates directly parietal cells and gastrin-secreting cells, G cells. Every hydrogen that went into your stomach combined with chloride was a bicarb in your blood. And so you had developed a little bit of metabolic alkalosis. Okay. Just from thinking about food. And then you had your gastric phase of digestion. Okay? And now you're in your process of reabsorbing the food that you ate. And those hydrogen ions in the food will be reabsorbed and reunite with their bicarb, and you'll no longer be in metabolic alkalosis. But right now, a good many of you are still in it. I can just see you yawning and this and that. Because what's the compensation for metabolic alkalosis, please? Respiratory acidosis. What happens in respiratory acidosis to your PO2? It goes down. And so you have two reasons for tissue hypoxia right now, and it's all physiologic. Uno, where's your curve, your oxygen dissociation curve? It's left shifted. Okay? And what's your compensation for your metabolic alkalosis, respiratory acidosis, or what's your PO2? Decrease. So when you have tissue hypoxia, do you get tired? Of course. So why did God do that to me? So that you would sit still, so that the nutrients that you just ate can be used to store in different tissues of your body for a rainy day, to help insulin do its job. That's why. If you're up there, after you ate, and all that ATP and all that stuff, you'd be using up the fuels that you should be storing. That's why God did that, not straight from Him. All right. So here we go. Get your hats on. You're already set. Big T right over there. You're all set. Okay, so you get the first one. No, I'm only kidding. Don't worry. A little click like this. You know what that was? Sphincter. All right. It's audible. It's always audible. When it's quick, fast, you can hear it. Well-trained ear can hear it. Okay, so here's a person that had a myocardial infarction 24 hours ago. He died, and this is his lung, and we have this fluid coming out. Okay? Transudate or exudate? Transudate. Okay? Mechanism. Decreased oncotic pressure, increased hydrostatic pressure. Which one? Increased hydrostatic pressure. Left heart failure or right heart failure? Left heart failure due to a myocardial infarction. So things backed up into the, what's behind the left heart? The lungs. So because the cardiac output decreased, the end diastolic volume and pressure in the left ventricle increases. And that pressure is transmitted back into the left atrium. What empties into the left atrium is the pulmonary vein. Normally it has an 8 millimeter hydrostatic pressure, and the oncotic pressure is 25. So the oncotic pressure is winning by 25 minus 8, 17. And as the hydrostatic pressure keeps on going up, as it backs up into the lung, all that blood, okay, then it eventually approaches the oncotic pressure, and you start leaking the transudate into the interstitial space, which activates your J receptors, and you're starting to get dyspnea, Carley's lines on an X-ray. And that's fluid in the interstitium. Then eventually it goes full-blown into your alveoli, pulmonary edema, which is what this is. Wow. Okay. This patient was envenomated by a bee sting on the arm, and this has happened to the face. Okay, exudate, transudate, lymphedema, what is it? It's an exudate, because this is what reaction? If the face swelled up with a bee sting over here, this is a anaphylactic reaction. So who's the main operator in this? Histamine. What type of hypersensitivity? 1. Increased vesicle permeability. There's an exudate here. That's what's causing its tissue swelling. Very good. First step in management. Airway. Next step. Fourth question. Okay, 1 to 1,000 aqueous epinephrine subcutaneously. Okay, they expect any second-year medical student to know that. So that was a board question. Okay. Oh, this is going to be a fun one. This patient has cirrhosis of the liver. Okay, there's pitting edema in those legs. There's ascites there. Let's start here. Mechanism, transudate or exudate? Transudate. Mechanisms. 2 answers. Decreased oncotic pressure. Why? Can't synthesize alveoli. What's the other one? Increased hydrostatic pressure. Why? Portal hypertension. Very good. Because you have cirrhosis of the liver and the portal vein empties into the liver, it can't. So the hydrostatic pressure increases in it, and it pushes the fluid out into the peritoneal cavity. So there's 2 mechanisms for the ascites. There's also one other one, that's an aldosterone, increasing aldosterone, reabsorbing salt and water. Okay, but here's pitting edema in the legs. I want the mechanism for that, please. Come on. Come on. Is it an increase in hydrostatic pressure? No. Is it a decrease in oncotic pressure? Yes. Okay, I'm changing the scenario. The patient that had left heart failure really didn't die. But then he started developing dependent pitting edema that looked like that. What would that mechanism be? Increase in hydrostatic pressure. When you're in right heart failure, then blood behind the failed right heart is your venous system. So isn't it interesting? These legs, depending on what the scenario was, has a different mechanism. If it's cirrhosis of the liver, then it's a decrease in oncotic pressure that did it. If it was a person with right heart failure, then it would be an increase in hydrostatic pressure that did it. Are you with me? This is boards. This is USMLE Step 1. That's where they ask these things. You guys seem to be handling it okay. You should start feeling good. I want to feel bad. Well, that's nice. You want to do that? That's just fine. You just feel bad. All right. This patient had a modified radical mastectomy on that breast, and then developed this non-pitting type of edema, diagnosis, lymphedema. This is the most common cause of lymphedema in this country. A lot of times in third world countries, it's Wucheria van Crossi and different parasitic worms that screw up your lymphatics. Don't forget lymphogranuloma venereum, guys and gals. That also produces lymphedema. Remember, that's a subtype of chlamydia trachomatis, and has this tendency of scarring tissue and lymphatics. And you can get lymphedema of the scrotum, you can get lymphedema of the vulva associated with that. You're aware of inflammatory carcinoma of the breast, the peau d'orange appearance of the breast. That's also an example of lymphedema too, because if you do a section to the breast and this terrible form of breast cancer, you'll see the dermal lymphatics plugged with tumor. And so what happens is the lymphatic fluid leaks out into the interstitium, and then the ligaments that hold the skin down, tether the skin down, and get this excess fluid in there, you get this dimpling effect that looks like the surface of an orange. That's lymphedema too. But the number one cause of lymphedema in this country is post-radical mastectomy, and believe it or not, you can run the risk of lymphangiosarcoma when you have chronic lymphedema of any extremity. So you can end up with a sarcoma from this too. This is a horrible thing. She has to hold her arm up on that hand because that probably weighs about 50 pounds. All that excess fluid in there. Not good. Not a good situation. Very hard to treat. Good. You did good. Now we'll see what you learned about renal fizz. Okay. All right. Well, ECF, ICF. Kind of a great name for a kid, you know. Sure. We can call them nephrotic, you know, that's what I say, nephrotic, get over here. Nephrotic, you go. Okay? ECF, over here. ICF, go. All right. ECF is extracellular fluid, 2 compartments, vascular, interstitial. Interstitial is 2/3 larger than the vascular. ICF stands for intracellular fluid compartment. It's 2/3 larger than the ECF. Okay, so want an integration on that? I'll give you one. You get 3, okay. How many liters of isotonic saline would you have to infuse in a patient to get 1 liter into the plasma? The answer is 3, because it's a 2/3, 1/3 relationship. You have to get 3 liters of isotonic saline, because 2 of those liters would end up in your interstitial space, and only 1 of them would end up in your vascular compartment. See, that's why, in order to keep a patient's blood pressure up when you're hypovolemic or for whatever reason, you need to really infuse the isotonic saline because it's not just staying in your vascular compartment. It's equilibrating with the interstitial fluid compartment. They actually asked that question on boards. Good question. Quite a lot of you. Okay. So that's an important concept that I want you to remember. Now, these diagrams over here are very commonly asked on boards, okay, in relationship to different fluid abnormalities, which we'll not go over, but I do have a question on it in my fluid and hemodynamics questions that you can fiddle with. Hopefully, it was discussed with you, but the height of the squares is the osmolality of the plasma. Okay, so the height of this is the normal osmolality of plasma, and the width of these things is the volume in each of these chambers. So in other words, if I had a low plasma osmolality, then the height of this thing would be lower than this over here. If I had an increase in the ECF compartment volume, then it would be expanded out that way. If I had an increase in ICF volume, it would be expanded out that way. So the x-axis is basically volume. The y-axis is plasma osmolality for these things. We'll see what that means in a second. Osmolality. Okay, what is it? It's a measure of solutes in a fluid. That's what the osmolality is. And they measure it by different kinds of ways that you don't need to know. When we talk about serum or plasma, the osmolality is actually mainly due to these 3 things that you see up here. Sodium, glucose, and blood urea nitrogen, otherwise known as BUN. All right? Now, they usually multiply sodium times 2. Why would they do that since it's only got 1 plus there? The answer is that's right, because it has chloride with it, and so it's 1 for the sodium, 1 for the chloride, and that's why they put 2. And we'll take off from there when you come back. That's if you come back. Okay? So let's off with the concept of osmolality. Forget, difference between osmolality, osmolarity. That's garbage stuff. So it's a measure of solutes in a fluid. So you can do a urine osmolality and be the solutes that are in urine. You can do plasma, solutes in plasma. Spinal fluid, whatever. Sweat, you can do it for that too. So it's 2 times the sodium. So let's say the normal sodium is 140, so we're up to 280. Ooh, that's high. Okay. Now your glucose is another one that's big, and we divide that by 18. So let's say normal glucose 100, 18, 100, roughly 5. That's not contributing a whole lot. Blood urea nitrogen. Who can tell me where the urea cycle is located? Liver. Part of it's in the cytosol, part of it's in the mitochondria. And what is it? Where did urea come from? Ammonia. Okay, that's how we get rid of ammonia. The end product of the urea cycle is urea, but it's ammonia that's fed into the system. So that's how we get rid of ammonia, which is of course very toxic. Okay, let's say the normal is about 12, 3 to 12, 4. So what is responsible for, in a normal person, our plasma osmolality? Sodium. Basically, the rule of thumb is you double the serum sodium and add 10. That would be roughly what the measured osmolality would be. All right, that's concept one. All right, now, two of these three things are limited to the ECF compartment. One of them, if it's increased, can equilibrate between the ECF and ICF across the cell membranes. Which one is that? Urea. So if urea is increased, that can equilibrate between the ECF and ICF, so there'll be an equal amount on both sides. Now I'm going somewhere with this, and it's the concept of osmosis. Okay? Because of the fact that sodium and glucose are limited to the ECF compartment, then changes in its concentration can result in the movement of water from where? From low to high or high to low? What is it? Low to high. Water will move from the lower side to the higher side. Just the opposite of diffusion. You better hope that we have diffusion going on in our lungs because you have 100 millimeters of mercury in the alveolar of oxygen, okay? And returning from your tissue, you got 40 PO2. So who's bigger, 100 or 40? 100, and so by the law of diffusion, oxygen moves through the interface and dissolves in your plasma to get it up to about 95. Okay? That's diffusion. Goes from high to low. But osmosis goes from low to high. Big time mistake oftentimes made by students. Okay, so let's see if you understand that. You have hyponatremia. Which way is water going to go? Is it going to go from the ICF into the ECF or ECF into the ICF? ECF into the ICF, because the lower part is in the ECF, hyponatremia. And so water goes into the ICF compartment, so it gets expanded by the law of osmosis. Now let's make believe the brain is a single cell, just for fun. So what would we see in the brain? Cerebral edema. Will we have mental status abnormalities? Sure. So signs and symptoms of hyponatremia would be mental status abnormalities by the law of osmosis. The intracellular fluid compartment of all the cells in the brain would be expanded. Okay, would be expanded. All right. How about if you had hypernatremia? Okay, which way is there a gradient now between the ECF and ICF when you have hypernatremia? Sure, which way is water going to move? Out of the ICF into the ECF. Okay, so what happens to the ICF compartment? It gets contracted. Okay, so make believe the brain, what's going to happen to all those cells in the intracellular compartment of the cells in the brain? Contracted. What kinds of symptoms will you get there? Small thoughts versus large thoughts. No, you're going to get mental status abnormalities. Okay? You're going to get mental status. So either way, when you have hypo or hypernatremia, you're going to get mental status. One from the brain being having too much water intracellularly, and the other too little. Okay. Now we don't have time to discuss this, nor is it on boards. The brain is very unique in that it can make idiogenic osmoles. It can actually, within a space of 48 to 72 hours, rehydrate itself anyway. So it's a very, very short-lived thing, but that's something that's not on board, not to worry about. All right, here we go. Let's say you have diabetic ketoacidosis. You've got 1,000 milligrams per cent blood sugar. Okay? So who's winning now is the king of osmosis, sodium or glucose? Because both glucose and sodium are limited to the ECF compartment. Now, some of you are still thinking, maybe. Maybe not. You're saying, Dr. Goljan, I never heard of glycolysis. Glycolysis occurs in the cytosol. So glucose is in the intracellular fluid compartment. No, it ain't. What does glucose always go in with? Phosphorus. Because you know all sugars are phosphorylated to trap them in there. So glucose immediately becomes glucose 6-phosphate and is immediately metabolized. Same thing with fructose, but that's fructose 1-phosphate. Same thing is true with galactose, but that's galactose 1-phosphate. It's metabolized immediately. So there is no glucose in fructose and galactose per se intracellularly. Okay, so which way is water going to move? Come on. Hyperglycemia, 1,000 milligrams. Come on. From ICF to ECF. Okay, so this is my ECF compartment. Normally has 140 milliequivalents of sodium in here. I'm adding pure water into this cup, and that water is coming from the ICF compartment. What happens to my serum sodium concentration? It goes down. That's called dilutional hyponatremia, and that's as far as you need to go for part one. Okay, to know what happens to the serum sodium when you have hyperglycemia. Okay, part two, I would have taught you a little further, but we don't have to. By the way, these notes are very good for part two. Very good for part two. So you're getting 2 for 1, actually. Okay, they're very good for part two, especially the system stuff. Okay, so that's cool. So the two things that control water movements in the ECF compartment are sodium and glucose. But in a normal situation, who's the one? Sodium. Very good. Very good. Urea doesn't control water movements because it's permeable. It can go through both compartments and establish an equal concentration on both sides. So let's get into the concept now. I think the next slide is tonicity. Tonicity. We have isotonic state, we have a hypotonic state, and we have a hypertonic state. Okay, what does this all mean? Okay, well, we have isotonic saline, don't we? We have hypotonic salines, like half normal saline, quarter normal saline. We have 0.05% dextrose in water. We even have hypertonic saline. We have 3%, we have 5%. Anybody know what percent normal saline is? 0.9%, okay? So we're referring to tonicity in terms of what the normal tonicity of our plasma is, which is basically controlled by your serum sodium, as you know. Okay. So, these are the three types of tonicity: isotonic, hypotonic, and hypertonic condition. Now, I'll just at this point mention the fact that when we do the serum sodium concentration in the laboratory, actually, it is a reflection of your total body sodium divided by your total body water. Now, most of you have never heard of this thing, but it is a valid concept. Okay, and this is very important for you to understand. Why? Because most of you, if I said if you had hypernatremia, would say that means your total body sodium must be increased, because if you have an increase in serum sodium, that means your overall total body sodium is increased. I can make a hypernatremia and have a normal total body sodium by losing total body water. If I decrease that, what would that do to the serum sodium concentration? It increase it. See, most of you would have thought that. But it's really a ratio of total body sodium to total body water. Now, I will show you how you determine total body sodium. It's not measured by any standard way of measuring. It's clinical exam that determines your total body sodium. Serum sodium, they just measure in plasma and serum. Okay, so that's easy to determine. So we'll go back to that concept. But here's the concept we want to get now. We have different kinds of fluid abnormalities where we can lose a certain tonicity of fluid, or we can gain a certain tonicity of fluid. And they just go berserk on this on boards. And so you need to know what they mean by these things. So when they talk about you have an isotonic loss of fluid, okay, what would they really mean by that? Well, we look at this ratio up here, the total body sodium and total body water. What it basically means is you're losing equal amounts of salt and water. Is that what an isotonic loss of fluid would be? Yes or no? Okay. And where would this fluid be? This isotonic fluid, would it be in your ECF and ICF compartment, or are we talking about mainly you'd be losing it from the ECF compartment? ECF. Very good. Okay, but what would your serum sodium concentration be if you lost isotonic fluid? Normal. Okay, very good. And what would your ECF compartment look like if you lost isotonic fluid from there? Contracted. But would you have an osmotic gradient for water movement into the ICF or out of it? No. Anybody want to know, or anybody know a clinical condition where you can get an isotonic loss of fluid? Oh, that's good. Very good. Hemorrhage would be good. What else? Diarrhea. Adult diarrhea. It's usually isotonic. Usually isotonic. Okay, good. Now, if we have an isotonic gain, that means we gain an equal amount of salt and water. Could anyone think of a cause of that? Someone getting too much isotonic or normal saline. Okay? Instead of 3 liters, which is what you thought you put down there, you wrote 8. Okay? And they gave 8 liters of isotonic saline. And what would your serum sodium be? Totally normal, because there's equal amount of salt and water there. But where would all that excess isotonic saline be? What compartment? The ECF compartment. Would there be any osmotic gradient for water movement? No. How about some hypotonic solutions? Well, by definition, that means hyponatremia. I mean, hypoglycemia is not going to produce a hypotonic condition because, remember, it was glucose divided by 18. I mean, you can have a 40 blood glucose, 18 in the 40 is going to, like, I mean, that would be like if you're peeing into the Atlantic Ocean, is it going to turn yellow when you pee into it? No. Okay? It's not going to do anything. Unless they added a dye to it, okay, and then you did pee into the water, it would change color. Okay, so that's nothing. So in other words, the most common cause of a low osmolality in plasma is hyponatremia. Natremia. Okay, so how can we get a decrease in serum sodium or a hypotonic condition? Well, what if we lost more salt than water? Okay, if we lost more salt than water, what would the serum sodium be? Come on, be decreased. Okay, so how would you define that type of solution where you're losing more salt than water? Would that be a hypotonic loss of fluid, an isotonic loss of fluid, or a hypertonic loss of fluid? Ooh. And where's the main place we deal with sodium, please? To get rid of it or gain it back? The kidney. So this would have to be something involving the kidney. How about a diuretic? Do you think when you give a patient a diuretic, like a thiazide or a loop diuretic, what do you think the tonicity of that fluid is that you lose in the urine? Hypertonic. And so that's why you end up with hyponatremia and a hypotonic condition. What's your ICF compartment look like now? If you have hyponatremia, which way does water move? Come on, into the ICF compartment. There you go. Very good, okay? How about this situation? You just gain pure water, but no salt at all. Okay, what would that do? Well, that really lowers your serum sodium. You're just gaining pure water. Okay. What do you think would be the most common cause of that? Gaining pure water, no salt. How about inappropriate ADH syndrome? Anybody know some kind of cancer that secretes ADH? Called small cell carcinoma of the lung. They don't use the term oat anymore. That's an older term now. We use the term small cell carcinoma. They don't use oat because it sounds like food. Okay, and so they don't use, the foods describing things anymore. Okay, would you gain pure water? Sure, because you learned in renal physiology that ADH renders the distal collecting and collecting tubule permeable to water. What water? Free water. And so if this ADH is present 24 hours a day, 7 days a week, you're going to be reabsorbing all that water back into your ECF compartment, diluting down your serum sodium, okay? And what would you be doing to the ECF compartment by gaining all this water? Expand it. And then what else are you going to be doing to your ICF compartment? Expanding it. So you're both ways you're expanded. Whoop, that way. Okay. Talk about mental status abnormalities. You know what that means? If I had a small cell carcinoma, what have I been drinking? Water. I would lose none of this water in my urine. Why? It'd all be sucked out before it even got to the toilet bowl via the ADH. So the more water I drank, the lower my serum sodium. So what would be the treatment of choice for inappropriate ADH? Restrict water. Why don't we restrict salt? Why would you want to do that? Your total body sodium is normal. The problem is you're waterlogged. ADH is there, and you're constantly reabsorbing water. Can you put that into a term, a normal physiologic term? Is that dilution or concentration? When ADH is present, come on, when ADH is present, are you going to be diluting your urine, or are you going to be concentrating your urine? There you go, you're going to concentrate your urine, because you're taking free water out of the urine and concentrating it. So when you have inappropriate ADH syndrome, you are always concentrating your urine. When ADH is absent, then what happens? I lose that free water and I dilute my urine. So I've been going to the bathroom, and for all this free water that I've been drinking, I've been peeing it back out because my ADH is suppressed, thank God. But if I had inappropriate ADH syndrome, all this water would stay in my ECF compartment and by osmosis also move into my ICF compartment. The lowest serum sodiums you will ever see are inappropriate ADH. In fact, I'm going to give you a pearl. On a board exam, part 1, 2, or 3, serum sodium less than 120, it's always inappropriate ADH is the answer. Always. Lowest, has anyone seen a serum sodium in a live patient less than 100 in this room? I saw one that was 86 at Reading Hospital, Reading, Pennsylvania, not too far from here. 86, alive. So I knew immediately when I was called down as an intern, it was inappropriate ADH. It was just a question of what caused it. And she wasn't a smoker. So she didn't have a small cell carcinoma, so I had to think about medications that can increase ADH. And I found out she was a type 2 diabetic. Okay, yeah, that's right. She was on diabetes or chlorpropamide. And hopefully you learned from your pharmacology lectures that all oral sulfonylureas, particularly the first generation ones, 30% of the time produce inappropriate ADH. That's what she was on. Okay, so you got to expand your knowledge on inappropriate ADH syndrome beyond small cell cancers and also include drugs and oral sulfonylurea is a big time. We'll talk again about that when we do endocrine. the inappropriate ADH. We're just right now at this point just getting you a concept of tonicity. So here we would have a hypotonic gain of fluid if we were gaining pure water, agreed? Here we'd have a hypertonic loss of salt producing hyponatremia. Okay, here's a situation where you're gaining both water and salt. Ooh, but a little bit more water than salt. And you're still ending up with a hyponatremia. These are your edema states. Okay, your edema states, your kidney edema states. Right heart failure, cirrhosis of the liver, those kinds of things have this scenario where your kidneys are reabsorbing a little bit more water than salt. You end up with a hyponatremia, and you'll end up with pitting edema. I'll just spill the beans on this right now. Your total body sodium, when it's increased, always produces pitting edema. I'm going to ask you a question. What compartment is all the total body sodium in? Come on. BCF, okay, which one is the biggest compartment? So where is most of your total body sodium? If it was increased, where would most of it be? In your interstitial fluid compartment. And what does sodium always have along with it? I'll rest my case. Whenever you have an increase in total body sodium, most of it is in the interstitial space. That automatically will expand it with a transudate, and you will end up having pitting edema. Period. Okay, so this particular scenario is involved in heart failure, right heart failure, cirrhosis of the liver, this situation. See, just changing the ratios of these things by, hypertonic loss of salt, like in diuretics, you can get hyponatremia. Gain of pure water, inappropriate ADH, you get hyponatremia, a hypertonic condition. By gaining a little bit more water than salt, we can end up with hyponatremia, a hypotonic condition. Hypertonic state, by definition, means you have hypernatremia or what else? Hyperglycemia. So any patient that has diabetic ketoacidosis is by definition in a hypertonic condition. That's certainly more common than hypernatremia. That's very uncommon to see that. Okay, when you have hypernatremia, I want you to tell me, no matter what the cause of it is, what's your ICF compartment look like? Come on, take osmosis, come on. It's shrunken. There you go, very good. So it's always shrunk. So you're thinking small ideas when you have a hypertonic condition. And we can basically just very quickly do these things. You can gain a little bit more salt and water. That's commonly seen in primary aldosteronism. Okay, you can see that situation. Here we can just lose pure water. Well, when we gain pure water, what did we call that disease? Inappropriate ADH. But when we lose pure water, what do we call that disease? Diabetes insipidus. Very good. Whoa! This is so cool. Good. All right. And you can lose a little bit more water than salt in the urine. Okay? Mixture. Okay? And that's called osmotic diuresis. When you have glucose in the urine or mannitol in the urine, you lose a hypotonic salt solution in the urine. Now guess what baby diarrhea is? It's a hypotonic salt solution. Adult diarrhea is isotonic. Baby diarrhea is hypotonic. So if a baby had no access to water, what should a baby's serum sodium be if they had a rotavirus infection? Come on. It should be high. If you're losing more water than salt, you should have hypernatremia. But what do you think most mommies do that don't know dork about how to take care of the baby with diarrhea? Well, they give them water because the baby's going to be thirsty. So you're going to be filling in that denominator because the baby's getting water. And so that baby can come in maybe with a normal serum sodium, or in some cases, if the baby's really sucking on that water, you can even have hyponatremia because you're filling in the denominator. So I'm going to ask you a question. What should you give the baby if they're losing a hypotonic salt solution? It's called Pedialyte, guys. It's called Pedialyte. What do you think Pedialyte is? What do you think Gatorade is? They are hypotonic salt solutions. And they're basically replacing what you lost. If you're losing a hypotonic salt solution, that's what you're giving back. A hypotonic salt solution. Now here's another board question. You had physiology, is that correct? Well, some of you are a little worried about shaking your heads. Yes. Why? Because I'm going to ask you a question. What has to be in Pedialyte, what has to be in Gatorade for you to reabsorb that sodium in your GI tract? Very good. Why? The co-transport. Sodium has to be reabsorbed with glucose or galactose. Fructose doesn't facilitate its diffusion. That was a board question. I knew it was coming, and it came up in terms of cholera. They asked about, in the oral replacement Are patients with cholera, what has to be in that in order for sodium to be reabsorbed? And the answer is glucose. No glucose, no reabsorption of sodium because of the co-transport pump that you learned about in the small intestine. Now, I did check Gatorade. Gatorade has fructose. That's not going to help sodium reabsorption, but it has glucose. And it has sucrose in it, which is converted into two glucoses. No, glucose and a fructose. So that is worth getting. Some of these replenishment things don't have glucose in them. They're absolutely worthless. So you're drinking all this stuff, you're not getting any of the benefits from the salt in them. What do you think sweat is? What do you think the tonicity of sweat is? It's a hypotonic salt solution. So wouldn't that look like this? Sure. So what should you have if you were sweating, let's say on a hot day in a marathon run or something like that? What should you have when you cross the finishing line? Hypernatremia. Okay. Now you should know from all of these different scenarios, which are all in your notes, and I'm not going to be going through these things because I think it's more important to do answer dates with you, which is poorly taught usually by PhDs. So I'm going to do that, and you can go and learn the volume things. No, I can understand that. PhDs don't know clinical things. And acid base is clinical. They usually have it all screwed up. Okay, that's been my experience. I don't know who taught you acid. Hopefully they did know what they were talking about, but we'll do that. Okay, so these are the tonicity things. All right. Arterial blood volume. Now, I know that probably who would have done this? Pastor will do this, if he already hasn't started on it. Effective arterial blood volume is the same thing as stroke volume and cardiac output. So I just call it EABV, effective arterial blood volume. You must absolutely know, guys, when your cardiac output decreases, all the physiologic mechanisms that happen in your body to restore volume, because it's the most serious condition our body can happen. When we get hypovolemic, when we have a decrease in cardiac output, that means that oxygenated blood is not going to get to our tissue. We are going to die. And so volume is supreme in our bodies. Okay, volume is supreme in our bodies. It's absolutely essential. So we need to know what our body does before we get to it and screw it up, which is usually the case. Okay. Why do you think the death rate in hospitals increases after July 1st? Because of the new residents that come in. That's an absolute known fact that the first three, that is the worst time to ever go to the hospital. If you're a patient, never go to the hospital in the first 3 months after July. July, August, September, because they all die. Because what does a resident know? That's a person that just came out of medical school. What do they really know about things? Nothing. I didn't know dork. And I was on duty the first day in the Reading Hospital in Pennsylvania. I was on duty for medicine. Bad place to put me. Because yes, what did I pray that I would not have? Cardiorespiratory arrest. So there was one. Not only one, two. And I was on duty in the 700-bed hospital, me and a villa, the two of us. Same school, Temple Medical School, Philadelphia. That's where I went. Okay, what did I know about cardiorespiratory arrest? Nothing. I don't know how. Thank God for the nurses. What do I do now? You do this, doctor. What do I do now? You do this, doctor. Thank God for the nurses. Holy smokes. They both survived. They both survived. I didn't know anything. I even called up the Bella. Help me, you come with me. I know it's my turn, but come. What do we do now? We don't know. What do we know? Give him this, doctor. And give him this, doctor. Okay. Oh, jeez. After 3 months, though, after a number of those things, we finally figured it out, and then people started living. Okay? It was nice, because we're not supposed to do harm to patients, but not those first 3 months. It's horrible. This is the truth. You don't know anything. And not only that, you're responsible because you have an MD degree. It's horrible. Well, whatever. All right, now. We have baroreceptors. We have low-pressure ones and high-pressure ones. The low-pressure ones are on the venous side. The high-pressure ones are on the arterial side, like carotids and arches of the aorta. Okay, they're usually innervated by the 9th and 10th nerve, the high-pressure ones. Now, when you have a decrease in arterial blood volume, in other words, a decrease in stroke volume or cardiac output, you underfill the arch vessels and the carotid. And so instead of having a vagus and 10th nerve type of a response, 9th and 10th nerve response, you have a sympathetic nervous tissue response. So catecholamines are released. And we want catecholamines when our stroke volumes decrease, because what is it going to do to the venous system? Constrict it. You're going to get venoconstriction, which is going to increase blood returning to the right side of the heart. That's good. You want that. You certainly don't want venodilation, because that's going to pull it in your legs. Okay, what's it going to do to your heart with all those beta-adrenergic receptors? Increase the force of contraction. Great. That's going to increase my stroke volume a little bit, not much. Okay, but my systolic will go up a little bit, and increase my rate, my chronotropic part. My heart rate will increase. Both of those are good. Okay, right? What's going to happen to my arterioles on the systemic side? What's going to stimulate the beta receptors in the smooth muscle? Remember, what does your diastolic pressure really do to? It's really due to the amount of blood that's in your arterial system while your heart is filling up in diastole. Who controls the amount of blood that is in the arterial system when your heart is filling up in diastole? Your peripheral resistance arterioles are. That's what maintains your diastolic blood pressure. Whoa! So when they're constricted, then there's very little blood going to tissue. So yeah, the bad news is the tissues are not going to get a whole lot of blood. The good news is you're going to keep your diastolic pressure up. Well, why wouldn't that be good? When do your coronary arteries fill, guys? Diastole. So someone's got to get screwed when you're in a bad situation. Okay? So the peripheral resistance arterioles constrict. All of that's done by catecholamines without us even being there. And then for free, it stimulates the renin-angiotensin-aldosterone system sympathetically. So renin's going to be released. Angiotensin 2 is going to be present. What does angiotensin 2 do? It's a vasoconstrictor of the peripheral resistance arteriole, so it's helping along the catecholamines. And then angiotensin 2 stimulates 18-hydroxylase, which Dr. Porter taught you, converts corticosterone into aldosterone. Okay? That's what angiotensin 2 does. And it stimulates aldosterone release. What's aldosterone going to do for us in this situation? We absorb salt and water. That's the most important thing so far, salt and water, to get our cardiac output up. And aldosterone is doing that. So that's all catecholamines. And of course, if the stroke volumes decrease, then what's the renal blood flow to the kidneys? Decrease. Is that a stimulus also for the renin-angiotensin-aldosterone system? Sure. And where exactly are those the receptors for that, for the juxtaglomerular apparatus? Exactly where, please? The afferent arteriole. It has sensors in it. They're basically modified smooth muscle cells that sense blood flow. And so we're going to get a little help there. Antidiuretic hormone will be released. Now that's not so cool, because what's that going to contribute? Just pure water. Is that going to help my cardiac output to increase pure water, or do I want salt to increase my cardiac output? What do I want? Let me just ask you a question. If I was bleeding to death, let's say I cut my wrist here and I was bleeding to death out here and I lost 3 liters of fluid out there. Well, all of you are saying, get a doctor, and a lot of you are doctors. You'll be just milling around me watching me bleed to death. Okay? Meanwhile, you call 911, there's all these doctors in here. Okay? The pathologist is already going to put a Y-shaped incision on me already here. Okay? He's going to be just checking me out with a Y-shaped incision. Right? The rest of you would say, don't touch him, get him, 911. We might have germs. All right. So I'm dying. And finally they come. Okay? How are they going to keep my blood pressure up, guys? They don't have blood there. Normal saline. Normal saline is isotonic. And what compartment is it going to stay in? My ECF compartment. Basically, normal saline is plasma without the protein. That's basically what it is. Isn't it true that any time you have hypovolemic shock from any cause, you can keep the patient's blood pressure up with normal saline just fine? Because normal saline is what stays in your ECF compartment. You couldn't raise my blood pressure with half normal saline. You couldn't keep it up with 5% dextrose and water. It's worthless. To keep my blood pressure up, you have to give me something that resembles plasma and has the same tonicity as plasma. That's what normal saline is. 0.9%. That was actually on part 1, that question, too. So ADH will be released also. That's a nerve response. Okay, now, I hope you learned in renal physiology about peritubular capillary pressures. Not really. I bet you did. Okay, where did you learn where you reabsorb most sodium in your kidney, in your nephron? There we go. It's the proximal tubule. See, you learned something. 60 to 80% of sodium is reabsorbed in your proximal tubule. That's correct. Where's the rest of it reabsorbed? Distal and collecting tube by who? Aldosterone. Okay, so most of it went up the proximal tube. But here's what maybe some of you never think about, like me. That's why I learned about this. Reabsorb it into what? Peritubular capillaries. That's nice. But in order for them to reabsorb all that salt-containing fluid, or anything that it reabsorbs out of the proximal tubule, the Starling's forces in those peritubular capillaries have to be amenable to it. Right? So I'm going to ask you a question. You have two Starling's forces. You have oncotic pressure that likes to keep fluids in a vessel. You have hydrostatic pressure that pushes fluid out of the vessel. Is that correct? Okay. If your renal blood flow is decreased to your kidney, when your stroke volume and cardiac output is decreased, what happens to your peritubular capillary hydrostatic pressure? It decreases. So if that's decreasing, what's increasing? Your peritubular oncotic pressure, and that is what's responsible for you reabsorbing anything into your bloodstream from the kidney. Ooh. So that's why I have PO, oncotic pressure peritubular capillary, is greater than pH, hydrostatic pressure. That's what allows you to reabsorb all that salt-containing fluid from your proximal tubule back into your bloodstream. Okay? So if we add up all the types of fluids that the kidney is going to be reabsorbing in a patient that has a decrease in cardiac output, any cause you want that, cardiogenic shock, hypovolemic shock, I don't give a hoot and holler what it's causing. Okay? This happens automatically. Every patient. Okay? So, does anyone know what the tonicity of the fluid is that you reabsorb out of the proximal tubule, the salt? It's roughly isotonic. So that's good. That's just like giving normal saline. So let's put 2 or 3 liters of that in here. Okay, just this cup. That the proximal tubule is reabsorbing because the peritubular oncotic is greater than hydrostatic pressure. But what is ADA? What is aldosterone reabsorbing? What is aldosterone? From the renin-angiotensin, what is that reabsorbing? Roughly isotonic salt solution, but not near as much as the proximal tubule. So let's put a liter of that in there. Those are all very nice things to have in our bloodstream. But what's ADH contributing? Pure water. Ooh. So let's put 2 liters of pure water into this cup, the ECF compartment. So when you add that all up now, you have all this isotonic saline reabsorbed, but now you're adding pure water. What does the tonicity happen? It becomes a little bit hypotonic. So that's what the kidney normally reabsorbs back into our ECF compartment when we have a decrease in cardiac output. Okay? This is all must-know stuff, this stuff here, because this is normal physiologic response to a decrease in cardiac output. For many causes. Now, what if you had just the opposite? Your stroke volume was increased. Your arterial blood volume was increased. Okay? What would happen there? Well, just the absolute reverse. The baroreceptors are now going to be stretched. They're innervated by the 9th and 10th nerve, and so we're not going to get a sympathetic nervous system response. We're going to get a parasympathetic response. We're not going to have vasoconstriction and an increase in force of contraction of the heart or anything like that. The object is we're fluid overloaded, get rid of it. The renin-angiotensin aldosterone system is not going to be activated with increased renal blood flow. Now that's not going to be there. The ADH is not going to be invited because you have volume overload, it actually decreases its release. Your peritubular hydrostatic pressure in those capillaries is higher than oncotic pressure, so even if you reabsorb the salt, you were not able to reabsorb it back into your bloodstream because it wouldn't get in there, you'd pee it out. And so you will lose a hypotonic fluid in your urine when you have an increase in arterial blood volume. These are all normal things that you must know. What happens when you have a decrease in cardiac output, all the physiologic responses, what happens when you have an increase. There's also a certain hormone made in your left and right atrium that will be released if you have dilatation of right or left atrium. What is that? Atrial natriuretic peptide, and what is that going to get rid of? No, well, it'll cut off ADH, but what does it also get rid of? It's natriuretic, guys. Okay, it'll get rid of salt. This guy actually acts as a diuretic. Atrial natriuretic peptide is only released in volume overloaded states. It's not released when you have a hypovolemic condition. No way, Jose. It's only when those atrium, either right or left, are dilated with excess fluid. That's when it's released. So these are normal things that you need to know. Okay, here's a boy question for you. Problem, no, okay. Patient given 3% hypertonic saline. Then they had this little chart down here where they had P-osm on the y-axis and they had serum ADH on the x-axis. And they had these little dumb letters, A, B, C, and D. Okay, now in your book, I put a little square in the middle. That represents normal. Okay? All right, so 3% hypertonic saline. What would that do to the osmolality? What are you adding to the patient? A hypertonic salt solution. What has to happen to the osmolality? Increase. So you know the answer is either going to be B or C. You know that automatically. Okay? So, if you have an increase in P-osm, what would that do to the serum ADH? It increases it. Remember, an increase in osmolality of plasma or serum causes a release of ADH. Okay? So then we'd have to go over, well, ADH goes from low to high, and so C is the answer. And this was a board question. But because I'm so nice to you, I actually put what A and B and D would also be in a normal situation. Why? Because if they use this chart for that question, well, then they'll use this chart for diabetes insipidus. They'll use this chart for inappropriate ADH. Let's do inappropriate ADH. Okay. What's the plasma osmolality in inappropriate ADH syndrome? Low, so you know that it's either A or D. Okay. And what about ADH levels? High. So is it A or is it D is the answer? D. There you go. How about diabetes insipidus? That's no ADH. Okay? So what does that do to serum sodium? It goes high, so it's either going to be B or C. And what's the ADH levels? Low. So which answer is it? D is correct. Very good. See how easy this is? It is when you do it, but then I get it as a problem and I get all confused. Welcome to the club. Things not so simple. Then I get home after I got this and I look at it and what did he say? What did he say? I'm all confused. Okay? And then in your confusion, you try to read something, you get all anxious, all angry, and you get mad at yourself. Does that pretty well describe it? We're all there. We all had that problem. So get over it. If you understood it now, basically you do understand it. It's there. Trust me on that. All right, so here's this thing again, and I promised you that I would tell you how you can tell what the total body sodium is in the patient. Well, you're going to tell me. I'm going to show you two pictures. This person, I want you to look at the tongue. And this person, I want you to look at those indentations in the skin. Okay, what's the total body sodium in this patient with the dry tongue? Decreased. What's the total body sodium in that patient? High. Physical exam tells you. Mayo Clinic proceedings said it is a very accurate way of telling total body sodium. Physical exam. So what you call dehydration, you know about skin tugger? When you pinch the skin, okay, and it goes up and see how mine went down real easy? Do you know that when you pinched my skin like that and it went down, it says that my total body sodium is normal? You're basically testing what your total body sodium is in your interstitial space by pinching the skin. That's what skin tugger tells you. So that's very important to do, except that old people all have it, you know, so they want to use something like the chest or the back or something like that. And then looking in the mouth and looking at the mucous membranes. So all those things you know about for dehydration, if they're present, you can assume that total body sodium is decreased. If none of them are there, you can assume total body sodium is normal. If you have pitting edema, dependent pitting edema in a patient, total body sodium absolutely is increased. Absolutely, unequivocally. Okay? So that's how you can tell the total body sodium in a patient by physical examination. Very important. So I'm going to ask you just a couple of questions. If I had inappropriate ADH and I'm gaining pure water, what's my total body sodium? Normal. But what's my serum sodium concentration? Low. What would I have to restrict? Water, okay? I have right heart failure and I have dependent pitting edema like that dude on the right. Okay? What did I say was the fluid that the kidney reabsorbs when your cardiac output's decreased? Hypotonic salt solution, a little bit more water than salt. Put that into the serum sodium formula. A little bit more water than salt. Okay, what's your serum sodium going to be? Low. Okay, what's in the numerator? Was the numerator increased with total body sodium? Yes. But in the denominator, you had a greater increase in total body water. Is that correct? I'm going to ask you a simple question like they did on Part 1 boards. What's your non-pharmacologic treatment of any of the edema states, like heart failure and cirrhosis? Restrict salt, restrict water. What's your treatment for inappropriate ADH? Restrict water. What's your treatment for any pitting edema state? Restrict salt, restrict water. Correct. That's all you need to know for Part 1. Don't do that. You have to restrict salt and water. And what would your pharmacologic treatment be if you had a pitting edema state? Diuretics. That's going to help get rid of a little bit more of the salt and also lose some water at the same time. But your non-pharmacologic treatment is restrict salt, restrict water. Why? Because you know you have an increase in total body water, so you got to restrict water, and you have an increase in total body sodium, so you have to restrict sodium. It's just that simple, guys. It's just that simple. And it's good enough for part one to get a lot of questions right. Okay, that's enough on that. Shock. Some of you are in shock right now, so I don't even have to teach you about it. I mean, that's going to be just something. Well, let me see how I feel right now. I'm cold and clammy, da-da-da-da-da-da. All right. Can you give me some causes of hypovolemic shock just to make sure we're all talking in the same wavelength here? How about diarrhea? Could that produce diarrhea? Yeah, cholera produce hypovolemic shock. How about blood loss? Sure, that can do it. How about sweating? Oh, yeah, that can produce hypovolemic shock. How about diabetes insipidus? No. What are you losing? Pure water. What's your total body sodium? Normal. You are not in hypovolemic shock. You couldn't be in hypovolemic shock if your life depended on it. For losing pure water, you're going to feel sick. Oh, yeah. Because you're going to be shifting blood, fluid out of your ICF compartment. You're going to be thirsty as all get out. But you're not going to be hypovolemic because all you're losing is pure water. Where would you be losing most of that pure water from? The ICF compartment. You have a perfectly normal exam in a patient with diabetes insipidus. Is this going to be thirsty? You can't have it. You won't have no signs of dehydration whatsoever by losing just pure water. None. It's the salt that's important. You lose just a little bit of salt, and all of a sudden you are hypovolemic. Here's a test that they actually had on part one. Okay, make sure that you know this one because it was a sample question that the USMLE sent out, and I happened to answer it for Kaplan. Right at the answer. It was a young lady that had a hypovolemic shock, and they asked how you treated the patient. What would you treat her with? Okay, and here's what they put in the stem of the question, so you know they can ask it on part one because it was a sample question they've already given out. They said that when she was lying down, her blood pressure was normal and her pulse was normal. When they sat her up, the blood pressure went down and the pulse went up. What does that mean? That means they're volume depleted, guys. That's called the tilt test. You better know the tilt test. Why was the patient's blood pressure and pulse normal lying down? No effective gravity, guys. Okay, you're lying flat, and so you had a reasonable amount of blood returning to the right side of the heart and then left side of the heart, and it was able to maintain your cardiac output. Everything was fine. But when you sit the patient up, you decrease, by imposing gravity, you decrease the venous return to the right side of your heart. And so if you're hypovolemic, it'll show up by a decrease in blood pressure and an increase in pulse. All those things we just talked about when your cardiac output's decreased. And what was it due to? Catecholamine effect. Blood pressure went down, pulse went up. Or another way they could do it is they could say that you have, let's say, 100/80 blood pressure and a 110 pulse lying down. You sat them up, they get a 70/50 blood pressure, the pulse is 150. Is that a difference? What does it mean? It means you're severely hypovolemic. It's called the tilt test. That was actually in the stem of the question on a part one USMLE sample question. See, they give away ideas when they give out those sample things. Any good educator would know, what they think is important about something like that. Okay, what was your first step? In fact, the answer was, what they were asking was, how would you treat the patient? And they had half normal saline down there. They had normal saline down there. They had 5% dextrose and water and some other retarded things. What was the answer? Normal saline was the answer. Okay, so that was the answer to that one. So let's break for 10 minutes. Okay, let's start up again. Okay, let me just run a couple questions by you. Let me run a couple questions by you to make sure you understand something. I'll give you a personal example. My first marathon in San Diego. I didn't take any fluids the first 20 miles. None. Zip. I was feeling good. Felt good, and then I hit what they call the wall. That means zip glycogen in any part of your body. And it's like you're walking in slow motion. Okay, and it was a pretty warm day that day. And so I was losing a lot of sweat, okay? So what is the tonicity of sweat, please? Say hypotonic. Is it pure water or does it have salt in it? So it's a hypotonic salt solution. Is that correct? Okay. Now this didn't actually happen to me from this point on, but let's say it did. The first part was correct. Okay? I did finish the race. I walked in, and what do you think was the impetus for that? Was it the old man that ran by me? No. Was it the teenage that ran by me? No. So what was it that was able to get me the last 6 miles to the finishing line when I was in a state of complete hypovolemic shock? A woman ran by me. That is true. You can show she beat me. I said, oh, she's doing it. I can do it. You know, I finished in 3 hours and 30 minutes, and I walked the rest of the way from 20 miles to the other 6 miles. So you can imagine how fast I was running the first 20. What an idiot. Okay, so let's say I collapsed. You do a tilt test on me. I'm 100/80 lying down with a pulse of 120. You sit me up, I get a little woozy. I'm now 70/60, 150 pulse. Am I hypovolemic from my sweating? Yes or no? What's your first step in management? What are you going to infuse in me? You're going to stick an IV in me. What are you going to give me to get my blood pressure up? Normal saline. Okay, so you put a liter in. I'm still showing no signs. You put another liter in. My blood pressure is now normal. But I still have signs of volume depletion, dry mouth and stuff like that. I'm still not completely together. Okay? And so, what are you going to hang up now on me? Okay, you got my blood pressure stabilized. What did you say the tonicity of my fluid was that I was losing? Hypotonic salt solution. So what are you going to hang up on me as an IV? Hypotonic salt solution. Could you give me an example? You're going to give me 5% dextrose in water? No. Why? Because there's no salt in it. Are you going to give me half normal saline? Yes, you are. That's correct. So what's the maximum of fluid therapy when you lose something? Give the patient what they lost. If I lost a hypotonic salt solution, that's what you give me. But if I'm hypovolemic, what's the first thing you always start with? Normal saline. I'll give you another example. Diabetic ketoacidosis. Do you have osmotic diuresis going on? Yes or no? What did I say was the tonicity of the fluid that occurs that you lose in your urine when you have excess glucose in it? You have hypotonic fluid, a little bit more water than salt. Agreed? Okay, so anyone that's taking care of a DKA patient knows when they take a blood pressure on them, they are severely hypovolemic, and that's the thing that kills them. The high glucose is nothing. Nothing. Your first step in management is volume depletion. So they all have hypovolemia, and some of them are in hypovolemic shock from all that salt and water loss. So what's your first step in managing a patient with diabetic ketoacidosis? Normal saline. You put insulin in? No, that's worthless. You just give them normal saline. What's the purpose? Make them normal tensive. That may take liters. Usually you're out 6 to 8 liters of fluid when you have diabetic ketoacidosis. It may take 6, 7 liters of isotonic saline before that blood pressure starts stabilizing. Okay, now I'm feeling better. I've still got my 1,000 milligrams % glucose, but volume-wise, I'm fine now. Now what are you going to do? What am I losing in my urine, guys? More water than salt. What are you going to hang up now on me and put insulin into it? Normal saline? What am I losing in my urine, guys? Hypotonic salt. What are you going to hang up on me? Half normal saline, and what are you going to put into it? Glucose. Insulin. That's right. So the maximum is whenever you have you're hypovolemic, what's your first step in the management of the patient? Normal saline to get the blood pressure normal. Then you can decide if you still need to give IV fluids, then you have to decide, well, what caused the hypovolemia? Was it sweating? And you give me a hypotonic salt solution. Was it diarrhea and I'm an adult? Well, then I just stay with the normal saline because that's an isotonic salt that I'm losing. You understand? Let's say you had a patient with diabetes insipidus, okay, and for some reason you didn't know they had it, and they went through a long surgery, and they didn't have, okay, they probably ended up with a 160 serum sodium and all that stuff, okay, and they get out of surgery, you notice they got a 165 serum sodium, okay, and then you find out eventually that the patient has diabetes insipidus. How would you treat that? Let's say the blood pressure, let's say the patient's blood pressure and everything's stable, and the patient is lucid. What would you want to give them? Water. Well, let's say you couldn't, it was just too dangerous to do it. They could aspirate it after surgery. What would you do? What are they losing, guys? Pure water. What are you going to give them? Water. IV. And so, what are you going to probably put in the water? You're probably going to make it what? 5% dextrose in water. Okay? There's nobody that's just going to give them pure water, because when that patient looks at their bill, okay, and sees that they were given pure water IV, you know, $35. Yeah, they say, hey, I could have drank that, buddy. And so you get 5% dextrose and water. Whoa, I got something important. No, all you did was get 50 grams of glucose. Okay? They just give that to give you little carbs. So basically, you give the patient, if they have to get an IV and they have diabetes insipidus because they lost pure water, give them something close to pure water. 5% dextrose in water is close enough. You're certainly not going to give them half normal saline because they haven't lost salt. You're going to salt overload them. Okay, that's just, we're getting off the concept for part one. That's more part two-ish, but let's just stop there at that point. Okay, shock. Okay, we have 4 kinds of shock. Part two deals with neurogenic, and so we're not going to deal with that, usually in the context of spinal cord injuries. And that's when you really got to know how to diagnose neurogenic shock. Now, we went through hypovolemic shock, and you brought up a couple of things, blood loss. It could be diarrhea, adult or kid. Anytime you lose salt, you can end up in hypovolemic shock. Okay, that's basically it. Now, cardiogenic shock is most commonly due to myocardial infarction. You all knew that. And then septic shock is most commonly due to E. coli. That's actually the most common cause of sepsis in a hospital. And where do you think it's coming from? An indwelling urinary catheter. It's not Staph aureus. Most people would say when you're in a hospital and you get septicemia, that's most commonly Staph aureus from an IV. No, E. coli beats it. Hands down. Okay, so the most common cause of septic shock is E. coli. Now, you had microbiology, and what makes a gram-negative organism, please? Endotoxins. Endotoxins in the cell wall is a lipopolysaccharide. So gram-negatives have lipid in their cell wall, gram-positives don't. What is that lipid in the cell wall of a gram-negative? Endotoxins. So a gram-negative organism is gram-negative because of endotoxins in its cell wall. And so if you have an E. coli sepsis, you're going to have a big-time problem, because you're going to be in what is called septic shock. Now, you can get it from gram-positives. Gram-positives have toxins in their wall, too, but it's way more common with gram-negatives, specifically E. coli. Big time, big time. All right, let's take the standard hypovolemic and cardiogenic shock. Okay? What's my skin going to feel like? Talk to me. Cold and clammy. Why? Vasoconstriction of my peripheral vessels. By who? Just go through what we just went through. What's my EAVV, stroke volume, cardiac output? Decrease. What did I say was the main? Catecholamines and angiotensin II and all those other things. I'm going to constrict my vessels in my skin and redirect the blood flow to more important organs in my body, like brain and kidney. So I have cold, clammy skin. What's my blood pressure? It's decreased. What's my pulse? It's increased. Very good. That's you see in classic hypovolemic or cardiogenic shock. Not so septic shock. That's unfortunate that you haven't had PASO for cardiovascular, because he would have taught you Pousseau's law, which is a concept that teaches you about your peripheral resistance arterioles, which control your diastolic blood pressure. Pousseau's law states that total peripheral resistance, referring to your arterioles, is equal to, and I'm going to make this real simple because this is all you really need to know for boards, viscosity of blood in the numerator divided by the radius of the vessel to the fourth power. That's all you have to know about Pousseau's law. So one simple question on boards was, what is the main factor controlling total peripheral resistance? Now that's a no-brainer. It's the radius to the fourth power, obviously. Okay? That's the main thing because it's to the fourth stinking power. Viscosity isn't to the fourth power. What controls the viscosity in your blood, guys? Your hemoglobin. And so if you're anemic, what's the viscosity of your blood? Decrease. If you have polycythemia, what's the viscosity of your blood? There you go. So anemia is decreased, polycythemia is increased. Okay, so what happens to your total peripheral resistance when you're anemic? It decreases because it's in the numerator. When you have polycythemia, what happens to your total peripheral resistance? It increases. Pretty simple so far, yes? Okay. Now, when you have septic shock, guys, you release endotoxins. They do horrible things. First of all, they activate the alternative complement system and cause eventually the release of C3A and C5A. Does that mean anything to you? What are they? They're anaphylotoxins. So what are they going to stimulate directly? the mast cells to release what, please? Histamine. What did the histamine do, please? Vasodilatation of what? Arterioles. You mean those peripheral resistance arterioles? One and the same. So if the blood flow is increased through peripheral resistance arterioles, what's your skin feel like? Warm. Just like it did in acute inflammation. Not cold and clammy, because they were constricted vessels. These are dilated. But also endotoxins damage your endothelial cells. Anybody know some kind of chemical in your endothelial cells that is a potent vasodilator? I know two. Nitric oxide is one of them, and another one is prostacyclin, PGI2. So we have about 2 or 3 vasodilators out there that are causing our peripheral resistance arterioles to become dilated big time. So that's to the 4th power. So what happens to total peripheral resistance if we have vasodilated arterioles in this patient in endotoxic shock? Guys, what happens? Talk to me. It decreases. All right. Now, some of you, you're going to need this image to understand what's going to happen. We know that total peripheral resistance arterioles control your diastolic blood pressure because when they're constricted, they can control the amount of blood that remains in your arterial system while your heart is filling up in diastole. Okay, so we know that if they're dilated, what automatically is going to happen to your diastolic blood pressure? It's going to pan out, buddy, big time. Okay. Now, I want us to picture a dam and a big reservoir. Okay, and you know that you can take up the dam gates and you can close the dam, the gates. Not that they're dam gates, but they're gates. Okay, I want you to picture a situation where all the gates to a dam that are holding back water in a reservoir are wide open. Anyone ever seen something like that? Okay, that's what happens to your blood when your peripheral resistance arterioles are dilated. It just, the blood just comes gushing through those arterioles, and where's it going to go? Onto your capillary system, supposedly feeding all your tissues with oxygen. But I'll ask you a question. Would that be a good day to go fishing below a dam, okay, to catch fish when that water's coming out that fast? You think it's going to be something like, do you think the fish are actually hanging around to look for food? No, they're getting bounced all over the place. Many of them are going to die because of the turbulent water. So, this is a terrible situation. There's all that blood going by, but do you think the tissue can get any of it? Any oxygen? No, it's going too fast because it isn't a controlled release of blood. It's coming out too fast. Not only that, is it coming back to the heart faster than normal? Is it? Well, sure, if the arterioles are widely dilated, that blood's going right through real fast and coming back to the right side of the heart faster than usual. It's kind of like your kids when you want them outside of the house because you got something to do, and you say, Mommy's got something to do. Okay, I want you out there for 30 minutes. Mommy's got something to do. And so you start doing something, and 2 minutes later they're bored and they're already in the house. So I just told you to stay outside so I can do something. Okay, well, I wanted to come back earlier. Well, that's what the heart's saying when there's blood. It'll look back and say, didn't I just pump you out? Yes, you did. What are you doing back so fast? The arterioles are dilated. So if blood is coming faster back to the heart, what's the cardiac output in septic shock? It's increased. That's heresy. What's the cardiac output in hypovolemic and cardiogenic shock? Decrease. What's the skin feel like? Cold and clammy. But what's the skin feel like in endotoxic shock? Warm, because the vessels are dilated. So it's a high output failure that occurs in septic shock. With warm skin, okay, those are major differences that you even have to know for part 1. Part 2, you even have to know this also. Okay. Now, I think, and I'm usually reasonably accurate on predicting how these people think that make up this test. I think that Swan-Ganz catheter measurements are perfectly legitimate for part 1. I know they're on part 2 because they basically, a Swan-Ganz a catheter stuck into the right side of your heart measures all the parameters that you learned about in physiology. And so we should be able to understand what they would show in these different types of shock. So let's introduce you to some of these terms that are seen in a Swan-Ganz catheter. And we'll be able to actually differentiate these forms of shock quite easily. The first thing is cardiac output. Okay, that can be measured by the Swan-Ganz catheter in the right side of your heart very easily. How does it matter? Systemic vascular resistance, that's a calculation that it can make based on things going on in the right heart. That's your total peripheral resistance. That's telling what your arterioles are doing. Isn't that interesting? Systemic vascular resistance measured by a catheter on the right side of your heart can actually tell you what's going on in your arterioles. Cool. It's a calculation. Now, this is a big one. This I can assure you will be on the test. Mixed venous oxygen content. Well, you already know what oxygen content is. It's 1.34 times the hemoglobin times the oxygen saturation plus the PO2. Well, you can measure that in the right atrium with a Swan-Ganz catheter. It is your absolute best test for tissue hypoxia. Lactic acid stinks because there's lots of things that can increase lactic acid and have nothing to do with tissue hypoxia and anaerobic glycolysis. But this one, mixed venous oxygen content, is what's actually returning from your tissue. So I want you to just think about this now, please. What's your cardiac output in hypovolemic and cardiogenic shock, please? It's low. So would you all agree, not only is there not a whole lot of blood, but it's not being pushed ahead with a great amount of force? Yes or no? Okay? So will the tissue have lots of time to extract oxygen from what little blood there is? Yes or no? Yes. So what happens to the mixed venous oxygen content in hypovolemic cardiogenic shock? Decrease, very, very low. That is correct. That's just because there's too little of it, and it's going through so slow because there's no force behind pushing it through. And so you get it extracts a lot more oxygen out of it than normal. But here's the one that's a little trickier. What do you think the mixed venous oxygen content is in septic shock when it's going through your tissues like the speed of light? It's high. In other words, tissues, even though there's lots of blood there, it can't extract the oxygen out of it. It's going through too fast. Okay? So you know that one. Then you have a thing called pulmonary capillary wedge pressure. We won't tell you how it's done. It's irrelevant. But what is it a measure of? It's a measure of the left ventricular end diastolic volume and pressure. That's cool. So here's a catheter in the right side of the heart that can tell you what the pressure is in your sacrum left ventricle. That is cool. All of these things are measured in a Swan-Ganz catheter. All of these things you should be able to use and solve and show and be able to see what the differences are between these types of shock. Now, the next one actually has it all there, but it'd be a lot more fun to see if you really understood it for you to tell me. Okay? Now, let's take hypovolemic shock and cardiogenic shock together. What's the cardiac output in both of them, please? Decrease. No problem, yes? What is it in septic shock? Increase. Okay. Very good. Now, let's deal with systemic vascular resistance or total peripheral resistance, which is a measure of what? What the arterioles are doing. Okay, what is the total peripheral resistance in hypovolemic and cardiogenic shock? It's increased. Equate that with something, vasoconstriction or vasodilatation. Vasoconstriction, very good. What is the total peripheral resistance in septic shock? Decreased. So we have two differences already between those two dudes. We have an increase in cardiac output, warm skin, and we have a decrease in total peripheral resistance. The other dudes have decreased cardiac output, increased peripheral resistance. Agreed? Mixed venous oxygen content, hypovolemic and cardiogenic shock, please. Low, very low. Septic shock, high. Okay? So in other words, this is really separating out real easy so far for between septic and hypovolemic and cardiogenic. But we have everything the same so far between hypovolemic and cardiogenic. How do we separate that one out? Okay, pulmonary capillary wedge pressure. What did I say that was a measure of? Left ventricular end diastolic pressure. What would the left ventricular end diastolic pressure be in hypovolemic shock? Low. What would it be in cardiogenic shock? I rest my case. There you go. You don't need to know what it is in endotoxic shock. Actually, it's decreased. Is that easy or what? It is. And does it encompass all the physiologic parameters that you do need to know for part one anyway? It sure does. So if they don't ask specifically this type of thing, they'll just use other terms. Well, cardiac output's cardiac output. Instead of using systemic vascular, it might say total peripheral resistance. Okay? And they could say left ventricular pressures. Okay? Instead of pulmonary capillary. They're still going to ask it. You know that. And because it's all physiologic principles. My second-year students have worked through this like nothing. No problem at all. They know there's no problem. I know I can get away with this in teaching because my kids are not any sharper than you guys. They don't have any problems in solving these things. Okay, neither do you. All right, now, I'm going to ask you another question. Of all the organs in our body, which one suffers greatest from a decrease in blood pressure? Kidneys. Kidneys do. What part of the kidneys? Medulla. Okay, now some of you wanted to say brain, didn't you? Not a good choice. Why? Circle of Willis. Your cardiac outputs decrease, your circle of Willis will distribute blood flow to those areas of the brain, those are the ones with neurons, and keep it going pretty good. Yeah, it's important, the brain, but it's got a circle of Willis to redistribute blood. No problem if you have cardiogenic shock hypovolemic in the brain. Okay, at least not for a while. But kidneys? Screwed. Screwed. Big time. So it's the kidneys. Isn't it true, guys, when someone has hypovolemic cardiogenic shock, septic shock, that oliguria and an increase in B1 and creatinine causes shivers in your body? Because you know that the patient's going into what? Acute tubular necrosis. There you go. And then what are all the nephrologists screaming? Volume, blood flow, renal blood flow, dobutamine, all that kind of stuff that increases renal blood flow. We've got to prevent the patient from going into acute tubular necrosis. Why? They're going to die. That's why. And it looks something like this. Does this look like a normal kidney? Well, what's that? That's the glomerulus. Does these look normal? Well, there's nuclei that are just barely there, but can you see vague outlines of what used to be renal tubules, especially in these right over here? Yes or no? This one's hanging in there. It's always someone that hangs in there. Okay? What type of necrosis is this? Coagulation necrosis. And what do you think is going to happen to these dead renal tubules? They're going to slough off and produce renal tubular cast, which is the pathognomonic cast in the urine, in acute tubular necrosis, and block urine flow, producing oliguria. In addition, other things will happen, causing a decrease in glomerular filtration rate. Voila, you are an ATN. And your chances of survival are zip. So it's the kidneys that are most affected when your cardiac output is decreased. Brain is probably a close second because those neurons absolutely need oxygen. But thank God for the circle of Willis, it can redistribute blood flow even though it's decreased and get it to those areas and protect them for a while. Heart, also even has a bit of a collateral circulation in it as well. But kidneys, there ain't no collateral circulation. And since the medulla only gets 10% of the cardiac output normally, when the cardiac output's decreased, it gets even less. Did you know that a person with sickle cell trait, not disease, can get kidney disease because of the renal medulla's oxygen tension is low enough to induce sickling? Did you know that? Because if you didn't, then you would have got the question wrong on part one. Young woman, black woman, has normal physical exam except laboratory studies reveal microscopic hematuria. The rest of everything was normal. B1, creatinine, everything's normal. What's your first step in the workup of the patient was the question. Part one, the answer was a sickle cell screen. Because she probably has sickle cell trait. So no, sickle cell trait is not without its problems. Okay? Because the oxygen tension in the renal medulla is low enough to induce sickling in those peritubular capillaries, which produces microinfarctions in the kidney, if it does. That was on part one, guys. It's on part one. Not two, I was on there too. It was also on part one. So that's a must-know thing. We review that again when we do kidneys, but I just wanted to mention how bad that medulla is in terms of oxygen flow, even normally. And so that's what we worry about most because we don't want to produce coagulation necrosis, which is called acute tubular necrosis. All right. I'm going to teach you acid base, which includes blood gases. Okay? It's not hard. This is what I find that most people don't know too well, and you lose some points on it. Okay? And so I want to go through this. Now, Henderson and Hasselbach screwed us up pretty bad with their stupid logs. They probably had a Lincoln log set and screwed everything up. Let me tell you why it's stupid. Okay? It's stupid because if you have an acidosis, you'd say, okay, that's an increase in hydrogen ions, pH increased. You have an alkalosis, okay, that's a decrease in hydrogen ions, pH should be decreased. No. It's just the reverse. When you have an acidosis, the pH is decreased. When you have an alkalosis, the pH is increasing. You say, that doesn't make sense. The hydrogen ions are increasing in acidosis, and you're decreasing alkalosis. I don't get it. Logs. Logs is an inverted concept. So you have to think in reverse. That has screwed up American medicine big time. Henderson and Hasselbach should be thrown out of all books, and they should be burned in effigy for causing such massive confusion in students related to acid-base. And you know what? There's one other person in some other book that actually wrote that down. I'm even afraid to do it because I don't know if those two dudes are still alive and they'll sue me. But man, they have screwed it up royally, big time. So we still have to deal with it. This is the way it should have been written in a non-logarithmic form, and that would make more sense. If we increase PCO2, that would increase pH of the H, and then you'd have respiratory acidosis. If we decrease this, that would increase that. That makes sense. This, that don't make any sense. So I just narrowed down to this. pH is equal to bicarb over PCO2, and I forget all these 6.1s and logs because they're absolutely worthless. And so if we increase the numerator bicarb, what should that do to pH? Increase it, what do we call that? Metabolic alkalosis. We decrease bicarbonate, what does that do to pH? Decrease, what do we call that? Metabolic acidosis. If we increase the PCO2, what would that do to pH? Decrease it, what do we call that? Respiratory acidosis. And if we decrease the PCO2, what does that do to the pH? Increase it, what is that? Respiratory alkalosis. Good! Compensation. Compensation is totally simple. Okay? Compensation is the body's attempt to try to maintain a normal pH, which it never does, but it tries. Here's a logical concept. If you want to make the pH roughly stay to normal, assuming you could, and you had metabolic alkalosis, which is an increase in bicarb, then what would you have to do to the denominator to keep the pH roughly normal? You'd have to increase it. And so when you increase the denominator, PCO2, what is that? Respiratory acidosis. So logically, respiratory acidosis has to be the compensation for metabolic alkalosis, right? According to the way the formula is, trying to maintain a normal pH, yes or no? Now, if you didn't understand that, what's the opposite of metabolic? Respiratory, and what's the opposite of alkalosis? Okay, you can do that. Now, that's not a good way, because that doesn't really mean you understood it. It's just a nice way of memorizing it. It is logical for respiratory acidosis to be the compensation for metabolic alkalosis, because if this is increasing in the numerator, and compensation by definition is the attempt of the body to bring the pH back to normal, then the only thing that would bring that pH back to normal by increasing the numerator is increasing the denominator. And so if we have metabolic acidosis and this is decreased, what do we have to do to the PCO2? We have to blow it off. If we blow it off, what's that called? Respiratory alkalosis. That's the compensation. If we have respiratory acidosis as a primary disease, okay, what are we going to have to do for compensation? We have to raise the numerator, which is bicarbonate metabolic alkalosis. Okay? And if we decrease the denominator as a primary disease, hyperventilation. I'm blowing off CO2. Hypoventilation, you learned this from PASO. What does ventilation mean? Is that an oxygen term or is that a CO2 term? It's a CO2 term, guys. And so if I say I'm hyperventilating, that means I'm blowing off. Hyper means increasing my respiratory rate. That's going to blow off more CO2. I'm going to get respiratory alkalosis. If I'm hypoventilating, that means my respiratory rate's decreased. I'm going to retain CO2. Respiratory acidosis. How do students screw that up? I don't get it. I don't get why that would be. It's straightforward. You breathe fast. What do you do? When you breathe out, what are you getting rid of? CO2. So you lose more. It's decreased. Respiratory alkalosis. If I'm just, what am I not getting rid of? CO2. In fact, I'll give you something funny. I use a steamer for my voice. And so it's a little big device, and you put water in it, and steam comes up, and I throw in a little bit of Vicks Vapor Rub liquid, and so I get the menthol. And I put my face over this thing, and I breathe it in through my nose, and it helps my vocal cords. That's what opera star singers use. Okay, I do that because I'm using my voice so much. Well, I thought to get more steam, I put a piece of cloth around the thing, this little device like this, so I'd really get all that steam. All that steam. And I was having a little problem with my breathing. I said, God, I'm having some problem, and I feel like I need oxygen. And so I'm trying to move my gut out from the edge of the table. It's got to be that. And it dawned on me, I was rebreathing my own CO2. Idiot. And so I took the stupid thing away, and there's regular sticking air, and it has little vents. And so I was getting air, and suddenly I felt better. I was rebreathing my own stinking CO2. Now, that'd be a great treatment for respiratory alkalosis, the paper bag thing. Just rebreathe it. That's the best thing to do when someone has an anxious, hysterical reaction. Stick a bag over their stinking head. If you don't like them, plastic. Okay? That'll solve the thing. That'll solve it real fast. Because you rebreathe your CO2. All right. So you got the idea what compensation is. Now I'm going to tell you what uncompensated means, partial compensated. But I will tell you this. Full compensation doesn't exist. You never bring the pH back into the normal range, with one exception, and that's chronic respiratory alkalosis in high-altitude livers, people that live at high altitude. And there's none that live high enough in this country to have that. That would be like Peru and places like that. That's the only case that's known in all the history of medicine where you can bring the pH right back smack into the normal range. And no one's still been able to figure out how that's possible. So normally you bring it close to the normal range, but not into the normal range. So let's do this logically now. Let's talk about the two respiratory conditions, respiratory acidosis and respiratory alkalosis, okay? And let's do it logical. Let's deal with things that deal with CO2, all right? And so you already know this already. You know that the respiratory center is where? The medulla oblongata. That's what controls our breathing rate. Yes or no? And then we have the upper airways. If we obstruct them, then we're going to have a problem with getting rid of CO2. So we have to deal with that. Then we have to deal with the chest bellows. What did Pascal call the chest bellows? What's the most important muscle of respiration? Your stinking diaphragms. Because when the diaphragms go down, what happens to your negative intrathoracic pressures? They increase. And what does that suck into your lungs? Air. What does it suck into the right side of your heart? Blood. That's why your neck veins collapse on inspiration. The negative vacuum sucks blood and air into your chest, guys. And on expiration, you have a positive intrathoracic pressure. It pushes things out. It helps your left heart push blood out. It also helps get rid of air. You with me? This is just simple respiration stuff. That's your chest bellows, your diaphragms, your intercostals, your sternocleidomastoid, but definitely your diaphragm. And then, of course, you got your lungs. Let's deal with it, okay? Here. All right? If I take a barbiturate with something that depresses my respiratory center, what's going to happen? I'm going to get what? Respiratory what? That's it. Respiratory acidosis. I mean, that's just a no-brainer. Okay, what if I had CNS injury to my medulla? Respiratory acidosis. Okay, so that's easy, no problem. How about respiratory alkalosis? Most common cause is anxiety. Some of you have that. When you take a test, and sometimes you feel strange. You start feeling numb and tingling around your mouth. Tips of your fingers start getting numb. You feel kind of twitchy. That's because you're in tetany. Because as you get alkalotic, and I'll teach you why this happens, your ionized calcium level gets lower, and you are getting tetany. And so you really feel weird. You're twitching, okay, and you're feeling paresthesias, numbness, and tingling. You think you're having a stinking stroke. And what it is that you're breathing too fast. Okay? Some of you know exactly what I'm talking about. And just watch your thumb go abduct into your palm, and you say, I didn't want it to do that. Not knowing that that was trousseau sign, or carpal pedal spasm, a sign of tetany. And then maybe you decide to tap over your nerve. I mean, you start twitching like mad. You got yourself a positive swastika sign. I mean, that's all tetany. That's because you're breathing too fast. So anxiety is a thing that can cause the rest. By breathing fast, by being anxious, you usually breathe faster, and you end up with that. Okay, pregnancy. All pregnant women have respiratory alkalosis. You want to know why? Estrogen and progesterone overstimulate the respiratory center. All pregnant women have respiratory alkalosis. A little bit. They say, well, I don't hyperventilate. When I was pregnant, I didn't hyperventilate. Doesn't matter. You had spider angiomas, which are arterial venous fistulas related to your high estrogen. They're in your lungs up the wazoo. You had AV fistulas in there. And so you clear more CO2 per breath than a non-pregnant woman. Of course, the AV fistulas go away if you deliver your baby. You got shunting going on in your lungs you don't believe when you're pregnant. And sometimes you see those little spider angiomas on your skin. You say, oh my God, what's this? I have cirrhosis. No, you don't. You are pregnante. That means pregnant in Greek. All right. All right. All right. Endotoxins overstimulate the system. So all patients in endotoxic shock have respiratory alkalosis. And since they're in shock, you tell me what else they have. Are they an anaerobic metabolism, yes or no? Yes. So what else do they have? Metabolic acidosis. Due to what? Lactic acid. There you go. So they have 1 teaspoonful of respiratory alkalosis because endotoxins overstimulated, all right? Let's just do a cooking class. Some of you understand that. Here's 1 teaspoon of respiratory alkalosis from the endotoxins overstimulating your system, and 1 teaspoon of metabolic acidosis. I'd like you to tell me what the pH is. Normal. That's what you get. Does that mean you're fully compensated? Oh, no. It means you got 2 blood gas disorders at once. The one I like for you guys for part 1, the one for endotoxic shocks part 2 is salicylate intoxication. Salicylates also overstimulate your respiratory center. So what's that 1 teaspoon of, please? Respiratory alkalosis, right? And salicylic acid is what aspirin is, guys. And so it's an acid. You're adding an acid to the body. So what's that 1 teaspoon of? Metabolic acidosis. So what should your pH be? Normal. There you go. Now, you don't have to get into the big deal about kids with salicylate intoxication versus adults. Now, I know that those of you that are pediatricians know that they go through the respiratory alkalosis phase very quickly, and they end up making profound metabolic acidosis. I know that, and the board doesn't make that distinction. Usually, you see it in adults. Usually, rheumatoids that are basically borderline or actually overtly toxic. They have tinnitus, all the signs of salicylate intoxication that we know. They're the ones that usually have that mixed disorder. But if you figure out that they have salicylate intoxication, they're looking for mixed disorder. So look for the normal pH. I'll show it to you. Don't worry. Don't worry. I'll show you what it looks like. All right. So we're done with respiratory center. Now, I don't know of any cause of respiratory alkalosis from an upper airway thing. Okay. How about this? Let's see how good you are. Got a kid, 6 years old, who has inspiratory stridor. Okay, first step in management, crash cart, and then you carefully bring the kid down to X-ray, you do a lateral X-ray, and you see the thumbprint sign, you have a swollen epiglottis diagnosis. Acute epiglottitis organism, please. H influenza, okay? Is it still markedly increased in kids? No. The vaccination has decreased it immensely. See, that's why H influenza meningitis is no longer even close to being the most common meningitis in kids anymore. Most common one depends on age. If you go over from 1 month to 18 years of age, it's Neisseria meningitis. This is the most common. H influenza is way down the list, unless the kid did not get vaccinated. So we don't see that anymore. Now let's make it a 3-month-old. Now what? Croup, laryngotracheobronchitis organism, parainfluenza. You do a lateral X-ray, steeple sign. In fact, they asked on part 1, where is the obstruction in croup? Answer, trachea. It's not at the level of the larynx, it's below it. It's swollen. That's part 1. I thought that was pretty interesting. Then there's a cafe coronary. That's the dude that's at a buffet usually. And usually hunched over their food with their eyes staring at the buffet line while they're shoving food in their mouth, worried that the shrimp are going to be gone. Okay? It's all, What do? Call a doctor. Okay? You're going to get that. Heimlich. Okay? Heimlich. And what are you going to do? Pointing towards their table, by the way. Okay? Because you don't want that big gob of crap to come out on your table. Okay? You're going to be a hero with everybody else. You're so wonderful. You're so perfect. But everyone at your table is going to be looking at you, you jerk. Why did you say, right on my damn soup? Okay? Now, what if they can talk? What do? Leave them alone. If they're partially obstructed, let them cough it out. They can't talk, full obstruction. That's part 2. Okay, so that's called cafe coronary. All right. Chest bellows. Well, I can think of all kinds of things that can screw up my diaphragm because it's innervated by the 4th nerve, which is the phrenic nerve. So I can make it a Herb Duchenne palsy on a kid that's delivered by a breech, and it's a brachial plexus injury, and the kid's having respiratory difficulty. Chest X-ray reveals the diaphragm on the right side elevated. Well, if you paralyze the diaphragm, you're going to be able to retain. What are you going to do to CO2? Retain it, okay? Because of that. I can think of these horrible diseases, like Lou Gehrig's disease, amyotrophic lateral sclerosis. That's how you usually die, because your lower motor neurons are gone, and so your upper motor neurons, and you can't breathe, because your diaphragms are paralyzed, your intercostals are paralyzed, and you're going to die. I can think of Guillain-Barré, favorite board question. You have an ascending paralysis in someone 1 week ago that had an upper respiratory infection. Now they're getting a paralysis. Spinal fluid shows increased spinal fluid protein, a slight increase in lymphocytes, gram staying negative. Diagnosis, Guillain-Barré, a demyelinating disease. Okay, that can do it. Polio. Poliovirus, as you know, destroys lower motor neuron, upper motor neuron things. That could do it. So things that paralyze the muscles of respiration produce respiratory acidosis. I can't think of anything for respiratory alkalosis that would deal with that. And of course, lungs, obstructive lung disease, restrictive lung disease. You did have respiratory lectures by an expert on that who actually runs a lab for pulmonary function tests, for crying out loud. That's Paso. And so you learn obstructive lung disease is not a problem with getting air in, there's a problem in getting air out. Compliance increased, elasticity decreased. You remember that. So you're retaining CO2. So what do you usually have in obstructive lung disease? Respiratory acidosis. As opposed to restrictive lung disease, like sarcoid, pneumonia. I got to finish up caisson's disease, which, believe it or not, they ask a lot of questions on, just like they do high altitude. They ask about people that like to go underwater, which amazes me. Why would somebody want to do something like that? For every 30 or 33 feet, depends on who you read, you increase 1 atmospheric pressure. In other words, we're 760 here, it's 760 times 2 when you're down underwater 30 to 33 feet. The reverse is true when you go in high altitude. For example, on the top of Mount Everest, the atmospheric pressure is 200. You're still breathing 21% oxygen, which most people don't understand. You're breathing still just like the oxygen we're breathing here, but the atmospheric pressure is less. And you learned the formula from Dr. Paso about how to calculate alveolar oxygen, right? It's 0.21 times what your atmospheric pressure is, right, minus the PCO2 divided by 0.8. And so you can see right off the bat that 0.21 times 200 is only 42, okay? And so you subtract from that, let's say, a normal of 40 for PCO2, 0.8 into 46. I mean, you're talking about maybe 2 millimeters of mercury of air in your alveoli. So you can see why you have to hyperventilate at high altitude, because as you lower the PCO2, what do you automatically do to the PO2 in your blood? It goes up. You have to hyperventilate, otherwise you die. But when you go under, the atmospheric pressure increases. So what happens is the nitrogen gases get dissolved in your tissue. You increase pressure. And so if you're down there exploring something underwater, maybe 60, 70 feet, and then some denizens from the deep is starting to come up and just kind of check you out for lunch, okay, you could potentially want to get up fast, you know, and get out of there. And because of that, what happens, like shaking a soda bottle, the gas comes out of it was dissolved in the fat and stuff like that. It comes out as bubbles. And the bubbles get in your tissue and also in your blood vessels, and they block the blood flow. That's called the bends. You get tremendous pain, and you can end up with quadriplegia because the little vessels that supply your spinal cord are very susceptible to that. Bladder, loss of bladder control, and eventually you could die from something like that. So the treatment for that is to put you in a hyperbaric oxygen chamber, and hopefully things will get better for you. That's called caisson's disease, or I guess that's what they call caisson's disease, the key term for that. Okay, nutrition. Eating disorders. They like to ask questions on eating disorders. It can come under behavioral science, but also can come under nutrition as well. When we talk about eating disorders, that includes obesity. Okay, it also includes your anorexia nervosa, bulimia nervosa. What's the main difference between anorexia nervosa and bulimia nervosa? Basically, the biggest difference is body image, distorted body image. Women that have anorexia nervosa they could be 60 pounds and they think they're fat. It's very distorted body image. It's a control issue. Basically, they've lost control over everything in their life, okay, except one thing they can control is what they put in their mouth. And I know all about this because my wife had anorexia nervosa, so I'm pretty up on this stuff. And what happens is, as you lose weight, lose 15, 20% of your body fat, body weight, your gonadotropin-releasing hormone decreases. That means FSH and LH decrease. That means you have low estrogen levels. That means you have no periods. It also means you're going to develop osteoporosis, just as if you were postmenopausal. That's the board question right there. Okay, the osteoporosis part of eating disorders, particularly anorexia nervosa. What will eventually happen is you will develop osteoporosis. Okay, and that's what that goal is for. That's as far as they go for part 1. Part 2 would ask you what you do about it. Let's say they'll usually use an Olympic athlete, Okay, a woman, let's say, that's a runner or something like that, she has no periods because her body mass is too low for gonadotropin-releasing hormone release. And I say, what do? Always think cheap, okay? What you do, the answer to the question is you try to convince the person to gain enough weight so that the periods come back. That's the answer, not birth control pills right off the bat. The answer is to try to explain to them that they need to gain enough weight to bring their periods back. Always think cheap with the boards, okay? Don't think drugs right off the bat. For example, first step in management of hypertension, weight loss, okay? Not, let's see, thiazides or let's see, forget it. You just missed it, okay? It's weight loss. First step of treatment of type 2 diabetes, weight loss. Because, as you downregulate, as you lose adipose, you upregulate insulin receptor synthesis, and so oftentimes you can control the hyperglycemia just by pure weight loss. So don't forget the obvious, okay? Think cheap for boards, and you'll get the answers right. So that's anorexia nervosa, some of the key things there. Usually you die of cardiac disease, okay? Heart failure, your heart just stops. My wife came pretty close to that, actually. Bulimia nervosa is not a body image problem. They don't have to be thin. They can be obese. They can be normal weight. They can be thin. So there's no weight type of thing with bulimia. They don't have a distorted body image, but they binge. They eat a lot, and then they force vomit, okay? You end up with, this picture's been on boards. I know what I forgot to do. I need a new one of these things or batteries in this. Because I knew this was running out yesterday, and I should have. Wait a minute. There was stuff in there, but I need another one anyway. I had this in my ear, and there was wax in there. That's a joke. You probably said, no, you put it up your nose, and there was a booger in there, right? Okay. But at any rate, this picture's been on board because he wants you to be able to recognize what enamel looks like. From the vomiting, the acid will wear down the enamel, and you'll end up with just dentine showing. So that brownish stuff is dentine. That's what all the enamel got. Those are the erosions that you get on the teeth. They want you to know stuff like that. Also, what the metabolic abnormality would you expect if you force vomit? Metabolic alkalosis. Of course, that's a very bad acid-base disorder because alkalosis less shifts your curve. And the compensation is respiratory acidosis, which drops your PO2. So you really develop hypoxia when you have metabolic alkalosis, and hearts don't like that. So a heart with tissue hypoxia oftentimes throws off some premature ventricular contractions. You have an R-on-T phenomenon, you go into VFib, and you're dead. And so metabolic alkalosis is very dangerous for inducing cardiac arrhythmias, and that commonly occurs in patients who have bulimia. They get metabolic alkalosis from the forced vomiting. Another thing they can get is they can vomit up blood, and that could either be Mallory-Weiss, where they have a tear in a distal esophagus, proximal stomach, or even worse than that, Boerhaave syndrome, they have a rupture, and air and secretions from the esophagus get into your pleural cavity. The air can dissect through the subcutaneous tissue, come around into your anterior mediastinum, and you get Hammond's crunch, which was asked on board. They described some young lady, and that when they said when you put the stethoscope on the chest, there was kind of a crunching sound there, Hammond's crunch. They won't say Hammond's crunch, but that's what it is. That's basically air that is dissected up into the interstitial tissue and into your mediastinum. It means you've ruptured your esophagus, and Boerhaave syndrome is very common in bulimics. So that's another one that they common there. So the two things on bulimia you want to remember is the vomiting, metabolic alkalosis, which can induce arrhythmias, and Boerhaave syndrome. Those are the key ones they hone in on. Remember now on obesity, we are using a different method. It's not just, finding you on a chart, your weight and all that stuff and height and all that. Now they use body mass index. Okay, and it's the kilograms over meter, kilograms of body weight divided by meters and height squared. Okay, the magic number is 30. If your BMI is 30 or greater, you're obese. If you're 40 or greater, you're morbidly obese. So now they use basal body mass index for defining obesity, not, these little charts like they get in the insurance companies. It seems to follow pretty good for defining these patients. What do you think is the main complication of obesity? The answer is hypertension. Hypertension is probably one of the biggest things that you get related to obesity. The actual mechanism is not fully understood, but hypertension commonly occurs. And if you have hypertension, it can get left ventricular hypertrophy, and eventually you do run the risk of heart failure if you have left ventricular hypertrophy, because you know that cardiac disease is the most common cause of death in hypertension. But there's many other things that you know about gallbladder disease, right? Cancers. Because remember, if you have a lot of adipose, then it means you aromatize. I hope you're not familiar with that term, aromatase. You aromatize a lot of 17-keto steroids like androstenedione into what? Estrogens. And so if you have hyperestrogenism, and all women that are obese have hyperestrogenism, then what risk do you have? Thank you so much. You have estrogen-related cancers. And they include things like breast cancer, endometrial adenocarcinoma, and then other ones that they more commonly get are colon cancer, all kinds of cancers. Okay, are associated also with obesity as well. And I think that's about all we need to mention on obesity. Turns out the United States is one of the top countries in the world for obesity. So that's pretty cool. You saw this slide before, but I want to go a little bit further. Remember, this was the little dude that had what? Kwashiorkor and what is this cat? Marasmus, okay? Marasmus is total calorie deprivation. They don't have enough calories. And so they have wasting away of their muscle. That's probably the biggest thing. But they have a really good chance of survival if they get food. Notice that this kid looks very like he's ready to get up and eat. Okay, now this little dude over here is probably going to die. They have a total number of calories that's okay, but it's all carbs, and they're missing protein. They also have anemias. They also have cellular immunity problems. In other words, when the skin tests them for their ability to react to candida or mumps or something like that, they show no reaction. That indicates that their cellular immunity is defective. Okay, they have the low albumin levels, ascites, they have fatty livers. So those kids are very, very sick, and they very frequently die. They're apathetic. You have to force feed them. So the little dudes that have kwashiorkor are more likely to die than those with marasmus. This kid has a couple things that you can clearly see. The kid has edema of the legs. You can see that. You can see the flaky paint dermatitis. Looks like the paint's peeling off of their skin there. Notice the flag sign, reddish hair. That's due to copper deficiency. So all of these are features of kwashiorkor. Okay. When you integrate in things in medicine, you should always ask yourself questions like, when you have vitamins, there's fat and there's water soluble. Okay, you should be able to, right now, to really understand nutrition, be able to say, well, what are the differences between fat and water soluble? Well, one obvious one is that fat soluble means that it dissolves in fat. So it means that it's taken up by chylomicrons. Okay, that's one of the features of the chylomicron. It's going to have A, D, E, and K in there because they're fat-soluble vitamins. Okay, that's one obvious difference, whereas water-soluble or water-soluble. Okay, another obvious difference is that if it's fat-soluble, it's more likely to be stored in fat, and so therefore toxicities are much greater, or greater chance of toxicity with a fat-soluble vitamin than a water, because if it's water-soluble, you pee it out. It's said in this country we have the most expensive pee in the world, because we're peeing out all those water-soluble vitamins we think. You know, in America we think if one works, then 10 works better. Okay, and so we basically we over-vitaminize ourselves, if there is such a word. And with all those water solubles, that's why I have such nice orange urine all the time. Okay, that ain't jaundice. Okay, that ain't bilirubin in there. That's the pigments from the pills that you take. In fact, some people, I remember even reading in some internal medicine thing, the most common cause of bright yellow urine is someone taking vitamins. Okay, so we have very expensive urine and also very expensive poop because most of the vitamins are worthless and they never break down. You end up in your stool anyway. Total waste of money. Okay. So those are obvious differences there, but there's even more than that. Water-soluble vitamins are all cofactors for biochemical reactions. And since you haven't had biochemistry, I can't have fun with you today because then you would be totally de-edified, okay, because it's big-time biochemistry. And since I like biochemistry, all the biochemical correlations that you need to know on nutrition are there, okay. So we'll just kind of hang low a little bit on really going in-depth into this, and I suggest strongly that after Hansen talks to you, that you read the nutrition chapter again, and you'll get a lot more biochemistry points by doing that. Okay, a lot of what she says will make a little bit more sense, because right now some of you just not right there where you should be with biochemistry. You haven't had it yet. Some of you haven't had it for years, so I can understand that. So all water-soluble vitamins are cofactors for biochemical reactions. Not so with fat-soluble vitamins. They have another life other than being a cofactor for a biochemical reaction. So there's a major difference there as well. Okay, some of you are experts in physical diagnosis, especially if you're British trained. And so you'd look at this eye and you'd see this kind of area of squamous metaplasia, this hot spot, so you know it's vitamin A deficiency. And you can see these little what look like goosebumps in the back of the arm there. That's follicular hyperkeratosis. These are signs, of course, of vitamin A deficiency. So let's talk about A. What does it do? Very important. Vitamin A is very important in the growth of children. Okay, the bone growth and muscle growth. So it's very important in children for growth, and you can have failure to thrive with vitamin A deficiency. Don't forget that. Also, you know about the visual purple in the eye, iodopsin, rhodopsin. In fact, the first sign of vitamin A deficiency is night blindness, which is called nyctalopia. So it's involved in that. And here's another big one. It prevents squamous metaplasia. That's kind of interesting. Prevents it. Okay, so that you don't undergo squamous metaplasia. And that's, of course, what's happening here. The eye is lined by a low cuboidal epithelium, and if you get squamous metaplasia, then you form these little white spots here. And if these become very extensive, they can go over the eye. You get the softening of the cornea. That's called keratomalacia. You go blind. It's probably number 2 cause of global blindness is vitamin A deficiency. Now, the first cause of global blindness is trachoma. Now, in this country, diabetes mellitus is the most common cause of blindness. But worldwide, it's trachoma, chlamydia trachomatis, and right after it's vitamin A deficiency from keratomalacia. Okay, lose your sight. So that's another feature of vitamin A. It's involved in preventing squamous metaplasia. So in other words, you could be a non-smoker, and you can get squamous metaplasia of your main stem bronchus, and some people say bronchogenic carcinoma. Okay, so it affects that as well. Very, very important concept. So that's the deficiency part of it. Now, they are into every single one of these vitamins that are fat soluble. They ask questions on hypervitaminosis because so many people take too much. Okay, so a very favorite one for hypervitaminosis A is the big game hunter who eats bear liver. Okay, so if they say bears, they say big game hunter, and they talk about headaches. What they're talking about is they get cerebral edema from increase in vitamin A, from hypervitaminosis A. They get cerebral edema with papilledema. Of course, that's going to produce headache. You can herniate and die. Also, you already know that retinoic acid, which is used for treating acne and also for treating acute progranulocytic leukemia, vitamin A toxicity not only can produce intracerebral edema, but also can produce severe liver toxicity. So hypervitaminosis A affects 2 main areas. One is the brain, that's the more common one, cerebral edema, and the second area is your liver. So if you've got a young lady on isotretinoic acid for cystic acne, you've got to be checking out her liver enzymes every now and then and checking her out for, whether she has any headaches and stuff like that. She could be developing papilledema and cerebral edema related to vitamin A toxicity. So that's the big one that they ask on that one on boards. Usually the big game hunter who has headaches, and then you have to explain why that is. He ate the bear. So in other words, the bear eventually got back. The hunter killed the bear. The hunter said, "Me hunter, I eat liver," kind of like Hannibal, "Me hunter, I eat brain," that kind of stuff. I've never watched that movie. But the bear gets back because that's where we store vitamin A, and there's massive amounts of vitamin A in bear livers, okay? And so the bear gets back, even though it's dead, the hunter dies, okay, with severe headaches or liver failure. It's cool. I think that's right. D is big time. Oh, vitamin D deficiency, big time, okay? This kind of surprised me. I thought the most common source of vitamin D was what you ate. That was wrong. The most common source is when you went outside. Okay, that's the sunlight. Okay, remember that, we always talk about cholesterol as something bad. Oh, cholesterol's bad. Not really. I mean, cholesterol is the main component of our cell membrane. Is that bad? No. Cholesterol is the starting point for making bile salts and bile acids. Is that bad? No. Cholesterol is the first compound that starts the synthesis of the steroid hormones in your adrenal cortex. Is that bad? No. And it's 7-day hydrocholesterol that's in your skin that gets photoconverted into vitamin D. Is that bad? No. So we need cholesterol. Okay, it makes bile salts, it makes hormones. Okay, it makes this vitamin D, cell membranes. Good Lord in heaven, we need cholesterol. So it's not all that bad. So sunshine actually is the most important way we get vitamin D. You don't think you get it from breast milk, do you? You don't hardly have any vitamin D in breast milk. You don't hardly have any vitamin K in your breast milk. That's why that has to be supplemented. Okay, so that's why you have to take your baby out. Make sure it's exposed to sunlight. It just takes a little bit of exposure, and there's the vitamin D synthesis occurs. I don't mean you take them out in the middle, in the winter, when it's sub-zero weather, your little dude's naked, and you're holding them up to the sun like this, because they're going to take you in. They're going to bring you in, and they're going to arrest you. Okay, but you probably say, but Dr. Goljan said my baby needs to get vitamin D, and I'm just making sure my little dude gets it. All right, that's not right. That's not what I said. Just a little exposure is fine. And don't stick them on a rotisserie with duct tape and turn them around like this, okay? You know, to kind of make an even tan on a little dude. Okay, that's not a cool idea either. Gotta protect the little dudes. So sunshine diet, remember, it gets reabsorbed in your jejunum, actually. And it has to undergo 2 hydroxylation steps. The first one's in the liver, where it's 25 hydroxylated. And then the second one's in the kidneys, okay? And that's 1 hydroxylated, so that's a 1-alpha hydroxylase. Who can tell me what hormone puts it there in the proximal tubule? PTH does, parathormone. Actually, it's responsible for the synthesis of 1-alpha hydroxylase. And even asked on boards where it's located, the answer to that is the proximal tubule. So you got to know where these different things are: angiotensin-converting enzyme, endothelial cells in the pulmonary capillaries, erythropoietin endothelial cells in the peritubular capillaries, 1-alpha hydroxylase, proximal tubules. That's where it's synthesized. And that puts the second hydroxylation step on, and now you have active vitamin D. Okay, now it works. And what does it do? Well, vitamin D reabsorbs calcium and phosphorus from the jejunum. That's its main function. It has to reabsorb both of those. Why do you think that's true? Because what's its main job? Mineralizing bone and cartilage. That's its main job. And remember, you have to have an appropriate solubility product to be able to do that, don't you? And so calcium and phosphorus are necessary to mineralize cartilage and mineralize bone. Okay, like the osteoid to make bone. And so it makes sense that it would reabsorb calcium and phosphorus because it needs to make sure that both of those are present in adequate amounts to have an adequate solubility product to mineralize it, which is what its main job is doing. Okay, so that should be understandable from that. We should talk a little bit about parathormone now. Well, since parathormone is somewhat related to vitamin D metabolism in that it helped its last hydroxylation step. Parathormone, as you recall, you get reabsorption of calcium mainly from right where your thiazides block sodium reabsorption, that early part of the distal tubule. Right there is where there's a channel, a calcium channel, that parathormone helps in the reabsorption of calcium, except that calcium has to kind of take turns with sodium. And so most of the time, sodium is being reabsorbed out of that, and calcium saying, my turn? No, I'm more of me than you. And so most of the time, calcium just has to wait and then sneak into that channel when it gets a chance with the help of parathormone getting it reabsorbed. And so you can easily understand, and I hope our fake from England taught you that when you're on thiazides and you block sodium reabsorption, that leaves the channel open totally for calcium. That's why hypercalcemia is a potential complication of thiazides. Of course, he told you that because I know the man from England, probably told you that, right? So you can run into that risk, right? So what would you use it for in therapy then? Calcium stone formers. Okay, calcium stone formers, because the majority of calcium stone formers have hypercalciuria. That's a board question. That's the most common metabolic abnormality in calcium stone form. They have too much calcium in their urine. Why? Because they reabsorb too much calcium from their gut. That's why. And so they put them on hydrochlorothiazide to suck the calcium out of their urine. Okay, so that they don't form stones again. Just gave you a couple more pharmacology points. I just thought I'd mention that to you. So it reabsorbs calcium in that location in the nephron. It decreases reabsorption of phosphorus in the proximal tubule, and bicarbonate decreases actually the reclamation of bicarbonate there. So that's what its main functions are. Also, as I said, makes 1-alpha hydroxylase in the proximal tubules and helps vitamin D get that second hydroxylation. This is very important, and you don't see this in too many books. Cecil's probably has the best section on this because I think the other ones don't want to deal with it because it's kind of hard. And that is how vitamin D and parathormone work together. Well, you know that vitamin D's main function is mineralizing bone. That's its main function. And so we know that osteoblasts are involved in that particular function. Okay, and it would be logical that the receptor for vitamin D would be located on the osteoblast, and in fact it is. Okay. And when it hooks into its receptor there, it causes the release of an enzyme. You should be able to tell me what that enzyme is. What is it? It's alkaline phosphatase, guys. So whenever you're growing bone or you're making bone from a fracture, you have a fracture and you're rehealing that fracture, you expect to see an increase in alkaline phosphatase because vitamin D would be hooking into that osteoblast and that would be releasing alkaline phosphatase, which actually makes the appropriate solubility product to mineralize cartilage and bone. Okay? Now you would think, knowing that parathormone breaks down bone and kind of helps maintain your calcium levels in your bloodstream. You would think that its receptor would be on the osteoclast, because that's the cell that normally breaks bone down as an osteoclast. It ain't though. There's only one hormone that has a receptor on an osteoclast, and what is it? Calcitonin. And we know that when calcitonin hooks into an osteoclast receptor there, it inhibits the osteoclast, and that's why it's used in treating hypercalcemia. Okay, also used in treating osteoporosis as well, as you know. Well, but there isn't a receptor there on osteoclast for parathormone. It's actually on the osteoblast, which really threw me. I defy you to find that in most books, except Cecil, maybe a few other areas. Okay, it's been documented. It's on the osteoblast, not sharing the same one as vitamin D, but very interesting. When it hooks into its receptor on the osteoblast, it releases interleukin-1. Now, another name for interleukin-1 actually is osteoclast activating factor. Isn't that interesting? It has another name. Here's this dude that helps us with fever and stimulates antibody synthesis and B-cell stimulation. It has so many different functions, but one of its big functions is that it can activate osteoclasts. Okay? And so it's the interleukin-1 released from the osteoblast when parathormone hooks into its receptor that stimulates the osteoclast to break down bone and maintain our calcium levels in our bloodstream. Okay, see how that works? That seems like a pretty important function, doesn't it? Is there a check on that interleukin-1? Sure, it's called our sex hormones. For you women, it's your estrogen levels that keep a check on interleukin-1, so it doesn't go too hog wild and break down, cause too much osteoclast activation. For us guys, it's testosterone, which kind of puts an inhibitory effect on that release of interleukin-1 from the osteoblast after parathormone hooks in there. And so you can see women why you get osteoporosis when you lack estrogen, is that when you lack estrogen, an interleukin-1 osteoclast activating factor is not checked, and you're breaking more bone down than you're putting in. And that's the mechanism of osteoporosis in a postmenopausal woman, breaking more bone down than you're making. That's the mechanism. That's a board question right there. That's how it works. Okay, very hard to find all that information in between the lines and all that stuff, but look, Cecil's most recent edition has the best rendition of that, and I just gave it to you. So you can see how parathormone kind of works in here. So they're kind of both working with calcium metabolism. Parathormone a little bit more in relationship to maintaining our calcium levels in our blood. Vitamin D a little bit more concentrated on mineralizing bone and cartilage. That's its main function. Okay. What was I going to say now? Oh, we have vitamin D deficiency. There could be a lot of reasons for that. You just look up here and you can see them all up here. Lack of sunshine. Yeah, that's a cause a lot of times in Britain. They don't have a whole lot of sunshine there, and they can get vitamin D deficiency quite commonly there related to that. You can get it from poor diet. Okay. You can get it from liver disease. Want a trick board question? They said a patient was on phenytoin for whatever, and said the patient had hypocalcemia. They wanted to know why. Tell me. Trick question. What does phenytoin, alcohol, barbiturates, rifampin all have in common in the liver, guys? It induces the cytochrome P450 system, which is located in the smooth endoplasmic reticulum. So you get smooth endoplasmic reticulum hyperplasia. So that means you metabolize drugs and other things that are made in the liver, which includes 25-hydroxy vitamin D. And so alcohol, phenytoin, rifampin, barbiturates, anything that revs up that cytochrome P450 system will cause a decrease in vitamin D, as well as drugs that you're giving the patient or whatever. That is big-time boards, big time. Another offshoot of that question was you have a woman that was on phenytoin and birth control pills and she got pregnant. Why? Well, the answer was the phenytoin revved up the system and increased the metabolism of the estrogen and progesterone in the birth control pills, so she didn't have significant enough levels to prevent her from getting pregnant. So they did that particular question, that concept, in relationship to vitamin D deficiency, and I did that particular concept in relationship to birth control pills. There's also an enzyme that's in the smooth endoplasmic reticulum which will always be increased in synthesis when you have revved it up. Name me. Oh, we got you. Gamma-glutamyl transferase. Gamma-glutamyl transferase is the enzyme of the smooth endoplasmic reticulum. So when that system is revved up by drugs, you have an increase in gamma-glutamyl transferase. That's one of the key tests for picking up an alcoholic guys. It's gamma-glutamyl transferase, big time. Okay, so liver disease can do it. You can have cirrhosis, but you can't hydroxylate it, or you can have a drug that revs up the system and it increases the removal and metabolism of it. But the most common one is renal disease. And what's the most common cause of chronic renal disease in the United States? Diabetes mellitus. You can see why that is, right? I mean, you got tubular damage, no 1-alpha hydroxylase, voila, can't make, you have inactive vitamin D. No problem with that understanding of that. So all people that have chronic renal failure are put on 125 vitamin D, which is not what you get in the store. Okay, would be a great board question. And I think it's just waiting to happen if it already hasn't happened. And that would be, you know, what would be the steps that would let's see, how would I word this thing for this off the bat? If someone gets over-the-counter vitamin D, what steps would it go through before it was metabolically active? And they can have A, B, C, D, E, whatever. Okay, and the answer would be it has to get 25 hydroxylated in your liver, and it has to get 1 hydroxylated in your kidney. It has to go through the whole thing. It's not 125 vitamin D. It's not. That's a prescription drug, and it's extremely dangerous. Okay, so a lot of people have that misconception that it automatically is working and functioning. Oh, no, no, no. You have to have a functioning liver and kidney for that to work. Isn't that a great question? Just got boards written all over it. Got boards written all over it. Okay. Well, you all know that if you have vitamin D deficiency and you're in a kid, they call that rickets. If you have vitamin D deficiency in an adult, we call it osteomalacia, which means soft bones. If you can't mineralize bone, you can't mineralize cartilage, then they're soft, which means that they're easy to fracture. So pathologic fractures are very common. Kids have a few things that are different in rickets that we see in adults. One is cranial tabes. They have very, very soft skulls. You can actually press in on their skulls and it'll kind of recoil like a ping pong ball. It's called cranial tabes. I mean, you could press forever on an adult skull and nothing's going to happen. So don't be there with a patient there. Be pressing on an adult. You know, what are you doing to my head? I'm trying to see if there's a recoil here. Okay? I mean, they're going to just drag you out. Okay, and just kind of disbar you. Okay, this guy was looking for cranial tabes in an adult. I mean, that would be terrible. Okay, that's not going to happen. So that's different. Second, they can get rachitic rosaries. Because of the fact that that's where osteoid is located in those costochondral junctions, and because they're vitamin D deficient, there's lots of normal osteoid there waiting to be mineralized, but there's not an appropriate calcium phosphorus solubility product. And so you get this excess of osteoid in that area, and it looks like little bumps. Okay, and they call it rachitic rosary. We don't see that in adults because everything's fused in those, so we don't get to see that. So those things are different in kids than in adults. They have cranial tabes and they have rachitic rosary. Otherwise, the rest of it's the same. Pathologic fractures being the big one. Let's see, anything else on vitamin D? Hypervitaminosis D, they've asked. And so, of course, that could be hypercalcemia, and then you run the risk for having more calcium in your urine. Voila, stones. There you go, stones. That would be the most common complication. I've got a little chart in there. They don't usually ask questions on type 1 vitamin D dependent rickets, type 2 vitamin D dependent rickets, but just in case they did, I have the information that you need. Type 1 is where you're missing the 1-alpha hydroxylase. That's type 1 vitamin D dependent rickets, and type 2 is where you're missing the receptor for vitamin D. That's basically the difference. Vitamin E. There was a while there, about a year ago, I guess this article came out. It says, all bogus. Vitamin E doesn't do what it says it does. Boy, they ought to take people like that and hang them up by you know what. What? Your toes. What do you think I was talking about? Bad science. Bad science. Okay? Okay. What is vitamin E's main function? To maintain your cell membranes. Prevent lipid peroxidation of your cell membranes. Okay, so in other words, it kind of protects your cell membranes from getting broken down by phospholipase A. That's basically what it does, and they call that lipid peroxidation. That's free radical damage to your cell membranes. Vitamin E prevents that. That's its main function. Its other function is it also can neutralize oxidized LDL, which is far more atherogenic than just LDL by itself. When you oxidize it, that makes it way more injurious to the patient than if it's not oxidized. And vitamin E will neutralize that. I saw in your Hansen put down that vitamin E and vitamin C both neutralize oxidized LDL, but most people don't have that down there. I think it's a smooth point. but definitely, unequivocally, vitamin E does neutralize oxidized LDL. Therefore, it is cardioprotective in that regard. So it protects our cell membranes from getting free radical damage. And secondly, it neutralizes oxidized LDL, that's the LDL that macrophages will phagocytose, and then they become foam cells, which is part of the atherosclerotic process, as you're aware. So those are main functions. Now, can you be deficient in vitamin A? Yes, but it's very uncommon. If we see it in kids with cystic fibrosis. And I think you could probably figure out why that is. Because right pretty much from birth, kids with cystic fibrosis not only have their respiratory problems, but you saw that poor pancreas in that little dude. Actually, I took that picture on an autopsy, which is very similar, apparently, when some students saw that picture up there, and they said, hey, that was the one that was on our board. And I said, no, it wasn't on your board because I took the picture. Okay, so it looked just like it. And there is one in Robbins, too, that's pretty similar, and hopefully you got that other sheet of paper. I went all the way through the 6th edition of Robbins and told you where to look at what pictures that I thought was something you might want to look at just before you get into the test, and put a little explanation next to each one of them. So that's everyone's really do. What about pictures? What about pictures? Okay. If you want about pictures, I wrote them all out for you. Just follow the little dictionary there, and you can go right through the 6th edition of Robbins, which is a total waste of time. But if you want to do it, go ahead. But I remember there was a picture similar to the one I had in Robbins on that. So they get malabsorption. And you all know, this was a Part 2 board question, select 4 it was, and they had all the vitamins down, and they said, select 4, you have a child with cystic fibrosis, what vitamin supplements would you going to give? Duh! That was easy. Okay, so if they have malabsorption of fat, then they're going to have malabsorption of the fat-soluble vitamins. So the answer was A, D, E, K. Whoa! That was so hard. No, it wasn't. So if you get a C vitamin E deficiency in this country, you'll be in cystic fibrosis patients. And I just told you that it maintains the integrity of your cell membranes. And so one of the features of vitamin E deficiency is a hemolytic anemia. Because if it's susceptible now to free radical damage, and you damage that membrane of the red blood cell, you're going to get a hemolytic anemia. It's going to hemolyze. And so that's one of the features. The other feature is things related to myelin. You can get posterior column disease. You can get spinal cerebellar types of disease. So they have neurological problems and a hemolytic anemia with vitamin E deficiency. Surprise, surprise, surprise. Some students said, Dr. Goljan, I like that. I had something to do with vitamin E toxicity and what it did. I said, what? Vitamin E toxicity? So what did I do? I looked it up in my notes, which apparently I didn't read. And there it was. I just never really paid attention to it. Vitamin E toxicity, by the way, it's defined as anything more than about 1,100 units. It's not a whole lot, guys. The average capsule is 400. So most people take 2, 3. You take a 3, you're already toxic. You know what it does, vitamin E toxicity? It prevents the synthesis of the vitamin K-dependent coagulation factors. That's 2, 7, 9, 10, protein C, and protein S. In other words, you're anticoagulated. Now, if you put that into the context, you'd say, but that was still not a good question. Oh, yeah, it's a great question. Because I know if I was somebody that had a myocardial infarction and I made it, I'm going to be thanking God, which you should do anyway, whether you don't have a myocardial infarction or not. But, I'd be thanking God, and I'd be making sure that I wouldn't be a couch potato, that I would be taking my antioxidants, okay, and they all know ACE Hardware, they're going to take my antioxidants and my aspirin one a day, and I'm going to be okay. But as you know, if you have an anterior MI, they very frequently anticoagulate you, and so you go home on 3 months of warfarin. Here's the trick right there. You go home on 3 months of warfarin. And so there you go. You're on your warfarin, got your little normal INR ratio, international normalized ratio. Then you go to the drugstore and get your vitamin E, and A, and C. And if one works, 10 works better. Okay? And so you take lots and lots of vitamin E, thinking that antioxidant, I'm helping myself. No, you're helping warfarin. And so what happens is you over-anticoagulate yourself now. Remember, warfarin blocks gamma carboxylation of the vitamin K-dependent factors. And now, vitamin E toxicity prevents the synthesis of the stinking factors. And so it's synergistic in activity with warfarin. You learned about that concept from Trevor. He tells you about certain drugs, and you got to be careful, actually enhance the activities, and some of them actually inhibit the activities. You need to be careful of that. And so all of a sudden, what you're going to see, I can just see the board question. I can just see it. And I can say, this guy's on warfarin. He's come home from a myocardial infarction, and he's taking the appropriate amount, and his INR ratio is off the map. And he says, I swear, I'm taking a warfarin just like you told me. I don't understand why it went like that. I can tell you why. He's taking too much vitamin E. That's the board question you watch. If they already asked what it does, then the next thing will be using it in a clinical context. And that's the clinical context you want to know. So in other words, it anticoagulates you. It's as if you're on warfarin, except it's a different mechanism for the knocking off of the vitamin K dependent factors. You just don't synthesize them. Very interesting. Okay, vitamin K. Here's another very poorly understood, and I remember seeing a lot of little questions that students had told me that they had on their exam. They said, no vitamin K, exclamation mark, parenthesis, I wish I did, close parenthesis. Okay, so let's make sure you know vitamin K. Well, vitamin K can come from what we eat, but most of it's synthesized by our colonic bacteria. That's where most of vitamin K comes from. Our anaerobes in our gut. See, that explains why we give vitamin K injections to our babies the moment they're born, because they only have about 3 days worth from the hookup to mommy when they were in utero, and in about 3 days they're not going to have any vitamin K, mainly because it ain't in breast milk. Okay, so they have a very low level of vitamin K between day 3 and 5, and they don't have any bacteria in their gut to make the vitamin K. See, it's a danger time. That's why they can get hemorrhagic disease in the newborn during that time, get bleeds in the brain and die. So we give our kids here in this country vitamin K shot right at birth to help them. Okay, so since most of it is made by bacteria from the colon. After 5 days, usually they're colonized, and then they make their own vitamin K, and then there's no problem anymore. All of that's board question stuff, guys. All of that's board question. Okay, now the bacteria make a vitamin K in inactive form. It's called K2, kind of like that mountain over there in the Himalayas. K2, the one. I'm going to climb K2. Good for you. I'm going to climb K1. Okay, there's a K2. There must be a K1, right? Okay. There's the First Baptist Church. There must be a Second Baptist Church. And if there's a second, there must be a third. And if there's a third, there must be a fourth. And it can keep on going. That's why he says I'm in 153rd Baptist Church. There you go. All those different numbers. Okay, so K2 is inactive and it has to be converted into K1, which is the active form. There's an enzyme that does that called epoxide reductase. Kind of sounds like epoxy glue. That's close enough. You can remember epoxy glue, and I think you'd be able to remember epoxide. Okay, it'll just come back. It's like Casper the Friendly Ghost, caspitases. That's close enough. You're going to be able to get anything on the test related to it. So you have to have that enzyme, epoxide reductase, to convert the inactive K2 to K1. What does K1 do? It gamma carboxylates the vitamin K dependent factors, 2, 7, 9, 10, protein, CNS. We do that when we do coagulation. We'll go through those factors and stuff like that. Now, gamma carboxylation is kind of similar to, your understanding of vitamin C. It hydroxylates proline and lysine. Nice. So what? Well, you found out. So what? You found out if you didn't hydroxylate proline and lysine, then the cross links that would make the collagen fibrils stronger are not going to be there. And so it's weak. So that was something. There's a similar analogy here. Gamma carboxylation of those vitamin K dependent factors actually activates them so that they are functional. Okay? The vitamin K dependent factors have something all in common. Okay, one is that they have to be activated by vitamin K1, but the other thing is they're the only coagulation factors that are bound to a clot by calcium. So they have to be bound by calcium in order to work in forming a clot. If you can't bind them, then you're anticoagulated. Well, guess what gamma carboxylation does? It's the glutamic acid residues that get gamma carboxylated on the vitamin K dependent factors. Vitamin K1 does that, and it allows calcium to bind those factors. And so it keeps them together, and so you're able to form a clot. So if you don't gamma carboxylate them, then they're basically useless, because calcium can't grab them to help in the formation of a clot. Okay, do you understand that? So that's the importance of it. So it's kind of similar. It's kind of an anchor point, in this case for calcium. In the case of hydroxylating proline and lysine, an anchor point for putting a cross bridge in for binding. You understand? So it's a similar concept there. Well, you'll probably figured out what warfarin does. It inhibits epoxide reductase. I mean, Trevor taught you that. We might have just used the term reductase. Okay, but that's what it does. It blocks it, so that means that all the vitamin K we have is K2, and we can't get no carboxylate anything, and so therefore the patient's anticoagulated. Understand that? Very important that you got that. Very, very important. Okay, there's lots of ways we can get vitamin K deficiency. How about broad-spectrum antibiotics? That's the most common cause in a hospital, actually. You just annihilate and sterilize the patient's bowel, and you kill those dudes that are making our vitamin K. So that's a common one right there. All right. Secondly, poor diets. Being a newborn, you can malabsorb it because it is a fat-soluble vitamin. Okay. Those kinds of things. All right. If you're deficient in vitamin K, you have a hemorrhagic diathesis, meaning you get bleeding. Okay. It could be into your brain, into your skin, because you're anticoagulated. Okay. You all know that also. Now, there's a couple little scenarios that are very interesting. They have good ones for the vitamin K. One, you have to know why the newborn gets vitamin K deficiency. One was pushing it a little bit. They talked about, I think it was a 6-day-old child was being breastfed and then had a bleeding diathesis. And they wanted to know why that was. And the answer was there wasn't enough vitamin K in breast milk, and so the kid was vitamin K deficient. That was pushing it because, that's about the time that the bacterial colonization occurs, but that's the way they asked it. Okay, so that was one they asked. The other one was a kid that ate rat poison. Rat poison is warfarin. Okay, rats eat it and then they get anticoagulated and die. That was one. And they also asked how you treated it. The answer to that is you treat it with intramuscular vitamin K. And another cool one was that a kid lived with his grandparents who were elderly and developed a hemorrhagic diathesis. Why? The answer is, and they don't tell you that the elderly people on warfarin. The answer was, when they put down the clinical scenarios, that the kid got a hold of some of the warfarin from the grandparent, ate it, and was in toxic levels. So then it was anticoagulated. So there's a lot of little tricky questions on vitamin K. Okay, that's great. Someone asked me, when you treat a patient with, let's say, that has a hemorrhage, they're over anticoagulated or they've taken rat poisoning, when we did the intramuscular injection, what form is that in? I have no idea. Okay, so I don't know if it's in a K1 form or whether it's K2 and it has to be converted into K1. I don't know that. If I had to guess, it'd be K1. The main reason being is that since warfarin would block epoxide reductase, and obviously that wouldn't be able to convert it to K1. So just logically, I would think, but I don't know 100%. Okay, let's see. Those are the main issues with vitamin K, and I gave you all the clinical scenarios that they've asked so far in the exam related to vitamin K. So I think we're done with that. All right, let's deal with some water solubles. This picture's been on a lot of boards, okay? And they'll give a history that it's an older person on a tea and toast diet, they usually say, which automatically tells you that they're malnourished, not taking in enough vitamins. Then they'll say that the patient gets bleeding of the gums when they're brushing their teeth. That's just a total giveaway for scurvy. Okay, vitamin C deficiency. And we've been kind of through this already because we told you with vitamin C, again, hydroxylates proline and lysine. By the way, it does that in the Golgi apparatus, okay, because that's a post-translational modification. That kind of stuff usually occurs in Golgi apparatus. And so you have weak collagen. The tensile strength of the collagen is weak because you can't cross-bridge it, okay? So that's the main problem there. And so what happens is your blood vessels are unstable and they rupture very, very commonly. Your gums will bleed because in a sense, the gums has type 1 collagen in it, it's weak. You get inflammation and you get bleeding from the gums. You lose your teeth. You very frequently get hemarthrosis. That'd be a great board question. What vitamin deficiency is associated with a complication commonly associated with severe hemophilia A? Isn't that cool? I just made that up in my head. Okay. Well, okay, severe hemophilia A. You know about hemarthrosis. So it's hemarthrosis, and what vitamin deficiency? Good vitamin C deficiency can produce that. It can produce hemarthrosis. Just be related to the fact that your blood vessels are unstable, and they rupture. Okay. There's a couple things. There was a sample question that the boards gave out, and in that stem they dealt with the tea and toast diet. They talked about perifollicular hemorrhage. They mentioned that there was hemorrhage around the hair follicles. And so, what does that tell me as an educator? It says, wow, they're getting into the physical diagnosis of vitamin deficiencies. Perifollicular hemorrhage, most of you will not be able to see this actually. because it's hard to even see right up here. But the hair follicles will have hemorrhage all the way around them from the rupture of the blood vessels around the follicle. So it looks like a ring around, instead of a ring around the collar, you got a ring around the follicle. Okay? The way I usually remember things is I try to, put things that are similar together. I think like a ring sideroblast. A ring sideroblast is a nucleated RBC that has too much iron in the mitochondria. Ring sideroblast, okay? Now we have ring around the hair follicle, hemorrhages around the hair follicle, vitamin C deficiency. And so it kind of puts those two together, and so you remember one, the other one pops into mind, okay? So you've made a little connection there. That's the way you learn, guys. That's the way you learn. So that was in the boards, ring around the follicle. Another one is they get little what they call corkscrew hairs. Kind of look like a pig's tail, kind of like a little, okay? That one you kind of can see if you're real up close. You can see that over here, right over there. It's a little corkscrew hairs. So notice the tongue. Notice you can get the feeling that tongue hurts. See how smooth it is? And so they get glossitis very commonly. Got a little chelosis over here along the angles. Okay, so that plus a hemorrhagic diathesis is scurvy. Excess vitamin C is very common in this country. People take way too much vitamin C. 6-8 grams of it a day. You're going to get into some serious problems, and mainly renal stones. Increase in uric acid stones and other kinds of stones. So that's a complication of vitamin C toxicity, stones. So we have vitamin D toxicity, stones. We have vitamin C toxicity, stones. That's enough for that. Anybody remember what we can use vitamin C as a therapeutic drug for? Ancillary treatment of methemoglobinemia. Remember, it is a reducing agent. Okay, it's a great scavenger hunter for free radicals, too. It can go around and just kind of knock off free radicals. Okay, this is showing a couple of the features of thiamine deficiency. Not this here. This is showing foot drop. This is clearly showing pitting edema. Okay, dry beriberi, wet beriberi. Okay, I could wax, very philosophical on this in terms of really go through that biochemistry behind this thing. But let me see if you can follow this one. As I told you, water-soluble vitamins are mainly cofactors for biochemical reactions. Right? By the way, is there a biochemical reaction that vitamin C is a cofactor for? Yeah, making catecholamines. Okay, you need vitamin C to convert norepinephrine into epinephrine. So yeah, that's a cofactor. But anyway, getting back to this thiamine. Thiamine is a cofactor for a lot of very important reactions that you learned from Dr. Hansen. One is transketolase reactions, which are involved in the pentose phosphate shunt. But the one you want to remember is pyruvate dehydrogenase. All those dehydrogenase reactions that are very critical in biochemistry. There's pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, and there's alpha-keto acid dehydrogenase. All those dehydrogenase reactions require thiamine as a cofactor. Okay, now let me show you the importance of knowing that, guys. Pyruvate dehydrogenase is the main reaction that converts pyruvate into acetyl-CoA. Okay? Pyruvate can also be converted into oxaloacetic acid with a carboxylase enzyme. When you combine acetyl-CoA with oxaloacetate, guys, you make citrate, and you're in the TCA cycle. Are you beginning to see something here? What would happen if you were thiamine deficient? If it's involved in a pyruvate dehydrogenase reaction which converts pyruvate to acetyl-CoA, then you're not going to have a whole lot of acetyl-CoA around, which means you're not going to have a whole lot of citrate around, which means you're not going to have a whole lot of ATP around. And so the problem with thiamine deficiency is ATP depletion. As a matter of fact, when you go from pyruvate to acetyl-CoA, you generate 2 NADHs. Okay? And since that's in the mitochondria, you get 6 ATP from that. So even just going from pyruvate to acetyl-CoA gives you 6 ATP. And then if you think about, the citric acid cycles, anyone just offhand remember how many ATPs you get from the citric acid cycle? 24. So I think 6 plus 24 is 30. The total that you could possibly get from going from glucose and metabolizing it completely is 38. And so if you're thiamine deficient, basically, you're out 30 ATPs. So the whole problem with thiamine deficiency is ATP depletion. Okay, very interesting. So how does this explain wet beriberi, dry beriberi? Well, it's explained by the fact that When you have dry beriberi, that's the peripheral neuropathies. Also refers to Wernicke's and Korsakoff psychosis. That's the dry beriberi part. Guys, you need a lot of ATP to make myelin. A lot of ATP is required in the synthesis of myelin. And so if you're ATP depleted, you can't make myelin, you're going to get peripheral neuropathies. This is foot drop, and that's due to common peroneal palsy. You can get, well, I'm going to do this. What's that? Wrist drop. What's that mean? Radial nerve. Oh, what's this mean? Claw hand, ulnar nerve, all those different peripheral neuropathies you can get because you can't make the myelin. Okay? And Wernicke's encephalopathy, remember, it's confusion, ataxia, and nystagmus. Okay, and then Korsakoff psychosis is you can't remember old things and new things. Kind of like an exam. You look at a question and say, you know, I used to know that, but I can't quite get it. That's Korsakoff psychosis. You know, acquired, related to stress. Okay, you know how it drives you crazy. You know, you say, it's familiar. I can even see it on the face, but I can't quite get it. That's classic Korsakoff psychosis type of thing that you see. So that's more the memory problem. Korsakoff, whereas Wernicke's confusion, ataxia, and nystagmus. That's all dry beriberi, along with peripheral neuropathy. Wet is heart failure. Heart failure. Now, the most common cause of vitamin deficiency in this country is not polished rice, you know, where they take the outer hull off the rice and take all the nutrients away. Most common cause is alcohol. So alcoholics are the ones that most commonly have vitamin deficiency. Okay? Wet beriberi refers to the cardiomyopathy. Now, when you look at this patient over here, who can tell me, this is wet beriberi, who can tell me what's wrong with this patient? Who can tell me the cause of this? Well, the patient must have had left heart failure, and then from left heart failure went into right heart failure, and now it's dependent pitting edema. Guys, doesn't the heart need ATP to function? So they're going to have what is called congestive cardiomyopathy. Their heart is going to have biventricular enlargement. The whole chest is going to be heart, and they have both left and right heart failure. Okay? Pitting edema of the lower legs is a sign of right heart failure, related to increase in hydrostatic pressure behind the veiled heart. So that's what the wet refers to, the pulmonary edema, left heart failure, the pitting edema, right heart failure. Okay? The cool thing about it is that if you give intravenous thiamine to patients that are alcoholics that have this, in some cases you can reverse this entirely. Unfortunately, some cases of alcoholic cardiomyopathy relate to direct toxicity of alcohol. There, it's not going to work. But if it relates to actual thiamine deficiency, you can actually correct it. So here's your board question. I'll talk about some dude that comes into an emergency room with some kind of thing that requires an IV. So an intravenous is put in, and they'll say it's 5% dextrose and normal saline. Okay? Then they'll say all of a sudden the patient develops confusion, and then they'll say the patient has nystagmus, and of course if they're laying down, they're not going to have ataxia. So we'll talk about ophthalmoplegia and eye weakness and all that stuff, and they say what happened. Well, the answer is that they went subclinical thiamine deficiency. And the moment that you hung up the glucose on them, the glucose went to pyruvate, and the pyruvate went to acetyl-CoA. You used up the rest of the thiamine. And then you went to acute Wernicke's encephalopathy. Every single board has that question on it. Part 1, 2, and 3 has that one on there. That's the scenario. And it's a moral of the story. The moral of the story is you give IV thiamine before you hang up any IV with glucose in it, usually in the setting of an emergency room. Remember, when people come into the emergency room, either comatose or semi-comatose, there's a couple things you automatically do, right? 50% glucose, just in case it's a hypoglycemic thing. 2, naloxone, just in case it's an overdose. 3, IV thiamine. Those are the 3 things you always do with patients that are semi-comatose or comatose in an emergency room. Those 3 things. So it's must be pretty high on the list to see this pretty commonly, huh? Emergency rooms, Wernicke's. It also means lawsuit. Yep. Okay, so that's thiamine deficiency. And you'll learn a little bit more about the biochemistry. You might be a little foggy on that thing. Don't worry about it. But one of the best teachers in biochemistry in the country. Okay, I've heard them all. She's the best. Now, well, some of you are really experts on diagnosis. So what's this patient have? Notice he got this rash in the sun-exposed area. Pellagra, guys. This patient has pellagra. This is niacin deficiency. You already know. You can probably say, diarrhea, dermatitis, dementia, right? You got it all down, huh? Well, what's the dermatitis? You're looking at it. Okay. Well, that's the dermatitis. Yeah, that's it right there. Okay. So you get hyperpigmentation in sun-exposed areas. This is called Cassell's necklace. I don't think women would like this. Can you please get me a Cassell's necklace? I don't think you want this for a necklace. Okay, it's permanently on your neck. No, I don't think so. So that's the dermatitis of pellagra, okay, which is niacin deficiency. You know all those NAD, NADP reactions? What do you think the N stands for? Nicotinamide. Where do you think it derived from? Niacin. So all those oxidation reduction reactions that you're going to learn about in biochemistry, which of course I have in my notes under niacin, and put them all out there for you, are niacin. So you can see how important this is in biochemistry. In fact, that pyruvate to acetyl-CoA, okay, went from NAD to NADH, and niacin was involved in there. Tryptophan can be used in synthesizing niacin. Okay, tryptophan can also be used in synthesizing serotonin. So there's that tryptophan relationship. That's why it's an essential amino acid. Must have it because you need it to make serotonin, which is a neurotransmitter, and you need it to make niacin. It's not the main source of niacin, but it's a good source for making niacin, tryptophan. Okay, let's see. Do I have anything else to say about it? Yes, nicotinic acid that Trevor taught you about. The least expensive liquid lowering drug is nicotinic acid. You all know about the flushing associated with it. Remember, you're supposed to take an aspirin before you take the medication that gets away the flushing related to nicotinic acid. Remember, it's used in treating familial combined hyperlipidemia. So when you have elevated cholesterol and triglyceride, that's the drug of choice. Just teach you a little form there. Just kind of re-stimulating the synapses that Trevor opened up, okay, with his English accent, which you all know is a fake. Okay. Well, you got a Brooklyn accent. I came from Brooklyn. I was born in Prospect Park, 1943. Whoa. And I lived in Uniondale, Long Island, till I was 18. So I can talk Brooklynese anytime I want. Huh? Okay. All right. Okay, so that's the pelagrin. Now, there's some I'm not going to show pictures of riboflavin. Again, this is biochemistry. You know about FAD, FMN, flavine adenine dinucleotide, FMN, flavine mono, whatever. That reaction all those reactions are riboflavin cofactors reactions. So whenever you have FAD reactions or FMN reactions, riboflavin is the cofactor for that. So we have niacin for the NAD, NADP reactions, riboflavin for the FAD, FMN reactions is riboflavin. Also, that very first reaction that converts oxidized glutathione into glutathione, that very first reaction, glutathione reductase is the enzyme, riboflavin is the cofactor for that. So it's got a couple very interesting things in there. All of this is in your notes. And so right now probably doesn't mean a whole lot to you, but when you get Hansen going through these things, you'll start popping and go back and read this chapter, because all the important biochemistry reactions are listed there. Okay, and you got to know those. Cold, actually, for boards. Cold. You got to know them real well. Pyridoxine, incredibly important. Today, one of the first things we'll be talking about are the microcytic anemias. And the very first reaction in the synthesis of heme involves succinyl-CoA plus glycine. Enzyme, ALA synthase, cofactor, B6. So it's important in the synthesis of hemoglobin and heme proteins. Remember, the cytochrome system is a heme system also. Okay? Myoglobin has heme, except myoglobin differs from hemoglobin. Hemoglobin has 4 heme groups, whereas myoglobin has 1 heme group. But there's heme also in the liver. The cytochrome system involves using heme. So it's very important in that also. So pyridoxine is involved in the synthesis of heme, which is a porphyrin. Okay? Pyridoxine is in the transaminase reactions, which probably don't mean a whole lot to you right now, especially if you've been away from biochemistry. That's okay. Okay? Transaminase. Basically, you'll learn that from Dr. Hansen that the most abundant substrate for making glucose in the fasting state is alanine, okay, which is an amino acid. It came from muscle, because when you're in a fasting state, you start breaking muscle down to get substrates to make glucose by gluconeogenesis. And so the confusing thing for students is how can an amino acid be used to make glucose? Transamination. Because transaminases, SGOT, SGPT, those dudes that are liver enzymes, they actually have a function in transaminases. They can take amino groups out and put amino groups into things. If you take the amino group, the NH2 group, or whatever it is, out, alanine produces pyruvate. That's the alpha-keto acid. If you take aspartate, an amino acid, take its amino group out of it, you have oxaloacetate, which is a substrate for gluconeogenesis. So you see the importance of this? If I take pyruvate and I add an amino group to it, I can synthesize alanine. If I take oxaloacetate and I add an amino group to it, I have synthesized aspartate. Understand? That's what the transaminases do, and B6 is a cofactor. Also, B6 is involved in the synthesis of neurotransmitters. That's why if a little dude is B6 deficient, they end up with severe neurologic problems and convulsions because of these neurotransmitters. B6 is important in synthesizing them. Big time stuff here. Transamination, big time. Neurotransmitters, big time. Heme synthesis, big time. Most common cause of deficiency, isoniazid. Did our little friend Trevor tell you that? All right. Okay. That's the most common cause of B6 deficiency, is isoniazid. Okay. That's why you should give the patient B6 whenever they're on it. Otherwise, they can develop neurologic problems. They can develop sideroblastic anemias, as we'll find out, related to the heme problem. Okay? Very important. Pantothenic acid is involved with fatty acid synthase, which is one of the main, it's not the rate-limiting enzyme of fatty acid synthesis, but it's important in making palmitic acid, 16-carbon fatty acid. That's its main function. Also, it helps in making coenzyme A. You're going to see a lot of coenzyme A reactions, acetyl-CoA. Pantothenic acid is involved in that. HMG-CoA, okay? Pantothenic acid is involved in that. Biotin, they've asked this on boards. Biotin is the cofactor on the other reaction with pyruvate. Pyruvate, acetyl-CoA, pyruvate dehydrogenase, thiamine. Pyruvate carboxylase, oxaloacetate, biotin is the cofactor. So you got thiamine on one side forming acetyl-CoA from pyruvate. You got biotin on the other side forming oxaloacetate. If you're deficient in it, which is as rare as hen's teeth, you'd have to eat 20 raw eggs a day on a consistent basis because raw eggs have avidin in them, which binds biotin, so you can become biotin deficient. And so usually what ends up happening, you go bald. You get a rash and go bald. That's the deficiency you get. Guys, I have all those high yields, as you know, and I look through them, and they get into that biotin reaction big time. Just see if you can think about this. Okay, if you're biotin deficient, you can't form oxaloacetate, right? That means you can't form citrate either, right? So there's a problem there. Second, first of all, that's the first step in gluconeogenesis. So you can end up with fasting hypoglycemia. Second, you're going to get a buildup of pyruvate, okay? And it's going to be forced to go in what direction? Lactic acid, okay? See, if you understand the reaction, where it is, you can actually figure out what things have to happen if you're deficient in it. That was a board question, guys. Okay, so those are all important things, all in your high yield in the biochemistry, okay? Plus Hansen will do a good job of going over those for you. Vitamin B12 and folate we'll do when we do hematology this afternoon. Okay. Trace elements are big time, guys. They've asked just about all of these, maybe not molybdenum. I don't think manganese. I probably even shouldn't put them up here. Chromium, anybody know what chromium is, what it's used for? It's called the glucose tolerance factor. It helps insulin do its job. I take chromium picolinate every day, and it's going to help my insulin do its job. I do notice, though, it sometimes makes me hypoglycemic. Doesn't do a good job. That, along with oatmeal, with all its fiber, can lower your glucose levels pretty fast. And so I get dizzy sometimes. So I'm going to back it off on my oatmeal a little bit. And chromium. So it's glucose tolerance factor. Pretty good thing to do if you're a type 2 diabetic to be on chromium. It's going to enhance what little insulin you have. Okay, copper, many enzymes. But the biggest one for boards is lysyl oxidase. That's that enzyme that puts the cross bridges between collagen fibrils, and I also might add elastic tissue as well. And so if you're copper deficient, then you have weak collagen and weak elastic tissue. That's why I can get a dissecting aortic aneurysm. And you saw that flag sign, that red hair, and the little dude with kwashiorkor, that's due to copper deficiency too. Okay, fluorine, you know you need fluorine to prevent dental caries. If you have too much fluorine, you're going to get mottled teeth. These white chalky teeth, kind of like bit top spot of the teeth. Okay, instead of having a white patch on your cornea, you're going to have it on your teeth. Okay, if you're from Colorado, you got it, because all the water there has too much fluorine in it. Okay, also you're going to get calcification of the ligaments where the ligaments go into bone. They'll be calcified, to be subject to rupture. Any good radiologist can diagnose fluoride poisoning. Okay, just by an X-ray, they see calcification right where the ligament goes into a muscle. They see calcification and fluorine toxicity. You're saying they don't do this on boards. Are you kidding? Oh, yeah, they do it. Forget manganese, forget molybdenum, selenium. Whoa, selenium big time. Big time. Big time. Selenium, actually, it goes back to that pentose phosphate shunt and forming glutathione. Okay, remember we had riboflavin helping that enzyme, remember? But then remember we said that glutathione can neutralize peroxide. That requires glutathione peroxidase, selenium. Selenium is the cofactor for that last reaction. So in other words, it's an antioxidant. Because if you were deficient in it, then glutathione could not break down peroxide. That's why it's an antioxidant. In fact, usually you see when you take vitamin E, you check it out, it says vitamin E with selenium. Because it puts the two antioxidants together. One working on glutathione, making sure it's able to do its thing, and the other one working on the lipid membrane, preventing free radical damage to it, and knocking off oxidized LDL. I think you can see the importance of all these things. Zinc is on every exam. I'd be amazed if you didn't get a zinc question. Here's the way they do it. Usually they'll say it's an older person who has dysgeusia, okay, which tries to screw you up. Okay? This means abnormal taste. So they have an abnormal taste. They can't taste. Not only that, they have anosmia. They can't smell. So smell and taste are both deficient in zinc deficiency. Plus, remember we told you that it was a metalloenzyme? It means that when they say metallo, that means it's an enzyme that has a trace metal as a cofactor. Okay, so collagenase is a metalloenzyme because it has zinc in it. And that breaks down the type 3 collagen so that you can form type 1 collagen. That's why it produces, if you're deficient, and you have poor wound healing. Okay, and you usually get a rash on your face. A rash on the face, dysgeusia, anosmia, poor wound healing equals zinc deficiency. Every exam has got it. Very important one, zinc. Diabetics are all zinc deficient, unless they're taking zinc supplements. Very, very important that you know about it. Very important to know all these stinking trace metals. Let me tell you why, guys. Let me just tell you why. It was a JAMA article a while back that went through the top 10 causes of morbidity and mortality in the United States. Number 1 was smoking. Number 2 dealt with diet, poor diet, and lack of exercise. So number 2. Number 3 was alcohol. Okay? And that's why these are the board since that time has been concentrating on prevention. So they ask lots of prevention questions related to smoking, related to alcohol, and related to diet and nutrition, guys. They're hammering it if you haven't figured that out yet. Not just part 1, they hammer nutrition on part 2. All these things are on part 2, everything I said. All of them. They're hammering prevention. So I want you to know everything there is to know about smoking, everything there is to know about alcohol, and everything there is to know about diet and exercise. That includes trace metals. Do not blow over this. I'll assure you, you'll miss a lot of points if you don't know this cold. Dietary fiber, remember you have insoluble and soluble fiber. Soluble fiber is the one that can lower cholesterol, not insoluble. Here's how it works. Let's see, how does oatmeal work, for example? Why do I take oatmeal? Well, oatmeal works this way. It has insoluble fiber in it. And what that does when it's in my gut is it's going to suck up water into it from my colon and bad things that might be there, like lipocholic acid. So you have physiology. You may not have gone through this in GI phys. But you recall that 95% of bile acids, bile salts are reabsorbed in the terminal ileum. Recall? What do you think the 5% was? Lipocholic acid. It's carcinogenic. Produces colon cancer. So if you're on fiber, insoluble and soluble, it sucks the lipocholic acid up into the interior of the stool, so it has no contact with your bowel mucosa. Plus, you go poo more often. And so you poo more often, and that has even less contact with your stool. Women, you're lucky because you recycle estrogen. See, the main way of excreting estrogens is in bile and out of your stool. But a small percentage of the estrogens recycle back into your system. Okay, you may not necessarily need that. Okay, and so when you're on fiber, it takes that estrogen that would be recycled back and you eliminate it, and you decrease the incidence of breast cancer, ovarian cancer, and uterine cancer because of fiber in your diet. This is pretty big time stuff, isn't it? Mm-hmm. Big time stuff. Yes, it is. All right, we'll forget that. Nutrition and aging, we'll forget. Special diets. I'm just going to mention one special diet, and that's the protein restriction. Anyone figure out why you would restrict protein? What 2 diseases would you restrict protein in? Well, renal failure would be one, because if you have excess protein, that's going to be broken down into ammonia and other things. Ammonia is going to have to be metabolized in the urea cycle. You're going to have increased urea, and that means the kidney's going to have to get rid of more urea. So that's not a good idea. You put them on a low-protein diet. What's the other one, please? Cirrhosis of the liver. You have cirrhosis of the liver, you have a defective urea cycle, therefore you cannot metabolize ammonia. Most of the ammonia that we have in our bodies, guys, comes from bacteria in our colon that have urease in them. Helicobacter pylori has urease in them, so do our anaerobes. And they break down urea into ammonia in our colon. And then that's ammonia is reabsorbed and then supposed to go back to our liver and go into the urea cycle and become urea, and we get rid of it. But if we have cirrhosis, we have no urea cycle. And so the ammonia levels increase in our blood, and they result in all the different changes that you associate with hepatic encephalopathy. The mental status abnormalities, asterixis, and all that stuff. Ammonia is one of the causes of that, along with octapamine and other gamma-aminobenzoic acid false neurotransmitters. Pretty important stuff. And so the two situations where we restrict proteins in the diet would be cirrhosis and chronic renal failure. Neoplasia. Where are we on now? You know, neoplasia is a big bugaboo. In fact, that's what's being taught as we speak back in my school. We dedicate 5 hours to teaching it in the school. And it'll be well taught, and you'll forget it. Okay? It's the nomenclature that gets you, and I just don't understand. I guess I should, because I'm a pathology, because this is just second nature to me to know this stuff, but I don't get why students have so much trouble with nomenclature. That seems to be the big bugaboo. I mean, most would not be able to tell me the difference between carcinoma and a sarcoma, leukemia and lymphoma. I have no idea. Most people, most medical students. Or if they do, they forget it real fast. So let's make sure you get it, huh? Because it's very important. Okay, so we have benign and malignant, huh? And the main difference, really, forget all the other crap about whether it has a capsule, no capsule, that's all bull crap. The main thing is benign usually doesn't metastasize. Malignant has the capacity to metastasize. That's the big difference between benign and malignant. There are exceptions to everything. Okay? I know a tumor that's benign that metastasizes. Okay? And it's an invasive mole. That's a benign tumor that can metastasize to your lungs, but it'll go away. So there's a benign tumor that can metastasize. I know basal cell carcinoma. Most common skin cancer invades but doesn't metastasize. So there are exceptions. But in general, the main difference between benign and malignant is that benign doesn't metastasize, malignant does. Forget all the rest of it. Okay, I'm going to go through some nomenclature. Here's the uterus, and you got these little dudes in there. Naming leiomyoma. Here's the board question. The most common benign tumor in a woman is most commonly located in which of the following organs? Uterus. Okay, because that most common tumor is a leiomyoma, which is a tumor of smooth muscle. The term fibroids is often used, bad term, and oid means looks like fibrous tissue, but isn't, and that's true because it's smooth muscle. Okay? I guess it's because they become so hard, okay, that they look like scar tissue, but they basically derive from smooth muscle. Do they become leiomyosarcomas? No. There's no transformation. Okay? This is the most common benign tumor in a man. Notice it's yellow. Yellow. I've got a couple of them right along my elbow right in here. They move around a little bit. What is it? Lipoma. Lipoma is the most common benign tumor in a male. Most common benign tumor in a woman is leiomyoma in the uterus. Okay, we have tumors, benign tumors of glands. They call those adenomas. Here's the adrenal. Here's an adenoma of the adrenal. You can see by the thinness of the adrenal cortex that this must be functioning. Okay? It could be making cortisol. What would that suppress? ACTH. What would that screw up in the adrenal cortex? Reticularis would undergo atrophy. And that's pretty much what's happening here. So this is a functioning adenoma, secreting cortisol, producing Cushing's in a patient. What if it was arising from what if it was making mineralocorticoids? That'd be Conn syndrome. Okay? So what would that be doing? It would be causing atrophy of which section? Zona glomerulosa. Hey guys, if you haven't figured it out, the 3 layers, GFR, glomerular filtration rate. Glomerulosa, fasciculata, reticularis. Glomerulosa, salt. The fasciculata, glucocorticoids. Reticularis, sex hormones. It's very simple. Okay, very simple. Make sure you know that. You actually have diagrams, with arrows pointing to these different things. Here's the tubular adenoma. This is the most common precursor lesion for colon cancer. Looks like a strawberry on a stick. Look at it because you're going to see it. You see something that looks like a strawberry on a stick? That's a tubular adenoma. It's a precursor for colon cancer. Okay, carcinoma, sarcoma. Carcinoma is a malignancy. All of this is in your notes. I see no reason for copying anything down. I honestly don't. You're going to miss the important points. Carcinoma is a malignancy of epithelial tissue. We have three epithelial tissues: squamous, glandular, transitional. Okay? This is squamous carcinoma. Look at it. Don't be looking down. Look at this. How are you going to recognize it? These dudes. These little swirls of increased redness in there called squamous pearls. They are on every one. If they're going to show you squamous cancer, they always show those. Every student in this room should know squamous cancer. What you got to do is recognize these little red things, that little swirls, nice and dark, nice bright red, squamous pearls, squamous cancer. Okay? So that's one type. What are these things? They're glands. You can see they're glands. They're round and they got something in the middle. Glands, adenocarcinoma. So they would show you a picture of an adenocarcinoma. They would show glands and there would be things inside. Not hard to identify. This right here is transitional cell carcinoma. Okay, these would come from the genital urinary tract, the bladder, okay, the ureter, the renal pelvis without transitional epithelium. So those are your three carcinomas: squamous, adenocarcinoma, transitional cell carcinoma. Okay, with me so far? Okay, some other terms. Diagnosis: malignant melanoma. First step in management: excision. Okay, this is a malignancy of the the melanocytes. What's the benign lesion called? A nevus. A nevus is a benign version. Melanoma is a malignant version. It's derived from the melanocytes. Okay, it's the most rapidly increasing cancer in the United States. That's not to say it's the most common cancer. I said it was the most rapidly increasing cancer in the United States. Okay, they're S100 antigen positive. They are APUD tumors. APUD, amine precursor uptake decarboxylation. What does that mean? Okay, it means they're of neural secretory or neural crest origin. It means they have, when you do an electron microscopy, which I have another picture of when we do lung, they have neural secretory granules on electron microscopy. S100 antigen is an antigen that we use for staining things of APUD origin or neural crest origin. Most, not all, will take up that stain. So they're part of the APUD tumors, and they're all up here for you except for a few. So melanoma is an APUD tumor. This is small cell carcinoma of the lung. Okay, that's an APUD tumor, neural secretory tumor. Its less malignant counterpart's called bronchial carcinoid. That's an APUD tumor. It's a carcinoid tumor of the tip of the appendix. That's an APUD tumor. Okay, this is a neuroblastoma in the medulla in a child. It's an APUD neural secretory tumor. They say, I don't think they have stuff like that. Oh, really? And what about the two-year-old that had nodules all over their skin? They biopsied them, so these small hyperchromatic cells, which are S100 antigen positive. That's it. That's all they said. And they said, where's the tumor coming from? The adrenal medulla. It was a neuroblastoma, metastatic to skin. So don't tell me they don't ask questions like this. They do. They do. So this is pretty nice because it really puts most of the APUD tumors, except I don't have a bronchial carcinoid up there. Sarcomas. Sarcomas are malignancy of mesenchymal tissue, not epithelial, mesenchymal. Okay, here's the bone. Okay, this is the metathesis. You can see that it's split up this little periosteum, so an X-ray would show Codman's triangle there. Because this particular tumor makes bone, you can actually on an X-ray see what looks like a sunburst appearance. Okay, diagnosis: osteogenic sarcoma. What do you think osteogenic means? Bone-making sarcoma. See this picture? This is on boards. They said this is a biopsy of a patient, a little girl that had a mass, a necrotic mass coming out of her vagina. So they biopsied it, and this was there, and it was Vimentin negative, keratin negative, and Desmond positive. Diagnosis. Diagnosis. And Bryan-O'Reilly-myosarcoma. Bryan-O'Reilly-myosarcoma. You should have known that. Why? Striations, guys. Those little striations of muscle. This is the most common sarcoma in children. It comes out of the vagina of little girls and out of the penis of little boys. Okay, so let's say sarcoma of a smooth muscle. Name it. Leiomyosarcoma. Striated muscle. Rhabdomyosarcoma. Fat. Liposarcoma. Very good. So those are malignancies of mesenchymal tissue. Carcinomas, epithelial tissue. Okay. I put these two together because you confuse them frequently. Who can tell me what this movable mass is at the angle of the jaw? No, mixed tumor. Mixed tumor. Okay. Mixed tumor. And what organ is it in? Parotid. It's your most common overall salivary gland tumor, usually benign, occasionally malignant. When it says it's mixed, it means it has two histologic different types of tissue in it, but they derive from the same cell layer. It's not a teratoma, which is the way they try to get you. This is a teratoma. How do you know? Because there's a tooth, there's hair, there's a comb underneath there, there's a toothbrush underneath there. God would never produce a teratoma with teeth and hair without supplying the things to take care of it. Teratomas derive from all three cell layers, ectoderm, endoderm, mesoderm. You all know the question on cystic teratomas of the ovary. 16-year-old girl, sudden onset of right lower quadrant pain. They always make it on the right lower quadrant. Why? They want to confuse you with appendicitis, Crohn's disease, ectopic pregnancy, follicular cyst, and the whole bit. You have to know the whole differential for right lower quadrant pain. Then they say you do an x-ray and it shows some calcifications in the pelvic area. Voila. Okay, you're dealing with a cystic teratoma. Okay, the calcifications could be bone or it could be these teeth. Okay? That's a teratoma, all three cell layers. Mixed tumor, two different types of tissue, same cell layer, carotid gland. Another name for these types of things are germ cell tumors because they have pluripotential. And they have a tendency of staying in the midline. And the ovaries are reasonably midline. Okay, anteromediastinum is right in the midline, so teratoma is commonly developed in the pineal gland. Is midline. So they talk about midline tumors, the teratomas, which are germ cell tumors. Okay, leukemia, lymphoma. There's a reason why I put these two together so that you can get this. Okay, this picture was on 8 million boards. I was teaching in Washington, D.C. when the first computer-based exam was given. And there was one student that actually took that test that day. It was the first day of lecture, actually. Came back, and of course, he was surrounded by people. Okay? And so, of course, I got him a loon. Okay. You have any hematology? Yeah. How many pictures? 2. I'm going to tell you what they are. Oh, no, you can't tell me what they are. Sure, I'll tell you exactly what they were. All right, go ahead. There was an hour rod and a myeloblast. His eyes went open like this because it was this picture. Here's your hour rods. That's a myeloblast. And so the second one was a hypersegmented neutrophil. That's right. Okay? B12 folate deficiency. If I had to pick 2 pictures, those would be the 2 I picked too. Okay? That's the way they did it. So you're almost guaranteed seeing this for leukemia and the hypersegmented neutrophil for folate B12 deficiency. A leukemia is a malignancy of stem cells in the bone marrow. And like all cancers, they can metastasize out of it and always do. Lymph nodes, like generalized lymphadenopathy, hepatosplenomegaly, guaranteed, and other areas of your body. So they derive from stem cells in the marrow and metastasize. A malignant lymphoma is this. Malignant lymphomas arise from lymph nodes. And because they are malignant, they can metastasize wherever they want, including bone marrow. Not all do, but they can. So they can metastasize to the same place as leukemias does. But one arises from the lymph node, the other one arises from the bone marrow. That's leukemia versus lymphoma. Now, who can tell me the most common site in the body for a lymphoma not developing in a lymph node? The stomach is the answer to that question. Most what they call extranodal, outside lymph node, primary lymphomas occur in the stomach. Now, little friend, Helicobacter pylori can produce them. Okay, this one you should get. This one you should get. What's the second most common location? Hint, it's a lymphoid organ in the GI tract. Peyer's patches. Where are Peyer's patches located? The terminal ileum. That's the second most common site. Are you with me? You better be, because this is big time. So I put these two. This is good. Mixed tumor versus teratoma, leukemia versus lymphoma. This, by the way, is your most common lymphoma. It's called a follicular B-cell lymphoma, and it's an example of knocking off an apoptosis gene. There's a 14-18 translocation of a heavy chain, and what happens is, when you get that translocation, the B cells make this BCL2 thing product, which inactivates the apoptosis gene in the B cell. Remember we said it's involved in programmed cell death. If you knock off that one, the apoptosis gene, then that cell's immortal. So it's the question on boards for an inactivation of apoptosis gene cancer. It is the most common of all the lymphomas. That's a B cell lymphoma. Okay, right now we're just giving you just little histories on these things and just names. That's what we're interested in now. We talk about this another time, and this another time. All right, trophoblastic tumors. These are tumors we see in pregnancy. Of course, males can get them, and that has nothing to do, so that's non-gestational. You all should know what this is because it's on every exam. What is it? It's a hydatidform mole. If it looks like a bunch of grapes, that's what it is. You all know that hydatidform moles present in the first trimester with signs of preeclampsia. So any patient that has hypertension, proteinuria, and edema, in the first trimester, you're going to do an ultrasound, and you'll see that you have the uterus too large for gestational age with snowstorm effect from the ultrasound. That's classic mole. This happens to be a complete mole, which has the highest tendency for going into this lesion. That's called choriocarcinoma. A mole is benign tumor of the chorionic villus. Chorionic villi are lined by trophoblastic cells. They include syncytial trophoblast on the outside. That's the part that has contact with the blood from which oxygen is going to be extracted. You better listen on this, okay, because they ask you the direction of how all the layers that oxygen goes through in the chorionic villus. They do. And under the syncytial trophoblast is a cytotrophoblast. Okay, then you have the little Wharton's jelly in the chorionic villus. And then you have a little vessel that's in the middle of the chorionic villus, which eventually becomes the umbilical vein, which is the one that has the most oxygen of all the vessels in the fetus. All of this is on board case. So the hydatidform mole is a benign tumor of the whole chorionic villus. That's why it looks like grapes, okay, because they're all dilated up. Now when you have a choriocarcinoma, that's not a malignancy of the chorionic villus, it's a malignancy of the lining of the chorionic villus, the syncytial trophoblast and the cytotrophoblast. Which are the two makes hormones, guys? Syncytial trophoblast, name them. Beta-HCG, what's the other one? It's the growth hormone of pregnancy. Human placental lactogen. Human placental lactogen is the growth hormone of pregnancy. It gives amino acids from mommy to the baby and glucose from mommy to the baby. Both of those are synthesized in the syncytial trophoblast. These are malignant, but what's interesting is when they're gestationally derived, even though they're metastatic to lung, which is their favorite site, they respond incredibly to chemotherapy like methotrexate, chlorambucil, and they go away. So it's an example of a highly, highly malignant tumor, but you almost get entire remission with just chemotherapy. That's wonderful. That's good. Break 10 minutes. All right, 10 o'clock. Okay. We're doing reasonably good. Okay, all that ends in oma is not necessarily benign. Okay, so take melanoma. If you just say that, you'd say, that must be a benign tumor of melanocytes. No, it's a malignant melanoma. Lymphoma, so that must be a benign tumor of the lymph nodes. Okay, no, it's a malignant tumor. So all that ends in oma is not necessarily malignant. Also, all that ends in oma is not necessarily a neoplasm. And I'm showing you the two good examples of that. This is called a hamartoma. A hamartoma is an overgrowth of tissue that's normally present in that area. And the one that you all know is a bronchial hamartoma. Basically, all this is cartilage. It's benign cartilage, and it presents as a solitary coin lesion in the lung, which makes you wonder about whether it's a granuloma or something of that nature, but it's a hamartoma. So they're not a neoplasm. The polyp of Peutz-Jeghers syndrome is a hamartoma. It's not even a neoplasm. That's why there is no really increased risk for colon cancer in Peutz-Jeghers syndrome, because the polyps are not neoplasms. The hyperplastic polyp, which is the most common polyp in the entire GI tract, is a hamartoma. So it's not even a neoplasm. Okay. All right. This one here is a section of stomach, and in the muscle wall of the stomach is benign pancreatic tissues. Does that belong there? Yes or no? No. So when you have benign tissue in a place it shouldn't be, that's called a choristoma, or another name, heterotopic rest. Either one of them. Okay. Meckel's diverticulum is a classic example. I mean, what's the most common complications of Meckel's diverticulum? Bleeding. From what? Well, usually either gastric mucosa that's ulcerated or sometimes pancreatic tissue causing the ulceration. Should gastric mucosa be in a Meckel's diverticulum? I don't think so, because that's in the small bowel. Remember, that's roughly 2 feet from the ileocecal valve. That's an example of a heterotopic rest. Should pancreatic tissue be in it? No. But it is, so that's another good example of a heterotopic rest. So hamartomas are non-neoplastic lesions, and therefore have no potential for producing cancer. Okay, so let's talk about the big word M, or the big word C, cancer. You know, one of the big misconceptions is that, increased mitotic rate means cancer. No. I mean, we have lots of cells in our body that are mitosing right now. That doesn't mean we have cancer. Mitoses are part of the growth of the cell cycle. The thing that really makes a mitosis malignant is this. See, that's not the normal mitotic configuration. This probably has a 4N cell. This has more chromosomes in it than normal. When you have an atypical mitotic spindle, that's cancer. So an increase in mitotic rate doesn't really mean anything. But when you have atypical mitotic spindles, that usually relating to the fact that they're aneuploid, they have more than the normal 46 chromosomes, they might have 63 or whatever, that's malignant. Okay. Also remember that the sine qua non, that means the key thing that determines whether something is malignant is its ability to metastasize. A couple other things I have listed down there for malignant cells, they have usually a longer cell cycle than the cell from which they derived. You do need to know about that. This is a memorization thing, but they throw it every now and then. You see how many doubling times does it take before you get a tumor that you can detect clinically? The answer is 30. 30 doubling times means 30 times going through the cell cycle. And you get a tumor that's about 1 centimeter in size, okay, 10 to the minus 9 in mass, okay? So 30 doubling times is something you want to remember, is that when a tumor can become clinically detectable. Malignant cells are immortal. I mean, so they really can't die. They can live forever in tissue. In fact, we use Burkitt's lymphoma cells as a test for immune complexes, okay? So we can grow Burkitt's lymphoma cells in culture. They're immortal. They don't like each other, okay? They kind of don't stick to each other. They lack adhesion. That's important because if they were stuck to each other, then how are they going to infiltrate tissue? So they lack adhesion. They don't like to stick to each other. So leave me alone. I want to burrow through this tissue myself. Okay, I don't want anyone impeding me. Okay, they have very, very simple biochemical systems, usually anaerobic metabolism. They have lots of enzymes. They have to have proteases because that's they're going to use to break through the tissue. Proteases. Okay, they're going to have collagenases to break through that basement membrane. So they have to have those kinds of enzymes to do things like that. Okay, those are the key things that make a malignant cell malignant. Metastasis. Three modes of metastasis: lymphatic, hematogenous, seeding. Now, this is a big misconception here, too. Now, then we have carcinomas and we have sarcomas. How do carcinomas usually initially metastasize? Lymph nodes. They drain to their regional lymph nodes. So for breast cancer, that's the axillary nodes. They can also go to the internal mammaries if they want. For colon cancer, it'd be the nodes right around it. For esophageal cancer, the nodes right around it. So they go to the local lymph nodes. What part of the lymph node? The subcapsular sinus. Okay, and this is showing cancer cells in a lymphatic here, and then showing here a lymph node that has been partially replaced by a malignant tumor. Okay, malignant tumor. So they first go to lymph nodes as a rule. But don't forget, if they can get through that lymph node and go into the efferent lymphatics, and that drains into the thoracic duct, which jumps into the subclavian, then they're hematogenous. So don't think that carcinomas are not hematogenous spread. Of course they are. And when they're hematogenous, that means they've already got through the lymph nodes. And so when they're hematogenous is when they can go to bone and liver and other places. Okay? So don't forget that. Carcinomas can be hematogenous. But usually first they go to the lymph nodes. In a sense, that's good because if we can feel that lymph node by clinical exam, we can maybe pick up that cancer at an early stage. Unlike sarcomas, which don't like going to lymph nodes. They just like going right through blood vessels right there, and they usually characteristically metastasize hematogenously. That's why the lungs and the bone are such common sites for sarcomas. Okay? They don't usually like going to lymph nodes. So those would be a little bit worse, wouldn't they? Because they go hematologous right off the bat. Okay, they don't give us any hints that they're there because they don't like going to lymph nodes. Now, the practicality of that is that if you have, let's say, an angiosarcoma of the breast, would you do a radical dissection of the axilla? No. Why? Because an angiosarcoma doesn't go to lymph nodes. You do a simple mastectomy. If it was a breast cancer, though, a carcinoma, you would take the breast, or you do a lumpectomy, and you'd sample a couple lymph nodes or do a complete dissection. Okay, that would be part of it because carcinomas go there. Okay, you understand? So there's practicality in knowing that. Okay, so this is lymphatic spread. You can see it's a lymph node here. This is tumor in a vessel. Now, I know my pathologist friend knows I'm trying to pass this off as sarcoma, and he knows that it ain't. But at any rate, sarcomas like to go in a blood vessel. This is a blood vessel. Here's tumor in the blood vessel. Actually, this is a carcinoma that doesn't know it is. It's a follicular carcinoma of the thyroid. There are some carcinomas that say, no, I don't always like to go to lymph nodes. I want to go to hematology. Okay? And so one classic one is the follicular cancer of the thyroid. It doesn't like to go to lymph nodes. It thinks it's a sarcoma. Okay? Kind of a transvestite thing, whatever you call something like that. Okay? Renal adenocarcinoma, you know, like to invade the renal vein. I mean, you shouldn't be doing that. Well, I like it. Why do you like it? I just like it. Okay? Okay, and that determines your prognosis, too. In fact, I've seen renal vein, I've seen it go all the way up the renal vein and up the inferior vena cava. I mean, it likes it so much. Hepatocellular carcinoma is always in vague vessels. So there's an exception to every rule I'm saying. Okay, but in general, carcinomas first go to lymph nodes and then have the potential for becoming hematogenous. Sarcomas usually don't like lymph nodes and go directly hematogenous, which makes them dangerous. There are some sarcomas that do go to lymph nodes, but you don't need to know them. Seeding. Seeding is a concept of like seeding. The farmer throws out seed, and wherever that seed lands, it expects it to go and burrow into the dirt, and out comes a plant. Okay? And so when we have cancers that are in cavities, a classic example of ovarian cancer, they have a tendency of seeding, little malignant implants. Okay? See, most ovarian cancers are surface-derived cancers. So that means they derive from the lining around the ovaries. And so you can see it's very easy for them to seed, throw out malignant implants of small little pieces of cancer and go over the omentum and into the Douglas pouch of Douglas, okay, which is just posterior to the uterus and just anterior to the rectum. We can feel that by rectal exam. The pouch of Douglas is to a woman as the prostate gland is to a man. When you do a rectal on a man, you press forward, that's the prostate you're feeling. When you do a rectal on a woman, you press forward, you're feeling the rectal pouch of Douglas, which we'll show you when we do GYN. Okay. Very important area because it's the most dependent part of a woman's pelvis. That's where things like unclotted blood go, and a ruptured ectopic. That's where endometrial implants go, and endometriosis. That's where seeding goes in ovarian cancers. The pouch of Douglas, a very important anatomic location. Been on many, many boards. So seeding, and this is an example of an ovarian carcinoma that's seeded to the omentum. Okay, so it actually can invade. You can actually seed in the pleural cavity. For example, if you have a peripherally located lung cancer, it can get to the pleural, it can seed through the pleural cavity. Okay, and you can see little implants all along. Glioblastoma multiforme, the most common primary malignancy of the brain in adults, can seed into the spinal fluid and implant the entire spinal cord. So can a medulloblastoma in a little child. Do the same thing. Okay, so seeding, that's the concept. So we have lymphatic, hematogenous, and seeding. That's the three mechanisms for metastasis. Okay, now I want to make sure you understand this concept, and that is, if they ask you about, most common cancers and stuff like that, could you please, when they ask something like that, first ask yourself the question, is metastasis more common than the primary cancer? In most cases, metastasis is the most common cancer in an organ. Okay, not a primary cancer. I'll give you an exception to that. Renal adenocarcinoma, that is the most common one, not metastasis to it. When we talk about lung, the most common cancer in the lungs is metastasis, and unfortunately, it's breast cancer. That's the most common cancer in the lung. It's breast cancer. So that means that women are more likely to have metastasis to lung. Bone, most common cancer of bone is not multiple myeloma, osteogenic sarcoma. No, metastasis. And unfortunately, again, the most common cancer that metastasizes to bone is breast. That's because that stinking Batson system, the BATSON system. It's a venous complex that goes from the base of the skull down to the sacrum. It has no valves in it, and the little tributaries communicate with the vena cava, and little tributaries go right into the vertebral bodies. And they collect all together on the inside, right around the spinal cord area, and go back up. So there's a horrible little system there. And so you take a woman with a breast cancer, for example. She's maybe got a little plug of tumor in an intercostal vein. She goes and picks something off the ground, and she dislodges that little piece of cancer from the vein to the vena cava into the Batson plexus and the vertebral body. 3 months later, she's complaining of low back pain. All of a sudden, she's stage 4 cancer just by bending over. Thinking Batson system. The most common bone metastasized to is the vertebral column. The second most common is the lumbar area. The vertebral column, second most common area is the head of the femur. Any good pathologist knows that, and no person gets a femoral head remover. Always take a section tube because things metastasize to it. Woman, breast cancer. I've seen breast cancer in the femoral head that they thought was related to degenerative arthritis. It was breast cancer that caused the problem. Okay. So none of that. Most common. What do you think the most common organ metastasized to is? Lymph nodes. That one you actually could figure out because carcinomas are more common than sarcomas. Carcinomas like to go to lymph nodes. That would be the most common metastasized to. This one will get you all. Ready? What's the most common cancer of liver? Metastasis. What do you think the most common primary is? You want to say colon, don't you? It's not colon. It's lung. Most common cancer metastasizing to liver is lung. Don't believe me? Look at Travison's textbook surgery. They have this big table with 100-something thousand autopsies, and by far and away, lung beat colon as the most common cancer metastasizing to liver. Second would be colon because of the portal vein drainage. Here's another one. Where would a testicular cancer metastasize to first, please? The paraortic lymph nodes. Why not the inguinal lymph nodes? Because remember, it derived from the abdomen and then descended into there. See, those are questions they ask in anatomy, guys. Okay, they take a clinical bent on a question that related to knowing that the testicles originally from the abdominal cavity, and then they just descended into the testicles. So if they're malignant, like a seminoma, first place is not the inguinal nodes. The first place would be the paraortic nodes, from whence they came. Okay, what about that left supraclavicular node? What do you think about with that? Metastasis. That's called Virchow's node, most common primary. Stomach. There you go. They don't say Virchow's node. They just say there's a mass in the left supraclavicular node. They do not give actual names to these things, which is Virchow's. And someone with weight loss and epigastric distress. Duh. Stomach cancer. Metastasizing. I want you to look at this, please. This is a radionuclide scan, which is the best test for looking for bone mets. Everywhere you see black, except that urine down over there, is metastasis in this poor woman with breast cancer. If this doesn't solidify in your head that the most common bone metastasizes to is the vertebral column, I don't know what will. This entire vertebral column is full of cancer. And there's your pelvic recurval bit. Notice you're going to get a little bit in that acromioclavicular area too. Now we have metastases that are lytic. We have metastases that are blastic. Lytic means they break bone down. Okay. You all know that multiple myeloma has these nice punched-out lesions. You want to know why? All malignant plasma cells have interleukin-1 in them. You already know what interleukin-1 is. It's got another name for it, osteoclast activating factor. So you already know the mechanism for that. Okay, so we have lytic. And so we can get pathologic fractures from that. We can also get, if they are lytic, what metabolic abnormality? Hypercalcemia. There you go. Okay. Then we have some that they go in the bone and induce an osteoblastic response. Take this, for example. I mean, that's bone. You can see it's dense, okay? So I want you to tell me what enzyme would be elevated in this patient. Alkaline phosphatase. And I want you to tell me, is this a male or a female? Play odds. Male. With what cancer? Prostate cancer, which is almost always osteoblastic. And because it's making bone, it's going to release alkaline phosphatase. Most common location for metastasis is the lumbar vertebra, actually. Fourth question. That an 80-year-old man with lower lumbar pain with point tenderness. Okay? Well, they said, what's your first step in management? And they said bone scan. They said PSA, prostate-specific antigen. They said rectal ultrasound. What's your answer? Your finger. Rectal exam was the answer. Why? That'd be stage 4 disease, which means that definitely the prostate is going to be palpable, so that'd be the simplest, easiest thing to do. Put your finger in there and check. You know, that's it. Of course, you are going to do a PSA. You are going to do a scan, but the first step in management is the obvious, the cheapest, your finger. Put something on it. Cut. I can't tell you how many people pick PSA, prostate-specific antigen. Bad error. Or radionuclide bone scan to make sure that's not lumbar metastasis. That's great. You're going to be doing that, but you should have done a rectal before. You with me? Good. These are lytic metastases. You can almost see that. Look at how that vertebra is collapsed. Okay. So we have lucencies, you know, where there's an absence of bone with lytic metastases, whereas in blastic you'll have entities on a regular X-ray. Okay? All right. Now, just a point. This is a CT scan of the liver. And you notice there's multiple defects. I want you to remember this and do not forget this. This is a general statement. If you see a gross specimen, an X-ray of something, I don't care, with CT, MRI, a gross, whatever, it's got multiple lesions in it, it's metastasis for your intents and purposes. Don't pick abscess, you know, or whatever. It's metastasis. Don't pick primary cancer. Primary cancers usually aren't like this. Usually they're within one area, maybe another area, but not all over the place. So if you see any growth specimen, any X-ray with multiple lesions in it, it's metastasis. Just find out where in that choice that deals with metastasis. You see it? Do not pick anything benign, ever. All right, here's just examples of other places metastasize to. There's the brain. What do you think the most common cancer brain is? Metastasis. What's the most common cancer killer in men and women? Lung cancer. Therefore, what do you think is the most common primary site for cancer in the brain? Primary lung. There you go. Okay, this is liver. You already know that's also lung. Here's lung. What's the most common cancer in the lung? Metastasis. And what's the most common primary? Breast. Okay? This is the adrenal gland. What do you think the most common tumor metastasizing to adrenal is? Lung. That's why they always do CTs of the hylar lymph nodes, and they have the adrenal glands in the staging of all lung cancers because they go so commonly to adrenal glands. Okay, and of course, this is bone. Is this lytic or blastic? It's blastic, so what is the most likely cause? Prostate cancer. There you go. All right. Stains. Well, I already mentioned one, Desmond. Remember intermediate filaments? Desmond is a wonderful stain for muscle, and that's why they use that when they think they have a muscle tumor, like an embryonal rhabdomyosarcoma. They do that. We have stains for keratin. Most carcinomas have keratin in them, and so we stain for that. We have stains for just about everything, and we use them in helping us identify different kinds of tumors. Okay, so that's all I'm going to say on that. Electron microscopy is not used very commonly in pathology. Only sometimes when we don't have no idea what the thing is. The stains don't work, all the different special things and all that don't work. We sometimes have to do electron microscopy and see if that'll help us. Okay? Sometimes, like for example, if we had an optic tumor, what would we see? Neural secretory granules. If we had a histiocytic tumor, like let's say histiocytosis X, letter C, we see Christian, what will we see? Burbic granules. Okay, because they're characteristic. And what would be the cluster designations that we would see? CD1, there you go. Okay, if we had muscle, what would we see? We see actin and myosin filaments. Okay, if it was a vascular malignancy, we'd see ribopelade bodies. These are the structures that have von Willebrand factor in them. We can actually see those things, so we know that things of endothelial origin. Are you with me? This is how they get at histology, guys. Histology is the least important thing on the exam, but the way they ask the questions is in relationship to how we use histology in making diagnoses in pathology. That's how they use it. And don't forget the gap junctions. And know all the gap junctions. Know which ones communicate, which ones don't, and all that stuff. Okay, now this is the most important part right here, oncogenesis. I'm going to make this as simple as I can. Why? Because I can't understand it all, because it's just so much to it. But I think what I've got is more than enough for this board. I'm going to be very simple on this. First of all, whenever you study something, always get the big picture first. Don't start delving into little picky facts. That's why you'll never end up with a knowledge of anything. But I can always tell when you don't know how to study. You open up a book and you start underlining right off the bat. You have no idea how to study. That's not the way you study, because you're already starting to get picky facts. The way you study is to get the big picture first. That means you don't underline anything. You just read it through fast at the level of a novel, or a little slower than a novel. You get the big picture. The big picture to me is definitions. Knowing the definitions of the different things. That's the big picture. Then you go back and study for, the mechanisms and stuff like that. Got to have a big picture. No big picture, you're screwed. So what would be a big picture, for example, tissue hypoxia. Big picture would be ischemia, hypoxemia, hemoglobin-related problems, uncoupling of oxidative phosphorylation. That's the big picture. Okay? You don't know that, you're screwed. You don't know tissue hypoxia. Okay? Got to do big pictures first. So here's the big picture. The way we're going to do this by, I don't know if you understand, for some of you may not have in your countries, and probably you're lucky, fraternities and sororities. In this country, in the colleges, they have all these things. It's a way you're going to remember oncogenesis. Okay, so if I was going to want to get into a fraternity in college, I have to be initiated. So the first step in malignancy is initiation. And that means mutation. It has to be mutation. There's always kinds of mutation. We'll learn them in a second. That's the first part of going into a fraternity or sorority. You have to go through initiation, do stupid things. But for oncogenesis, it's a mutation. Okay? We like you. You did all the stupid things. Please come into our fraternity. Okay? So now you'll be promoted. Okay? You are promoted into the fraternity. So promotion is the second step of oncogenesis. That's where you make multiple copies of that mutation. Remember, from going into the G1 or the S phase, you've got a mutation in there, and you start going through that cell cycle. Bad news. You're making multiple copies of it. That's promotion. Okay? And then you're in this fraternity, and you really are really good. So we want to make you president. We want to make you in charge of the whole thing. So you progressed in that fraternity or that sorority, and now you're a leader. That's the third step in oncogenesis, is progression. And what that means is that different kinds of cancer cells have different functions. It's basically a community of malignant cells that has one purpose: to kill you. Okay? Okay, you just see this big collection. It says, okay, who wants to stay where you are? Me. Okay, you're the couch potato, you stay here. Who wants to invade right where you are? Me. Okay, so they're given special things to be able to invade. Who wants to go to the lung? Me. Okay, and they're given special things with receptors to hone in on the lung. Yep, that's the way it works. I mean, they even have some, who wants to resist the chemotherapy they're going to throw at us? Me, okay? And so they have those that can actually, resist the chemotherapy before you even throw it at them. That's why culturing cancer cells is the big thing now, and they're kind of doing like they do with bacteria. They put the sensitivity plates, the Kirby Bauer. You can do that with malignant cells now. They do it with melanomas. They take your tumor, they put it in the culture medium, and they can put discs that have different chemotherapy agents in it and see if it kills them. And then they can give you the exact chemotherapy agent and it'll kill it. That's where it's going. But unfortunately, they can't do that for every cancer. Otherwise, that would be the best way. This is called progression. So could you please tell me what the stages are in order, please? What's the first stage? Initiation. What does that mean? Mutation. Okay, what's the next step? Promotion. What does that mean? Dividing it, making multiple copies. And what's the last stage? Progression. What does that mean? That's subspecializing. Okay. Good. That's the big picture. Now let's go and start getting into the finer points. Well, we have two sets of genes that are involved in cancer. One, we have those that are involved in the growth process. Those that are involved with cell cycle-related things. We've already been introduced to some of those, okay? Then we have those kinds of genes that kind of like monitor things, suppress things. So we have groups of cells that are involved in the normal growth cycle, and then we have other types of genes that are involved in suppression. Those are called suppressor genes. Okay? Those are the two big sets of genes. Now, you all know, and you should have had this in cell biology already. Let's take things that are involved in trying to get a cell to divide. Well, first of all, we have growth factors. A good example is epidermal-derived growth factor. Okay? We have certain, what they call proto-oncogenes. These are genes are cancer genes, but normally, when they haven't been activated, they actually serve a normal function in a normal growth process. That's why they're called proto-oncogenes. When they become oncogenes, that means that they're bad. They are cancer-producing genes. And so we have certain proto-oncogenes that code for growth factors. A good example is CIS, S-I-S. It's a proto-oncogene. Its only function is to make the growth factors. All growth factors have to hook into a receptor. Just like all hormones have to hook into a receptor. Okay, insulin hooks into a tyrosine kinase receptor on adipose and muscle. Everything has to hook into some receptor. Okay, so we have certain proto-oncogenes whose main job is to make receptors. So the ERB2, the classic one for breast cancer, is an example of an oncogene, a proto-oncogene who codes for a receptor. Okay, codes for a receptor. Another one's RET. The RET, which is in men syndromes, men 1, men 2. Okay, men 2A, 2B. I just love it, men 2B. We have that, those involve the receptors, not the growth hormone, the receptor for it. That's their specialty. We have to send a message. We have to send a message to the nucleus. And so then we have a whole other set of proto-oncogenes whose job is to send a message. They're kind of like the telegraph system. We have some of them that are located in the actual cell membrane. You already know about that. That's the RAS proto-oncogene, whose job, its messenger is a GTP. It sends a phosphorylated protein message. And so it's a cell membrane located messenger system. And we have the ABL, ABL proto-oncogene, who's lives in the cytosol, very close to the membrane. And it also is involved in messages as well. So we have to have some messenger system. Okay, who's the messenger sent to? Well, it's sent to a group of proto-oncogenes that are in the nucleus. And once that message is sent to them, then they stimulate nuclear transcription of that message. In other words, the cell divides and makes whatever it is it's supposed to make. The classic proto-oncogenes there are the MYC proto-oncogenes. We have NMYC and CMYC. Okay, NMYC and CMYC. One's for neuroblastoma, the other one's for Burkitt's lymphoma. Okay, so in review, the proto-oncogenes involved in a normal cell process involve those that make growth factors, make growth receptors for those factors, those that send messages, A lot of the messages are phosphorylated proteins. That's why tyrosine kinase is oftentimes attached to the receptor right off the bat. So as soon as, let's say, insulin, for example, hooks into a receptor on the nanopells, it activates tyrosine kinase. We're right on the receptor, so it's located actually right there, which makes a phosphorylated product, which goes and does the nucleus to go divide and all that stuff, and goes to the Golgi apparatus and says, okay, guys, where's GLUT4s? And so the old GLUT4s come out. That's glucose transport units, kind of like golf carts. And those little GLUT4s from the Golgi apparatus go to the cell membrane of the adipose, and they're the receptors for glucose. Okay, so that's how that works. Okay, so the messages go to nuclear transcribers in the nucleus. And those are the MYC oncogenes. Okay. Now, who's controlling these dudes? The suppressor genes. We already mentioned the two most important ones, the RB suppressor gene and the P53. There are other suppressor genes, but those are the most important ones. They kind of control the cell cycle. Remember, they try to keep it in the G1 phase so that everything can be cleaned up a little bit before it goes into the S phase and gets initiated. Got me so far? Try to be as simple as possible. Okay. Now, how do we initiate a cell? Mutations, for example. What are the mechanisms of the mutations? Not a whole lot of them, actually. Probably the most common one's a point mutation. Okay? Now, if you don't know what that is, usually in biochemistry, when they do the DNA stuff, and Reichenbach probably is the one that does that, when they do that kind of stuff, they talk about point mutations in those little trinucleotide things. It could be substituting adenine for thymidine or something like that. Okay? So point mutations. In fact, the two most important genes involved in cancer are both involve point mutations. That's the P53 suppressor gene. There's a point mutation that knocks that one off. And then there's the RAS oncogene's a point mutation. That was a board question. They had groups of genes, and they said which ones are by point mutation. Okay, and that was a P53. All suppressor genes, by the way, are all point mutations. That's real easy. But the other dudes, the proto-oncogenes, have a couple different ones. Okay, so RAS and P53. So one thing's point mutation. That's probably the most common. Another one that you'll understand more when you get your DNA lectures, if you haven't had those already, is what is called amplification. It's kind of like PCR, polymerase chain reaction. It just kind of makes multiple copies of something. That's called amplification. The ERB2 in breast cancer is an amplification type of a system. So that's a different kind of mutation. But here's the one you really want to remember, translocation. Translocation. That's taking some place and putting it in another place. Okay? Right now, you've all been translocated. Is this the usual place where you are? No. Okay? So you've been translocated over here. Okay? You have another place that you live. Is that correct? All right. But unfortunately, in translocation, you get translocated, you can't go back. You stay. If you want to stay here, say no. No. Okay. All right. Now, some of the classic translocations, every one of them that's important in your notes. Here's the big one. Is chronic myelogenous leukemia is translocation of the ABLA, that's non-receptor tyrosine kinase activity, ABLA, from chromosome 9 to 22. And there it fuses with the break cluster region to form this fusion gene. And then all of a sudden, because it has that tyrosine kinase activity, it sends a message, and all of a sudden, those cells, those stem cells just keep on dividing. Okay, we have chronic myelogenous leukemia, of course, chromosome 22 with that fusion gene is called Philadelphia chromosome. There you go. And then we have a cancer associated with Epstein-Barr virus that translocates the MYC nuclear transcriber gene from chromosome 8, and it sticks it on the chromosome 14. It don't like it there. And so you end up getting Burkitt's lymphoma. Okay? Burkitt's lymphoma. Now, if you want to understand the Epstein-Barr virus relationship, it's quite simple, actually. Remember we said there's a receptor for Epstein-Barr virus in all of our B cells? Anybody remember what it's called? CD21. Do you know what it does when it hooks into that receptor? It causes B cells to become plasma cells and make antibody. They're unbelievable stimulators of antibody synthesis. So is cytomegalovirus. And because of the fact that it stimulates the B cell to become plasma cells, there's a lot of divisions that occur there, guys. And so doesn't it make sense that the more a cell divides, the more something bad can happen to it? Okay, so here's this EBV virus. A14. All of a sudden there's a translocation of the MYC oncogene from 8 to 14. And the next thing you know, you're making multiple copies of that, progression, and you got yourself Burkitt's lymphoma. So that's how EBV predisposes to that particular cancer. It just increases the mitotic rate and it's a greater chance. the greater chance you do something, the greater chance you're going to screw up. Isn't that right? That's the same thing. Same thing is true with mitoses. It's basically that simple. Okay, 1418 translocation is important. That's the one for the B-cell lymphoma involving the inactivation of the suppressor gene. Those are the big mutations. There's another one I'm blocking, 1517, translocation for acute progranulocytic leukemia. Anybody know why they're honing in on acute progranulocytic leukemia just for fun? You can treat it with retinoic acid. You can treat it with vitamin A and cure the patient. And even ask, how does it do that? The answer is, it matures the blast. And so what is a malignant cell becomes benign. Can you imagine treating a cancer with vitamin A? It's unbelievable. The same kind of stuff that you use for cystic acne. You could use it treating a cancer. No wonder why it's on the exam. So they ask everything about acute progranulocytic leukemia. The translocation, 1517, the treatment with retinoic acid. Every exam has it. All right. Those are the important ones, guys. All right. These are your suppressor genes. Okay? They do what they're supposed to, suppress. So when we knock them off, then that means whatever they were suppressing keeps on going. Okay? Okay, so we already talked about RB, we talked about P53. This is the adenomatous polyposis coli. That's the one for familial polyposis. That's the suppressor gene. We have the neurofibromatosis one. That's a suppressor gene. We have the Wilms tumor one. That's a suppressor gene. We've got these dudes, BRCA1, BRCA2. Okay, BRCA1, BRCA2. Basically, both of them are involved in DNA repair. Okay, one's on chromosome 13 and one's on chromosome 17. Okay, the breast cancer 2 is the one that's totally associated with breast cancers. Breast cancer 1 can be breast cancer, ovarian cancers, and others. Okay, only 15% of breast cancers have any kind of genetic relationship, so most of the time they're not genetic. But they're suppressor genes. Okay, so these are the key suppressor genes over here, and those are the different diseases that we see them in. All right. Now, getting out of the molecular level and going up to another point. Another point. Okay, we know the mechanisms of mutations, point mutations, translocations, amplification. Okay, we know about the proto-oncogenes can be activated by these things. We know that suppressor genes can be inactivated. Okay, who does this? Why do they do these things? Well, you know we have three main ways: chemicals, viruses, and radiation. Those are the three main ways. Okay, now this is a trick question. Are you ready? Actually, you can figure it out. The answer will be obvious after I give it to you. Which of the three is the most common mechanism for initiating a cell, producing a mutation? How many think it's chemicals? Raise your hand. How many think it's viruses? Raise your hand. How many of you think it's radiation? Raise your hand. The answer is chemicals. Guys, smoking is the most common cause of death in the United States. Polycyclic hydrocarbons are the carcinogen in smoke. It's a chemical. It's a chemical. It's even more important, more common, often associated with cancer than virus-induced cancer or even radiation-induced cancer. It's chemicals. In fact, like 80%. Big time. So don't forget smoking. That's the number one. It's not just lung cancer, guys. It's mouth, squamous of the mouth, larynx, lung, pancreas, bladder, lots of things. And a lot of times it's not number one, but it's maybe number two. Cervical, colon, leukemias. Holy mackerel, that's a lot of cancer. Polycyclic hydrocarbons, you bet. Okay, so I'm just going to show you just a couple little picture things that relate to some of these things that predispose to mutations happening. Now, this is a little papillary tumor in the bladder. What do you think the most common cause of that is? Well, it's a transitional cancer. And what do you think the most common cause of transitional cancers are? Smoking. But what if you worked in a dye industry? What would that be? Aniline, there you go. What if you had Wegener's granulomatosis, you were put on a drug, you ended up with hematuria? You did a cytology and you saw some abnormal cells. What drug was the patient on? Cyclophosphamide. That's the way they would ask it, guys. I know that our little English friend taught you about cyclophosphamide and hemorrhagic cystitis, okay, using Mesna to prevent that. And I know he mentioned the fact that it's also an unbelievable carcinogen for transitional cell carcinoma. So the way they ask it is they'll present a case and a person was being treated with something and have a side effect and you have to tell them what the drug is. In this case, it was cyclophosphamide. That's how they do it. Okay. All right, here's lung cancer, and we're using toothpicks to hold up the main stem bronchus. And of course, the most common cause of this is polycyclic hydrocarbons and smoke. The cancers that are most often associated with smoking and main stem brain cancers are squamous and small cell. Okay, here's a virus-associated cancer. Here's a dude with non-pruritic raised red lesions. Diagnosis? Come on. Carpus sarcoma, guys. Carpus sarcoma. Virus, please. Herpes 8, not 6. Not 6, that's roseola. Herpes 8. Herpes 8. That's it right there. This picture has been on many, many exams. Diagnosis. Burkitt's virus. Epstein-Barr virus. Name some other ones with Epstein-Barr virus. Nasopharyngeal carcinoma. What group of people commonly? Chinese. Okay. Liver. What about liver? Hepatocellular carcinoma. Hepatitis B. What country? Asia. Okay, because of the high incidence of hepatitis B, and then there's a certain mold in the fluid named the mold. Aflatoxin B. So that combination of having hepatitis B, cirrhosis, plus the aflatoxin, that's what makes that one of the most common cancers in the Far East. Okay, so hepatitis B. Of course, C also can produce liver cancer too. Some people say it's the most common. Some people say it's the second. It's kind of 40-30 in terms of percentage. Most books that I've read said 40% in favor of hepatitis B, and then 30% in favor of hepatitis C. Now, somebody else might tell you the opposite. It's a moot point. It's a moot point. I don't think I'd worry a whole lot about that. Okay, here's some of the other viruses here. Okay, how about HIV? Is that associated with any cancer? Primary CNS lymphoma. You want to know how they're going to ask that question? The rapidly increasing incidence of primary central nervous system lymphoma in the United States is directly attributable to the increase in A, B, C, D, E. The answer? HIV. There you go. That's how they ask a question like that. Got it? All right. Okay. Remember also EBV for malignant lymphomas other than Burkitt's as well. They can do that too. Forget HCLV1. That's not too important. Herpes 8, coppacees. How about human papillomavirus? Squamous cancers, cervix, vagina, vulva, and don't forget, anus and homosexuals. Unprotected intercourse, common board question. Okay, so the same HPV, 16, 18, 31, that can produce cervical, vaginal, vulvar cancer, is the same one that can produce anal squamous cell carcinomas in homosexuals. Common board question. HPV. Remember how that worked? E6, E7 protein products, E6 knocks off the P53, E7 knocks off the retinoblastoma. That's a pretty cool little virus there, huh? All right. Radiation. Okay, this is chronic myelogenous leukemia over here. This exact slide was on boards according to a few students that were taking a review in New York. Okay, what is the most common cancer associated with radiation? Leukemia. And the most common leukemia associated with radiation is chronic myelogenous leukemia. That's the one with the 922 translocation. Of what? Proto-oncogene. ABLA. ABL. Okay. This is a papillary carcinoma of the thyroid. That's another very big one for radiation induced. So if they give a history of anyone that had radiation in the head and neck area, and they say that they have non-tender nodular masses in the cervical region, that's metastatic papillary carcinoma of the thyroid related to ionizing radiation. Okay, very, very simple, straightforward question. Okay, another good one is osteogenic sarcoma. So another way they ask things is by profession. They could say which medical profession is most subject to would most likely get acute leukemia. That's what I would ask it, and radiologists. Okay, because the most common radiation-induced cancer is leukemia. Who's the one that works most with radiation? Radiologists. So they can ask it that way. Just like they could ask Jakob Creutzfeldt disease, what radiation, or what would you generally be? Neuropathologist. Okay, you're dealing with brains. You have more association with brains and the prions. See, they do things by where you work. Okay, and they can ask the question. All of these are in your notes. Thank you. Okay. I'm pulling my breath. That's why I'm breathing so hard. Diagnosis. Basal cell carcinoma. This exact picture has been on hundreds of exams, and it's just the histology. And when they say basal cell, they mean it. It means it derives from the basal cell layer. Look at that. Bonk, bonk, bonk. Doesn't that look like it's just dripping off the basal cell layer? You also notice it's multifocal? Okay. Also notice it's multifocal. So what kind of radiation is this? Non-ionizing radiation. Ionizing is the bad stuff, the radiation. And what is it? Which will UV be like? Is it UVA, UVB, UVC? B. B's bad, right? What's UVC? Not UVC, UVA. What's light? Those of you that like dermatology, like to fluoresce superficial dermatophytes, okay, will find Chagrin's patches and tuberous sclerosis. Use Woods light, which is called black light. That's UVA light. UVB light is the stuff that you try to protect yourself from getting skin cancers, like basal cell, most common, squamous cell, second most common, malignant melanoma. Or UVD, thymidine dimers, that's the mechanism of it. Okay, so this, make sure you know the basal cell relationship. Okay, here's a precursor lesion for a certain cancer that's commonly seen in sun-exposed area. You can scrape it off and it comes back. Actinic keratosis. Okay, what's another name? Solar keratosis. And what cancer does it predispose to? Squamous. There you go. Very good. Kind of looks pearly, grayish, white, and it looks like something you just scrape off. And doesn't. You can just see to scrape off the thing, but it's a dysplastic lesion. That squamous dysplasia is going to grow back. Okay, and so eventually, only about 3 or 4% of actinic keratosis becomes squamous cancer. Anybody know what heavy metal predisposes to this, please? Arsenic. Anybody know what country is experiencing a major increase in skin cancers related to arsenic? Bangladesh. That's going to be a board question because it's all over the news. Apparently the water supply is contaminated with arsenic, and all the arsenic-related cancers are increasing. That's skin cancer. That's also going to probably be in time lung cancer. It's also probably in time also going to be angiosarcoma of the liver because arsenic's involved in that. So here's a situation in a country where everyone's getting exposed to it because it's in the water. So they use current events very frequently on exam questions. They do. This is a kid that had a wide eye reflex. Retinoblastoma. Chromosome, please. 13. Okay, it's sporadic and it's familial. Okay, so how many mutations does it take for a sporadic to become retinoblastoma? 2 separate ones. You have to knock one off on one of the chromosomes 13s, and then one on the other one. Okay, how many if it's autosomal dominant genetic inheritance? 1. You're born with one already inactivated. All you need is one more mutation on the other chromosome, retinoblastoma. Is a wide eye reflex most commonly due to retinoblastoma? Say no. No. The answer is congenital cataract is the most common cause of a white eye reflex. And don't go shining a light in a little newborn's eye and it's white and say, oh, retinoblastoma, and recalling everybody and this and that. Most commonly it's due to congenital cataract, which could be due to some of those congenital infections like cytomegalovirus, rubella, any number of those suckers. So it doesn't mean something, ho-hum, something that's got to be investigated. Anybody know what drug is that predisposes to cataracts while I'm thinking about it? Why would a patient with Cushing's syndrome have cataracts? Corticosteroids. They predispose to cataracts. Okay. All right, let's break. We'll finish up neoplasia the next hour and start hematology probably. A lot of good comments on I saw a lot of good comments that students that took the exam had on the Q bank, and they said it was the most like what their exam was of anything they ever ran across. So apparently it's got good reviews from people that have taken the exam. So it's a good product. All right. Genetic disease, guys. This patient, wherever there's sun-exposed area, would be predisposed to all the skin cancers, basal cell, squamous cell, and melanomas. It's an autosomal recessive disease, namely eczeroderma pigmentosum. What's the defect? DNA repair enzymes. Now, there's another group of diseases that are listed in the notes that are also DNA repair enzyme things. Remember, BRCA1, BRCA2 is involved in that. So is P53, isn't it? Splices out those defects. But they're called chromosome instability syndromes. They include things like Wiskott-Aldrich syndrome, Bloom syndrome, ataxia, telangiectasia. What's another one? Fanconi syndrome. All these have problems with DNA repair, and they commonly ask these on examination. So I just wanted to mention that. There's a basic rule of thumb. It doesn't always hold. From upper lip up is basal cell country. From lower lip down is squamous cell. Okay, so I will show you when we do GI, I'll show you a lesion on the lower lip, and I'm going to ask you what odds are, what is it? And you should say squamous cell carcinoma. If I had one on the upper lip, odds are would be basal cell. Remember that one that was on the inside of the nose was above lip. So a crateriform lesion of upper lip and higher is basal cell country, lower lip and lower is squamous cell. Okay, it's a basic rule of thumb. There are many exceptions to that, but it's reasonable. It's reasonable. So why am I showing this keloid again with the same kind of lesion that we saw on the skin that we call the squamous cell carcinoma? Why am I doing that? Did I make a mistake? Now, remember we were talking about squamous cell carcinomas and third-degree burns, and squamous cell carcinomas developing in areas of drainage from, let's say, a sinus, and this ulcer that doesn't heal with antibiotics, So in other words, where there's constant irritation and there's divisions of cells related to that irritation is always a greater risk for cancer. And it just turns out that the most common cancer would be squamous cancer in those areas because you're dealing with squamous epithelium, not glandular epithelium. This does not hold for scar cancers, by the way, of the lung. Most scar cancers that relate to old TB scars or something like that are adenocarcinomas, not squamous. It just holds to things on the skin, okay? That this relationship with burns and draining sinus tracts, that's squamous cell carcinoma. Who can tell me the only bacteria associated with cancer? Helicobacter pylori. Name the two cancers. Adenocarcinoma and low-grade malignant lymphomas. Two cancers for that sucker. God, amazing little organism. Guys, you better listen up. I know for a fact this picture was on the exam because someone almost had a conniption. This one, what's the matter with you? And that's, might have had someone a little bit more manic than me that day. Okay? So I know for a fact that that says on there. Grade and stage, guys. You better listen real careful. Big time. What's the grade of a cancer? Well, the grade of a cancer is what's it look like. Okay? And if you can identify what it is because it's doing something like making keratin or making glands, then it's well differentiated. Another term, low grade. If you look at something, which would be most of the things that you look at, it's anaplastic, high grade, fully differentiated. In other words, you can't tell by looking at it under the microscope what it is. That's grade. That's a grade term. Okay, let me see if you can grade these tumors now. Can you tell me what the origin of this is? It's squamous. Why? Because you have these beautiful keratin pearls there, and so because you identified it, is that a low grade or a high grade cancer? Low grade. I want you to look at that. What do you see? You see gland-like spaces, right? So this is an adenocarcinoma. You identified it as malignant glandular cells. So is that low grade or high grade? Low grade. Very good. So grade is what it looks like. Now listen careful. Listen careful. Stage. Now I don't want you to forget this, please. I want you to remember that T is in toy, N is in Nancy, M is in machine system. Because here's what it does. This is the most common staging system. It goes from least important to most important. Now, here's where your problem is. You think that when, let's say, take breast cancer. You got a breast cancer, and they say that the low axillary nodes are involved. Okay? You think that that's the worst thing of all. No. That's the end part of TNM. What's even worse than that is if it's outside the lymph nodes, like bone, lung, or liver. So just because it goes to the lymph nodes doesn't mean that that's the most important prognostic factor. So T stands for the size of the tumor, okay? That thing, that's what it basically is. The T stands for tumor, how big is the sucker. A magic number seems to be 2 centimeters. If a tumor is over 2 centimeters, it generally has a chance of metastasizing. Whenever you look at staging things for different organs, 2 seems to always come out. So just remember 2. N stands for nodes. That's the next most important thing for prognosis is nodes. The third is M, that's metastasis outside of nodes. So what is the most important prognostic factor for cancer? Is it grade or stage? Stage. And in staging, what's most important? The size of the tumor, whether it has lymph node involvement, or metastasis to other areas? Metastasis. Now, let me give you an example on someone's boards and how they screwed it up. So they described their prostate cancer. They said, which of the following has the worst prognosis? And they said, first, prostate cancer limited to the prostate. And then they said, went into the seminal vesicles. Then they said, went into the wall of the bladder. Then they said, went to the lymph nodes around the bladder. Then they said, went to bone. There you go. What do you think the ding-dong picked? The lymph nodes. He picked that because he didn't know the T and N system. Missed it. Just remember T and N, you can't get screwed up. If they don't mention something outside of the lymph nodes, then the lymph nodes would be the most important. But if they mention liver or bone or something like that, my God, that's stage 4 by definition. Okay, don't forget that. Very, very important. Good Lord in heaven. So let's look at this. This is colon cancer. That's a lymph node. Okay, so what's the most important? The size of this tumor or that lymph node involvement? Lymph node involvement. Now let's say it said that there was also a similar focus of cancer in the liver. Then what? The liver is the most important prognostic factor. Very good. All right. Host defenses. You've had immunology. You know what the most important host defense we have? Our little friend, the cytotoxic CD8 T cell. That is the numero uno most important host defense system we've got. And we have other things, macrophages, natural killer cells. It even says what they do, natural kill. Okay, the natural killer cells, they can do that. Antibodies, like type 2 hypersensitivity can do it. So there's a number of other mechanisms, but numero uno is CD8 cytotoxic T cells. Why they do rounds every day looking for altered class 1 antigens. And whenever you have a neoplastic cell, those class 1 antigens are altered. Boy, when that's cytotoxic T cells, it gets very interested in that. Kills that cell. Okay, puts out perforin. That's the signal for who? Caspase-8s to do what? Apoptotically kill that cell. Remember, it has to be a signal. Signal to who? The proteases, which they call caspase-8s, and then they start breaking down the nucleus, screwing up the mitochondria, and then the cell dies without any inflammatory infiltrate whatsoever. Cachexia, you need to know on that cause, and that's tumor necrosis factor alpha. It's irreversible. Once you see this, a poor patient with disseminated cancer just beginning to go into a catabolic state, you can give them total parenteral nutrition until it comes out of their ears. They will not get their muscle mass and stuff back. It's all over. That's due to tumor necrosis factor alpha. Hematology, lots of different things. Hematologic causes of anemia are present in malignancy. So the most common anemia in malignancy, most common is anemia of chronic disease, which we'll discuss today. Okay, that's the overall most common, but there could be other ones. Signs like colon cancer, for example, could be, if you remember, left side obstructs, right side bleeds. If you have a right-sided colon cancer, then iron deficiency would be more common. Also, what if you metastasize to bone and replaced all the bone marrow? That could be a mechanism. Or use chemotherapy drugs, that are cell cycle specific or non-specific, and you wipe out the stinking marrow. There's another cause. They can have autoimmune mechanisms with certain types of cancers, but overall, most commonly, it's anemia of chronic disease. Most patients that have disseminated cancer are hypercoagulable. What does that mean? That means they have a tendency for forming clots. Of course, this is a classic example. The dude that has a painless jaundice, he's got, let's say, a left supraclavicular node. I'm going to throw that in as a distractor for you. Has light-colored stools. And he has this peculiar lesions in the vein that seem to jump from one part of his body to the next. Okay, what's that? That's trusosine. That's superficial migratory thrombophlebitis in a patient with carcinoma of the head of the pancreas. Pancreatic cancers can also go to the left supraclavicular node. They ask the trusosine very commonly. They don't say trusosine. They just describe this vascular problem in the veins that just kind of jumps from one place to the next. It's pretty reasonably common. That's an example of a hypercoagulable state. Another thing we very commonly see with disseminated cancer is thrombocytosis, an elevated platelet count. I can't tell you how many times I've been asked to do bone marrows on patients and say, we need you to work up the cause of this thrombocytosis. Most of the time I can just do it from a hematology slip. I see if they have iron deficiency, then that's the cause of thrombocytosis. I see a scar over here, okay, it's had a splenectomy, okay? And then I look for anemias and stuff like that, and then to see if they have TB, that could be another cause. But when I can't find any obvious cause for thrombocytosis, I rule out myeloproliferative diseases and stuff like that. It's always cancer. 40% of all disseminated cancers are thrombocytosis. And what I usually find that they missed is colon cancer. You want to know why? Didn't do a stool guaiac. I said, you do a stool guaiac in this patient? No. I think I do one. They do one. Positive. Colonoscopy. Cancer. That's the cause of thrombocytosis. Remember, guys, a stool guaiac is part of any normal physical exam. If it's not done, you have not done a complete exam. Remember that. Always. Fever. Most common cause of fever and malignancy is a gram-negative infection. Usually the gram-negatives are the hospital that you're in dying. E. coli, if you have an indwelling catheter. If you have a respirator, Pseudomonas aeruginosa. If you have an indwelling catheter, maybe in a vein or something like that, Staph aureus. But that's gram-positive. So most commonly they're gram-negative. In fact, the most common cause of death in cancer is infection. All right, paraneoplastic syndrome. Very, very important, guys. Very, very important. Now, let me tell you what this is. These are signs, sometimes symptoms, that say that you may have an underlying cancer present. So they're kind of like little clues that something's going on in a patient. Now, why would this be important? Well, maybe if you recognize this clue, you can actually find that cancer before it's metastasized. Okay? So that's the key for knowing these things. Now listen carefully on this. The most common paraneoplastic syndrome is hypercalcemia. Now, I'm going to present two mechanisms, and you're going to tell me which one classifies as paraneoplastic. Remember, the purpose of these things is to find some clue that will detect the cancer before it's spread. That's the basic thing that we're saying. All right, there's two mechanisms for hypercalcemia malignancy. One is you metastasize the bone, produce some kind of chemical, interleukin-1, prostaglandin E2, that activates osteoclasts, produces lytic lesions in bone, voila, hypercalcemia. That's one. That's the most common. Two, it could be a calcificated cancer like a renal adenocarcinoma or squamous carcinoma of the main stem bronchus that just sits there and makes parathormone-like peptide, and it just causes hypercalcemia to occur because it acts like parathormone in breaking bone down a little bit. Which one's paraneoplastic? The second one. And that's certainly not the most common one. Good. All right. These pretty much summarize these pictures, all the important paraneoplastic syndromes. Okay. Now notice there's two lesions that are black here. And both of these, interestingly, are phenotypic markers for the same cancer, gastric adenocarcinoma. Usually this lesion, this black lesion, is under the arm, not always. This is called acanthosis. Finish it. Nigricans. Okay. And this is called seborrheic keratosis. Now don't go bananas on this. Okay. Because a single seborrheic keratosis doesn't mean a hill of beans. I got a pile of them under my axilla, which I'm not going to show you. Okay. But I mean, they're there. These are not even neoplasms, guys. But here's the thing. When they suddenly develop like overnight, this cross of these, boom, all of a sudden they were there yesterday, they weren't there yesterday, now they're there. That's called the lesser Trelot sign. When you get multiple outcroppings of these things, that is a phenotypic marker for gastric adenocarcinoma. So it's kind of easy to remember because there are two black lesions that are markers for an underlying gastric adenocarcinoma. I know some of you are pretty sharp and you know that acanthosis nigricans is associated with other things. I know you know about the insulin receptor deficiency related to diabetes, also MEN syndromes. So it's a phenotypic marker for a lot of things, and most commonly gastric adenocarcinoma. Diagnosis? Clubbing. Better diagnosis. Hypertrophic. I forget the other part of it. Hypertrophic. Whatever. It's an inflammation underneath in the bone, periosteitis. Okay? And it's the inflammation of the underlying bone that stimulates increased soft tissue development around it and produces the clubbing. So it's hypertrophic osteoarthropathy. That's what it is. That's what produces clubbing. Now, clubbing isn't always associated with malignancy. You can see with bronchiectasis, inflammatory bowel disease. But if it were to be a malignancy, it would more likely be primary lung cancer. Okay? Now, this is the least common collagen vascular disease, but the one most commonly associated with an underlying cancer. I'll give you a hint. They have an elevation of serum CK. Dermatomyositis is the answer. And some of you should have recognized this as raccoon eyes. It's so-called heliotrope or raccoon eyes of dermatomyositis. Okay, and that's an inflammation of skin and muscle. And so they got myositis, which releases serum CK. High association with leukemias and cancer, lung cancer, lymphomas, etc. Anybody know what the name of the little patches over the knuckles and stuff like that are called? Goldschmidt patches. Goldschmidt patches. Dermatomyositis. Okay, now we have some vegetations here on the mitral valve. They're sterile. These are associated with mucus-producing cancers like colon cancer. Okay, it's a paraneoplastic syndrome. This is called merantic endocarditis. Merantic endocarditis. And they are benign. I mean, they're not benign, but they're not infected. There's no infection. It just basically seems to be associated with mucus-secreting colon cancers, merantic vegetations. Can they embolize? Sure. In fact, that was a board question. I mean, their ability to embolize, sure, because they're pretty big. I mean, you can see those chipping off there. Now, would you need some history to separate that from rheumatic fever? Oh, you bet you would. Okay, it looks very similar to that. In fact, it looks like it's right along the margin of the valve. Oh, yeah, no doubt about it. Except the history would relate more to colon cancer than rheumatic fever. Polyarthritis and stuff like that. Okay, they would be giving this versus this. Okay, I don't think I would be thinking infective endocarditis with this because it's too even along there. Infective endocarditis get these huge vegetations at different places. Liebman-Sachs, not a chance. Liebman-Sachs endocarditis vegetations are all over the place, including down here, no way. So the only thing you could potentially confuse that with is rheumatic fever, that's it. Okay, so those are your some of your paraneoplastic syndromes. Now the list is up too. You ready? Okay, there's another merantic vegetation. Okay, these are little snippets here, and you're going to tell me what the cancer is and where it's located. Ready? Okay, hyponatremia or Cushing's. Lung cancer. small cell carcinoma, hormones. ADH for that, ACTH for that, small cell cancer. What's another thing that's unusual about small cells? They're output tumors, S100 antigen positive, neural crest origin, neural secretory granules on electron microscopy. Okay, hypercalcemia or secondary polycythemia. Wrong. Renal adenocarcinoma. Okay, renal adenocarcinoma. Renal adenos can make parathermal-like peptide, and they also can make erythropoietin. Okay, about hypoglycemia or secondary polycythemia. Hepatocellular carcinoma. Okay, they can make erythropoietin, there's your polycythemia, they can make an insulin-like factor, there's your hypoglycemia. Okay, how about, this is the hardest one actually, how about hypocalcemia or Cushing's? I'm going to give you a hint. It can be an autosomal dominant variety of this, and this particular tumor is one of the rare tumors where the tumor marker can be converted into amyloid. The answer is medullary carcinoma of the thyroid. And what was that tumor marker that can be converted into amyloid? Calcitonin. There you go. This is the way you ask your ectopic hormone syndrome, guys. If you're sitting there with your fingers in your ear, okay, this is the way they ask them. Okay, so this is all memorization. There's nothing that you can't think your way. You can only one thing you can think your way into, and that is it's pretty obvious to me that a kidney cancer can produce erythropoietin. I mean, that is not. That's just an absolute no-brainer. All the other stuff you just have to know. Just absolutely memorize it. There's no other way. Let's see how you do on tumor markers. Okay, what two tumor markers do you always get when you have a male with a testicular cancer, please? Alpha-fetoprotein and HCG. Now, what is alpha-fetoprotein in a testicular cancer a marker for? What kind of cancer? Yolk sac tumor. What's another name for that? Endodermal sinus tumor. Now, think of this, guys. Think of this. Alpha-fetoprotein. Doesn't it sound young? Fetoprotein. Did you know that alpha-fetoprotein really is the albumin of the fetus? That's really what it is. And so tumors in kids, like of the ovary in a girl or of the boy, are most commonly yolk sac tumors. Okay, alpha-fetoprotein. You know, young kid, and even the name sounds young. Alpha-fetoprotein. Okay, you also know it's associated with hepatocellular carcinoma. Okay, that's the tumor marker you would want to get to that. You also know open neural tube defects, it's increased. You also know that you have to be on folate before you're pregnant to prevent open neural tube defects. And you also know that in Down syndrome, alpha-fetoprotein down is decreased. Those are all the facts that you need to know about alpha-fetoprotein. I want you to find for me a marker for a malignancy of bone that's associated with a monoclonal spiking. Bench-Jones protein, and what are we talking about? What is multiple myeloma? What is Bench-Jones protein? It's the light chain of the immunoglobulin. Very good. Okay. I want you to find me the tumor marker for prostate cancer. PSA. Is it specific for prostate cancer? No. Why? Because it can be increased in hyperplasia. But is it sensitive? Yes. But is it specific? No. Is it increased if you do a rectal examination? Absolutely not. Anyone that taught you otherwise is an idiot. Okay, simply they're an idiot. Want to know why? It's not an enzyme. It was prostatic acid phosphatase? Of course. This is an antigen, guys. It's actually within the actual cell. There is no way that it increases with the rectal exam. No way. A lot of internists teach you, oh, the PSA, never do a rectal exam before you're going to get a PSA. Bullcrap. Doesn't affect it whatsoever. Now, if it was prostatic acid phosphatase, yes, it would. So they're kind of confusing with that. Okay? Please don't fall for that mistake. Okay. How about breast cancer, surface-derived, CA-125? Okay, how about, which one did I say? Ovarian cancer or breast? Oh, breast, no, that would be 15-3. How about ovarian cancer, CA-125? 19-9, they don't ask. PSA alpha-1, CEA. How about carcinoma embryonic antigen? What's that for? Colon cancer, but we also use it in small cell, we also use it in breast, but mainly colon cancer. You know it can be part of an immune complex? You can get CEA, anti-CEA, immune complexes which deposit in the kidney and produce nephrotic syndrome. Name the type of nephrotic syndrome, please. Is it minimal change disease or lipoid nephrosis? Is it focal segmental glomerulosclerosis? Or is it diffuse membranous glomerulonephritis? Which one is it? Diffuse membranous glomerulonephritis. When we get to kidney, we'll find out that a good percentage of the nephrotic syndromes in adults Well, the most common overall cause is diffuse membranous glomerulonephritis, but a good percentage of those are related to malignancy. And one of the most common malignancy is colon cancer, because CEA can be the antigen part of an immune complex and end up depositing in the glomeruli. Okay, if you thought a woman had a trophoblastic tumor or a mole, what marker would you get? Beta HCG. Very good. Very good. Okay. I gave my last slide to my buddy that's doing the neoplasia lectures, and I couldn't find another one, so I'm going to just go from what I remember as the last part of the notes. You ready? What's the most common primary cancer? All right, I'm going to word it this way. Primary tumor of the brain in kids. The answer is a cerebellar cystic astrocytoma. Now here's what you were taught. You were taught medulloblastoma. Wrong. You didn't listen to the way I asked the question. I said, what's the most common primary tumor? I didn't say whether it was benign or malignant. See, all astrocytomas are benign. Okay? So the most common actual tumor of the brain is, primary tumor of the brain is a cerebellar tumor derived from astrocytes. Now, if I worded it this way, what's the most common primary cancer of the brain in a kid? Then what would the answer be? Medulloblastoma, and again, that also derives from the cerebellum. Big mistake. You see it wrong in lots of different books. You probably said, well, how do you know I'm right? Because I check the right books. I go and I read New England Journal of Medicine that deals with brain tumors, and also the literature on this thing. So I'm correct in what I'm saying. In fact, it's not even close. Cerebellar astrocytomas are way, way more common than medulloblastomas, but they're benign. And medulloblastoma. Now, what's the most common? What are some other common childhood tumors? What is the most common childhood cancer? Leukemia. What leukemia specifically? Acute lymphoblastic leukemia. The second group mainly is central nervous system tumors, and we already know that one. And then right after that, we get into things like neuroblastomas, very, very common in adrenal medulla. And then we have Burkitt's lymphomas right up there also, B-cell. Ewing sarcoma, it's a tumor of bone. Remember the onion skinning type of calcifications that you see with that. Another big one is the embryonal rhabdomyosarcoma. Those are the kind of the childhood ones. You don't really need to know. You basically need to know what's the most common of them. Leukemia, ALL. Okay. Now let's deal with adults. Okay, let's deal with incidence. I didn't say cancer kill. I said incidence of cancer. Women, what's your number one cancer? Breast. What's your second? Lung. What's your third? Okay, men, what's our first? Prostate. Second. Third. Good. Notice that colon's third all the time. All right, now let's talk about cancer killers. Men and women. Okay, let's go back to men. Second, prostate, women. Breast, third, men. Women. Trick question. What's the second most common cancer and cancer killer in men and women combined? Colon cancer. There you go. Colon cancer is. When you put the two of them together, remember, we both have colons. So even though they were third for the individual sex, when you put us lump us together, then the second most common overall cancer and cancer killer is a colon cancer. When you lump us together. I actually did the math on it. I looked up, put all the numbers and added them together, and it was true. That's why from age 50 on, you should have a rectal exam and a stool guaiac, and then get a flexible SIG and or colonoscopy, depending on your risk. Because after 50, the most common cause of colon cancer, of positive stool guaiac, is colon cancer. Your differential is colon cancer, colon cancer, colon cancer, colon cancer, colon cancer after 50. Really? And what's the one after that one? Colon cancer. Okay? All right. GYN cancers, incidence, most common. Most common GYN cancer, leaving out breast. Okay, your choices are cervical, ovarian, and endometrial. Which is the most common of the three? Endometrial, numero uno. Numero tuo, that means number two in Spanish. I know it's not, don't worry about it. Some of you will, oh! What's number two? Ovarian. What's number three? Cervix. Why is cervical cancer the least common GYN cancer? Pap smear. Okay, now here's what some of you are thinking, if you're thinking at this particular time. 11:30. No. Is it that late? No, that can't be right. Someone changed that. It is that late. Oh, my God. Okay. Here's what you thought, some of you. Say, I don't believe that. Because if you do a cervical pap and you pick up cervical cancer, wouldn't that increase the incidence? But what are you picking up? Why wasn't that a correct statement? That's correct if that was true. You're picking up cervical dysplasia. You pick up squamous cell dysplasia. That's not cancer. And you pick it up, and then what do? Usually end up doing a cervical cone or something like that, and the patient's cured. And because of cervical pap smears, the incidence of cervical cancer has gone down dramatically because you're picking up the precursor lesion. See, initially with mammography, the incidence of breast cancer increased because things you couldn't feel were now seen. So the incidence went up. Same thing with prostate cancer and PSA. Now they kind of leveled off, which means we need more sensitive techniques to pick them up now. Okay, now on cancer killers. GYN, numero uno. Ovarian, numero 20. Cervical, numero 30. Endometrial. So the best way of remembering it, the most common one has the best prognosis. Endometrial is the most common, but it has the best prognosis. Okay. All right. What is the only known existing tumor vaccine? How many of you got vaccinated against hepatitis B? All of you better have your hand up, because if you don't, then you're crazy. Okay. Why? What is the most common infection transmitted by accidental needle stick in a hospital? Hepatitis B. You want to know why? The viral burden of hepatitis B in the blood is greater than any infection. In other words, it's even more so than HIV. All right. So you got three things that you're not going to get if you've been vaccinated. One, hepatitis B. What's the other hepatitis you're not going to get? D, because you need surface antigen. What's the other thing you're not going to get? Hepatocellular carcinoma related to hepatitis B related cirrhosis. Three things. So it's the actually only existing tumor vaccine there is a vaccination with hepatitis B. Asked all the time. You just never think of it that way, but it's true. Did you know you can eradicate hepatocellular carcinoma, it's the most common cancer in the Far East, by simple vaccination of every one of those people? You eradicate hepatocellular carcinoma. Okay, I think those are the key things that were in that last part there that's important. Let's start hematology. Okay, I'll let you kind of get yourself kind of situated, take a deep breath. Okay. This is the big nemesis of most medical students. You want to know why? There's all these different things there, and you get them all confused. I'm going to give you a key, which I already gave you. The way that you make hematology easy is big picture. Okay? Now, to me, big picture is something less simple. Microcytic anemias, MCV less than 80. Iron deficiency most common, anemia of chronic disease, thalassemias, sideroblastic anemias. Boom. Macrocytic anemias, greater than 100. B12 folate deficiency, play odds, folate, and alcoholic. Normocytic anemias, low reticulocyte count, corrected. Okay? Would be aplastic anemia, renal disease, that kind of thing. Normocytic anemia, corrected reticulocyte count increased. Those are your hemolytic anemias, spherocytosis, sickle cell, G6PD deficiency, autoimmune hemolytic anemia, microangiopathic. That's the big picture. If you don't have all the different anemias down into a classification, you are screwed. Okay? You have to know that. That's your big picture, because they always give you the mean corpuscular volume on the test, and so you can immediately classify it, guys. And that way it makes it so much easier, as opposed to which ones increase production, which ones, this. That's a terrible way of looking at it. The best way is to use the mean corpuscular volume as your mechanism for classifying anemias. And I'm telling you right now, it makes anemia extremely simple to diagnose, especially on an exam. Okay. Now, the reticulocyte count, next to a complete blood cell count, is your first step in the workup of any anemia. What is a reticulocyte? A reticulocyte is a young red blood cell. In exactly 24 hours, a reticulocyte will become a mature red blood cell with a biconcave disc. If you have an anemia, the reticulocyte count is important because it tells you where the problem is. Is it a problem in the bone marrow in making the red blood cell, or is it a problem outside the bone marrow causing the problem? Well, the way you can determine that is a reticulocyte count. Because if the bone marrow was the problem, then your reticulocyte count would not be good. There would not be an appropriate response. What do I mean appropriate response? I mean you got a marrow that has RBC hyperplasia like I showed you in the slide yesterday. It's revved itself up, it's making lots of red blood cells, and should be putting some of those reticulocytes out a little bit prematurely. That means it's working, it's doing something to try to correct the anemia. Good! Okay? So it tells you whether the bone marrow is responding appropriately or not. Now, goodness gracious, guys, if I have blood loss right now, don't expect my reticulocyte count to be elevated in 24 hours. It takes at least 5 to 7 days before you can begin getting that response. Kind of like the kidneys dealing with bicarbonate and acid-base disorders. I mean, it just sits there for a couple of days, and all of a sudden, did I get a message that I have to kind of increase my reclaiming of bicarb? Yes, I did. Okay, let's get going on it. It takes at least 3 to 4 days before we even begin thinking about it. Kind of sounds like a medical school student in the GO phase of the cell cycle. What's the thing that gets a medical student out of a GO phase? What's the stimulus for getting a GO phase medical student into the cell cycle, into G1? Test. They are in the cell cycle, and they stay in there like malignant cells. Test is over. Back in the GO phase. Back in the GO phase. Waiting for the next test for the stimulus. All right. It's a good way of remembering it now, right? Yeah, I use funny things like that because you won't forget that. You won't forget that. Okay. So, if there's nothing wrong with the bone marrow, then I should have a good host of good reticulocyte response. If there is something wrong with the bone marrow, I don't. That's important, guys, because it may decide whether I'm going to do a bone marrow or not. Okay, if I have a good reticulocyte response, why in God's green earth would I want to do a bone marrow exam? Because there's nothing wrong with it. It's responding accurately. Okay. Okay, so it's going to determine what route I'm going to take. Okay. Now, here's the part that gets you. You have to correct the reticulocyte count to the degree of anemia. I won't explain why, just accept it. Otherwise, we'd have to spend 15 minutes explaining why. You have to correct it for the degree of anemia. It's a very, very simple correction, guys. And here it is right here. Okay, basically, the corrected reticulocyte count is the hematocrit of the patient divided by 45, which is considered the normal. They don't change that number whether it's a male or female. And they multiply that times the reticulocyte count that you're given. Okay? So here's an example. Let's say the patient's hematocrit is 15%, which of course is a very severe anemia. Okay? And let's say the reticulocyte count that was initially measured is 9%. Well, that's increase. Anything over 3 is actually considered increase. And so on the surface now, if you didn't do this correction, it would look like the bone marrow is responding appropriately because it's 9%. But you have to correct it for the degree of anemia. Okay, so let's do that. So 15 over 45 is 1/3. Divided by 9 is 3. So actually, when we correct it for the anemia, we have a 3%. So that's really what the corrected is. Okay, that's right at that marker for saying good response. So 3% or greater, good response. 3% or less, bad response. So it's basically saying, yeah, that's a reasonable response. Okay, that's going on in the patient. Okay? Now, I'm going to go back. I'm going to go here. I want to show you that what a reticulocyte looks like because it's on boards. Okay, this is a reticulocyte. Okay, is that the way they look with a regular right heme stain? Nope, you've got to do a special stain to see these little black filaments in there. In fact, those are RNA filaments. And because they're RNA filaments, that means that the reticulocyte is still synthesizing hemoglobin. So in that 24 hours, about 25% of the hemoglobin that's normally should be in a mature cell is being synthesized. That's pretty interesting. And so you need RNA filaments for that. So you cannot see these things without doing special stain. Okay, that's what they look like. So they look like little worms, little black worms in the red blood cell. There's no way you could confuse this with a Heinz body. I will show you what one of those look like this afternoon. No way. Okay, now I want you to look at these cells. Okay, this is not a special stain. This is a right heme stain. You notice anything unusual about the color of those? What's the color? Bluish. We use the term polychromasia for that. Say that. Polychromasia. Okay. Why? What does this mean? These are younger red blood cells than these 24-hour-old reticulocytes. These are cells that still have that basophilia that they have before they become, that are usually present in the mouth. These are not normally present in the peripheral blood. When we see them, it means that the bone marrow is really responding to this thing. It's even pushing some of these even younger cells out. And so whenever the board says polychromasia present, they're talking about these cells. And these cells take 2 to 3 days before they become a mature RBC. Now, why is this important to you? Well, first of all, because they ask it on boards. And second of all, we have to make an additional correction. Why? Well, when we're working up an anemia and we do a corrected reticulocyte count, we want to know how is that bone marrow responding right now in this day. We're not interested in what's going to happen 2 to 3 days from now. We're interested in what's happening right now. See, here's the problem. When we do the reticulocyte stain, these dudes are going to have RNA filaments in them too, and they're going to be counted and the reticulocyte count falsely elevated. We don't want these dudes in there because these things take 2 to 3 days before they become a mature RBC. We want these dudes in there. That's what we want. So these dudes are screwing up our reticulocyte count. So how do we factor them out? Very simple. Divide by 2. Okay. So we make our first correction for the degree of anemia. That's done automatically. Okay. In this case, we did it with 3%. Okay. And so we look at the CBC split, and we see nothing that says polychromasia. That's it. That's the corrected retic count. But let's say the CBC split said polychromasia present. And that means we have to make an additional correction. And so we just arbitrarily divide by 2. And so now all of a sudden, our corrected count is 1.5%. Is that a good bone marrow response? No. Can you see why the board is interested in this, guys? The board is interested in this because if you had stuck with this when in reality it was really this when you factor this out, then you would have gone in a totally different direction working up your anemia and you spent all this money. That's why we're in our H and O's and PPO things right now, guys. We ordered too many tests. Okay? The classic physician in the United States, I know because I did most of the hematology as a pathologist. I've done thousands of bone marrows. So this is one area I'm very familiar with. And you can always tell a moron that's working up an anemia when you see the orders. B12 folate, ferritin, bone marrow exam, direct Coombs, osmotic fragility test. They're all down there. Hemoglobin electrophoresis. Anything that deals with red blood cells, it's there. That's an idiot. That's someone that thinks that the laboratory is going to make the diagnosis. They have no idea how to work it up. That's a lot of money, guys. It costs about $1,500 to do a bone marrow and report it out and all that stuff. It's big time, not to mention the uncomfortableness of it. You've got to think. And so you don't do stuff like that. It's called shotgunning. Okay? That's Sylvester Stallone. That's Arnold Schwarzenegger. Okay? Knocking everybody off. Okay? As opposed to apoptosis. One at a time. Dirty Harry. Okay? So Dirty Harry is apoptosis. Arnold and Sylvester are infarction. You know, big time cell necrosis. 300 cells dead versus uno. Okay? All right. So that's why this is important. And they use the term polychromasia. When you see it, guys, that means you've got to make an additional correction. And sometimes the whole question rests on whether you recognize that. They think it's that important. Okay, so that's the point that I want to make there. Okay. What's this called? Reticulocyte. Can you see that with a right gene sustain? No. What are those things? RNA filaments. You know what you want to say? Ribosomes. Ribosomes don't look like threads. Ribosomes look like dots. That's basophilic stippling. So when we talk about lead poisoning, coarse basophilic stippling, those are persistent ribosomes, not RNA filaments. When we have these little things that look like filaments, like worms, that's RNA. Okay. When we look at a CBC split, there's diagnoses that actually can be made most of the time. The rule of 3 is pretty good, and that is if you multiply the hemoglobin times 3, it should roughly equal the hematocrit. So can you work backwards? So we had a 15% hematocrit for the previous example. What was the hemoglobin? 5. Okay, right, that's correct. That's a pretty important thing. There's something that's totally unrelated to this that I also do at this point because it's good to keep it with this because it's another rule of 3. So it has nothing to do with the CBC split. Okay? And that is transfusion of packed, not whole blood, packed red blood cells. So here's the rule. For every unit of packed red blood cells you transfuse in a patient, you're going to increase the hemoglobin by 1 and the hematocrit by 3%. You with me? Here's your question on boards. Ready? Patient got a 5-gram hemoglobin, was given 3 units of packed red blood cells. The following day, the hemoglobin 6. The hematocrit's 18. Is that an appropriate response? What should it have been? 8 with a hematocrit of 24. Now put your noggins on. Why wasn't it 8? The patient has a GI bleed, guys. The patient's bleeding. Please don't forget the obvious. The most common cause of anemia in the whole world is iron deficiency. The most common cause of iron deficiency is a GI bleed overall. So the most common reason why the hemoglobin and hematocrit don't go up after transfusion of red blood cells as you're losing blood, most commonly in the GI tract. Never forget that, please. If you were thinking hemolysis, wrong. I mean, that's like 1 in 250,000 chance of having a hemolytic anemia related to transfusion. Forget it. Okay, no way. So it's most commonly due to a bleed. That's the reason. That's the reason. Okay. Reference intervals, forget. Hemoglobin electrophoresis is mainly used to detect different kinds of hemoglobinopathies, which we'll discuss. Okay, now we talked about red blood cell industries and indices. MCV is very important. Now, this is not MTV, guys. This is MCV. This is mean corpuscular volume. How big is the dude? Okay, is it a small dude, a normal dude, or a big dude? Okay, and what happens is the machine does this. Every red blood cell has to go through an aperture, and it sizes it. And then it takes an average. And this is the best way of classifying anemia, so you must know this. If the normal is 80 to 100, if the average MCV is less than 80, then you're by definition microcytic. And so your differential then is a microcytic anemia. It's play odds, it's iron deficiency. If it's between 80 and 100, you have an anemia, then you're normocytic anemias. If it's greater than 100, then they're macrocytic anemias. That's probably the simplest one because it's either B12 or folate deficiency. Okay, that is really simple. Now, but there's a problem with this. I said it was an average. What if you have small cells and large cells, called dimorphic red blood cell population? What would the MCV be? Normal, that's right. It's kind of like those blood gases, right? You have a primary, let's say you have a metabolic acidosis, and then you have a metabolic alkalosis. Okay, what would the pH be? Normal. So you have a microcytic anemia as well as a macrocytic anemia. What would the MCV be? Normal. How could you have that? How could you, let's say, have an iron deficiency anemia and, let's say, folate deficiency? Well, it depends on whether you know where these things are reabsorbed. Iron is absorbed in the duodenum, folate is reabsorbed in the jejunum, and B12 is reabsorbed in the terminilium. So that means you have small bowel disease like celiac disease. When you have malabsorption, guys, that affects different areas of your small bowel. They're going to affect those things. So, for example, celiac disease, the most common cause of malabsorption, is involving the duodenum and the jejunum. Then obviously you're going to have a deficiency of iron and folate. You're going to have small cells and large cells. Let's say it's involving jejunum and terminilium. Okay, well then it would be B12 and folate deficiency. Okay, so it's possible to have two anemias at the same time in a normal MCV. Do they usually do that on boards? Nah. This is the second year medical students this test. They don't get into something that bad. Now, to date, to my knowledge, from what I've heard from students, since I don't sit down and take the test, they have not asked about RDW. That's too bad because it is very, very important. It stands for red blood cell distribution width. It basically is the machine looking at the RBCs that are coming through the aperture and saying, are they all uniformly small? Are they all uniformly normal? Or are they all uniformly macrocytic? Or is there tremendous differences in size? The RDW can detect whether there's a change in the size of these things. Okay, and it reports it as a number. Okay, so I'm going to give you an example. Let's say you have a microcytic anemia, RDW increased. Okay, so what do you know so far? It's microcytic, and the RDW is increased. What does that mean? That there's different sized microcytic cells. Okay, there's a difference in the sizes of these things. Okay, maybe you got some small ones and maybe some normal ones, and the RDW is picking that up. Now I want to ask you a question. You develop microcytic anemia overnight. The cells all of a sudden, when you're deficient in iron, become microcytic. You think there's some cheerleader that says, on the count of three, we are going to become microcytic. Are you ready? 1, 2, 3, microcytic. No. Okay? You're normalcytic before you become microcytic. So can you say it? When you have developing microcytic anemia, you're going to have some normalcytic cells that haven't become microcytic yet. And you're going to have some small ones. So there's going to be a size variation. And guess who picks that up? The RDW does. Matter of fact, any good hematologist knows when they look at a CBC split, this is the trick. You see a low MCV and you see an increased RDW, it's iron deficiency. Period. That can't be thalassemia because that's genetic. They're all microcytic. Okay. Right off the bat, you can make a diagnosis of that. Okay. So I don't know whether that's a waste of time in telling you that because I don't know whether they've asked that yet. Anybody know? Anybody see the RDW at all on the exam? You've seen it? Part 2, but not part 1. If it's on 2, then it could be on 1. Okay. White blood cell counts, platelet count. Well, nothing more to say on that one. Can you elaborate? No. Okay. You're being mean. No, I'm not. All right, I want you to look at this smear, please. Look at it. Oh, they're all uniform in size. I just want to see how you guys see. Make sure that all the specks are out of your eyes. Is that small? Is that large? So what would the RDW be in this? High. Okay, good. I just wanted to see where you are. Okay, does these cells anything to look at normal about these RBCs? No. Well, yes, spherocyte. Okay, that's good. Anything else? Target cell. Now, I like these two things because a spherocyte has too little membrane. And that's why it can't hold the biconcave disc. It's just a sphere. So it's too little membrane. A target cell has got too much membrane. What do you just think? It's got too much membrane. Now, you know what? Not the best way. That's an obese cell. That's an anorexic. Okay? Remember, the anorexics they're way too low in their weight. So too little membrane. And so they can't hold the biconcave disc they form a sphere. Okay? Target cell is an obese cell. Where do we get big when we eat too much? Right here. Right? All right. Comes out right in the middle. Same with the red blood cell. That's about right smack in the middle of that red blood cell. Bulging. It's got a little bit of waistline problem. And that's because the excess membrane bulges like this. So that means because it's bulged like this, there's more hemoglobin that can collect in there, and it makes it look like a bullseye. So I want you to remember this. A spherocyte is a what cell? An anorexic cell, too little membrane. A target cell is a what cell? It's an obese cell with too much membrane. Why is it important to recognize a target cell? Because they're markers for alcoholics, because it alters the cholesterol concentration in the membrane, and secondly, hemoglobinopathies. Things like thalassemia, sickle cell, and hemoglobin C, and all those things always have target cells in them. So they're very, very important cells to know. Okay, lastly, for this morning, I want you to look at these cells here. Okay? These cells here. And I want you to look at these cells here. Now, this is what a mature red blood cell looks like. It looks like a biconcave disc. You see it? Okay? There's not a hole in it. It's not like a donut. Okay? Donuts have holes in them. Okay? But it's thin there. Because it's thin there, there's less hemoglobin there. And there's more going to be concentrated at the edges. That's why you have a central area of pallor in a normal red blood cell when it's lying flat. I want you to look at this and just get a feel for what is considered normal on this thing. This is kind of pushing it, this slide. I don't like this one totally. What is the matter with these things? Okay, just get a feel for that. Okay, what's considered normal? All right, I want you to look over here now. All right, let's pick that cell. Is that a normal area of central area of pallor? Yes or no? No. How about that one? No. How about that one? No. Okay. You know what you just diagnosed? A microcytic anemia. Because all of microcytic anemias have one thing in common. They all have a decrease in hemoglobin synthesis. Does it make sense? If you don't have a whole lot of hemoglobin, then the redness of the cell is going to markedly drastically decrease, and you're going to see a greater area of pallor. Is that agreed? So all of you don't even need the MCV. You knew by looking at that, by the fact that there's no hemoglobin in those cells, it was microcytic. And if you played odds, it's iron deficiency. So don't tell me you can't recognize these things on a peripheral smear on an exam. Yes, you can. Now, what did I say a spherocyte was? It was a cell that had too little membrane, and so it was a sphere. Look at that, please. You see a central area of pallor in that cell right there, that cell right there, that cell right there, that cell right there. Do you see an area of central pallor there? No. That means it must be a spherocyte. So don't tell me you cannot recognize spherocytosis, because there'll be little red cells, all red, no central area of pallor. And don't tell me that you're not able to recognize a microcytic anemia, because there'll be cells that have lots of blank, lots of pale color to them. You can hardly see the hemoglobin in them. Those are always the microcytic ones. So it's extremely easy to, for a medical student taking an exam, to identify spherocytes, and extremely easy to recognize microcytic cells with hypochromia and things like iron deficiency, chronic disease, that type of thing. Very easy. You just did it. Okay, that's enough for now. So this afternoon we'll finish off. I don't know if we'll finish hematology, but we'll get pretty close to it. Guys, this classification scheme you see up here has helped me for 25 years of doing hematology. It's never failed me. Nor the way I'm showing you to go about working up anemias has never failed me either.
You have to have a system for doing things, not just hematology, that's everything. Okay, you have to have a system. If someone comes in with dyspnea, you have to have a system for how you work that up. Someone chest pain, a system for how you work that up. Okay. So, when you have anemia, in my opinion, the best way of classifying is by the mean corpuscular volume. There's a couple things, as I alluded to already, that you have small cells and large cells. They'll come out, with a normal MCV. But overall, this works pretty good. For blood purposes, unequivocal. It's just absolute, straightforward hematology. No tricks, no nothing. And so it's relatively straightforward. This will help you for part 1, 2, and 3. Everything I'm saying is on part 2 and on part 3. So it works for all 3 tests. All right, we're going to deal with the microcytic anemias first, then we'll go into the macrocytic, and then we'll go into the normocytic. Now, in the normocytic, you see the reticulocyte count is the most important way of separating out how you're going to work up normocytic anemias. Remember, whenever you have a reticulocyte count, that's what the technologists give you in percentage. You have to make a correction first for the degree of anemia, hematocrit of the patient over 45 times the reticulocyte count. Okay, and then you look and see if it says anything about polychromasia. If it doesn't say polychromasia is present, then that's it. You just correct for the anemia, and you have a number. If it's 3% or higher, bone marrow is responding appropriately. If it's 2% or lower, it isn't. It's just that simple. If polychromasia is present, then you divide that initial correction for the anemia divided by 2. You look at the number. 3% or higher, good response. 2% or lower, bad response. Very simple, straightforward way of looking at it. Okay. So we'll be going through all of these things. Now, whoa, okay. A couple physical signs of anemia that I've chosen here. This, of course, is what? What do they call this? Spoon nails, huh? What's that the sign of? Iron deficiency. Another name is chorlonikia. Okay? This is called ketosis when you get cracking. That's due to everything. And you go like this. It can be anything that produces this, but you also can see it in iron deficiency. You can see it in riboflavin deficiency. So that's not specific for anything. And then, pallor of the conjunctiva. If your conjunctiva are pale, you have 6 grams or less hemoglobin. You look in the palmar creases. Now, this only works for those who are Caucasian. You look in the palmar creases and you don't see red in them, you're anemic. Okay, mine has nice red things in it, so I'm not anemic. Okay, don't come up here, women, showing me your pale creases, because that means you have iron deficiency. All right. This is the lead line. Okay, you see that kind of discoloration right at the gum margin. You've seen that in lead poisoning. Remember, the neurologic exam is very important in B12 deficiency, because you knock off the posterior columns and your lateral cortical spinal tract. So you have proprioception abnormalities, decreased vibratory sensation. And then if you have lower motor, the lateral cortical spinal tract, you have the Binsky's and stuff like that. So these are kind of classic things that we see in different kinds of anemia. We're going to start with the microcytic anemias, and you have this little chart in your notes. And I like to start first when we're dealing with microcytics with iron studies. And I'll make this as simple as I can. There's basically 4 iron studies that you can get. Serum iron. The normal serum iron is about 100. Okay? That's easy to remember. Same thing as the alveolar oxygen. It's normally 100. We have ferritin, which I think is the best test. Serum ferritin, that's a soluble form, a circulating form of iron storage. Ferritin. And the beauty of it is it represents the amount of iron you also have stored in your bone marrow. So, if you had to pick one test for diagnosing iron deficiency or anemia, chronic disease, or iron overload disease, it'd be serum ferritin, because that's the best overall screening test. Okay, so we have serum iron, we have serum ferritin. Now we get into some problems that you have. And that's TIBC, total iron binding capacity, percent saturation. Very confused by students. Please tell me what the carrying protein is for iron, please. Trans, which means carry ferrin. So that's pretty easy. Transferrin carries iron. That's the name of the protein. Where is it made? Where are all proteins made? Liver. Okay. Listen very, very carefully. Transferrin and total iron binding capacity are the same. But listen, just think about it. Total iron binding capacity. You just finished telling me that transferrin is what carries iron. They're the same.
All right, that's fact one. Fact two, there is a relationship of iron stores in the bone marrow with the transferrin synthesized in your liver. And it's a very simple relationship. When the iron stores in your bone marrow are deficient, a la iron deficiency, that is a signal for the liver to make more transferrin. So it's increased. Therefore, what's the total iron binding capacity in iron deficiency? Increased. Very good. So low iron stores, increased transferrin synthesis, increased TIBC. Kind of like an inverse relationship like hormones. T4 increased, TSH decreased. T4 decreased, TSH increased. Iron stores decreased, transferrin, TIBC increased. And the vice versa. Iron stores increased, transferrin synthesis decreased. Decreased TIBC. Very, very simple. Very, very simple. Okay? All right. Percent saturation is a calculation, actually. It's your serum iron divided by your total iron binding capacity. Now, normally the serum iron, as I said, is 100. Normally the TIBC, 300. So you tell me what the normal percent saturation is. 100 over 300. You guys are pretty good in math, right? Certainly better than me. I'm an idiot in math. Total idiot. 33%. You know what? That's a very interesting thing. You had a very good teacher in endocrinology called Porter. Okay, and did you notice that hormones, when they bind to their binding proteins like thyroid hormone and thyroid binding globulin, transcortin, and cortisol, that's always 1/3 of the binding sites are occupied by whatever's on the binding protein. Isn't that correct? Isn't 33% 1/3? Yes or no? Yes. So that's no surprise. 1/3 of the binding sites on binding proteins are usually occupied by the things they bind. It's even pretty close for albumin. Okay, albumin about 1/3 of the binding sites are occupied by, have calcium binding to them. So it's pretty close for that too. So it's a concept in terms of binding proteins and what they bind. It's roughly 1/3 of the binding sites. And that's what percent saturation of iron is talking about. Okay, so the iron's 100. The total iron binding capacity is 300. So the percent saturated, 100 over 300 is 33%. Okay. So those are your terms. Those are your terms that we're going to be using when we discuss the microcytic anemias, which involve usually the problems that deal with iron. Okay? So those are your iron studies. You have this diagram in your notes, and I always like to give you mechanisms. Okay, I'm going to use this note, this slide right here, to discuss the pathogenesis of each of the microcytic anemias. Okay, and then you can go to the tables. All the anemias, all the white blood cell problems are in tables. Cool. Do they work? Big time. Big time. So they're nice, simple, and neat. Okay, remember, the microcytic anemias have a few things in common. One, they're microcytic. Why? Well, basically because their problem is in making hemoglobin. That's the mechanism of microcytic anemias. They can't make hemoglobin. I don't get it. Well, here's the thing. When a red blood cell is developing in the marrow, it's the hemoglobin concentration in that developing red blood cell that determines the number of cell divisions. Therefore, if the hemoglobin synthesis is decreased, that's a signal to the red blood cell in the marrow to increase the number of mitoses. And you all know that when cells mitose, they go from something that was originally big to something smaller. You already know that. And so because of the decrease in hemoglobin synthesis in those red blood cells, for the reasons we'll talk about momentarily, there's extra divisions. Voila, and microcytic. So that's the mechanism of that. So all four groups of microcytic anemias have a decrease in hemoglobin. That's what characterizes it now. So all we have to do is think about hemoglobin synthesis. It's easy. So hemoglobin's heme plus globin. Okay, what's heme? Iron plus protoporphyrin equals heme. What's globin? That's going to be you guys. And we've got a woman over here, she's alpha. That's a good thing to be. We have beta. Not too bad. Delta? Yeah. Gamma? 2 alpha, 2 beta? Talk to me. Hemoglobin A. 2 alpha, 2 delta? Talk to me. A2. 2 alpha, 2 gamma? That's very good. Those are your globin chains. Heme, iron plus protoporphyrin, plus globin chains equals hemoglobin. Okay. Now we can dispense with 2 of the 4 microcytic anemias in a split second. Iron deficiency, you don't have iron. Okay? Whoa! Therefore, there's no iron here to put together with protoporphyrin to form heme. So that's easy. Okay? That's the mechanism. No iron, no heme. No heme, no hemoglobin. Whoa. All right. Anemia, chronic disease. It's something built into our system that God put there. And that is, when we have inflammation, our bodies respond to inflammation as if it's an infection. Now, you may or may not have learned in microbiology that bugs, particularly bacteria, increase their reproduction with iron. So the more iron, the more they reproduce. And so the concept is, when you have anemia, chronic inflammation, and the body assumes that it's related to a bacterial infection, the object is to keep iron away from the bacteria. Okay. How does it do that? Well, it's like a safety deposit box. You have the key. Okay. Iron is normally stored in macrophages in the bone marrow. Okay. That's where transferrin goes to pick up the iron to deliver to the red blood cell. And it's like a safety deposit box. Since we don't want bacteria to have access to iron, we're going to lock it away in those macrophages in the bone marrow and lose the key. So we got lots of iron in those macrophages in the bone marrow, lots of it, but you can't get it out. So what's the good news? The good news is you're keeping it away from the bugs, so they can't reproduce. What's the bad news? You're keeping it away from the red blood cells, so you have a decrease in hemoglobin synthesis. But unlike iron deficiency, where there is no iron in the macrophages in the bone marrow, there's piles of iron in the macrophages, but it's like a safety deposit box, and you're the only one that has the key. You lost it. And so you can't get it out. So, irrespective of that, your serum ions decrease because it's all locked in the macrophages, and so you don't have enough iron to make heme. So it's basically the same mechanism as iron deficiency, but for different reasons. One, you have no iron. The second one is you have lots of it, but it's locked in a safety deposit box, and you can't get it. Either way, you can't make heme, you can't make hemoglobin. So we knocked out 2 out of the 4 already. The next one is the least common of the microcytic anemias, and we call them sideroblastic anemias. What's sidero mean? It's another word for iron. So iron has lots of terms. Ferric, ferro, sidero, both of them mean iron. Now, you're going to learn in biochemistry that there are certain biochemical reactions that are in the cytosol. There are certain biochemical reactions that are in the intermitochondrial membrane, oxidative phosphorylation. The mitochondrial matrix, beta-oxidation of fatty acids, TCA cycle. And in the cytosol and the mitochondria. Gluconeogenesis starts in the mitochondria, ends up in the cytosol. Urea synthesis starts in the mitochondria, goes into the cytosol, comes back into the mitochondria. And heme synthesis. Part of it in the mitochondria, part of it in the cytosol, part of it in the mitochondria again. So there's 3 different biochemical reactions that have cytosol and a mitochondrial component. With me? Well, the first part of heme synthesis, or porphyrin synthesis, because that's what this is, okay, begins in the mitochondria. That's what this square is. This is a red blood cell in the bone marrow. That's its membrane. That is its mitochondria. Okay, and the first reaction is the must-know reaction. That's succinyl-CoA. Remember, that's in the TCA cycle. It's a substrate for gluconeogenesis. And if you could put that together with glycine, the simplest amino acid, did you know glycine's a neurotransmitter? I hope you do. Is it a stimulatory one or an inhibitory one? It's inhibitory. Of what? Muscle. And what blocks it? Technospasm. Tetanus toxin. Blocks glycine, and that's why I get opisthotonus, rhesus sardonicus, and all that excess tetanic contraction. You've inhibited glycine. So now the muscles are in a constant state of a contraction. Hopefully you knew that already. Every third amino acid in collagen is glycine. And here we see glycine also involved in heme synthesis. Whoa! So here it is, glycine, and here's the rate-limiting enzyme. You better know, when Hanson's done lecturing to you, you better know every rate-limiting enzyme for every important biochemical reaction. If you don't, you're going to get a pile of questions wrong. That is the absolute single most important thing in biochemistry. What's the rate-limiting reaction? You happen to know what it is in cholesterol synthesis? You should, because you talked about a drug that blocked it, HMG-CoA reductase. Okay? Well, what do you think the rate-limiting enzyme is in heme synthesis, or porphyrin synthesis? Aminolevulinic acid synthase. Now, what's the cofactor for this? Our little friend pyridoxine. All right. And so what happens is it comes together and you form delta-aminolevulinic acid, and you got a bunch of other crap enzymes, and you go to porphyrin, uroporphyrin, back into the mitochondria. Why don't you mention the other things? Because they're not important. Oh, okay. And so I got It's funny, like I'm talking to myself as if it's a person in me, but really I'm not crazy. Okay, I'm really trying to put into words what some of you are thinking. Okay, and it also wakes you up a little bit. Okay, I really have to do this in the afternoons, which is the absolute worst time to lecture of all. It's the afternoon, worst. Okay, so we got a little protoporphyrin here, and then plus iron. Now, who go put those two together? Well, here we got this metal with protoporphyrin, so it's going to have to be some kind of chelatase. It's chelating agent, and so it's called ferrochelatase. That combines iron together with protoporphyrin to form our little friend heme. Heme has a feedback mechanism, as do all rate-limiting enzymes, with ALA synthase. So if heme's increased, it inhibits ALA synthase. If heme is decreased, it enhances it. Understand? Good. All right. Now, let's deal with these rarest of the microcytic anemias, sideroblastic anemias. There's three main causes. Uno, that means one. Okay. Alcohol. Now, that's not to say that sideroblastic anemia is the most common anemia in alcohol. Now, some students think that's what I said. No, I just said that the most common cause of sideroblastic anemia is alcohol, an alcoholic. Actually, the most common anemia overall, believe it or not, is anemia of chronic disease, followed by folate deficiency. So this is not common, but the most common cause of this not common anemia is alcohol. Why? It's a mitochondrial poison. Remember, it uncoupled oxidative phosphorylation. It damaged the inner mitochondrial membrane. It allowed protons to go in there and drain them off. If you do an electron micrograph of the mitochondria in an alcoholic, they're huge. They're called megamitochondria. They're damaged. So any process that occurs in the mitochondria is really screwed up, which includes heme synthesis. And so what happens is iron, being dumb, gets delivered to the red blood cell by transferrin, and it says, duh, where am I supposed to go? Well, some of you stay there and it gets stored as a little bit of ferritin, but most of the time you're going to make it direct, so go right into the mitochondria. Bad news. Why? You can get in, but you can't get out. Now, iron probably tries it, bonk, 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 and okay, it's trying to get out of the mitochondria, but here it is. You've got this damaged mitochondria, which it doesn't know is damaged by alcohol. It goes in there and it can't get out. So would you all agree that you're going to get lots of iron being caught in that mitochondria, and that mitochondria is going to start filling up with iron? Huh? A mitochondria located around the nucleus of a red blood cell in the bone marrow? Yeah? And so we have the ringed sideroblast related to that, which is the marker cell for sideroblastic anemia. It's also an iron overload disease. You will have excess iron because of this. And you're not going to get heme because the whole stinking mitochondria is damaged by alcohol. So that's the most common cause. Okay, then we have B6 deficiency, which is called pyridoxine, as you recall. If you're deficient in this because you didn't have it given to you when you're taking isoniazid for treatment of your tuberculosis, then what's going to happen? Well, this is clear. No B6, no heme. The very first reaction is not going to happen. But iron doesn't know that. It has no brain. And so it just goes right in there, and it says, wait for the porphyrin. It's not here. I'm going to try to get out. Bonk, bonk, bonk. Can't. Ring sideroblast. All right. The third is lead poisoning. All right? So lead actually produces a sideroblastic anemia. Now, lead is a denaturer. All heavy metals denature proteins. Are enzymes proteins? Yes or no? Yes. So it denatures lots of proteins. And the one it likes to do it the most is this one, ferrochelatase. That's its favorite enzyme to screw it up. It's denatured. What does that mean? It don't work. Isn't that cool? You okay up here, you knock that off, no heme, no hemoglobin, microcytic anemia. It has a less of an inhibitory effect, but it does have a little one on aminolevulinic acid dehydrates too. So you can have it here or you can have it here. But the one you want to remember is the one it most commonly knocks off, and that's ferrokelatase. Okay, so when iron comes into this, it can come into the mitochondria, it's not going to be able to bind with protoporphyrin to form heme. Voila, no heme, decreased hemoglobin, microcytic anemia. Now I'd ask you a question, because this deals with products related to enzymes. If ferrokelatase is decreased or inhibited, heme decreases, but what happens to protoporphyrin before the block? Increases. And that used to be the screening test of choice for lead poisoning. Okay? You'd have an increase in red blood cell protoporphyrin. It's not used anymore, and I can figure out why that is. I wonder if you can. If you don't have iron present because you have anemia, chronic disease, or you have iron deficiency, what do you think is going to happen to protoporphyrin in the mitochondria? It's going to increase. And so what they did was they found out they got a lot of people that had an increase in red blood cell protoporphyrin, and then when they got blood lead levels, they were negative, and said, oh God, we got a patient with iron deficiency or anemia, chronic disease. And so in other words, it wasn't very good screening, because they ended up working up other anemias. So now that is no longer the test of choice for screening or for screening or confirming lead poisoning. They just go right to the money. Blood lead level is the screening and confirmatory test for lead poisoning. For RBC protoporphyrin, no longer. Too many false positives. Okay? All right. That's the only concept I wanted to get at here so far in terms of pathogenesis. Now we're going to deal with the thalassemias. And pathogenesis we're talking about now. So you're still alpha. You haven't changed. Any of you guys want to change? Say no. No. You're still beta. You're still delta. You're still gamma. Okay? Now let's deal with the thalassemias, which are genetic diseases, autosomal recessive. Let's deal with the simplest one, the easiest one, alpha thalassemia. If you're interested where they are, it's under the little charts that deal with the anemias and thalassemia and the mechanism. You don't really need to look because it's just very, very simple. Now listen to me. So you could be going there and you're going to miss the whole point. You're going to miss thalassemia as fast. I mean, it's going to be like a jet plane right over your head. Okay? All right. Now, who do we see alpha thalassemia in? Two main groups of people. The Asian population and the black population. In fact, all genetic diseases involving hematology are seen in the black population. G6PD, beta thal, alpha thal, sickle, all of them are commonly seen in the black population. Okay, so alpha thal is Far Eastern black population. Okay, now let's talk about hemoglobin electrophoresis so we can understand how we can diagnose the thalassemia. Hemoglobin electrophoresis is like any other electrophoresis. It separates things out on the basis of size and charge. And so you can clearly separate out hemoglobin A, hemoglobin F, and hemoglobin A2 clearly on cellulose acetate because they have different migrations. And so they do that. So they pherese it, hemoglobin A settles out, hemoglobin A2 settles out, hemoglobin F settles out. So how do they know how much is there? They stain the cellulose acetate thing. And so it produces density. The density is going to correlate with the concentration of each of those hemoglobins. So how are they going to know what the percentage is? It's simple. They run a densitometer straight across it, and it converts the density of the stain to a percentage. And it turns out that U hemoglobin A, 2 alphas, 2 betas, is the predominant hemoglobin in an adult, 95, 96%. U hemoglobin A2, 2 alphas, 2 deltas, maybe 1 or 2%. U hemoglobin F, 2 alphas, 2 gammas, maybe 1%. That's the normal. So notice it's expressed as a percentage. You with me now? Good, here we go. Alpha thalassemia, autosomal recessive, is a problem in making alpha globin chains. Do all of you guys, A, A2, and F, require her to make you? Absolutely. So all of you are equally decreased. If she's decreased, your hemoglobin A is decreased. If she's decreased, hemoglobin A is decreased. If she's decreased, hemoglobin F is decreased. Will that show up on an electrophoresis? No. So the hemoglobin electrophoresis is totally normal because they're all equally decreased. So there's no way it can pick it up. Now, turns out there are 4 genes that control alpha globin chain synthesis. 4. If you have a deletion of one of those 4, you don't even have anemia. So you don't even have to worry about that one. If you have, I got to wash my fingers. I don't want a bad finger up here. Okay. Okay. You see someone that broke this finger and they got this big cast like that and it comes out like that and it's so cool and they put it out in the window and they got this big thing making a statement to the whole world. Okay. But anyway, 2 gene deletions, problem. You are minimally decreased. Okay? And so you're going to have a mild anemia. And the reason why it's going to be microcytic, guys, is because the globin part is going to be decreased. Right? Okay? So you remember that's going to mean that you're going to get a microcytic anemia. You're going to have a decrease in hemoglobin concentration. That'll be the stimulus. Okay? Understand that? That's called alpha thalassemia minor. We see this in the Far Eastern population and the black population. Now, if you have 3 gene deletions, that's not good. Rarely do they ask us on boards, but whatever. You are really decreased. Okay? And so what happens is there's a really bad anemia. In fact, it even has a hemolytic component to it. And you beta change, you get really irritated that there's no alpha change event. So you get so irritated that you form your own hemoglobin. So 4 of you get together, and so you have 4 beta chains together, and you form hemoglobin H. Now, if you do an electrophoresis there, is hemoglobin H a different hemoglobin? Yes. You think it'll migrate in a different place than other normal? Yeah. So that one you can diagnose with hemoglobin electrophoresis. That's why it's called hemoglobin H disease. Okay. 4 gene deletions, you never really even are born alive. It's a spontaneous abortion usually. I got an interesting correlation there. Okay? U gamma chains, seeing what beta chain did when it was irritated, you say, where is alpha chain? Because there ain't any. Okay? And so you say, I got to do something. What are you going to do? I'm going to pull my own hemoglobin. 4 gammas, that's full hemoglobin bars. Would that show up on electrophoresis? Yeah. Would it matter? No. Why? There's no baby. Baby dead. Now I ask you a very simple question. See if you can put this together. What do you think the spontaneous abortion rate is in the Far East? Very high. Why? Because that's where alpha thalassemia is most commonly located. Therefore, what cancer do you think would be most commonly seen in the Far East if the incidence of spontaneous abortions is increased? Choriocarcinoma. There you go. And that's true. It's just a perfect logarithmic relationship. If there's an increase in abortions, as you know, spontaneous abortions as well as hydatidiform moles all predisposed to choriocarcinoma. There's an extremely high incidence of choriocarcinoma in the Far East because of alpha thalassemia. Do you understand what I just said? That's classic board stuff. Putting things together and integrating it. All right. We're done with alpha thal. How do you treat it? I can tell you how you don't treat it. Don't give them iron. That's what most of the morons do out there. Oh, you got some microcytic anemia. I can't think. Hemoglobin electrophoresis is normal. It's got to be something there. Wouldn't give you iron. Oh, that's the worst thing you can do. Then you iron overload them, and now you're going to kill them. You leave them alone. You say, hey, you got this. You got probably have alpha thalassemia because everything is looking like that. The hemoglobin, it's nothing. Don't worry about it. Okay. You got alpha thal. It's nothing. Really? A lot of times people like that. Sometimes they make little shirts. I have alpha thal. Ask me about my alpha thalassemia. Why? Okay, because they have something unique that won't hurt them. It's like Goljan's disease. You know, second most common cause of jaundice. Is it bad enough? No, it's nothing. You just get jaundice maybe when you're having eaten. There's nothing, right? Right, nothing. Goljan's. It's got a nice ring to it. Okay? I think I'll have a shirt. Ask me about my Goljan's disease. Okay, why? These are people that are starving for information and starving to talk to people. Okay? In fact, my entire second-year class did just that. Asked me about my Goljan's disease. They did that. Okay? As a memoriam for me, I guess. All right. So we're done with alpha thal. Okay? Now, beta thal is a lot more interesting. Population. Not Far Eastern. We still have black population, and we have Greek and Italians. So black, Greek, and Italians. Beta thal. Okay? You're not thinking beta thalassemia in Far Easterns. All right. You're decreased. Okay. Beta chain. Now, they did ask a question that was B plus on the top, beta with 0 on the top, and just B by itself. B by itself means you're making a normal amount of beta chains. B with a little positives on it means that you are making it, but not a lot. B with a 0 over it, you're not making it at all. Okay, so that's what those different things mean. Okay, now that's a bit different. This is a bit different because beta thalassemia, even though it's autosomal recessive, has nothing to do with gene deletions. It deals with splicing defects. It deals with stop codons. In fact, the very, very severest form of beta thalassemia is the stop codon. So that means you actually terminate or never even start making beta chains. That's what stop codons do. I mean, that's about my knowledge of DNA, too, right there. Stop codon. I understand stop. Okay. All right. Well, let's deal with the mild one, which is the one they ask on Part 1 boards. You're a slightly decreased beta change, probably because of a splicing defect. But alpha, are you okay? Say yes. Are you okay, delta? Say yes. Are you okay, gamma? Okay, he just shakes his head because he's a fetus. I can't talk. All right. All right. So we can understand why you don't talk. Because your hemoglobin F. Okay. You can start babbling, though. Can you babble a little bit? Okay. Beta change, you're decreased. Alpha, you're okay. Delta, you're okay. You're okay. So what hemoglobin is going to decrease? A. Okay? And what's going to increase, actually, because you're decreased and she's available, delta is going to get together, hemoglobin A2, gamma is going to get together, hemoglobin F. So we have a decrease in A and an increase in A2 and F. Will that show up on a hemoglobin electrophoresis? Yes. And the reason why it did is because beta chain was decreased, and that decreased hemoglobin A, that would show up. So the only way you can diagnose beta thalassemia is with hemoglobin electrophoresis. What are you going to do about it? Nothing. You better pray that it ain't the severe type where you're not making any or hardly any beta chains. That's called Cooley's anemia. You're not going to live past, 30. You're going to have a constant transfusion requirement. In fact, most of the time they die of iron overload disease and all those multiple transfusions, or hepatitis C and hepatitis B and HIV. It's horrible. It's a horrible disease. That's called Cooley's anemia. But they don't usually ask that. Usually it's just a mild beta thalassemia. Very, very common. Very, very, very common anemia. See it very, very commonly. Okay? Now, if you really understood what I said, then you should be able to answer this question. And this is most commonly seen in the black population again. It's a genetic disease. It's very common, actually. And it's called beta delta thalassemia. I want you to tell me what would the hemoglobin electrophoresis show if it was a beta delta thalassemia. Hemoglobin F rather, is the answer. Okay? Let's see. For those that didn't get that, beta, delta. So beta change, you're decreased. Delta. Delta change, you're decreased. So who's left? Alpha, gamma. It's called hemoglobin F disease. It's called hereditary persistence of hemoglobin F. It's a nothing hemoglobinopathy. Okay? You don't have anemia, nothing. It's just interesting. You just basically have predominant hemoglobin F. Okay? So that's what beta delta. If you understood that, then you really understand the concept of how the thalassemias work. Good. So we're done with that. As a matter of fact, we're done with this chart. Okay. So if you want, you can go to the tables if you want. Let's just discuss some of the causes of iron deficiency anemia. And the best way of understanding that is by age brackets. Prematurity is clear cut. Why that would produce iron deficiency? Because every day that a baby's not in utero, it's losing iron. Okay, so that's an easy one. Their iron stores are all decreased. That's why all preemies have to be given iron supplements, because they all would develop iron deficiency. How about a newborn? If they had iron deficiency, check their stool. Probably is going to be positive for their blood. The way you're going to prove that, whether it's their blood versus mommy's blood, which it swallows with the APT test, like the first three letters of aptitude, that's part 2. Most of the time, blood in the stool of a newborn, when that comes out with meconium, is blood the baby swallowed from mommy. So it'll have hemoglobin A in it. But for some reason, it was hemoglobin F blood that came out of the baby's stool. Most common cause is Meckel's diverticulum. So bleeding Meckel's diverticulum is the most common cause of iron deficiency in a newborn. Also, I might add, child in general, Meckel's diverticulum. Don't put Meckel's diverticulum as the cause of iron deficiency in an adult, because most of them will have bled by 4 years of age, and so you already would have known you had it. I mean, that would be way down your list for iron deficiency in an adult, Meckel's diverticulum. If you're talking about a woman under 50, clear-cut, unequivocal menorrhagia. That's the most common cause. So you get a really good menstrual history. You're under 20, the most common cause of it's going to be anovulatory cycles. Between 20 and 40 years of age, it's going to be ovulatory cycles, with irregular shedding of the endometrium and stuff like that, inadequate luteal phase. It's pregnancy-related bleeds. It's a endometrial polyp that's bleeding, that kind of stuff. Okay? So menorrhagia is the most common cause of iron deficiency in a woman under 50. Okay? How about men under 50? Peptic ulcer disease, and if you play odds, it'll be duodenal ulcer. Okay? Over 50, men and women, clear-cut, unequivocal colon cancer. That's what you got to worry about. That's it. Done really with iron deficiency there. There's really not a whole lot more to say about it. But thalassemias, not a whole lot more to say about it. We already know which groups of people it's in. We know that they're genetic diseases. We know that you don't do anything to them, especially give them iron, because all their iron studies are normal. Let's just review, though, before we leave the iron deficiency, let's just go through the laboratory test. What's the serum iron in iron deficiency? Low. Now think, what's the TIBC? Ah, good. What's the percent saturation? No, think now. It's the iron, which is low, divided by the TIBC, which is high. What's the percent saturation? Low. Now, you should be able to think that out. If you don't have iron, why would you think that you would be saturating transferrin if you don't have iron to begin with? If you don't have iron, of course the saturation of a transferrin is decreased because you don't have any to put on it. Doesn't even make sense. And what's the serum ferritin level? Low. All right. Anemia chronic disease, I don't have a whole lot to say about because it's related to inflammation. Okay? But I do have something that I want you to tell me is what the iron studies show. Can you remember what's the mechanism? It's locked in a safety deposit box. You got plenty of iron, except you can't get it out. So what's the serum iron? Low. Now think, what's the total iron body capacity? Low. Very good. Remember high iron stores? Decreased transferrin synthesis. Percent saturation? Low. But serum ferritin? High. Because you got piles of it. So what's the main difference in laboratory tests that'll distinguish chronic disease anemias from iron deficiency? Ferritin, there we go. The other one's TIBC, but no one uses that. Good. What's the iron studies in mild alpha thalassemia and mild beta thalassemia? Normal. Why? It has nothing to do with iron. It has to do with globin chains. Okay. Okay, we'll get to the sideroblastics in a second. All right, let's deal with it. We'll do it right now. Okay, first of all, I want you guys to look at this smear. Okay, see that smear right there? I want you to tell me whether there's an appropriate amount of hemoglobin in those cells. No. So that means then that they're more than likely microcytic, it's more likely a microcytic anemia, and this could be either iron deficiency, anemia chronic disease, thalassemia, or even lead poisoning. Agreed? Okay. This is a ring sideroblast. Now, the only way you can see a ring sideroblast is to do bone marrow. Okay? And you have to stain it with Prussian blue, which stains iron. Remember, I told you that mitochondria are usually around the nucleus, and so they're all filled up with iron. And so here's the nucleus, and these are mitochondria all filled up with iron, and they go form a ring around there. That's why it's called a ringed sideroblast. This is pathognomonic of a sideroblastic anemia. So if you thought that B6 was producing your deficiency, was producing your microcytic anemia, you'd have to prove it. You'd have to get a bone marrow and prove that you have those ring sideroblasts. If you thought that alcohol was the cause of the microcytic anemia, if you ruled out all the other stuff, then you'd have to prove it with that. But certainly, if you suspected lead poisoning, why in God green earth would you do a bone marrow to look for one of these things? It'd be present, but isn't there something that's simpler? How about a plain old blood lead level? Okay? You don't have to do bone marrow to prove that one. You can just make your diagnosis that way. Okay? Here's another. This picture right here has been on many, many boards. This exact one. Here's another section with a ring sideroblast as well. Let's just deal with lead specifically now, lead poisoning. Okay. I think probably everybody in this room, if I said lead poisoning, the word that you would say would be coarse basophilic stipling. Okay, that's where you have red blood cells that have measles. They have lots of little blue spots all over them. That's probably the best one right over there. Now, do we need a special stain to see basophilic stipling? No, we don't. It shows up on a regular Reichington stain. What are they? When we say basophilic stippling, well, what are we talking about? Why do we see these little things that look like measles of the red blood cell, these little blue dots all over the place? The answer is that lead denatures ribonuclease. And the purpose of ribonuclease is to break down ribosomes. And so if it's denatured and it can't break down the ribosomes, they persist. And they give us a fantastic marker in the peripheral blood that we can see and say, this is lead poisoning. Isn't that cool? It's very, 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 very specific for lead poisoning. Coarse basophilic stippling. Okay? If it's an RNA filament, what are we talking about? A reticulocyte. But if it's a persistent ribosome, what are we talking about? Lead poisoning. Okay. Now I want you to look at this X-ray because this X-ray was on the boards. I know exactly where it came from, the scope manual, which is no longer available now. That's where they got the picture from. They still have it. What's this? That's the epiphyses of the fingers of the child. Okay, and that's lead. The only heavy metal that can deposit in the epiphyses of bone is lead. Mercury can't, arsenic can't, only lead can. And so you can see the deposits in the epiphyses. That's why they have failure to grow. Because if you screw up the epiphyses of a kid, okay, they are not going to be able to grow properly. That's what the heavy metal is going to be doing. So it's the only heavy metal that will actually deposit in the epiphyses. Now, they are extremely clever on lead poisoning in terms of the clinical scenarios. Okay? Now, the one that you all are aware of is a little dude that lives in a poor area and is eating paint or plaster from their crib or the wall, and it was, the old days, the paint had lead in it, okay, and they get lead poisoning. And you remember that the classic presentation, severe abdominal colic, okay, that they commonly get. They have problems with cerebral edema, okay, that can occur, so they can get convulsions and stuff like that, and of course they're going to have a very severe microcytic anemia. You can do a flat plate of them, and you can actually see the lead in their intestine. You can actually see there's three things actually that you can see with a flat plate. Iron. So if a kid took iron tablets from, say, a mommy that's taking iron for menorrhagia, okay, the little baby gets it and they eat the iron. Okay, you can actually see on X-ray the iron tablets that are left undigested. Okay, you can see lead with just a plain flat plate. You can see mercury with just a plain flat plate. So you can see these things actually. So abdominal colic, severe microcytic anemia, failure to thrive, cerebral edema. There was a board question on that. What was the mechanism of the cerebral edema? Boy, I had to look big time for that one. I looked in Nelson's textbook of pediatrics, and there it was. It said that the cerebral edema is related to increased vessel permeability in the brain and relates to the buildup of delta-aminolevulinic acid. Okay, remember, if you block peroxylase and everything distal to that block increases, right? So protoporphyrin and all those other things, including delta-aminolevulinic acid. And apparently it's toxic to neurons, and that's what's causing it, apparently. That was something else. I couldn't believe that one, because, it wasn't in the standard textbooks. I had to look about 5 different books to find that one. And, of course, it's in your notes. Okay. Just want to make sure, because you were worried. Now, that was an easy one. Then the other ones, the guys that work in an automobile factory that have abdominal colic and diarrhea, okay, lead poisoning, because they have exposure to batteries. Usually in automobile factories, they incinerate batteries to get the lead to reuse it again. So the old workers in an automobile factory with colic and diarrhea is the other one. That's pretty clever too. The moonshine one is extremely a giveaway. Some people still make alcohol in old radiators, bad thing because they were lined by lead. Okay, so you make your alcohol, you automatically get lead poisoning. That's called moonshine. So that was one they actually put. That was kind of a giveaway. Okay, the one I think is the trickiest one for lead poisoning was the pottery painter. That was the trickiest one, because pottery is commonly painted with lead-based paints. Okay, and a lot of times when they paint on them, to make that the tip of the paintbrush, nice and sharp so they can make fine detail, they oftentimes, okay, and so they get lead on their tongue and they end up with lead poisoning. You're all aware of the fact that if you have lead, if you have pottery from certain countries, because there's so many that it could be your country. We won't mention which countries. Okay, we could have a riot here. Not in my country. Okay. In country X, in country X, okay, the pottery that you can use for dishes often has lead-based paint on them, and you can get lead poisoning from that. Okay, so those are the scenarios. Those are the only ones that have been asked on board. The classic kid eating plaster, the moonshine question, the guys that work in an automobile factory, and the one that is a pottery painter, the way they ask lead poisoning questions. I can't even imagine any other one they could use. Adults seem to get the neuropathies, the foot slapping gait of peroneal palsy, the wrist drop of radial nerve palsy, the claw hand of ulnar nerve palsy, the lead lines in the teeth. Adults usually get that with the colic and diarrhea. Okay? That's it. Done with those diseases. All right. Now to see if you got everything. Here we go. You have a chart that fills us in. You ready? We have iron deficiency here, and we have iron TIBC percent sat ferritin. Let's go. Iron, what is it? Low TIBC, high percent sat, low ferritin. Very good. A for all of you. Second one, anemia chronic disease. Iron, TIBC, percent sat, low ferritin. Very good. Another A. little smiling stickers with a little smile, little yellow, just stick them on your forehead. I don't have one. Just make believe. But you got to make believe for crying out loud. Okay, alpha and beta thal, iron, normal. GWT, percent fat, ferritin. What are you going to do about it? Nothing. Very good. Now, lead poisoning, as well as all the other sideroblastic anemias, are iron obeliscus. Finish this. You don't worry, you'll get the time. I'm type A on this one. It's an iron overload thing, just like hemochromatosis and hemosiderosis are, because it's all that excess and iron. So it's iron overload. That's all I'm going to tell you. This is tricky. If you get this one, you're really good. Now, iron should be no problem. What's the serum iron in an iron overload disease? Hi. Okay, now I want you to think, what are the iron stores? What are the iron stores in iron overload disease? Very good. So therefore, what's the TIBC? Low. Very good. Think iron overload disease. Percent saturation. High. Very good. And then, of course, what's the ferritin? High. Very good. You know what the natural tendency to do when you have iron overload disease? Think everything's high. And so you commonly say, high, 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 high. Wrong. High, low, high, high. Right, break. All right, let me make sure that we have this thing on. Okay, guys, this kinds of questions that I've been getting. A lot of you are trying to find shortcuts. There aren't any shortcuts, guys. There's no shortcuts in terms of the material that you have in your hand, because, as I told you, this is a distillate of 25 years of teaching, and it's down to the bare minimum. So don't come up and ask me, okay, I only have this amount of time for the exam, before to study, what do I need to study, what don't I need to study? I can't answer that. Okay, I cannot answer that, because everything in there has some meaning to it. Okay? And so, as I told you, if you can get through all those notes, and plus the other ones from other people on that, your score should be high. If you can't get through all of them, then obviously it could potentially be lower, because you wouldn't have come across it. That's all I can tell you. So don't ask me for any tricks, because I would try to give you the tricks if I knew what they were. There aren't any. Okay? Don't come up and say, do I need to know this? Okay? Basically, I'll just say it right now. Yes. Okay? Okay, that's the answer. So don't ask me. Okay, because then other people that want to ask questions never get a chance to, because they're busy wondering about whether that's going to be asked. I didn't write the questions on the boards. Okay, so I don't know. All I know is what you tell me was on your exam, and they're in your high yields. Okay, and then I put them in the notes. And I put them in notes. So I can tell you. I can tell you that they work, because I have a pretty good track record. Okay, so that's all I can say. So let's move on. I'll have to get to make this a little brighter when I get back home. But you have this slide on B12 and folate. And so we're on macrocytic anemias now. This is very important. This is really biochemistry, okay? So I'm not going to go too crazy on it, just enough so that you can understand why B12 and folate are involved in DNA synthesis. That's the key you want to remember. If you're B12 and folate deficient, then what's going to happen is you're not going to be able to make DNA, specifically because you have a problem with making this TMP over here. Okay, what does that stand for? Deoxythymidine monophosphate. Can't make it. Okay? So if you can't make that, that means that you're not going to be able to mature that nucleus. Remember, immature nuclei don't have a whole lot of DNA in them. But as you make DNA, they become more mature, and the nucleus starts getting smaller and smaller and more condensed. Okay? So because of the fact that you cannot make the DNA, and you have this big old nucleus that never matures, that makes all the nucleated cells in your body big. That's why these are called megaloblastic anemias. A good pathologist has diagnosed B12 and folate deficiency in a cervical pap smear. When you're looking at the squamous cells, you say, God, hey, look at the size of those nuclei. They're huge. You call up and say, hey, what do you know about this lady? And you oftentimes can make a diagnosis of folate and or B12 deficiency. Guys, any cell that has a nucleus has DNA in it. Okay? And so any cell with a nucleus is big. So it's not just the hematopoietic cells that are huge. All the nucleated cells in the body are huge. GI, squamous cells, all of them, because they all have DNA. Okay? All right. Now, another name, by the way, for B12 is cobalamin. Sometimes we use that term rather than vitamin B12. And the reason why they do that is cobalamin, B12 has cobalt in it. And so they use the term cobalamin. That's another name for B12. Okay? So that's what this CDL is over here. Okay, now, the circulating form of folate is called methyl tetrahydrofolate. Tetra means 4. Okay, that's what this is up here. This is circulating folate. The purpose of cobalamin is to take the methyl group off of methyl tetrahydrofolate. It's kind of a menial task of B12, and that's why it gets so irritated with it. But it takes the methyl group off methyl tetrahydrofolate. Okay, so here we go. Took it off. Now it's called methylcobalamin. And now, methyl tetrahydrofolate is now called tetrahydrofolate. All right. We don't get the methyl group off of folate, we're not going to make DNA. It's basically that simple. So if you're B12 deficient, you can't get the methyl group off, you ain't going to make DNA. You're deficient in folate, you ain't going to make DNA. You need both of them because cobalamin has to take the methyl group off. All right. It's like rugby, you know, lateral passes. Okay, British play rugby, we play football. They call that football, we call it rugby here. Okay, and so cobalamin gives the methyl group and it adds it to homocysteine. When you add a methyl group to homocysteine, it becomes methionine. Now, some of you know, because you've been close to biochemistry, that methionine is the amino acid that you want to have for one carbon transfer reactions. So if you say, I need a carbon, and you say, get methionine to come, because it gives you a carbon. Remember, methyl is CH3. It's a carbon. And so methionine, you're going to find out in your biochemistry lectures, carries one extra carbon with it that it will give to biochemical reactions that need an extra carbon. Okay, that's going to be very important in biochemistry, as you will find. But even more important than that, I'm going to ask you a question. If you're B12 or folate deficient, I want you to tell me what the serum homocysteine level is going to be. It's going to be high, guys. Now, everyone in this room should know what the meaning of a high serum homocysteine level is, because that's big-time news. Public radio has it. They always talk about homocysteine. Homocysteine. What's the big deal about homocysteine? It produces thromboses, including myocardial infarctions. Homocysteine damages endothelial cells, predisposing them to thrombosis, which includes myocardial infarctions. So the natural question is, what's the most common cause of an increase in homocysteine? Do you think it would honestly be homocystinuria, a rare autosomal recessive genetic disease? I sincerely doubt it. What do you think it is? Well, the answer is either going to be B12 deficiency or folate deficiency. Which of the two is more common? Folate. So what's the most common cause of an elevated plasma or serum homocysteine level in the United States? Folate deficiency. Having said that, am I also saying that people with B12 and folate deficiency have an increase in incidence of thrombosis and myocardial infarction? Yes. Yes. That's why in big centers, not usually in small community hospitals, cardiologists order serum homocysteine levels. But usually the general internists and stuff like that usually don't do that. But in bigger places, they do. And the most common cause of an elevated homocysteine level is folate deficiency. And I hope you can see why. Okay, if you're folate deficient, then you're not going to have a methyl to add the homocysteine to become, you're not going to have a methyl group over here. Okay, so homocysteine is going to be increased. If you have B12 deficiency, okay, you're not going to have a methyl group to make homocysteine methionine increase. So either way, you have folate or B12, it's increased. All right, now let's just follow. So we don't have to really go crazy about this thing. Tetrahydrofolate seems to be the start of this cycle. And we go around here, and we have a nice little reaction, and I'm sure Hansen will go through. And we've got this little compound over here, and we've got this thymidylate synthetase here. So we know this is where the DNA is made. It starts with this little substrate over here. We have this enzyme over here, and we convert this DUMP to DTP. That's DNA. So this is the substrate that's necessary to act upon to form your DNA. Okay, so when it is used in the making of DNA, it's called dihydrofolate. Now you already know. It's already starting, little bells are starting to go. Dihydrofolate. I remember that English guy that was teaching us in pharmacology. And he said something about an enzyme called dihydrofolate reductase, which converts the oxidized dihydrofolate back to tetrahydrofolate. And you learned that there were lots of drugs that block dihydrofolate reductase, didn't you? You learned that methotrexate did. You learned that trimethoprim sulfamethoxazole did. There's thousands of things that inhibit dihydrofolate reductase. Therefore, if they do that, then what's going to happen to DNA synthesis? Decrease, and what kind of anemia you're going to have? Macrocytic. There you go. Okay. So that's how it all comes together. So you need B12 and folate to make DNA. The function of B12 is to take the methyl group away from methyl tetrahydrofolate and hand it off to homocysteine to become a thionine. Okay? And then you have tetrahydrofolate that starts off the cycle for making DNA. And that's how it works. Okay? Now, B12 is humiliated by having to just transfer methyl groups. And so it said, we only have something different to do that's important. Well, and then so whoever he asked this thing to said, that's an odd request. It's an odd request? Yeah, yeah, because we really do need you for something. Like what? Well, it turns out that we can take care of even-chained fatty acids and metabolize them with no problem. In other words, those that have 2, 4, 6, 8, the even chain. But we're having a problem with the odd-chain fatty acids because we only can break them down at the propionyl-CoA. That's it. And we can't go any further, and we're ending up with a lot of people with dementia and all that stuff. Can you help us in odd-chain fatty acid metabolism? So B12 actually is impressed with this. I mean, if I don't want to volunteer for this thing, that people are going to be demented and have some kinds of problems with, propionate chain and all. Oh, yes, it's very important. Very important. Would you do it? Sure. And so it's involved in propionate metabolism, which is odd-chain fatty acid metabolism. And here it is. Here's propionate. Remember, you always acetylate them. And then that forms methylmalonyl-CoA. And here's where our little friend comes in. And now B12 comes in right over here in the conversion of methylmalonyl-CoA into succinyl-CoA. And I have to put it in there. It should be right there. And then, of course, succinyl-CoA is in the TCA cycle. Cool. So it helps convert methylmalonyl-CoA into succinyl-CoA. That's what B12 is. It's a cofactor for that particular enzyme right over there. Okay? Can you see then that if you're B12 deficient, there's a certain thing that will build up. Certainly methylmalonyl-CoA will build up, and certainly the propionates are going to build up. Is that correct? And methylmalonyl-CoA becomes methylmalonic acid, which, as you know, is a very, very sensitive and very specific test for B12 deficiency. It will increase. So whenever you have a situation where B12 levels are equivocal in the blood, always get a methylmalonic acid level because that will never fail you. It will always be increased. So the reason why you get neurologic problems in B12 deficiency, guys, is because you're of the propionate metabolism. If you don't have B12 here, then you can't convert these odd-chain fatty acids into succinyl-CoA. And so they build up, and it screws up myelin. You can't synthesize myelin. And so what ends up happening is you end up with dementia, you end up with demyelination of the posterior columns and of the lateral cortical spinal tract. Okay? You do myelin stains on the spinal cord, you see no myelin in the posterior column, you see no myelin in the lateral cortical spinal tract. Gone because of this. And so because of dorsal or posterior column disease, you have problems with proprioception, you have problems with vibratory sensation, and you now go up the lateral cortical spinal tract, you have problems with upper motor neuron problems, spasticity, Babinski signs, and then patrol. Add insult to injury, you have dementia. All of these things are related to B12, not folate because it's not involved in propionate metabolism. And what they're going to hammer in your heads on boards, 1, 2, and 3, is they will always tell you that you can have B12 deficiency and you can correct the anemia with high doses of folate, but you can't correct the neurologic disease. So you must make a specific diagnosis. Otherwise, you could be led down a bad path here, and you think that you have a folate deficiency because you corrected the hematologic conditions and didn't, but you really had B12 deficiency. Okay. Now I'm going to give you an interesting concept that you may not have heard before. About a year ago, they were talking about patients with Alzheimer's disease, some of which improved a little bit with injection of vitamin B12. You want to know why they improved a little bit? Because they didn't have Alzheimer's disease. That's because of the dementia, that B12 deficiency. Have you heard anything else about that wonderful study since then? No. No. You see, here's the bad part. Mayo Clinic Proceedings made probably the best article on B12. You don't have to have anemia with B12 deficiency, but you can have the neurologic disease. Moral of the story, anyone in this room in working up a patient that has dementia that doesn't get a TSH, to rule out hypothyroidism, and doesn't get a B12 to rule out B12 deficiency, you're going to get yourself in big-time problems somewhere down the pike. Because those are reversible causes of dementia. Okay? That's the moral of that story. Very important that you understand that. Okay, I think that's enough on this. Let's discuss just the normal metabolism of B12. Remember, it's an animal product. So you cannot be a pure vegan and get B12. Okay, it's got to be an animal product. In fact, there was a specific question recently comparing a pure vegan to an ovo-lacto-vegetarian. Okay, you had to know what the difference was. Well, the answer is if you're an ovo-lacto-vegetarian, you're taking dairy products as an animal product, you would not have to be on B12 supplements. But if you're a pure vegan, which means that you purely take vegetable products and no dairy or meat products, you would require B12. So Boards is on to this, okay? Boards is on to this. Okay, so we have to eat meats or dairy products that have B12. The very first thing you do when you're chewing is it binds to R factor. R is in Robert factor in saliva. Now, the purpose of the R factor is to bind the B12 to protect it from getting destroyed by acid in your stomach. Probably most of you may have even heard of R factor. I didn't until I read the article in Mayo Clinic Proceedings, and then all of a sudden R factor started coming around. I know you're wondering about intrinsic factor, aren't you? You're saying, what about intrinsic factor? You sure he's not screwing that up? No, I'm not screwing it up. Okay? So the R factor protects the B12 from being destroyed. Intrinsic factors made by parietal cells. And I want you to tell me exactly where they're located. Are they pylorus antrum or body fundus? Body fundus. That's where parietal cells. Now, they have two things, don't they? Acid and intrinsic factor. All right. Intrinsic factor isn't destroyed by acid, so it doesn't need anything to protect it. So the B12 R factor complex goes into the duodenum, where there's intrinsic factor waiting for it. Okay, so now how are we going to get intrinsic factor to bind with B12? Well, we've got to cleave off the R factor. So that means we have to have a functioning pancreas to do that with enzymes that will cleave off the R factor. So now B12 can say, hello, intrinsic factor. Hello, B12. Bonk. Okay, they are complexed. Now what do? They take a long trip. Do they go to take a trip in the duodenum? No, that's iron country. When they hit the ligament of trites, which is the beginning of the jejunum, are they going to get hit there? No, because that's folate country. So they have to go all the way to the terminal ileum, where there are receptors for intrinsic factor, and that's where it gets reabsorbed. That's the same place you reabsorb bile salt, isn't it? That's the same place that Crohn's disease is, isn't it? So it's fair to say that if you have Crohn's disease, you have bile salt deficiency with concomitant malabsorption, and you also have B12 deficiency right off the bat. Yes or no? That's a board question. Okay. So that's how it works. Now, the most common cause of all this stuff is pernicious anemia, which is an autoimmune disease with destruction of the parietal cells. There's actual autoantibodies against parietal cell. There's even autoantibodies against intrinsic factor. And it destroys the parietal cell. Where did you say there was? Body and fundus. Do you think it just knocks those off like Dirty Harry? Or do you think that there's an autoimmune response and destroys them? Everyone around them also gets knocked off. What do you think it is? Is it a Sylvester Stallone, Arnold Schwarzenegger thing? Or do you think it's a Dirty Harry? Just knock off the parietal cell and just suddenly disappear. What do you think? Everything gets destroyed. And so you end up with an atrophic gastritis of the body and fundus. No parietal cells, no acid. That's called achlorhydria. No intrinsic factor. Ooh. I spit on him. I got over here. He saw it. He was listening to me attentively, and all of them. Don't worry, it's sterile. I got a vasectomy. Everything's sterile. Okay. I'll stay over here. Okay. That's the danger of sitting in the front row. By the way, anyone that wears glasses usually has to clean them at the end of the day. There's little specks on them. They say, why did I get my glasses on? It's spit. It's spit. Okay? It's spit. I'll just tell you the truth. It's spit. All right. Whatever. Okay. Where were we? It destroys everything there. And so you have an atrophic gastritis of the body and fundus. You have no acid, and what would that predispose to? Cancer. Achlorhydria is a major predisposing cause for gastric adenocarcinoma. So we see that as a potential complication, too. Okay? Now, what else? Well, you could be a pure vegan and develop B12 deficiency. Okay? What else? Oh, you can have chronic pancreatitis. Who do you see that commonly in? Alcoholics. Why would that produce B12 deficiency? Can't cleave off the R factor. That could be another cause of B12. I have a giant worm called a fish tapeworm called Diphyllobothrum lutum. Okay, I can just see it with its mouth open like this. And those B12 intrinsic factor complex going, get a life, worm. I mean, there's other things to eat. Okay? So we got that one. And that's common on the exam because someone on the board clearly has had that tapeworm. Because that would have to be the rarest of them all. You'll always see that stupid question on there. And probably someone from Chicago because it's the lake trout in those lakes up there that carry that worm. So some Chicago pathologist always put this on the test. And he probably has this tapeworm. Okay? Also, you can have bacterial overgrowth. That means that you have some peristalsis problem there in that small intestine. Maybe you have diverticular pouches there and stasis. Whenever there's stasis, guys, you get bacterial infection. That's true of urine, too. You know, if you have a bladder, you know, that doesn't peristalse, you're going to get infection. You've got a small intestine that doesn't peristalse, normally it doesn't have bacteria. It will after a little while. And so bacterial overgrowth. Bacteria love B12 intrinsic factor. They use it for dessert. And they like salt on their food, too. So they also have bile salt deficiency. They eat bile salts, and they eat B12 intrinsic factor when you have bacterial overgrowth. And then, of course, you can have terminal ileal disease, and that equates with Crohn's disease. All of these things can produce B12 deficiency. Are we with me? Now, how was I able to do all that stuff? Because I know the normal. I know how everything works. Therefore, it's very simple to actually think about causes of each of these things. You don't know the normal, you'll never understand the abnormal. I'm trying to prove that to you all the way through all these lectures. We always go over the normal first, and then we screw it up. Okay? So if you don't know the normal, you'll never understand B12 deficiency. Okay, let's go to folate. Folate's a little interesting. Folate's seen in animal and plant products, so you don't get this from being a pure veg. In fact, pure vegan's got piles of folate. Now, here's a couple interesting things about folate, because folate's where all the pharmacology tie-ins are. Okay, so you really want to listen to this. You already heard one of them, dihydrofolate reductase. There's two more. Folate, when you eat it, is in a polyglutamate form, okay, which means you can't reabsorb it in the jejunum. So it has to be converted into a monoglutamate form, and there is an enzyme in your small intestine called intestinal conjugase, which does that. There is also a drug that blocks intestinal conjugase so that you can't do that. That's called phenytoin. And so if they ask you about someone that's on phenytoin and ends up with a macrocytic anemia with hypersegmented neutrophils, neurologic examination is normal, that just excluded B12, and they ask you what drug is the patient on, the answer is phenytoin. Okay? That's its mechanism, blocks intestinal conjugase. Okay, let's say you have monoglutamate. You're going to absorb folate in the jejunum. There's two things that prevent the absorption of monoglutamate form from the jejunum. One is birth control pill. Two is alcohol. See, that's the main reason why alcoholics, the most common cause of folate deficiency is alcoholism. It actually blocks the reabsorption of folate. Now, the other reason you probably already know is that B12, you got 6 to 9 years supplying your liver, so that's very uncommon to get deficiency from that. But folate only has 3 to 4 months. And so most of you thought that, well, you only see folate deficiency in these street people that, really just drink all the time and don't eat and all that. Baloney. You can have an excellent diet, you're still not able to reabsorb folate because alcohol blocks the reabsorption of folate. Woo! Okay? All right. So, that's folate. Remember we said that the circulating form then of folate, when you do reabsorb it, is methyl tetrahydrofolate. And who takes the methyl group off? B12. And who does it give it to? Homocysteine, which becomes methionine. Very good. What happens to the methyl tetrahydrofolate? What does it become? Tetrahydrofolate, and you can just see it. Just picture it in your head. Just picture that coming around the bend, and there's this thing down there, which we don't have to name, and there's DNA down there. Dihydrofolate, dihydrofolate reductase, back to tetrahydrofolate. Okay? So those are the key things related to folate. Okay, now in terms of hematology, this picture right here is the one that they usually select for boards. How do I know that? That guy that I said that took the exam, the first exam, I showed him the hour rod. He said, that was the exact cell. I already showed you that. Then I showed him this. I said, was this the one? He said, that's the exact one. This is the one they use. Okay? So how do you know it's hypersegmented? Because I said so. No. You know because it has more than 5 lobes. Okay, so let's count. Okay. uno, 2-0, 3-0, 4-0, 5-0. Notice that exceptional Spanish. Okay, so what are we up to? 5-0, right? 6-0, 7-0, 8-0. Okay. You mean that's not Spanish? I got the right accent, don't I? See, most Americans think that all you got to do is use the accent and speak English, and you're speaking a foreign language. I did that in Italy. Do you understand me? Okay? My wife's watching me do this. Okay? And so this guy was a smart aleck Italian. He says, Noah Ayadonta. This is so cool. The guy was very sharp. Very sharp. I actually did that. My wife kicked me in the butt. She says, you idiot. What you're doing is using the accent, and you're just speaking English, you jerk. No, whatever. All right. So this is a hypersegmented neutrophil. Guys, this is so important, this stupid cell, because it means you either have B12 or folate deficiency, even if you don't have anemia. It's the very first thing that comes up even before you have anemia. It's important. It just doesn't suddenly arise there and mean nothing. And if the neurologic exam is normal, then you know it's folate in terms of board purposes. If it's an abnormal neurological, it's B12. Now the test for proprioception is the Romberg test, okay, which most of you think is a cerebellar test. Okay. Now Romberg test you do with the patient standing like there with the hands either this way or out there, right? Okay, you say close your eyes, open them. Okay, so that's a negative Romberg test. Okay, I was able to keep myself. But if you have posterior column disease, you're okay here. Say close your eyes, open them, close them, open them. Okay? That's a problem with proprioception. Why? Because when I closed my eyes, I didn't know where my joints were. I'm not talking marijuana either. I'm talking about these joints, these joints, these joints. Okay? They're not swaying around looking for their joints. Okay? It's because they don't know where they are. When your eyes open, then you have other things that can tell you where you are. You understand this? Now, this is what a person with cerebellar disease would be. Stand still. Close your eyes. Open them. I mean, how could that be a cerebellar test? I mean, really. Good Lord in heaven. I can't tell you how many students think that a Romberg test is for cerebellar ataxia. That means whether their eyes are open or closed, they're all over the place. Good Lord in heaven. Okay. Remember, when you get that tuning fork and you're fiddling around with the head, you know, like that, checking for Renee's and the Weber test, why don't you move it down to the lateral malleolus, too, and see if they have vibratory sensation. You can pick up B12 and the B12 deficiency just like that, absent vibratory sensation. Those are all posterior column things, guys. Okay, so these are the key cells. Look at the size of these suckers. This is a bone marrow. Look at the size of that nucleus. That's because it never matured. That's why it's called megaloblastic. Now, guys, hematopoietic cells are made outside the sinusoids in the bone marrow. It is analogous to the quartz of Billroth in the spleen. Quartz of Billroth in the spleen is basically a place where there are fixed macrophages. And then the RBCs and white blood cells have to get back into the sinusoids in the circulation through these holes. Okay? They get through, and now they're in sinusoid. The same thing happens in the bone marrow. Okay? They have a place which would be equivalent to the quartz of Billroth, and that's where they're made. And then to get into the circulation, they have to fit through these little narrow, couple microns there, wide holes to get into the sinusoids in the bone marrow to get into the bloodstream. I suggest to you, could something that big get through those small slits and get back into the sinusoids? Yes or no? No. So you can picture a big feast of all these macrophages with all these big megaloblastic cells, piles of them, that can't get into the sinusoids. That's white blood cells, that's red blood cells, that's even platelets. Can't get out. Okay, and the macrophages just kill them, knock all of them off, and just massive carnage. I mean, this is clearly Arnold Schwarzenegger kind of stuff. You have, I mean, blood going all over the place. Probably the macrophages just take a bite out of each thing. Let's go bump, 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 and they just die. Okay, screaming and yelling and all that kind of stuff is going on in there. So what do you see in the peripheral blood? Nothing. Pancytopenia. Severe macrocytic anemia, neutropenia, thrombocytopenia. These are characteristic findings of B12 and folate deficiency. Everything's too big in that marrow. Can't get out into the circulation. Schilling's test, and then we're done with the macrocytic anemias. Shillings, I would have put money on, was British. Shillings, they use that for money. So it has to be British. Turns out it's American. It was amazing. I almost fell over when I found out that shillings was American. Okay, now, it's a fantastic test for localizing B12 deficiency. So you already documented this B12 deficiency. You want to know why. What's the cause of it? Okay? Here's how the test works, guys. The first thing is you know they have B12 deficiency, so you give them radioactive B12 by mouth. They swallow it. You collect the urine for 24 hours and see if any of it comes out in the urine. Okay? Nothing came out. So now you prove they're having a problem with reabsorbing B12. Okay? So you just kind of quality controlled it. So there's a problem. Now let's see if we can figure it out. Now I'm going to give you what we're going to do, and you're going to tell me what the problem is. Are you ready? The first step is to give radioactive B12 and intrinsic factor together. Okay? Collect the urine for 24 hours. All of a sudden, piles of B12 is in the urine now. What's the disease? Pernicious anemia. Because you added what there was missing, intrinsic factor. Let's say it didn't work. What did you exclude? Pernicious anemia. So we've got to do the next step. The next step is give them 10 days worth of broad spectrum antibiotic. Come back in 10 days, you just give them radioactive B12. Piles of radioactive B12 come out in the urine. What's the diagnosis? Bacterial overgrowth, because you knocked off all those bugs that were eating the B12. Okay, that didn't work. Okay, and we got one thing left in your armamentarium: pancreatic extract. So you get these couple pills, which is pancreatic extract. Okay, you swallow it. Okay, then you give them radioactive B12 and see what happens. 24 hours later, radioactivity all over the place. What did you diagnose? Chronic pancreatitis. If that didn't work, then it's one of the other things. Could be Crohn's disease, could be a worm that's eating it, something like that. It's a very simple test. It's commonly asked on boards because it requires you to think. So B12 absorption is corrected by adding intrinsic factor, pernicious anemia. Corrected by adding an antibiotic, bacterial overgrowth. Corrected by adding pancreatic extract, chronic pancreatitis. That's the way you do the test. And that is the end of those. Normocytic anemias. Okay. Now we're going to first deal with those normocytic anemias where when you do the corrections, okay, correction for the anemia, it turns out on if there's polychromasia, you correct it, the correction is less than 2%. So you say, that's good. Normocytic anemia and the bone marrow ain't responding correctly. Now, the first two things that you see here is early iron deficiency and anemia chronic disease. And I want you to think of why that's true. Remember I told you that you have to have a normocytic anemia first before you become microcytic. You just don't overnight go into microcytic. So you still have to have in your differential diagnosis of a normocytic anemia with a decrease, with a corrective acidic count less than 2%. You still have to get a ferritin. That's totally legitimate. In fact, here's how it works in iron deficiency. It goes through these different stages. Let me tell you that the very first thing that happens is that your ferritin levels go down. Then the next thing, iron decrease, TIBC increase, percent fat decrease. You still don't have anemia, guys. So in other words, all the iron studies are abnormal before you even had any anemia in iron deficiency. Then you get a mild normocytic anemia, and then eventually microcytic anemia. Okay? All right. So you still have to do those. All right? Now, why do I say blood loss less than a week? Well, that produces normocytic anemia. Okay? Why would you not have an increase in the reticulocyte response? There's nothing wrong with the bone marrow, you just lost blood. Not enough time. And I said you need 5 to 7 days to start getting revved up. Okay, so you could have blood loss as a cause of the normocytic anemia if it's under a week. After 1 week, you would get an appropriate response. Okay? Other things, aplastic anemia. What does that mean? It means you have no marrow. Of course, if that's true, what do you think you would have in the peripheral blood? If all the hematopoietic cells were destroyed in the marrow, what would you expect to see in terms of the peripheral blood? Pancytopenia. You have normocytic anemia, thrombocytopenia, neutropenia. Everything's decreased. You've got to do bone marrow. Got to do bone marrow. Kind of look like this. Okay, that's a normal marrow. That's a marrow that's aplastic. You don't see anything. That's the spicules there. The rest of this is just plain old fat. Okay, this is a normal. That's aplastic anemia. Okay? Very common, very easy diagnosis to make. In terms of causes of this, most cases they can't figure out. Whenever they can't figure out something, you know what word they always use? Idiopathic, don't they? Okay. You should probably have a P in it, idiopathic, because most of the time they just haven't had a real good history, especially here in this country. Okay, you learn, and a lot of times in your country, especially if it's British thing, you learn the importance of a history and physical exam. In this country, it's not pushed that much. Everything's lab. Of course, the British think we're a bunch of idiots, and they're probably right, because of the fact that, look at those Americans over there, they always get laboratory. We could just look at the patient and make a diagnosis. Okay. So they stand there in the room looking at the patient's looking at them. Yeah, that's the way it is. You look at the patient, you make the diagnosis. You go there and you go right to the bed. What do? They hit you over the head with a 2x4. You fail! Go back. You start all over again. Okay? Got to look at the patient first. The patient will tell you what they have. Okay? Look at them. All right. Okay. Get a light. All right. Okay. Then you got to do a thorough history and physical. Okay? Now what do you do? Laboratory. That's what the Americans do. What is the matter with you? You tell me what you expect to say. I expect this, and this. Good. Let's go. All right. That's the end of it. No laboratory. Okay. So you can take that to an extreme a little bit. Okay. All right. So that was cool. That was good. I never did that one before. And so you got to get a real good history. What drugs are you on? Drugs? I don't think drugs. Yeah. Okay. We're talking about prescriptions. Okay. And so you go through all of them because drugs would be the most common known cause of aplastic anemia. You learned a whole pile of these different drugs. Now, how many people are going to say, well, I'm taking chloramphenicol right now? I mean, how many people are going to be saying that? Nobody. Okay? So, chloramphenicol is the cause of aplastic anemia. It's retarded because, no one's on it. In fact, if they are on it, report the doctor to the society for getting him disbarred. I mean, you just don't use chloramphenicol, except in rare situations. Rocky Mountain spotted fever is one of them. It's a great drug for Rocky Mountain spotted fever. But whatever. Got to think of other things, okay? Like things like the indomethacin and some of those drugs, phenylbutazone, and things that are thyroid-related drugs. In other words, drugs, okay? And check out the PDR and see, if they can produce marrow depression. Okay, so always good drugs. Second, infections. And one of the biggest infections for aplastic anemia is hepatitis C. If you have purely an aplasia of red blood cells, and everything else is okay, it's just the red blood cells that are totally destroyed with virus. Parvovirus, very good. But when everything's destroyed, hepatitis C is the usual cause of that. Okay, and then of course radiation can do it. So drugs is the big thing, and then infection, hepatitis C, if it's just the red blood cells that are out, parvovirus, and then radiation would be the main causes of it. And that's it for aplastic anemia. I want you to tell me the mechanism of a normocytic anemia less than 2% corrected erythroid count in renal failure. What's the mechanism? Decreased erythropoietin. Do we have erythropoietin available to give to somebody? Sure. Okay, it's made by recombinant DNA, and it's revolutionized the treatment of anemia in chronic renal failure. So they no longer have to get blood to correct their anemia. So that's decreasing hepatitis B, C, and HIV. So it's a wonderful thing. Of course, if you don't have any in your hospital, just go to a professional cyclist, okay, who all taking it, who's using it as doping. Okay, that's when they say doping. The athletes are doping. What they're taking is erythropoietin to increase their amount of red blood cells to carry more oxygen so they can last longer. And that's what they're doing very commonly now in professional sports. That's it. Those are the normocytic anemias. Corrected erythroid count less than 2%. Early iron deficiency, anemia chronic disease, aplastic anemia, chronic renal failure, blood loss less than a week. Malignancy, another one. All right, now this is the more fun one. The normocytic anemias where the corrected erythroid count is greater than 3%. But before we do these, we have to go over mechanisms of hemolysis. Okay, and students get a little bit screwy on this thing, so we'll go a little slow on this. There's two ways that you can kill a red blood cell. You can kill it intravascularly. Now, intra means within the vessel. You can kill it. That's not too common. Or you can kill it extravascularly. What's extra mean? Outside of the vessel. Now, let's think about that one. That's one students don't get. What do you mean outside the vessel? How are you going to kill something outside a blood vessel? Macrophage. It means a macrophage killed the red blood cell. It took it out, so to speak. Ran in and take it out. Cortisol rock, usually in the spleen. Sometimes in the liver sinusoids, they have fixed macrophages, but mainly the cortisol rock. And every red blood cell has to take a couple trips a day through the cortisol rock and be examined in the dark by a macrophage. Can you just imagine going into this dark room and somebody is feeling all over your body? Okay, and you're just praying. You're just praying there's nothing on the surface, okay? You didn't pick up an IgG or C3b, because if you did, it would be something like this. That's it. Why is there no further sound? You've been phagocytosed and destroyed. Because the macrophage has receptors to IgG and C3b. You're dead. Okay, well, what if you don't have IgG and C3b? Well, you can still die. Why? Because you're in bad shape. I mean, you're out of shape? In a sense. You're a sphere. How's a sphere going to fit through a 2-micron hole to get into the sinusoids? It can't. And you can see it's trying. Bonk! Bonk! And you can just see the macrophage is smiling in the dark. You having trouble getting out? Yeah! How come it never finished the yes? It was phagocytosed and killed. Okay? So spherocytes are going to be removed extravascularly. They can't get out. Neither can a sickle cell. They're in a bad shape. They can't get out through the 2-micron slit. Okay, what else can take them out? They got something inside of them that wasn't removed. Like what? A piece of nucleus. That's called a Howell Jolly body. Well, a macrophage will try to get that out. Why? Because it's like a monkey. That's like insects for it. You know, it says, ooh, there's something inside of you. Let me pick it out. Okay? Sometimes they can take it out without killing the cell. Sometimes, you know, someone that's not paying attention can take too much membrane out and dies. So that's called extravascular hemolytic anemias. So in review, those anemias would be due to IgG or C3b on the surface. Those are autoimmune hemolytic anemias. Okay? Or you have an abnormal shape, like a sphere or a sickle cell. You ain't going to make it out of the spleen to get removed by macrophages. Extravascular. So that's the concept there. Now what's the end product of phagocytosing an RBC? Unconjugated bilirubin is the answer. Because when that RBC is broken down and you got hemoglobin, there's an enzyme in there that splits heme from globin, and the globin is broken up into amino acids, and it goes into the amino acid pool. And then it takes the heme thing, splits that open, gets the iron, and says, let's save this. Now I got protoporphyrin, and it keeps on breaking it down, and eventually ends up as bilirubin in the macrophage, in the spleen. And then that's spit out of the macrophage into the bloodstream. Remember, that's lipid-soluble, unconjugated bilirubin, binds to albumin, goes to the liver, and is taken up and conjugated. So, what clinical finding do you see in patients with extravascular hemolytic anemia? Jaundice. There you go. I'm going to ask you a simple question. Does any of that bilirubin get in the urine? No. 2 reasons why it isn't. 1, it's lipid-soluble. 2, it's bound to albumin. Albumin don't get in the urine. So you're jaundiced, but you don't have any of it in the urine. Now, intravascular is a less common type of a hemolytic anemia. That means you die within the vessel. Well, how do you do that? Well, you die within the vessel if you bang into something. That should be there. Like maybe, remember that congenital bicuspid aortic valve with all that calcium there? What if you banged into that on your way out through the aorta? You think maybe you would damage yourself, maybe be smashed into an oblivion and die intravascularly? Sure. Absolutely, you can get intravascular. What if you had IgM that was on the surface of your red blood cell, that red blood cell? Okay? What's that going to do? Remember I said that it's the most potent activator of the complement system? Is it going to stop at, is it going to go from 1 to 9, or is it going to stop at C3 like IgG does? It's going to go to 1 to 9, which means that it's going to sit on that red blood cell, activate the complement system, and it's going to be a hole made in that, and it dies intravascularly. So anything that's IgM mediated will be intravascular hemolysis. Okay? So that would be the kinds of things there. So what are you going to release into the bloodstream if you're killing the red blood cell intravascularly? Hemoglobin. Well, that's a valuable commodity in our bodies, guys, because we don't want to lose hemoglobin in our urine. We're going to lose some anyway. But we want to retrieve some of it back so we can get the amino acids out of it, and they certainly don't lose the iron. And so there's a specific protein that's made in the liver whose only function in life is kind of like the Maytag person who over there has nothing to do. Okay, this particular protein usually has nothing to do because there's not a whole lot of intravascular hemolysis going on. So it's just waiting around for something to do. Anybody know the name of the protein? Haptoglobin. Sometimes called the suicide protein, actually, because when there is intravascular hemolysis and there's all this hemoglobin, it binds to it and then forms a complex which is phagocytosed by a macrophage, and so it gives its life, in a sense, to retrieve the hemoglobin. And so then what happens to the haptoglobin levels in patients with intravascular hemolysis? They decrease. Is it possible to get jaundice with this? Yeah, but usually you don't, because if the macrophage is phagocytosing it, there is that potential for it because the hemoglobin is broken down, but usually not. And so the key thing for intravascular hemolysis is you get hemoglobinuria, and you have low haptoglobin levels. That's what marks that particular thing. Do you understand that so far? So what are the two mechanisms for hemolysis? Extravascular, intravascular. When I say extravascular, who removes them? Macrophage. What's the end product of that? Unconjugated bilirubin. What's the clinical manifestation? Jaundice, you got it. You have intravascular hemolysis, then what happens in the urine? What do you see? Hemoglobin. And what's decreased? Haptoglobin. Good. Got it. Those are the key things. Now, this is probably not as important, the concept of intrinsic versus extrinsic, so we'll just take our break and then we'll decide whether we're going to talk about that or not. Probably not. Okay, let's reaccumulate like pitting edema. Okay. I think I'll tell you what intrinsic versus extrinsic means. I'll just give you an example. My son had attention deficit syndrome, and it was hard to get his attention. Okay, so I would grab him and I'd say, Kate, there's something intrinsically wrong with you. What does that mean? There's something wrong with him. Okay, so when we talk about a hemolytic anemia that's intrinsic, there's something wrong with the red blood cell that's causing it to hemolyze. Like what? No spectrin in the cell membrane, or what else? No decay accelerating factor in the cell membrane to neutralize complement. What else? No G6PD enzyme in the pentose phosphate shunt. What else? Some abnormal hemoglobin, like hemoglobin S. So there's something intrinsically wrong with the red blood cell that causes it to hemolyze. Okay. Extrinsic means there's nothing wrong with the red blood cell, but it happened to be in the wrong place at the wrong time. It just happened to just smash into that calcified valve. There wasn't anything wrong with it until it hit that stupid valve. Okay? And so that would be extrinsic. It's extrinsic. There was nothing really wrong with the red blood cell. There it was minding its own business, and IgG and C3b sat on it. And since red blood cells don't have arms, I mean, they can't get it and take it off. Okay? And so there it was minding its own business, and then these suckers came on it, and then it's just dreading going to the course of Bilrock because it knows what's going to happen to it. It says, I know it's IgG. I know it's C3b. I am a goner. Okay? And so it just goes into that abyss, and it never comes out again. Isn't it sad? I get tears every time I tell this story about the fear that this poor little the red blood cell must go through. I mean, I get that because I'm getting senile and senescent red blood cells. I can just imagine, I can feel for them now, being older myself. Because, you know, when you get older, you get crotchety, and you can't really don't have the same flexibility. And so that poor red blood cell, when it's 120 days old, and it gets into the course of Bilrock, by that time it knows the names of all the macrophages. You know, hi Joe, hi Sam, hi Sally, you know. By that time, they know it, you know, and then it says, okay, you're clean on the outside and all that. So let's see if we can get to that little 2 microns. Say, oh, okay, let me do it. You having a little trouble? Are you having a little trouble, Joe? Kind of. Let me try again. Okay. I can't get out. I can't. Okay, why couldn't it finish the sentence? Who's phagocytosed? All right. You're starting to catch on. All right. So now let's look at these. Let's deal with something intrinsically wrong with the red blood cell, causing it to hemolyze. There's nothing wrong with the bone marrow, but there's something intrinsically wrong with the red blood cell. So the corrected reticulocyte count is greater than 3%. After we correct for everything, it's still greater than 3%. I have a mnemonic, MAD, M-A-D. If you like damn, you can use that too, but I like MAD better. M-A-D. Membrane defect, 2 examples, spherocytosis, paroxysmal nocturnal hemoglobinuria. A, abnormal hemoglobin, sickle cell trait disease. D, deficient enzyme, G6PD deficiency. Those are the most common ones in that group. Okay. Okay? So let's just deal with these real quick. Now, do you see anything abnormal about this red blood cell? Look at that one, that one, that one, that one, that one. What don't you see? Central area of pallor. Therefore, what must it be? A serocyte. Okay. How will it be removed? Come on, all that stuff with all that fun and all that extravascularly. Can't get out of the spleen. So how do these patients manifest themselves clinically? Jaundice. What's the main type of bilirubin? Unconjugated. You got it. Okay. Now, what's the defect? Spectrin. What's the genetics? Autosomal dominant disease. Okay? Now, because the spleen is the one that's removing these cells, it gets a little bit hypertrophied after a while, so splenomegaly is always seen in these patients over a period of time. Also, would it surprise you that they get gallbladder disease quite commonly because they do have a lot more unconjugated bilirubin presented to the liver, so there's a lot more conjugation occurring, and there's a lot more bilirubin in the bile than usual. And whenever you supersaturate anything that's a liquid, you run the risk of forming a stone. You supersaturate urine with calcium, okay, you're going to run the risk of getting a calcium stone. You supersaturate bile with cholesterol, you're going to get cholesterol stone. You supersaturate it with bilirubin, you're going to get a calcium bilirubinate stone. And so these patients commonly have gallbladder disease at a very early age related to gallstone disease, and then all of a sudden they do a CBC and they see they have a normal cytic anemia with a corrected retic count that's elevated, and they look at the smear and says, oh my goodness gracious, this patient has congenital sericitosis. So what's the diagnostic test for this? Osmotic fragility. They put these poor little red blood cells at a wall-to-wall membrane. Remember, they have two little membranes. And they put them into these test tubes with different tonicities of saline, and they don't last normal saline. I think you put them into that, they go beep, okay, because as soon as they get any sodium in them, they have no room for anything else. They just pop. So that increased osmotic fragility. Treatment, splenectomy. Got to remove the thing that's removing them. Now that's not going to make this become a biconcave disc, but at least there's nothing around that can knock it off anymore. That's it. That's congenital sericitosis. I have no slide for paroxysmal nocturnal hemoglobinuria, usually not on exams, but just in case, it's a defect in decay accelerating factors. See, while you were sleeping last night, while I was sleeping last night, we had a little bit of mild respiratory acidosis. We don't breathe as fast when we sleep as we do now. Of course, if you have obstructive sleep apnea, you really have a problem with respiratory acidosis. But at any rate, when you have acidosis, that predisposes to complement coming and sitting on your cells that are circulating in your bloodstream. That's all of them. RBCs, platelets, white blood cells, all will have complement sitting on it. Now, so how come we don't get complement destruction of our RBCs, neutrophils, and platelets every night when we sleep? The answer, in our membranes, we have a decay accelerating factor, which causes increased degradation of that complement so it doesn't have an opportunity of drilling a hole in our membrane. And so we don't wake up in the morning with hemoglobinuria and neutropenia and thrombocytopenia, thank God. Okay. So if you are missing decay accelerating factor, then complement is activated. It goes from 1 to 9. And if that's true, then what type of hemolysis is it? Is that intravascular or extravascular? Intravascular. It's called paroxysmal, just think of the term, nocturnal hemoglobinuria. It's occurring at night, and you wake up in the morning, and what do you pee out? Hemoglobin. Okay? And so when they do a CBC on you, you not only have a severe anemia, which is normocytic, okay, you also have neutropenia and thrombocytopenia, pancytopenia with disease. It's a very bad disease, paroxysmal nocturnal hemoglobinuria. Now, you all should know what this is. That's a sickle cell. Okay, it looks like a sickle, smells like a sickle, tastes like a sickle, it's a sickle. Okay. Now, I'm going to ask you, first of all, an easy question. Could this be sickle cell trait? No. In sickle cell trait, you have no anemia, no sickle cells in the peripheral blood. Now, you could have sickle cells in a certain part of your body. Where would that be? The renal medulla and the peritubular capillaries, but you ain't going to see them in your peripheral blood. All right. Now, the reason why that is, in sickle cell anemia, sickle cell disease, the amount of sickle hemoglobin in your red blood cell determines whether it's sickles or not. The magic number is 60%. If you have 60% or more hemoglobin S in your red blood cell, then it can spontaneously sickle. Okay, so that's the key thing. Another thing that determines whether it can sickle is the oxygen tension in your blood. If you lower the oxygen tension, let's say the hypoxemia or something, that can induce sickling. Okay, so that can do it also as well. All right. Now, remember, it's an autosomal recessive disease. So you've had Have you had a little bit of genetics? I guess that's going to be with Reichenbach on Monday. Yeah, on Saturday. Okay, he's good, by the way. He's really good. Nice, slow, methodical, good flight. Okay. So what is autosomal recessive? Now, what does that mean? It means that both parents have to have the abnormal gene on their chromosome. Usually they're both traits. So you can't have a person that's normal and a person with trait or a person with disease. You have to have the other partner has to also have the abnormal gene, as you'll find out. So it's usually two traits, and they either know or they don't know that they have the disease. Okay, the trait. And so you have about 25% chance of a totally normal child. You got a 50% chance of a sickle cell trait, and you got a 25% chance of sickle cell disease when you have an autosomal recessive inheritance pattern. We have two asymptomatic carriers together. Same thing is true for cystic fibrosis. Asymptomatic carrier male, asymptomatic carrier female, 25% chance no cystic fibrosis, 50% chance an asymptomatic carrier of it, a 25% chance for having the actual cystic fibrosis, because you have to be homozygous for that abnormal gene. Okay, now that's going into genetics. All right. Now, let's talk about some of the key characteristics of sickle cell trait and sickle cell disease. Remember we said in a sickle cell trait, if you have a black individual that is totally normal on physical exam, has a totally normal CBC, but has microscopic hematuria in their urine, what's your first step in the workup? Sickle cell screen. Always get a sickle cell screen, because microscopic hematuria is always abnormal. You always have to work that up. But in the person that's a black individual where sickle cell is in 1 in 8 people, that's the first thing that you're going to be thinking about. Not a renal stone and not IgA glomerulonephritis. You're going to be thinking sickle cell trait more commonly. Okay? So that'll be your first step in working the patient up. Do a sickle cell screen. And if they have sickle cell trait, it'll be positive. Okay? That's all I want to say about trait. Let's just talk about disease. When we talk about sickle cell disease, there are two things that are happening. One, you have a hemolytic anemia, so you have an anemia to deal with, usually extravascular. Second, you have occlusion of small blood vessels by these sickle cells. Can you imagine these cells just piling up in a little capillary? It's like a log jam in Oregon or Washington, out there, when their loggers put the logs in the water, okay, and all of a sudden there's a jam, okay? Well, that's kind of like what sickle cell vaso-occlusive crises are like. You got all these sickle cells, and all of a sudden there's a jam. So that means it's going to be ischemia to whatever tissue it's supplying. And that produces pain. Ischemia always produces pain. And so they're usually painful crises. And it can be in any organ in the body, from lungs to liver to spleen to bone marrow. Unfortunately, when it begins in little children, it begins in the hands and feet with a so-called dactylitis. Okay? Those are examples of vaso-occlusive diseases. And so the two things we worry about with sickle cell disease are, one, the anemia, which can be oftentimes very severe and commonly requires a transfusion requirement, and secondly, vaso-occlusive disease, where the sickle cells are just blocking the circulation. And you can see over time that that's going to produce damage to those individual organs. Kidneys are going to get screwed up. The spleen is going to get eventually auto-infarcted, so it's about the size of your thumb. But understand this. You don't have autosplenectomy till probably the first decade. Maybe not first decade. I always screw that up. Maybe somewhere 18, 19, 20s when the spleen's about the size of your thumb. First 10 years of your life, you have splenomegaly. Splenomegaly because you have all those trapped cells in there, the red blood cells. So don't think that the spleen is completely auto-infarcted and has almost disappeared, right off the bat. No, it takes at least 18, 20 years before that dude is totally annihilated. But I'll tell you this, after 2 years, it's totally non-functional. So you might have a big spleen, but the sucker ain't working because it's just been so damaged. So how are you going to know when that happens? How are you going to know when the patient has a non-functioning spleen by 2 years of age? Let me show you the reason. I'll go back to that in a second. That's how you know. You're saying to yourself, is that just a speck on a slide? No. That is a piece of nucleus. That shouldn't be there. It's called a Howell Jolly Body. That's how you know the spleen ain't working in that little dude. Because if the spleen was working, a fixed macrophage in the cords of Burov would have pitted that out and removed it. When you start seeing these come up, there's only one of them here, in your peripheral blood, you know the spleen ain't working. And fortunately, actually, it's by 2 years of age when this happens. Why is that fortunate? Because that's the time you can get pneumovax. You see, when your spleen is non-functional, there is one infection that you are going to get, guaranteed, and that's strep pneumoniae sepsis. You are guaranteed. That's the most common cause of death in a little dude with sickle cell disease, is strep pneumoniae sepsis. And so they try to cover them with antibiotics, and they try to cover them, of course, with pneumovax, but you can't give pneumovax until 2 years of age. And that's just about the time when the spleen ain't working and you start seeing Howell jelly bodies present. Okay. So that's a concept that I want to get across, and they like Howell jelly bodies on examinations. I can't find the slide that they have, but I know that there's a slide. Just take this cell right over here with the Howell jelly body. Okay, put it together with this slide. So let's say that cell was right over here, the Howell jelly body, and this over here. I mean, that's one of the slides they have on the boards. So we'll have the sickle cells, and we'll have another red blood cell with a Howell jelly body in it. Okay, and they'll ask you about the what's going on in the spleen. The answer is it's totally dysfunctional. It doesn't work at all. Because if it was, the macrophages would have removed the Howell jelly body. Comprende? Got that one so far? Now, in terms of boards, for part one, they don't spend a whole lot of time on therapy. They don't spend a lot of time on things like pre-autism, some of those kinds of things. They spend most of their time on when do they first get their first sickle cell crisis. When does a poor little dude develop this? Where their poor hands are all swollen up, they're so painful, their feet are the same way. This is called dactylitis. Now, when is this going to occur? Right at birth in a sickle cell? No. And the reason for that is that hemoglobin F inhibits sickling. And as you know, newborns have 70-80% of their red blood cells normally have hemoglobin F. Okay? Now, in a sickle cell disease, it'd be something like this. 60 to 70% of their RBCs have hemoglobin F, and the other ones have hemoglobin S. Okay? But there's enough hemoglobin F to prevent sickling. It inhibits it. But then as those red blood cells get broken down and replaced, the hemoglobin F decreases and the hemoglobin S increases. By 6 to 9 months of age, it's a high enough concentration to induce sickling and their first vaso-occlusive crisis, which produces this, dactylitis. This exact picture is on board. Now, here's something really, really sad. Remember that slide I showed you of the hand with the epiphyses? That was his hand. So this was a kid with sickle cell disease with dactylitis, and they x-rayed the hand, and the reason why those bones look all washed out, they were all white, they were infarcted. Because what's happening is there's bone infarctions occurring from all the sickling in the bone marrow, and it's infarcting the bone. Okay, and that's why it hurts so much. And then they x-rayed this poor kid's hand, and lo and behold, the poor little kid had lead poisoning too. Had a double whammy, sickle cell disease and lead poisoning. Isn't that horrible? And it was this poor little kid that they took this picture on. Okay, so this is important. Dactylitis usually doesn't come until 6 to 9 months. Why? Because hemoglobin F inhibits sickling. That's the reason. Okay. The last important one that they usually ask on examination is the osteomyelitis. Okay? These patients are very, very susceptible to osteomyelitis, and not the usual Staph aureus cause, but usually salmonella. One reason for that is the dysfunctional spleen. You see, salmonella is destroyed by macrophages. It's not destroyed by other mechanisms. And because the spleen is totally dysfunctional, it can't filter out salmonella. And so that's why it is actually the more common cause of osteomyelitis. Actually, in Cecil's, in their little table, it's about 75% of the time it's salmonella species causing osteomyelitis and sickle cell disease. And then it goes, the next most common one is Staph aureus, and it keeps on going down. But salmonella is numero uno. That's commonly asked on exams. Okay? Let's see, anything else? Yes. What did our little friend with the English accent tell you about a drug that can be used in decreasing the incidence of vaso-occlusive crises? Hydroxyurea. And how did that work? It increased hemoglobin F synthesis. Of course, though, you have to take a chemotherapy agent, so that's not too cool. Okay? That's about it. There's a lot more on sickle cell disease, guys, but for part one, those are the key things that are tested. I did put the other things in the notes because I like my notes to also be used for part two, so I kept the other things in there too, but they're not the ones that they usually ask on part one. Remember, this is for second-year medical students who don't have any clinical experience yet, so they don't get into things like acute chest syndrome, they don't get into things like aplastic crises, they don't get into that stuff. That's more part two-ish. Part one is the kind of stuff that we just discussed. What's that called? Howell jelly body, all right. All right, now we're down to the D of the intrinsic defects, and this, of course, is G6PD deficiency. What's the genetics? Sex-linked recessive. Anybody know? You all know that most enzyme deficiency conditions are recessive. Isn't that correct? So when you're talking about inborn errors in metabolism like PKU, albinism, homocystinuria, the majority of those are autosomal recessive. Isn't that correct? Okay. So that means you got a 1 in 4 chance with 2 asymptomatic carriers having a kid with the disease, correct? But remember, sex-linked recessive is recessive too. Okay? Could you name for me, please, 2 sex-linked recessive enzyme deficiencies? Well, this one's one, G6PD, and the other one involves purine metabolism, Lesch-Nyhan syndrome. There you go. And Dr. Hansen, I know, will cover that beautifully. Lesch-Nyhan syndrome is on every single exam. Why? Because it's a classic correlation of a disease with a biochemical pathway, purine metabolism, big time. Remember, those are the kids that are mentally retarded, self-mutilation, the whole bit. An increase in uric acid, and HGPRT is deficient. Don't ask me what that stands for. It's something big. It's something very, very big and long. Okay, so we don't have to worry about that one. Just like PPRP, and that thing. Forget it. Okay, it's a very, very long name which I don't know, but you'd be able to figure it out if you saw it, because it'd be this long across the computer screen. And you'd be able to figure out there's a P, there's an R, and okay, this is what it is. Okay. I know the first H stands for hypoxanthine, and the rest, screw it. I don't know. Now, this is very important, guys, and it'd be a good review for you here. Remember that there's a couple things you can do with glucose 6-phosphate, one of which is to make glutathione and also to make ribose 5-carbon sugars for making DNA. Isn't that correct? From this pathway. Also, you can make glycogen from glucose 6-phosphate, as you'll learn in biochemistry. This can be converted to glucose 1, UDP glucose, and glycogen. Or glucose 6-phosphate can be the substrate used for making glutathione and other substrates. Here's the key thing. Here's your enzyme, and you're going to have you're going to be able to make NADPH, which is the major factor for anabolic types of biochemical reactions in our body, like steroid synthesis and stuff like that. Okay, then we go to the next part of it. NADPH will reduce oxidized glutathione to our little friend glutathione. And what's its job? Is to neutralize peroxide into water. Anybody remember what the name of the vitamin was that catalyzed this reaction here? Riboflavin. Anybody remember the enzyme that helped glutathione neutralize peroxide? Glutathione peroxidase. And what was a trace metal that was involved in it? Selenium. That's very good. Okay. Every living cell, guys, makes peroxide as an end product. That's just a normal end product of normal metabolism. And that's why every living cell has to have some way of handling it. Now, you already know about the enzyme catalase. Catalase is present in all cells except RBCs, and that can neutralize peroxide. Remember, it's stored in peroxisomes. Okay? The other way that you can neutralize peroxide is with glutathione. That's the only thing available to red blood cells. They don't have catalase. And so if you're deficient in this enzyme, then you've got a problem. Because as this increases, why would that increase to a point where you start hemolyzing? Well, if you had an infection, it would be more of it. Or if you took a certain drug that was an oxidizing drug, like a sulfur drug or a nitro drug, you're going to get a lot more peroxide around. Not good. Because peroxide is not going to be able to be neutralized if you're deficient in that enzyme. And so what's going to happen is peroxide is going to really do a job on your hemoglobin. It's going to cause it to clump up, and we call those Heinz bodies. It's just a bunch of hemoglobin all clumped up together. And it's going to do a job on your red blood cell membrane. In fact, that's the real problem, because it damages the red blood cell membrane so much that the primary mechanism for destruction is intravascular. There's a little bit of element of extravascular, but it's mainly intravascular hemolysis, precipitated by infections and or precipitated by drugs. Now, let me tell you the 2 drugs that have been on that they're using alternately on examinations. The one that used to be the most famous one was Primaquine. And so it was always the medical missionary question, okay? And then they got malaria, and then they received a drug, they usually don't say Primaquine, and developed 2 or 3 days later hemoglobinuria, chills, and a hemolytic anemia, okay? And that was the Primaquine-induced hemolysis. Lately, they're using Dapsone. Dapsone is the one they're using. Of course, that's used in treating leprosy. So they're going to have to find some way to worm in Dapsone into the question and in terms of treating. In fact, I looked that up. Every person that's in a leprosarium, before they put them on Dapsone, they do a screen for G6PD because of the high incidence of producing hemolysis. So that's just a normal screening test they do on patients with leprosy that they're going to put on that zone because it's so high. Who do we see this disease in? Pretty much the same ones that we see with beta thal. That'll be the black population, the Greek, and the Italian population. So beta thal and G6PD deficiency are two things that kind of in the same groups of people. Let me show you what the Heinz bodies look like. Now this is what a smear looks like in someone that's actively hemolyzing their red blood cells. And you can see they look kind of ratty, okay, but you don't see anything bad. But you do a special stain on them, and this is what these cells really like. Look at that. Look at all these little clumps, blue clumps of it, all over the place. Notice some of them are right on the membrane. These are called Heinz bodies, okay? Now take this one over here. Okay, when this goes into the course of Dulac, the macrophage will see that big thing, and it'll take a big bite out of that membrane, okay? And sometimes it's just a small bite, and so that cell can get out into the peripheral blood with just a piece of its membrane missing, okay? Like something took a bite out of it, hence the term bite cells. Okay, bite cells. Take, for example, this red blood cell. I can see just a little bit of membrane here, but just make believe it wasn't there, and you have this cell that looks like a big bite was taken out of it. It's a very, very characteristic finding in the peripheral blood in G6PD deficiency, or bite cells. So you have to do special stains to identify these Heinz bodies. That's why another name for this is called Heinz body anemia. In patients that are Greeks or Italians that have a very severe form of G6PD deficiency, they can just eat fava beans and precipitate a hemolytic episode. Okay? And that's fava beans like in salads and stuff like that. But sometimes they call it favism. And that can precipitate it as well. Last thing on G6PD deficiency is diagnosis. Okay. When you have an acute hemolytic episode, guys, the last thing in the world that you want to do to make the diagnosis is to get an enzyme assay. Why? Because the only cells that are hemolyzed are the ones that are missing the enzymes. The ones that have the enzymes or have G6PD are still going to be there. So you'd have a normal assay. So you never use enzyme assays in active hemolysis. You do the stain, special stain to identify the Heinz bodies. When the hemolytic episode is over, that's when you confirm your diagnosis with a G6PD assay. On occasion, that question has been asked. And that's pretty much it for this. Okay? Almost guaranteed that you're going to get a G6PD deficiency question. I would literally say that probably 95% of you in this room will have a question on it. That's going to either be Dapsone-related or Primaquine-related. Okay, autoimmune hemolytic anemias. You had immunology, so you know that warm-reacting antibodies are IgG, and cold-reacting antibodies are IgM. Okay. Would it make sense to you that the most common autoimmune hemolytic anemia is warm, and the most common cause of it is lupus? Would that surprise you? Shouldn't, because it's a concept. When you have autoimmune disease in your family, guys, you have certain HLA types which predispose you to that autoimmune disease. So therefore, you should not be surprised if you had one autoimmune disease, you're likely to have another. Okay, so patients with lupus not only have lupus, but they commonly have autoimmune hemolytic anemia, autoimmune thrombocytopenia, autoimmune neutropenia, autoimmune lymphopenia. Patients that have Hashimoto's thyroiditis, the most common cause of hypothyroidism, very commonly have other endocrine diseases. Like what? Pernicious anemia, vitiligo, autoimmune destruction of melanocytes. So if you have one autoimmune disease, it's very likely that if you have some hematologic problem or something else, it's also autoimmune related because of the HLA relationship. In fact, one board question is, if you have a family that has an autoimmune disease, what would be the single best screening test to use? That's the question. The answer is HLA. Okay, find out if they have the HLA type that's specific for lupus or Hashimoto's. They have specific HLA relationships. That would be the best screen. That would be the best screen. Because not all autoimmune diseases have positive serum ANAs, anti-nuclear antibodies. Okay? So that would be HLA would be the best way of really testing everybody to see if they're predisposed to something. Okay? What I decided to do on this is to use the drug-induced autoimmune hemolytic anemias, which are always asked on boards. I don't know if Trevor did this with you, but it's very important that you get this down. So lupus would be the most common cause of autoimmune hemolytic anemia, and it's going to have IgG and C3b on the surface of the red blood cells. So how is that going to be removed, that cell? Macrophages. So that's an extravascular hemolytic anemia. Now, how are we going to know that there are IgG or C3b antibodies on the surface of those RBCs. What test? Coombs test. Direct Coombs or indirect Coombs? Direct Coombs. Direct Coombs detects directly the presence of IgG and or C3b on the surface of red blood cells. Indirect Coombs is what you women get when you're pregnant and you come into your first visit. They do an antibody screen on you to see if you have anti-D, anti-this, anti-that. So when you're looking for an antibody in serum, not on a red blood cell, in the serum, that's an indirect Coombs. So another name for it is an antibody screen. Direct Coombs is looking for IgG and or C3b on the surface of red blood cells. You can't do a direct Coombs on platelets. You can't do a direct Coombs on neutrophils, only on red blood cells. So the test of choice if you suspect an autoimmune hemolytic anemia is a Coombs test. Don't never forget that. All right. Now there's 3 types of drug-induced hemolytic anemia. That's the second most common cause of autoimmune hemolytic anemia. The most common is lupus. The first one's penicillin. Mechanism of penicillin, where is it? Let's see. Don't forget this thing, I don't need it. The mechanism of penicillin is this. Penicillin, when anybody takes it, the BPO group, that's called the penicilloyl group of penicillin, attaches to your red blood cells. And so if you're on penicillin right now, you have a little piece of penicillin attached to your red blood cell. Now you better pray that you don't develop an IgG antibody against that. Because if you did, then an IgG antibody would attach to that BPO group on the surface of your red blood cell, and when that sucker goes to the spleen, it's going to get removed extravascularly. So what type of hypersensitivity is that, please? 2. Here's a question. I was on board. Person's on penicillin, develops a rash. What type of hypersensitivity? 1. Person's on penicillin, develops a hemolytic anemia. What type of hypersensitivity? 2. That was a board question. Let's do the next one, methyldopa. Another name, Aldamet. Use, antihypertensive. One of those drugs that can be given to a pregnant woman with hypertension. Remember, there's only basically 2. That's hydralazine and methyldopa that can be used in pregnant women. And both have their complications. Methyldopa, as you know, can produce a hemolytic anemia. Hydralazine can precipitate drug-induced lupus. It's second to procainamide as a cause of drug-induced lupus. Okay. How does methyldopa work? Well, it's different than penicillin. That's why they love this question. Methyldopa screws around with your Rh antigens on the surface of your red blood cell and alters them. It screws them up so bad that you make antibodies against your own Rh antigens, IgG antibodies. So the drug is not sitting on your membrane. It just screws around with your Rh antigens, screws them up so bad that you form IgG antibodies against D and E and all of them. Okay? And those IgG antibodies attach to that red blood cell. Who removes it? Macrophages. What type of hypersensitivity? 2. So penicillin and methyldopa are both 2. The third one is the innocent bystander. That's immune complex. Classic drugs, quinidine. It's probably the classic drug for this one. What is happening is quinidine is acting as a hapten, and an IgM, not G, antibody attaches to the drug, forms an immune complex. So we have the drug and IgM attached together and circulating in your bloodstream. Now you already know that this is a different hypersensitivity. This is what? 3. And you even also know how it's going to die, because I said IgM. So what's IgM going to do when that immune complex sees a red blood cell down there and says, that's the one we want to destroy? And it comes down and sits on the top. What is IgM going to activate? The classical pathway, and you're going to stop at C3, you're going to go to C9. C9, so what type of hemolysis is that? Intravascular. So if that's true, what protein would be decreased? Haptoglobin. And what would be present in the urine? Hemoglobin. Very good. Guys, that is so important. You're going to get clearly one of those 3 or more than those, a question related to how they produce a hemolytic anemia. Guaranteed. Okay? Guaranteed. All right. This is how you guys are beginning to look right now. Okay? Some of you probably identify with some of these cells right now. Let's see. How many of you feel like a fish? Nobody. Okay. How many of you feel like, let's see, a tadpole? Nobody. Okay. How many of you feel like a German helmet? You know, you're on your motorcycle, Harley, and you got this little German helmet. Nobody. How many of you feel this totally nondescript as a piece of crap? Everybody. Okay. Now, what is this type of hemolytic anemia called? It's called a microangiopathic hemolytic anemia. And what are these RBCs that are all fragmented called? Schistocytes. Schisto means split. I'm saying schistocytes. Did you hear this? Schistocytes, not other sites. Okay? Schistocytes. Okay? And they produce these all weirdo forms. Okay? It's kind of looking at clouds and saying, that looks like this. Well, you can identify with these things. Now, these guys hit something. And it's sitting right next to it on the left. This is what it hit. And this happens to be the most common cause of this hemolytic anemia. And that is aortic stenosis. And these cells hit, when they were normal, they had hit this thing, they got totally destroyed like this, and so it's an intravascular hemolysis. The hemoglobin concentration goes down, half the globin is lost in the urine. Now, guys, let me tell you something. Is this a chronic intravascular hemolysis? Sure. Are you going to be losing a lot of hemoglobin in the urine? Yes. What does hemoglobin have attached to it? Iron. So what's another potential anemia you can get in these patients, guys? Iron deficiency anemia. Man, they like this question. It's this long on boards. Because they go through the murmur characteristics. They don't say aortic stenosis. They're going to describe the systolic ejection murmur, right second intercostal space, radiating into the carotids, has an S4 heart sound, increases in intensity on expiration, has a prominent PMI, and then they're going to say, and they have the following CBC findings, and that's this long. And you see, low MCV. Ooh. And then they say that fragmented, don't say schistocytes, it gives it away, a fragmented RBC present. And they say, what happened? The answer is that it's a microangiopathic hemolytic anemia related to aortic stenosis. I can't tell you how many times it's been on an exam. That's when they make this long. They get lots of physical diagnosis in that. Okay. So these are called schistocytes. Okay. Other causes, DIC. Disseminated intravascular coagulation and disease. You know, most of us think that RBCs are pretty strong, right? They are very, very fragile. And so just little fibrin strands and disseminated intravascular coagulation split them right in half. So you commonly see that in that. And when we talk about thrombotic thrombocytopenic purpura, we talk about hemolytic uremic syndrome, probably tomorrow. Okay, we're going to see schistocytes are involved in that too. Because if you have these little platelet plugs scattered throughout all the small blood vessels in your body, you're going to have a big-time problem in banging into these things. And you're going to have schistocytes and a microangiopathic hemolytic anemia, big time. Those of you that are long-distance runners, this is runner's anemia, okay? Because if you're doing long distance, you smash the living crap out of your red blood cells when you hit the pavement. And very commonly, because I've ran 3 marathons, very commonly you take a pee after you finish the marathon and you see hemoglobin in it. That happened to my buddy that ran the Boston Marathon. How do I know? Because I was standing next to him when he peed. And all guys always check what the other guy's doing. So I looked over there and said, Bob, check out the urine. And he had hemoglobinuria. There's the same idiot that didn't listen to the instructions at the beginning of the race. Because you're on this road that's even smaller than this is wide, and it goes back way back there. And you're stuck in there like this. And he said, make sure before you get in line to go to the bathroom, because it's going to take a long time before you even reach the starting line. Bob didn't listen. He did not listen. Okay. So we heard the gun go off. This is the time that Bill Rogers ran, as we can say that long ago. But they didn't put us in the front line. We were idiots. So we're at the back. And so I don't think I moved for 4 minutes. Okay, now you go like this. And they said, if your shoe comes off, don't pick it up. A couple people have been trampled to death. And so we're walking about like this when we hit the starting line. And then Bob's right next to me and says, I got to take a crap. I says, what are you telling me that for? What do you want me to do about it? He says, I really got to take a crap. I said, didn't they tell you to go to the bathroom? I didn't think it was going to be this bad. What am I going to do? Well, what do you think Bob did? He's a pathologist. They're very, very disgusting people. There's this poor sucker that's watering his sapling in the front of his house. Okay. He went, this is the true story. He ran over to this. He grabbed the sapling, he pulled his pants down, and cracked right there. He took the guy's hose, was staring at him incredulously, cleaned his butt off, picked the thing up, and finished the race. That was disgusting. And that's what he did. That's what he did. It was disgusting. He actually did that. This is a true story. So he deserved to get hemoglobinuria. He deserved it. That was terrible. I said, Bob, what did you do that for? He said, well, you got to crap. Oh, God. What an idiot. All right, this is a freebie, guys, because you've already had micro. Who can tell me what this is? It's malaria. Which type? Falciparum. Why? Well, first of all, it's only ring form. Secondly, you have superinfection. You got more than one ring form in there. 1, 2, 3. What's the other form that could potentially be in falciparum malaria? The comma-shaped things. Okay, so the gametocyte and the ring forms are the only thing out there. These produce a hemolytic anemia. Remember, the hemolytic anemia correlates, and the fever of malaria correlates when the cells rupture. That's when you get the fever spikes. Anybody remember the fever pattern? Quotidian. Okay, which means it can come up anytime versus the other types. Okay, so I thought I'd just throw falciparum. This exact picture's been on many, many, many boys. Okay, where are we? Here, okay, but we're 5 minutes away from a break. Warm white blood cells. That's pretty good. It's not too bad. And so I kind of have a conglomeration of different things up over here. So let's talk about some of the benign changes that occur with different types of cells. Now, we already know about neutrophils. We already know that when we have acute inflammation, especially related to things like appendicitis, etc., we get absolute neutrophilic leukocytosis, right? Left shift, toxic granulation. Okay, so we know that. But I want to introduce you to two more terms. Leukemoid reaction. Okay, what does oid mean? Sounds like but isn't. So what do they say? They're saying it looks like it's leukemia, but it isn't. It's something that's benign. Usually a leukemoid reaction can involve any of the cell lines. You can get leukemoid reactions in lymphocytes, neutrophils, eosinophils, and other cells. Okay? Now let's talk about neutrophils. What causes leukemoid reactions? Well, usually serious infections, things like TB, sepsis, and you get like greater than 30,000, greater than 50,000 cells in the peripheral blood. That's called leukemoid reaction. They like that. Okay, so it's a benign, or let's say over-exaggerated response to an infection. Let me tell you who really gets these things. Kids do. When kids get any kind of infection, otitis media, don't be surprised to see if you happen to get a CBC of 30,000 neutrophil count. Do not be surprised. Okay, now if it was an adult with otitis media, maybe they'd have 12,000. Kid, 30,000, because they get an exaggerated response. And there's a certain type of infection that scares the crap out of pediatricians. Okay. Unfortunately, not pathologists, but pediatricians. It scares them. And that is pertussis. If you have whooping cough, you get a rip-roaring lymphocytosis, big time. 60,000, not uncommon. So what do you think pediatricians go berserk? Why do they go so berserk with a 60,000 count, all of which are lymphocytes? What do you think they're worried about? Acute lymphoblastic leukemia. Except the problem is they don't have anemia and they don't have thrombocytopenia. But they literally come in pale. Saying, could you please look at this peripheral blood? I got this kid, he's coughing and all that stuff, and I think there's pertussis. I said, I've already seen it. Mature lymphocytes are totally mature, they're not atypical, there's no anemia, no thrombocytopenia, it's pertussis. Okay, so that's called a leukemoid reaction. Okay? So that's what I wanted to introduce you to, and that's about it on that. Okay, there's lots of lymphocytes. You can see these things. Remember, kids often with viral infections, they get a lymphocytosis, or with pertussis, they get a lymphocytosis. This is an atypical lymphocyte. I don't really like that term. Not that it matters. Who cares whether I like it or not? But basically, it's a lymphocyte that's doing what it's supposed to do when presented with antigen. It's responding to the antigen by dividing and getting bigger. So it's basically an antigenically stimulated lymphocyte. Now, I said atypical lymphocyte. What was the absolute first thing that went through your mind? Mono. Okay, but can I expand your knowledge a little bit? Okay? Mono isn't the only thing that can produce these large, beautiful, bluish staining cells. Cytomegalovirus can do it. Toxoplasmosis can do it. Any cause of hepatitis can do it, viral hepatitis. And there's a drug that can do it that we already talked about once. This drug produced a macrocytic anemia. Could you tell me what that drug was? It blocked intestinal conjugates. Phenytoin. Phenytoin produces an atypical lymphocytosis. So could you please expand your mind on atypical lymphocytes? Turns out that this is a patient that had infectious mono. What's that due to? Epstein-Barr virus. And it's usually transmitted by kissing, okay, because the virus holds up in your salivary glands. And it infects what cell? Don't say T, say B. And what's the receptor? CD21. Very good. Okay. Now you all know about mono. You know that you get a viremia, generalized painful lymphadenopathy, you get an exudative tonsillitis very commonly. And most of the time it isn't group A strep. Most of the time it's the virus itself that's producing that tonsillitis. They all have hepatitis but never have jaundice. I've never seen jaundice in mononucleosis. Never seen it. And the transaminases are off the map. I've seen 2,000, 3,000 SGPTs and, and increased SGOTs. They never goes into chronic disease, but they always have a hepatitis. Of course, they have a spleen that has a tendency for wanting to rupture. Usually not spontaneously, like they say. Usually some kid that's in high school that's got mono, you tell them, don't wrestle anymore, don't play football, and they don't listen to you, they get tackled, and they rupture their spleen, and they die, and they go after you and try to sue you. When you told them, don't do that. Okay, so you got to be very careful, especially with high school kids that are in sports when they have mono. You write it down in your stuff there, and you get that parent in there and say, do not let them for 6 to 8 weeks do any contact sport, because their spleen can rupture. Do we understand each other? Okay, and then usually the parents will get that and keep the kid from doing it, and you from getting a lawsuit. Okay, so let's break for 10. Okay, so I think we were left off with an atypical lymphocyte. Terrible term to be called. Isn't it terrible when you're doing what you're supposed to be doing and they call you atypical? I mean, you're reacting to the way you're supposed to and say, you know what, you're atypical. I said, no, I'm supposed to be doing this. I'm energetically stimulated. Still atypical. Okay. Now to get that Downey cell crap, okay, that's some jerk that's trying to get his name in print. Okay, so, don't worry about Downey cells and crap like that. I mean, good Lord in heaven. Okay, so they're big cells. They got lots of cytoplasm. They kind of look like they're just flying through the blood. Okay, many things can cause. Now let's talk about mono. Okay, we talked about the hepatitis that usually does not have jaundice with it, that it doesn't become chronic. We talked about the big spleen. You all know that stuff. Okay, so where can you get screwed up? They'll give you a classic history. You know it's mono, and they'll say, which of the following tests do you order? And you're looking for mono spot, and it ain't there. Why is that? That's because that's a trade name. And they don't use trade names on the exam. So what is it that a monospot is really trying to detect? Heterophile antibodies. Now let's break that word apart. What's hetero mean? Different. What's phile mean? Loving. Different, loving antibodies. What the heck does that mean? I know antibodies love each other. Okay, that's not what we're talking about. Now these are the heterophile antibodies in mono. Anti-horse antibodies. Anti-horse RBC antibodies. Is that weird? A human has anti-horse red blood cell antibodies. That don't make any sense. That's a different loving antibody. Also, how about anti-sheep red blood cell antibodies? I'm not a sheep. I don't go, I don't do that. How come I have antibodies? That's why they're called heterophile antibodies. Okay? Doesn't mean I have to be perverted to get these either, by the way. I know a lot of you were thinking about that. Okay? You don't have to be perverted. You just get these antibodies. Okay? So, those are what you're looking for in the monospot test. As a matter of fact, specifically anti-horse red blood cell antibodies is what you're looking for in the monospot because it's absolutely unique to mono. No other disease has those kinds of heterophile antibodies. And that's what they're looking for. So don't look for monospot. You ain't going to see it. Basically, you look for heterophile antibody tests, and that will be the answer to that. By the way, once you have mono, you always have it. You have the chance of developing recurrent disease any time in your life. Most of the time, most people have 3 or 4 recurrences in a lifetime. My daughter had it when she was a teenager. She's developed it. And every now and then she gets swollen glands, gets very tired, and it just comes back for a little bit. Okay, so you never lose Epstein-Barr virus. You always have it. And where does it live? In your B cells. Actually, these are T cells. The atypical lymphocytes in mono are T cells that are reacting against the infected B cells. Okay. That's it for mono. Okay. This is a monocyte. And remember, monocyte is the king of chronic inflammation. So we would expect monocytosis in patients that have chronic infections. Give me a couple examples. How about rheumatoid arthritis? Is that chronic? Sure. How about Crohn's disease, ulcerative colitis? Is that chronic? Sure. Monocytosis. How about lupus? An autoimmune disease. Is that chronic? Sure. So monocytosis is seen in chronic types of things. Malignancy, monocytosis. Okay. Now the fun part is the eosinophil, and we've seen this slide already, and eosinophilia. Okay? So to just kind of liven things up a little bit, in the last dwindling hours or minutes of the day, let's have a quiz. I can already hear the sphincters contracting. Okay? When I hear 100 sphincters contract, it makes a noise. And I just heard it because I said quiz. That's too close to test. Okay? And so there was a reaction to it. Okay, all you got to do is use your thumbs. Make believe you're Caesar, like in that movie Gladiator. Okay? What's this mean? Okay? Okay, yes? What's this mean? No. This means you don't know. Kind of like that. Okay? Okay, so this, yeah, he's going to tell you. No. This, I haven't the slightest idea. Okay, you ready? Here we go. We'll start off easy. Hay fever. Okay, very good. Okay, rash in a patient with penicillin. Very good. Okay, I see somebody going like this. Looking around. Okay, I give the answer. Very good. Terrific. Quick. The reflexes are so quick. That's good for this time of day. It means your ATP levels are fine. Probably on creatine. Why does creatine give you energy? Because it's what binds phosphate, and that's the phosphate that you get from making ATP. That's the only thing creatine does. So what serum test would be markedly elevated in someone that's taking creatine for their muscles? Creatinine! Because the end product of creatine metabolism is creatinine. And so they have creatinine levels as high as the ceiling. Okay? Of course, the BUN is normal. And that's because they're on creatine supplements. You know what? That's a board-worthy question. There's lots of people take creatine. Okay? And so they can put this down there and you see horrendously big-time creatinine levels in some guy that's a bodybuilder. The urea level's normal, and they say, what's causing it? The answer is on creatine supplements. And so many people do that. Okay, but at any rate, that's moving along. So you're doing good so far. Now we're going to have real fun. Amoebiasis. You're not moving your finger. You're not moving your finger. Okay, all he's doing is working on his nose. He's not getting his finger up. And the thumb he's using, that's the worst part of it. Okay. Okay, now. Amoebiasis, you went like that, right? Pinworm. Okay. Strongyloides. Okay. Malaria. Okay. Well, you really got screwed up. No protozoa, but this is eosinophilia. So that rules out amoebiasis, that rules out malaria, that rules out giardia. No protozoa. Only invasive helminth. Is a pinworm invasive? No, it's not. You do not have eosinophilia with pinworm infection. Those are perverted worms. What do you mean they're perverted? The male and female take a trip down to your anus while you're sleeping. They mate in your anus. They lay eggs in your anus, which cause you to itch in your anus, and you scratch it while you're sleeping, and usually it ends up going in your mouth, and you reinfect yourself with your own eggs. That's perversion. But they do not invade your mucosa. There is no eosinophilia, guys, and pinworms. It's a classic board question that gets you. So no protozoal infections, only invasive helminths. Strongyloides, of course. Adult ascariasis, no. Why? Because all they do is get together and obstruct your bowel. It's when they have a larval form that goes across your lungs. Remember that transmigration route it takes in there, and then you swallow it and then develop it. When you're going across the lungs, that's invasive. Then you have eosinophilia. But the adult ascariasis, no eosinophilia, because it's not invasive. So type 1 hypersensitivity, anything type 1 hypersensitivity, yes. Anything protozoa, no. In terms of worms, not adult ascariasis, no. Not pinworms, no. All the other ones, yes, because they invade. Whipworms, all that kind of crap. Okay, so gave you some points there, gave you some points. Polycythemia is always asked on boards 1, 2, and 3, and so you have to have a real good concept of this. Okay, it means that you have an increased RBC count, hemoglobin, hematocrit. Now, this one you really want to listen up on. It's too bad it's this time of the day to be talking about something this important, but that's the way it is. Now, the first concept that I think is important is there a difference between RBC mass versus count? Well, before I do that, is there a difference between serum sodium and total body sodium? Sure. Serum sodium is milliequivalents per liter of plasma. Total body sodium is milliliters per kilogram of body weight, the total amount that you have. Similarly, RBC mass is the total number of RBCs you have in your entire body in milliliters per kilogram of your body weight. So it's all you have. It can be measured by radioactive technique. Red blood cell count is the number of RBCs you have in a microliter of blood. So it's how many you have in a certain volume of blood. That's the RBC count. Now, why am I making a big deal out of this thing? Listen, what if during the break, during lunch break, you went out and ran, and you got volume depleted? What would your RBC count be? It'd be high. Why? Because if you're volume depleted, then you'd be hemoconcentrating your red blood cells because it'd be a little less plasma volume than you were when you weren't running. Okay, so that would hemoconcentrate, so it would look like there's more RBCs per microliter of blood because you decrease plasma volume. If that's true, which it is, but what would the RB mass be? Were you actually synthesizing more RBCs when you're running? So what would the RBC mass be? Normal. That's why that's important. Okay. So there's two types of polycythemia, relative and absolute. Relative is where you have a decrease in plasma volume causing an increase in RBC count, but the RBC mass is normal. That's actually the most common cause of polycythemia right there. So let's say you really do have an absolute increase in RBCs. The next question is it appropriate or is it inappropriate? All right. What would be appropriate to have an increase in actual synthesis of RBCs? Tissue hypoxia. Any cause of tissue hypoxia you know would be an appropriate response. So if you have lung disease and you have hypoxemia, it would be appropriate for you to have it. COPDers always have high RBC counts unless they're anemic from something. If you live at high altitudes, they always have a slightly higher RBC count. That's an appropriate polycythemia. Okay? But what if I had perfectly normal blood gases and I didn't have tissue hypoxia, yet I did have an increase in RBC mass? That would be inappropriate, wouldn't it? So there's two things that we have to think about when an increase in RBC mass is not an appropriate response. One is polycythemia rubra vera, which is an example of a myeloproliferative disease. That's a stem cell disease in the bone marrow. And when I say that, that means that the stem cells are kind of like dictators. They kind of no longer respond to checks and balances on them. And they basically will make whatever they want, when they want it, and nothing can tell them not to do it. So it's a neoplastic disease of stem cells. There is a propensity for going into leukemias in these things that you would expect because that's also a stem cell disease. So it would be inappropriate to have totally normal blood gases, no evidence of tissue hypoxia at all, and have an increased RBC mass. And of course, one thing is that polycythemia rubra vera. The second one would be if you had some tumor or some kind of cyst with an excess production of erythropoietin. So, for example, you have a renal adenocarcinoma making erythropoietin, causing an increase in RBC mass. Is that an appropriate thing or inappropriate? It's inappropriate. It's a tumor that's just inappropriately making it. So, in review, polycythemia is relative or absolute? Relative means you just lost plasma volume, running, whatever. RBC count increased with mass normal. And then when we have an increase, an absolute increase in RBC mass, you have to ask yourself, is it an appropriate increase or is it inappropriate? What would be appropriate? Anything that's causing a hypoxic stimulus for erythropoietin release. That would be appropriate. Okay? If there isn't a hypoxic stimulus and you have an increased absolute RBC mass, then that means you're either ectopically making it with some tumor or some cyst or something like that in some tissue doing it, or you have polycythemia rubra vera, myeloproliferative disease. Got that so far? Okay. Now let's deal with polycythemia rubra vera. Now, I'm going to redefine myeloproliferative disease for you. It's a stem cell disease where it's neoplastic, where the stem cell has lost all regulation. Nothing can inhibit it anymore. Okay. 4 diseases, sometimes people consider 5 diseases, fit under this definition. Polycythemia rubra vera fits under this definition of myeloproliferative. Chronic myelogenous leukemia, that's the only leukemia that's put under this category. I think I know why they do it, but it's not important for you to know. So it's considered myeloproliferative. 3, adenogenic myeloid metaplasia. That's where the bone marrow is replaced by fibrous tissue. That's considered myeloproliferative. 4, and the least common, essential thrombocythemia. That's where the stem cell that makes platelets just goes bananas, and you make 1,600,000 platelets per microliter. That's another myeloproliferative. So those are the four main ones. Some people stick under this myelodysplastic syndrome, which is a pre-leukemia type of syndrome. Some people call that myeloproliferative. Okay, so those are fit under it. Now let's deal with polycythemia rubra vera. The easiest way of teaching you this is 4 H's. 4 H's. First H, and most important H, hyperviscosity. Remember I told you Puisseau's law? Okay, total peripheral resistance equals viscosity divided by the radius to the 4th power. Remember that? Well, what do you think is going to happen if you have polycythemia? It's going to increase viscosity. What is that going to do to peripheral resistance? Increase it. Your blood's going to be sludging around like mad. And guess what it's going to predispose to if the viscosity is increased? Thrombosis. And it's thrombosis that kills you in any polycythemic state, in particular polycythemia rubra vera. Thrombosis of what? Anything you want. Dural sinuses, hepatic vein, Budd-Chiari. In fact, the most common cause of Budd-Chiari syndrome, hepatic vein thrombosis is polycythemia. Coronary artery, superior mesenteric vein, you name it. Anything you want can be thrombosed if you have blood literally sludging around because you have hyperviscosity. See, that's why they do phlebotomies, guys. They do phlebotomy to reduce viscosity so you don't thrombose. Let me tell you another reason why they do phlebotomies, to create iron deficiency. They want to make you iron deficient. That's pretty strange. Why would you want to make someone iron deficient? Because if you make them iron deficient, it's going to take longer time to make more RBCs. You're going to have to get more iron stores back before you begin making more RBCs. You're just slowing down the process. So you purposely make them iron deficient. That's weird, isn't it? Okay, so that's what hyperviscosity. If you don't remember anything else, that's probably the most important one. Okay, because that's the one that kills them. Hypervolemia. It's the only polycythemia where there's also an increase in plasma volume that matches the increase in RBC mass. None of the other causes of polycythemia have an increase in plasma volume. Now, both RBC mass and plasma volume can be measured by radioactive techniques that are done in most big-time hospitals, can do both. So it's very unique for polycythemia rubra vera to have an increase in plasma volume. My impression of why that's true, myeloproliferative diseases take years and years and years to develop. And so I think that what's happening is, because it's such a slow process, the plasma volume is able to keep pace with the RBC mass, and so they both kind of go up together because it takes so long, as opposed to other things that might be shorter. That's what I think. Who cares? It's increased, and it's very useful. Third H, what's the third H? Is histaminemia. All cells are increased. RBCs, white blood cells, and platelets in polycythemia, including mast cells and basophils. Here's a classic pearl for you. Patients with polycythemia very commonly will come to you with a history like this. They'll say, "Doc, when I take a shower, hot, warm, cold, doesn't really matter, I itch all over my body." That is a tip-off for my polycythemia rubra vera. Why? Because mast cells are increasing, and you know they're in the skin. And temperature changes can degranulate mast cells, causing them to release histamine. And you get generalized itching. Guys, there's very few things that produce generalized itching. And one of them is bile salt deposition in your skin in patients with obstructive jaundice. That's one thing. And the second is mast cell degranulation. That's it. Those are the only things I can do. Is generalized pruritus. That's a very, very big one. Okay? And that relates to the increase in histamine release from mast cells. Also, remember they get that face that's kind of ruddy, very red looking? I bet most of you thought, like I did, that's due to the increase in RBC mass, right? They're all congested. No, that redness is due to histamine, producing vasodilatation. They get headaches like migraines, very, very common in this disease. The last H is hyperuricemia. As a concept there, guys, hyperuricemia, because nucleated hematopoietic cells are elevated, like neutrophils or stuff like that. And when they die, nuclei have the purines in them. And so the purines are going to have to go into the purine metabolism, and the end product of that is uric acid. That's a concept you've got to remember on the exam. I'm sure our friend, the guy that has that little accent that sounds like English, okay, I'm sure he told you that when you have cancers, okay, and you're going to treat them with a chemotherapy drug, and they're going to die. A lot of cancer cells are going to die. You always have to put them on what drug to prevent them from going into renal failure, from urate nephropathy, from all this uric acid. What's the drug? Allopurinol. You have to do that. You have to block xanthine oxidase because you're going to be releasing millions and millions of purines when you kill those nucleated cells. And they're going to go down there and they're going to form uric acid, and your tubules are going to be filled up with uric acid, and you're going to go into renal failure. You have to put them on allopurinol. Okay? That's called a tumor lysis syndrome, if you want to know a name for that. Well, the same thing happens in polycythemia rubra vera. Got such an increase in number of cells, they eventually die, you run the risk of hyperuricemia. So that's the key things for that one. Believe it or not, you're ready to fill in the blanks. So there's the blanks. I'm going to go turn real quick to them. No, I don't want you to turn. I want you to do this on your own, all by your lonesome. Are you ready? Okay, we have RBC mass, not count, mass, plasma volume, oxygen saturation, and erythropoietin. You ready? Okay, what would you put in for polycythemia rubra vera for RBC mass? Increase. Good. Good so far. Plasma volume. Increase. Very good. Now think. Now you're going to have to think. Oxygen saturation. Normal. Very good. It's inappropriate polycythemia. Now think. Think. Think O2 content. 1.34 times the hemoglobin times the oxygen saturation plus the PO2. That's the hint. What's the erythropoietin level? Low. Decreased. You got piles of oxygen because you have piles of RBCs, and that would suppress erythropoietin. So you have low erythropoietin levels. It's a hormone, guys. Remember, hormones have to have some checks and balances. So if you got enough oxygen, erythropoietin is suppressed. If you don't, it goes up. Okay, so in review, we have an increase in mass, volume, normal O2 fat, low erythropoietin. All right, how about chronic obstructive pulmonary disease? Let's throw another one in. Tetralogy of Fallot. Put another one in. Someone living in Breckenridge, Colorado. Way up there. That's where my daughter lives. Okay? What would the RBC mass be in these patients? High. Okay. What would the plasma volume be? Normal. What would the O2 saturation be? Decreased. Very good. And what would the erythropoietin level be? Increased. See, it's an appropriate polycythemia because it's relating to the presence of hypoxic stimulus. Good. You're doing good. This is wonderful. You're doing wonderful. Okay, let's have a renal adenocarcinoma, and you got polycythemia. Okay. So what do you think the RBC mass is? Increased. Plasma volume, normal. Oxygen saturation, normal. Erythropoietin, increased. Well, that shouldn't be, right? If you got normal gas studies, you shouldn't have an increase in erythropoietin. Why was it increased? It's being ectopically produced. So I could use a hepatocellular carcinoma. You know, it can be anything. It's not always neoplasms where you can get ectopic secretion. Any renal cyst can do it. In fact, if you just look at the kidney like this, and it can cause it to increase erythropoietin. Okay? I mean, it can be anything that does it. Hydronephrosis, Wilms tumor, anything in the kidney can cause it to just make too much erythropoietin, not just cancer. Well, I got one thing left. That's your relative's polycythemia. No, it's relative polycythemia. RBC mass, normal. Plasma volume, decreased because everything else is normal. Guys, that's it. That's as hard as you can possibly get on part 1, 2, or 3. You got all those things, you're polycythemia accredited. All right? Take a look at this slide, guys, because according to a student that was sitting in this classroom in earlier spring, it said this slide was under test, which doesn't surprise me, because it's the pathologist that puts the slides on your exam, and I happened to talk to that pathologist at one time when he was drunk. That guy just about told me everything. Okay. I said, you get the slides from existing pathology slides that's not your, oh, yeah, we're not going to make any pictures of this. So, you know, all pathologists have great slide sets. I mean, that's like collecting butterflies for us, slides, you know. And so we have all the slides, so I'm not surprised. And I said, isn't it true? Isn't it true? Remember when we took our passports? Isn't it true that most of the time, let's say 90% of the time, don't even have to look at the slide to answer the question because they give it away in the STEM? Oh, yeah, but 10%, you got to really look at it. Okay, that's just what I thought. Okay, so most of the time you do not. I remember when I was taking my past boards, I was like 30 ahead on the slides because I went back to this. And then when the slide came up after about a minute and a half, I had to double check I was right. And it's the same thing on this board. Most of the time, you do not even have to look at the picture, whatever it is they're giving, because it just absolutely gives it away. But I would look at it, you know. But you really, in most cases, don't have to. So don't worry about slides, because you'll be able to figure it out even without it. You just give it away. Well, this is chronic myelogenous leukemia. And before we do this, I want to describe what you find in leukemias that's going to help you in being able to recognize that it's leukemia they're talking about, and then what type of leukemia it is. And you want to know what? This is really easy. In fact, if you can remember the age brackets for leukemia, you'll get all the questions right on leukemia. So remember, we said it's a malignancy of stem cells in the marrow, and it can metastasize anywhere it wants. So that means you're always going to have generalized lymphadenopathy, hepatosplenomegaly, That's a given. You're going to have that. Okay, second, you're going to have abnormal cells in the peripheral blood. Blasts. That could be myeloblasts, lymphoblasts, what else? Monoblasts, megakaryoblast, any blast you want, okay? I'm going to have a blast. That blast could be out there too, okay? So it's going to be some abnormal cells that are blast out in the peripheral blood in all the leukemias, okay? Third, because it's arising in the bone marrow, it's going to crowd out all the normal hematopoietic cells. You're always going to have anemia. Always. Usually normocytic. Okay? Second, usually, 99% of the time, thrombocytopenia, because you're crowding out the normal megakaryocytes for making platelets. And you're going to have usually, not always, an increase in the count, white blood cell count, with these abnormal cells present. Okay? You with me so far? The only other thing you got left to know is what separates acute from chronic leukemia. Simple. You got to do bone marrow. Got to do bone marrow anyway. And you count blasts. And if it turns out that the number of blasts is less than 30% of the white blood cells in the marrow, then that would qualify as chronic. If the percent blast is over 30%, it's acute. So a blast count determines whether it's acute versus chronic. That's how you can tell. Now all we got to do is age brackets, and this is absolutely idiot-proof for boards. If we're talking about 0 to 14 years of age, what's the leukemia? ALL. That's number one. All right. That's a given. 15 to 39, acute myelogenous leukemia. And what do you think the cell's going to be if they happen to put a picture of it up? A myeloblast with what in it? An RS. So 15 to 39 is acute myelogenous leukemia. Okay, from 40 to about 59 years of age, 2, acute myelogenous leukemia and chronic myelogenous leukemia. So they're more like, 30, 39, or 40 to 59 years of age. A little favor of acute. You're talking about 60 and over, you're talking about chronic lymphocytic leukemia. Guys, they always give you the age, and they literally give it away when they do that. They literally give it away. I've had many students say, you know what, Dr. Goljan, I got every one on that leukemia is right, there's no doubt about it. And I got all of them just by age. It's that simple. Okay, so what this quiz is? 0 to 14, ALL. 15 to 39, AML, what are you usually going to see in the peripheral blood? Blast with ROS, okay? 40 to 59, AML, CML. How are you going to separate those two? Bone marrow, okay? What's CML going to have? Less than 30% less. What's AML going to have? Greater than 30%. Of course, there'll be a couple other things for CML that you already know, Philadelphia chromosome, et cetera, et cetera. Okay, what about 16 over? CLL, very simple. As a matter of fact, CLL is the most common overall leukemia regardless of age. That's how common it is. When I was practicing in Yuma, Arizona, in 1 week, in the wintertime when all the snowbirds came, that's the people that live up in the north and they come down to the southwest, okay, I would diagnose CLL 5 times a week. Okay, it was that common. I mean, we'd see this is just like, it's just so common. So it's the most common leukemia, that's one. It's certainly the most common leukemia after 60. Now listen to this one. It's the most common cause of generalized, non-tender lymphadenopathy in someone over 60. Now, is that because it's a lymphoma? No. It's because of what? It metastasizes to lymph nodes. Every one of those things has been on an exam. So it's very simple. So you got a 62-year-old dog who's got generalized non-tender lymphadenopathy. Answer, chronic lymphocytic leukemia. Don't pick malignant lymphoma because that's not going to be right. It's going to be chronic lymphocytic leukemia. Okay, let me give you the history on this so you can see how easy it'll be to recognize even though you know the answer already. This is a peripheral smear from a 49-year-old man. He's got 150,000 white blood cell count. He's got 1% of myeloblast in his peripheral blood and bone marrow at examination. It's got generalized non-tender lymphadenopathy, hepatosplenomegaly, thrombocytopenia, normocytic anemia. Diagnosis: chronic myelogenous leukemia. There you go. It's right age bracket, right percentage of blasts. Now, what tests you're going to get to prove it? You're going to get a Philadelphia chromosome study. Okay, remember, that's that 922 translocation of what proto-oncogene? ABLA. Remember, that has non-receptor tyrosine kinase activity. And when you translocate it from 9 to 22 and fuses with the great cluster region, forms this fusion gene, that's the Philadelphia chromosome. There is a stain that you can also use called leukocyte alkaline phosphatase. We would take this smear right here, and we would overlay this stain on it, and see which cells, which neutrophils in this smear would take up the stain for alkaline phosphatase. Here's the concept. Mature neutrophils all have alkaline phosphatase in them. Neoplastic neutrophils do not. Why? Because they're neoplastic. That's the clue. And so it's actually a very easy test to do in chronic myelogenous leukemia, because we overlay it over it and we look for the stain and see if there's any staining. And there's no stain, because we look at the neutrophils. We look at that cell, which is a segmented neutrophil. There'd be no stain. If that was benign, it would have had taken up the stain, but there isn't any. So you count 100 of these things in there, and you grade them from 0 to 4 on intensity of stain, and it's usually 100 zeros. Okay? And so you add it all up, and I think it doesn't take higher math to figure out that 100 zeros equals 0 score. And that's called a leukocyte alkaline phosphatase score. It's always low in chronic myelogenous leukemia. So what are the two main tests for proving that your diagnosis is chronic myelogenous leukemia? The Philadelphia chromosome study, and what's the other one? Leukocyte alkaline phosphatase score, which is low, usually like 0. Good. Excellent. We'll do other leukemias in a second. All right. What does that look like? A teardrop. That's right. Little tear. It's crying. Why? Because there was this dictator that used to live, and I'm going to tell you the story of this. There's a dictator that used to live in the bone marrow, and it said, "Attention, hematopoietic cells. We are going to move." Of course, there was a big, up-to-do about this thing. Okay, and everyone said, "Where?" And it said, "Spleen." Okay, so it was a migration of hematopoietic cells from the bone marrow to the spleen. Now, when you take up hematopoiesis in a place other than the bone marrow, there's a name for that. And you know it has to be extra medullary hematopoiesis. That's the term we apply when the hematopoietic cells go someplace else to make their cells. Why the spleen? I don't know. They can do it in other places, but it's a reasonably big organ, so they can do it. And so the spleen is huge. Some of the biggest spleens you will ever feel will be in this disease called agnogenic myeloid metaplasia. And it's a smart dictator. It knows that some people are going to complain and they want to go back. And so he sends back some megakaryocytes and say, "Okay, you go back to the marrow, and I want you to lay down collagen all the way throughout the marrow so that nobody can go back and find a place to live." And so that's what happens. The megakaryocyte goes back, follows out the order, and fibroses the entire stinking bone marrow. And that's why the old term for this is myelofibrosis and myeloid metaplasia. Now they call it agnogenic myeloid metaplasia. Well, remember, there's always 10% of people that never get the message. And so some dudes never heard we're moving to the spleen. And so a few dudes will hang around, even in that fibrotic marrow, and do their thing, okay, like red blood cells. But to get out into the sinusoids, they're going to have to worm their way through strands of fibrous tissue that oftentimes damages their membrane. Plus, it hurts. And so when it hurts, what do? You cry. And so in the process of coming out and hurting itself, getting through all this barbed wire, fibrous tissue, and getting into the sinusoid, it finally makes it into the peripheral blood, but it's been irreparably damaged. It hurts, they cry, and they permanently identify themselves as a teardrop. It's sad. It's a sad story. I get so sad every time I tell this story. Okay? And it's a wonderful marker for this particular disease. So somebody that has this huge spleen with teardrop cells has what disease? Agnogenic myeloid metaplasia. Very good. Now, would you say there's too many platelets in this? Say yes. Okay. And this is the myeloproliferative disease. They never asked on board. This is essential thrombocythemia. That's a neoplastic stem cell that wants to make too many platelets. And that's all I'm going to say on that one. Okay. We're ready for the other leukemias. I'm going to give you history. You're going to tell me the diagnosis. You ready? Let's look at this one up here on the left. Okay, this is a patient that's 4 years old that presents with sternal tenderness, fever, generalized non-tender lymphadenopathy, hepatosplenomegaly, normocytic anemia, 50,000 white blood cell count, many of which have very abnormal appearing cells, like these. Okay? What's your diagnosis? ALL, acute lymphoblastic leukemia. Okay? And these, you don't have to identify those as lymphoblasts. You don't need to. You already know it's ALL. Remember, that's the most common cancer in kids. Do you remember that? Okay. There's one thing, maybe two things you need to know about ALL for part one, and that is the most common type actually has the word common in it. It's common ALL antigen B-cell leukemia. Remember, that's a CALA antigen, and it even has the cluster designation. Do you remember what the cluster designation for the CALA antigen was? 10. So it's CD10 positive, CALA antigen positive, B-cell acute lymphoblastic leukemia, and that's all you need to know for part one. Part two, you would need to know a few more things about remission induction therapy and that kind of crap, now for part one. All right, so you got that one. Very good. Let's go to this one. Okay, this is a peripheral blood from a 65-year-old man who has generalized non-tender lymphadenopathy, hepatosplenomegaly, normocytic anemia, thrombocytopenia, I think I said, and 90,000 white blood cell count, almost all the cells resembling these cells up here with these a couple smudge cells around. An additional interesting thing is this patient also has hypogammaglobulinemia. What's the patient have? Chronic lymphocytic leukemia. Now I'm going to ask you a question. Why do they have hypogammaglobulinemia? Because these are neoplastic B cells, guys. Can they change into plasma cells if they're neoplastic? No. So why would they have hypogammaglobulinemia? Because then the neoplastic B cells, they can't transform into plasma cells to make gamma globulin. So what's the most common cause of death in these patients? Infection related to hypogammaglobulinemia. That's right. Okay. You already knew the answer was when I said 65. If you didn't know that, then you already knew the answer when I said generalized non-tender lymphadenopathy. I didn't have to say anything anymore. You know, it was still, again, CLL. All right. Now, this one I didn't tell you, but you probably all know this. This is a patient, probably 62, has splenomegaly, generalized, usually don't have generalized, but let's say hepatosplenomegaly, big old spleen, and they have these weirdo-looking cells with kind of these little projections of the cytoplasm, and a special stain was ordered on these cells to make the diagnosis. What was that special stain? TRAP, the TRAP stain, tartrate-resistant acid phosphatase stain. And what cancer is this? What leukemia? Hairy cell leukemia. Very rare. I may be seeing 3 cases in my entire life. The only thing they ever ask about hairy cell leukemia is that stain. TRAP is the abbreviation, tartrate-resistant acid phosphatase. Okay, and that's it on that. Have you seen this slide before? Yeah, that's the hour rods. Okay, so this is a peripheral smear from a patient that is 35, who has generalized, who has, let's say, a 50,000 white blood cell count with many abnormal cells appearing like this in it, has 70% blast in the bone marrow, anemia, thrombocytopenia. What's your diagnosis? Acute myelogenous leukemia. Okay, and what are these called? Hour rods, which really are abnormal lysosomes, actually. Little splinters. They look like little red splinters in the bone marrow is what they are. Okay. Now, here's a few more over here. Now, I know that most of you were forced to memorize the French-American-British classification of M0 to M7. Is that correct? You should have taken your instructors and hung them up by their toenails. Okay? Because they never asked that on boards. 1, 2, or 3. Do Goljan's and all that bullcrap, don't worry about it. If you're going into hematology or internal medicine, that'll be on your boards. There's only a couple things you need to know about these acute leukemias. You need to know what an hour rod looks like. You need to know the leukemia that likes to infiltrate gums. Could you name that one for me? Acute monocytic leukemia likes to invade gums, and there it is right there. For those of you that memorize them, you know that's M5, okay? And this one you need to know. This one. Now, talk about hour rods. This one over here is so full of them, it doesn't have any cytoplasm left now. And so many of them even got out into the blood here. This is acute progranulocytic leukemia. This is M3. They always have DIC. So all the leukemias, this is numero uno for disseminated intravascular coagulation. Second, it's got a translocation, 15-17. Third, you treat it with what? retinoic acid, which is vitamin A. And how did it work? It causes these blasts to mature into benign cells. Isn't that incredible? It maturates them so that they can form, they become benign cells. That's amazing. Every one of those things I just said is on the board. The translocation, the treatment, how the treatment works, the DIC relationship, all of them I've been asked as individual questions on the boards. It's that important. Okay? That's it. Those are your leukemias. We've done our anemias. Got 15 minutes. And exactly 15 minutes, I can finish all you need to know about lymph nodes, too. Yeah. Why? Because we never ask any questions other than, let's say, things like Hodgkin's disease and stuff like that. It's nothing. So 15 minutes will be done with this, too. So tomorrow we can do coagulation, blood bank, and then start cardiovascular and even do respiratory. All tomorrow. We'll understand what our heart and lungs are doing. We'll understand the concept of the pathology of love when we talk about the heart. Am I on the right side? Yeah, left side. Okay. Yes, there are changes that occur in the heart when you're in love. Okay? It pounds more. It's a palpitation that you can feel even when you're lying down. It's just boom, boom, boom. You say, I wonder what's the matter with me. It's love. Isn't that cool? Love causes your heart to pound. I really like that. Is your heart pounding at all? Not really. It never has. Maybe when I run it pounds, and that's about it. When I had Graves' disease, it really pounded. That's nice. Okay. That's too bad, but you haven't had that. Okay, guys, you see this lymph node up here? You ever had a lymph node in your neck that hurt when you pressed on it? Let me show you how easy this is. If you have a lymphadenopathy and it hurts, it's never malignant. How about that for a start? Because what it means is you have some kind of inflammation that's causing it. So painful lymphadenopathy is never malignant. It's not leukemia, it's not lymphoma, it's some inflammatory condition, which doesn't always mean infection. You got generalized lymphadenopathy, it's lupus, but it's painful lymphadenopathy because you're stretching a capsule, it's an inflammatory condition, and that produces pain. Okay? When you have non-tender lymphadenopathy, always think malignant. The first thing you think about is metastasis to it, or the second thing to think about is a primary lymphoma originating from it. Do they always tell you whether it's painful or painless? Always. So they say painless, you're not going to pick any answer that deals with cancer or lymphomas. You're going to pick something that's inflammatory. You with me so far? Okay, you can have localized lymphadenopathy and generalized. What does generalized mean to you? Let's say generalized painful lymphadenopathy. A systemic disease. A systemic inflammatory disease. That's what it should mean to you. Okay? So in HIV, they all have lymphadenopathy. Is it generalized? Of course. It's a generalized disease. It's a viremia. So it's generalized. How about Epstein-Barr? It's generalized. Yeah, of course. Lupus. Is that a systemic disease? It's called systemic lupus erythematosus. It's generalized. But if you have exudative tonsillitis, is that generalized? Of course not. It's going to go to the local node, and that's going to hurt. Now, how about breast cancer? Is that generalized non-tender lymphadenopathy? No, it just goes to the local regional nodes. All of these things are put into the stem of the question, and it literally narrows down the list of possibilities to something very simple to pick out. Painful, inflammatory. Painless, cancer. Localized, painful, some infection draining something. Localized, non-painful, some cancer that's draining, that's spreading to that lymph node. You with me? Okay. All right. Now, they have pictures commonly of a lymph node, guys, on the boards. And they have arrows pointing to it. This is the sinus of the lymph node here, and so that would be probably A. Then this little jobby here would be B, and then the stuff in between would be C. Okay? You ready? If you have Bruton's A gamma globulinemia, which one of these areas, the sinus, the germinal follicle, or this area would be absent? The germinal follicle, because what's in the germinal follicle? B cells. It'd be absent, be gone. Now, if you had the George syndrome, which part of this lymph node would be screwed up? This part, the paratrabecular, because that's T-cell country. You would see absolutely none of this, and all you would see are germinal follicles. And what if you had histiocytosis X? That means Hand-Schuler-Christian, letter of seaweed disease, okay, which is a true histiocytic CD1 positive tumor. Where would you see that? Right here. It's the sinuses have histiocytes. That's good. What if you had severe combined immunodeficiency due to adenine deaminase deficiency? You would have none of these and none of these, but you would have histiocytes, because that's a combined B and T lymphocyte deficiency. Are you with me? That's how they ask it. You see, when macrophages process antigen and they deliver them to B cells, that's what causes these germinal follicles. These are B cells that are in the process of dividing and dividing and dividing, and what's the end product going to be when it comes out of this germinal follicle? A plasma cell, which is going to be making what? Antibodies. This is just called reactive lymphadenopathy. This could be lupus. This could be something draining your tonsillitis. Whatever it is benign. Do you see anything different? I mean, these look like follicles, okay? But isn't it have a little bit of different demarcation, light stain, darker stain? There's a little bit of difference in the types of cell populations. This looks like, everything looks like it's the same, even though it's forming follicles. What is this? This is a malignant lymphoma. In fact, you've already seen this slide before. What's the origin of this? If you've got these things that look like follicles, what do you think of? Follicular lymphoma. And what do you think it's of? What cells? B cells. This is your most common non-Hodgkin's malignant lymphoma. What else did I tell you was strange about this particular tumor? Translocation, 1418, and what happened when you translocated it? What was knocked off? The apoptosis gene. And so the cells are now immortal. Okay? See, this picture was on boards. Can you tell where it was taken from, a cross-section from? What do you think this is with the little cartilage in there? And what do you think these little elastic arteries from? Okay, this is the trachea, and these are branches of your elastic arteries. This is lymphoma. Remember they used to describe lymphoma as fish flesh? It looks like fish flesh. Which kind? Flounder. How about that? Okay? Well, if you like red snapper, a red snapper look. But do you see something strange about this tumor? Is it invading through the cartilage? Is it invading or avoiding the elastic arteries? Okay, so you learned another concept. What two tissues are resistant to invasion by cancer cells? Cartilage and elastic tissue. That was a board question. So I killed two birds with one stone by showing this thing up. Now, when I say I killed two birds with one stone, do you think that means when I throw a stone, two birds fall over dead? If you do, you're schizophrenic. A rolling stone gathers no moss. What does that mean? Well, that's simple. Duh, that's simple. The stone goes so fast, the moss can't stick to it. Hospital. Psychiatric consult. That's concrete thinking. Okay, so that's one of the things that happens, of course. When you're schizophrenic, you lose concrete thinking. You mean that's all you have is concrete thinking. You can't think abstractly. And so you use these terms, and you see how they answer. It's one of the tip-offs. And then, of course, you ask them, are people talking to you all the time? Like right now? Well, you're talking to me. That's not some kind of auditory hallucination, okay? That's just whatever. Okay, so you can't invade elastic tissue and cartilage with tumor. Very rare. You've seen this slide before? Okay, what did the kid have? Burkitt's lymphoma. What was it due to? Epstein-Barr virus. What was the translocation exactly? 814. And what did it translocate from A? MYC oncogene, MYC. Okay. Now, you probably learned that the morphology of a Burkitt's lymphoma is a starry sky appearance. Remember that? Okay. Well, what were the stars? These dudes. These are, no, this is not lymphoma. These are just normal benign macrophages which look like stars in the black night of the sky. That's what they're supposed to be, the black night of the sky. Starry sky, okay, appearance. These little cells here are the Burkitt's lymphoma cells. These little things are macrophages, so it looks like stars in a nighttime sky. It's very characteristic of Burkitt's lymphoma. At about number 3, most common cancer in kids. Right now, it's got a fantastic, there's a French chemotherapy system. We can actually cure this disease now. There's a little dude that just basically recovered from Burkitt's lymphoma that was in his face. And in the United States, we don't get it usually in the jaw, but this kid did. In the United States, Burkitt's lymphoma is the most common lymphoma in kids. It's in the abdomen. Usually Peyer's patches, periaortic lymph nodes, somewhere there. It's rarely ever in the jaw. Burkitt's lymphoma that looks like this is more common in Africa. Burkitt's lymphoma in kids in our country is more in the abdominal cavity, periaortic nodes, Peyer's patches, something like that. Even testicle sometimes it involves that. That's all I have to say about Burkitt's. Now this person really looks like he's got some problem there. Okay? He's got these little plaque-like lesions. First of all, he's got no teeth. That's one problem. He's got these plaque-like lesions, and most people say, this guy's got some rip-roaring fungal infection. Okay? Because they took sections through it, and they saw these what they thought were inflammatory cells in the epidermis, and they said, sure, I know it is, but they couldn't find any fungus. So they had said, okay, let's call this mycosis fungoides. Okay? Because it's got to be a fungus even though we can't find it. Well, it turns out that those inflammatory cells that they thought that were present in the skin were actually the neoplastic cell. Okay, guess what they were? Of all things, helper T cells. So the neoplastic cell in mycosis fungoides is the helper T cell. Isn't that amazing? I mean, that's a dude that's what helps everybody. It's not helping this dude a whole lot. Okay? And so it's a T cell malignancy that usually involves skin as well as other organs, including lymph nodes. Now look at that cell. Well, that's a cell that's called a Sézary cell. You see, what's interesting is because idiots like to get their names in print. They knew this was mycosis fungoides, but when one of those malignant helper T cells gets into the peripheral blood, we're going to call it something different now. We're going to call this now Sézary syndrome. And so that's what causes confusion with students. It's basically the same thing as this, except some of the malignant cells got into the peripheral blood. Okay, this is an electron micrograph down here of a child that had a rash on the skin, an eczematous rash all over, a generalized non-tender lymphadenopathy, hepatosplenomegaly. So you know it's bad. A biopsy was done of the rash, and it was a monomorphic infiltrate of cells that was CD1 positive. And so they did an electron microscopy of those monomorphic appearing cells, and it showed this structure in it. Well, first of all, what does the patient have? That's a malignant histiocytic lesion, in this case, Lederer seaweed disease. The fact that I said CD1 proved to you was a histiocytic disease, and what do you think this is called? A Burbick granule. What does that look like to you? A tennis racket. Now look at it again. I want to see how good you are at integrating. There's a bacteria that's a spore former that has a terminal end spore that also looks like a tennis racket. Who am I? Clostridium tetani. That sounds pretty close to tennis, doesn't it? Clostridium tetani also has a spore at the end of it. Remember, spores don't take up the stain because they're within the bacillus. And so when I see a Burbick granule that looks like a tennis racket in a histiocyte, the very next thing that I associate that with is a Clostridium tetani spore. And so I can keep these two concepts in my mind, even though they're not related to each other. So this is a Burbick granule. All right, Hodgkin's disease. Hodgkin's disease. You know, they still call it disease. You want to know why? Because anyone with fever, night sweats, and weight loss has got to have TB until proven otherwise, right? Right? Okay. And so these patients would come in with localized, but they would be non-tender lymphadenopathy. They'd biopsy these things, and they'd look at their lymph nodes, and they'd look and say, oh, look at this, these are all benign, and they'd see these little dudes over there and say, hi, look who's looking at me, you got this guy looking at me, that one. Okay, he is, he's got an ophthalmoplegia, because that eye's going that direction. And so they probably, the pathologist waved that in under the microscope, hi little cell, let's find a malignant cell. Okay, so who would have thought that that was a malignant cell? Because all these lymphocytes are benign. No wonder why they thought it was a disease. Fever, night sweats, and weight loss. They biopsy the lymph node and they see these things. How could that be malignant? It is. That's the neoplastic cell of Hodgkin's disease, and it's got a name. Name it. Reed-Sternberg cell. That's what you guys call owl eyes. Okay, you call it an owl eye. It looks like an owl with the eyes in there, okay? Well, that's an owl eye. So is cytomegalovirus an owl eye. So is Giardia an owl eye. So is the Aschoff nodule rheumatic fever in owl eye. There's so many sticking owl eyes, forget it. Okay? That's the neoplastic cell, guys, of Hodgkin's disease, a Reed-Sternberg cell. Not these other lymphocytes. That would be a lymphoma, a regular lymphoma, a non-Hodgkin's lymphoma. The malignant cell in Hodgkin's disease is the Reed-Sternberg cell. So if this is true, and it is, the less number of these things that you had, the better the prognosis. The more that you would have, the worse. Does that make sense? You don't really need to know all the different types of Hodgkin's disease for part one. Lymphocyte predominant, nososclerosing, mixed cellularity. You don't need to know that at all. All you need to know is, what is the malignant cell? Reed-Sternberg cell. What's the most common one? That's the one this woman had. I think maybe that was a message. Isn't that amazing? That was exactly 5 o'clock. Okay, read break. So you'll find out the rest of the story tomorrow morning. That's if you're here.